Good morning, everyone, and I welcome all the speakers, chairperson, delegates, medical students from India and abroad. After yesterday's power-packed session on pediatric endocrinology, the toughest part of endocrinology, now today's session are based on diabetes and its related complication. So we would be discussing right from the basic like glucometers, SMBGs to CGMS, that's continuous glucose monitoring system, to the latest of insulin pumps and DIY pumps, do-it-yourself pumps, from the clinical examination of the foot to the diabetic distress to the best of diabetic technologies in present era, from young diabetes to the genetics of diabetes to the rare forms of diabetes in adults, from GDM to MODY, everything will be discussed in this session for today's lectures. Not to forget about the kidney and the heart, because they are the most important thing. That is why we are treating diabetes, to prevent complications. So that also we are going to discuss. And very two important session not to miss, that's frequently encountered and infrequently discussed, those things which we don't see in which we see in clinical practice, but we don't see on the CMEs and conferences. So that is something which is very important for your clinical practice. So that things are also discussing. And to complete the session, we have obesity workshop, which is the newest pandemic. So we'll have a complete 1 hour session for the obesity workshop. To begin with, I request our tech team to please start with the Saraswati Vanna. May the goddess bless us with the power of knowledge. Tech team.
Ya kundendu tushar dhamana, ya shubhra vastravruta, ya veena varadanda vanditakara, ya shveta padmasana, ya brahmachyuta shankara prabhutibhi देवैः सदा वन्दिता, सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा। शुक्लां ब्रह्मविचारसारपरमाम् आद्यां जगद्व्यापिनीम् पुस्तकधारिणीम् अभयदा जाड्यान्धकारापहा। हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदा।
Thank you. With this, I, Dr. Mayur Agrawal, DM Endo from Bhopal, declare this session, this conference as open for second day. And let me introduce my colleague, Dr. Kanaiya Agrawal from Gorakhpur. He is heading Hormone India Gorakhpur, to please take over the session and introduce our chairpersons.
Good morning all. Thank you, Dr. Mayur. And so I welcome all the chairpersons. First of all, I'd like to introduce Dr. H.S. Trivedi sir. He's a retired professor of medicine and he has various national and international publications. He's a well-known speaker in the Madhya Pradesh. Secondly, I welcome the Dr. Narendra Rai sir. He is a senior consultant and neurologist in the Neurocity Bhopal. And thirdly, I welcome Dr. Hasmukh Jain sir. He is a consultant physician. His area of interest is the diabetes, cardiology, rheumatology, and he is also managing critical care. Lastly, I welcome Dr. Alok Verma sir. He is a consultant physician, especially the non-invasive cardiologist and preventive medicine, and he is running the smart clinic. So I welcome all the chairpersons for the wonderful session. So I hand over the session to the Dr. Trivedi sir.
Sir, kindly unmute, sir. Trivedi sir, kindly unmute. Tech team, can you unmute, sir?
Good morning.
Good morning, sir. You are audible.
Can you see me? Am I audible?
Yeah. Yes.
Ajay.
Hello, sir.
Good morning, Zargar sir. Dr. Trivedi, sir, you are on mute.
Hello.
Yes, sir. Good morning, sir.
Let's start.
Yes, sir.
Yes.
Can we start it now?
Yes, sir.
Yes, sir.
Yes,
Please
sir.
introduce
Yes, sir. We
ourselves
can
first,
start.
speaker, sir.
May I request Dr. Priya to start the deliberation?
Yes, sir. Please, kindly introduce Dr. Priyanka Kukrele, sir.
Yeah?
You have to introduce Dr. Priyanka Kukrele for the session. It is mentioned here in the slide, sir, about her achievements. It is mentioned about her achievements in the slide, sir.
What achievement you want to get it from me? That I already worked for more than 52 years as a consulting physician for so many years. Still continuing my job of as a physician and consulting physician and being interested in diabetes for so many years.
Sir, I'll start definitely.
Yes,
Thank you,
yes.
sir. Thank you so much, sir. Thank you, sir.
Ria, can you please share my slides? Yeah. Okay, ma'am.
May I request Dr. Priya to start the lecture
Yes, sir. I'll definitely start, sir.
so that you can, that the person can just enjoy and they can be benefited much more than just giving all those deliberation and what are achievement, etc. That's all.
Definitely, sir.
The lecture is a much more inspiring part of things should be over there, so that can be useful more to the public and the human mankind. So I request your honor to start the lecture. Okay.
Yeah. Thank you so much, sir. So the talk I'll be covering today is 100 years of insulin. So I'll be telling the mainly what all events happened in last 100 years for the discovery of insulin and how we have evolved in last 100 years. Next. So the agenda in short I'll be covering is the past of the history of the insulin and the present, the relentless innovation towards a relentless disease, and the future, how bright it is. Next. So the first part of our talk is the history. Now diabetes. What was the life before the discovery of insulin? Before insulin, diabetes was mostly a fatal disease. The most effective treatment was to put the patient of diabetes on very strict diet, that is like minimum carbohydrate diet. Sometimes patient even died of starvation itself. You can see the starvation treatment of diabetes, how strict it was. That ultimately lead to the malnourishment of the patient, and it was very difficult to treat the child in those days when insulin was not discovered. Next. Now, insulin, a discovery which gave hope to all those people who are suffering from diabetes. Sir Frederick Banting was the name behind the greatest discovery of diabetes, that is insulin. Next. Now, Marjorie was the name of the dog in which the first time the insulin was experimented and it was discovered successfully. Next. Just a second, sorry. Delay. So Leonard Thompson was the first patient to receive insulin in Toronto when it was discovered by Banting and Best. Next. So the past events which led to the discovery of insulin, we will talk from year 1920 to year 1923. It was an era of discovery of insulin, and so much was going on for the discovery of insulin. The idea came into the mind of Frederick Benting. He met Mr. MacLeod and to finance him to give his laboratory, and he gave his student best to work with him. Then what they did together is they took out the activity of crude extract in a pancreatomized dog, and then they used to inject those extract in the dogs, and then finally they discovered insulin. And they got Nobel Prize Award to Benting and MacLeod for the discovery of insulin. Now, this was published in Lancet 2020. It says that it was 60 years now back. It said that 40 years with insulin and 4,000 years without. Today, there must be 300 million people with diabetes whose lifespan has increased on an average at least by 10 years. This makes a total of 30 million years of productive human life in one country alone. And this statement was given 60 years back. So we can understand the importance of insulin and how much life it has saved in a developing country like our country. Next. Now, the Fantastic Four name behind the insulin discovery were F.G. Benton, C.H. Best, J.B. Collip, and J.J.R. MacLeod. Next. Now, over the past 100 years, more than 10 different categories of medications has been developed. Now, first of all, in 1921, animal insulin first came, and then it was followed by intermediate acting insulin, which is the NPH insulin. And in around 1950, we came with the first generation sulfonylureas, followed by metformin. Over the period of 1960 to 1980, there were other recombinant human insulin, second generation sulfonylureas, and then there was discovery of in 1980s, 1990s analog insulin like Lispro and all. And then after 2000, we have multiple OHAs like incretin effect were discovered, and GLP-1 analog, DPP-4 were discovered, SGLT2 were discovered in 2013. And there were newer generation of combination of insulin. And the latest one is like peptide in a pill, the semaglutide, which was discovered in 2019. So today, these medicines are used in various combinations to form the individual treatment plans for people with diabetes. Yet, insulin still remains plays an important role in both type 1 and type 2 diabetic patients with the highest glycemic efficacy. Next. The discovery of insulin significantly improved the life expectancy. As we can see, before the discovery of insulin, the patient who was denoted as having diabetes mellitus was like very difficult to accept to the family, because the lifespan of that child will be like maximum 1.5 years, or maybe lesser than that. And immediately after discovery of insulin, like in around 1945, you can see there is increase in lifespan by plus 35 years. The life will be added to that child or to that person. Now in 2015, we can see the person can live almost a normal life with the help of insulin and other OHAs which we have. So following the discovery of insulin, the average life expectancy of a person diagnosed with diabetes improved dramatically. And earlier it was very less, and now it has improved significantly. Next. So now talking in brief about the present innovations towards a relentless disease, that is diabetes mellitus. Next. So what were the innovations since the discovery of insulin? As we can see, from 1974, there were first complete total synthesis of human insulin was done. And then in 1982, there was first recombinant insulin available. Then there was the first analog insulin, Lispro, which was discovered in 1996, followed by Aspart. In year 2000, first basal analog, that is Glargine, was discovered, followed by Ditimer and Digludec, other basal insulins. Then there came insulin Glargine U300. Then the insulin faster acting insulin like Aspart came into the market in 2018, and ultra rapid Lispro in 2020. Next. Now, in short, talking about the generation of analog insulin. So from 2013 2017, we have Tresiba, Ryzodec, Toujeo, Fias, all these drugs. So talking about them in brief, like Tresiba, it has an ORI dosing, better FPG control, lower glycemic variability, and it has a CV safety. Coming to Ryzodec, then it can be given as OD or BD dosing. It again has a better control of FPG, lower risk of hypoglycemia. Coming to Toujeo, which is U300 Galargine. It also has a OD dosing, better FPG control, and lower glycemic variability than Galargine U100. Coming to the Fiasp, which is ultra fast acting insulin aspart. It has twice as fast onset of appearance in the bloodstream, and it has superior 1 hour, 2 hour PPG control with mealtime faster aspart versus aspart insulin. Next, coming to the patient benefit with evolution of basal insulin. So how the basal insulin has evolved from the NPH insulin to Galargine U100 to Ditimer to U300 to Degludec. Next, in brief about them, NPH was the earliest basal insulin which we used to use, and still in the resource setting like our government medical colleges, we still use NPH as a cheaper option in our country. It controls fasting hyperglycemia. Next, the Galargine U100 has an OD dosing, but it has lower risk of hypoglycemia as compared to the NPH insulin. Then came next Ditimer. It also has a lower risk of hypoglycemia versus NPH. Next, Galargine U300. It has an advantage of lower risk of hypoglycemia as compared to the Galargine U100, but limited flexibility advantages are the limitation. Degludec is the last basal insulin next, which came into the market. It has a OD dosing. It has the flexibility of 8 to 48 hours, better FPG control, lower glycemic variability, and a CVC. Next, coming to the evolution of mealtime insulin. We came from a regular human insulin to aspart lisperglulising, and now we have the faster acting insulin aspart. So earliest with us was the PPG control. For PPG control, still we use regular insulin. Next, in short about them, it controls mainly PPG, but it has lack of mealtime flexibility. Next, coming to the aspart lisperglulising, it also has a good PPG control, mealtime flexibility is there, and they have lower risk of nocturnal hypoglycemias. Next, coming to the drug, that is the latest one, faster acting insulin aspart. It closely mimics the physiological mealtime insulin secretion and better control of both 1 hour, 2 hour PPG, and it has the lowest risk of nocturnal hypoglycemia outcome. Next. Now coming to the premix insulin. The earliest premix insulin which we used was biphasic human insulin, then came biphasic analog, then insulin degludec combination with the aspart. Next. So a word about them. Next, Riya. So biphasic human insulin, it controls both fasting and postprandial hypoglycemia. It is simple and convenient. It can be titrated based on pre-meal blood glucose value. Next, coming to the biphasic analog insulin, it has OD-BD dosing, lower risk of hypoglycemia versus the biphasic human insulin. It has mealtime flexibility. And coming to the combination of IDEC acid, that is degludec and aspart.
Ma'am, 2 minutes are left, ma'am. Sorry to disturb. 2 minutes are left.
Okay, sir. I'll try to finish. OD or BD dosing with the largest meal of the day. Next. So what are the key realities of managing diabetes in India that impact the choice of insulin? So the main problem with us, we are the high carb eaters. The high PPG level is there in patients. Next. So the high carbohydrate, 61 to 70% of energy intake in all parts of our country comes from carbohydrates. Next. So mainly 50% of the day we spend in postprandial phase. Next. So PPG level has to be controlled, and high PPG leads to higher HbA1c level specifically in our country. Next. And unlike the Western population, PPG control is main problem at all levels of HbA1c, be it less than 7% or more than 8 to 9%. PPG contributes significantly to HbA1c in Asian countries. Next. So we have the co-formulation, the latest one, the degludec and aspart combination. Next. 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 So the future, in short, in few slides. Next. So we have seen the isolation of insulin. It was discovered in 1921 And we have come a long way. And the drugs which are under the pipeline are once weekly insulin, and other many discoveries are going on in the field of insulin. And we are also talking about beta cell replacement. Let us see next 100 years what all things we have in future. Next. So future is bright, like we have trials on once weekly insulin going on under phase 3 trial. Next. So let us see now the summary of my talk. In our quest for better insulin, we have come a long way, and still there is a long way to go. Though we have advanced with newer analog insulins available with better efficacy, safety, and patient convenience, the adoption is yet low. It is time to breach the insulin inertia with decisive steps, and newer analog insulin and delivery devices will help physicians cover the treatment gap. Next. So a word of wisdom at the last. We should always cherish what you have, because not all people are blessed with the things that you are enjoying. So we can imagine the trauma of a patient who was not having insulin in 1920s. And now we have so many options, so many insulins we have. And we should always cherish and be open for both patient and the physician point of view to accept insulin in our life. Thank you so much. I hope I have completed in time.
Yes, ma'am.
Yeah. Yes. Thank you.
Trivedi sir, please unmute yourself. So, thank you, ma'am. I like Dr. Narendra to take a next session for Dr. Rakesh Parikh sir and introduce him, so we can start to move our next.
Thank you, Hormone India, and thank you, Maru.
Thank you so much, ma'am. Thank you, ma'am. We are glad by you. Thank you.
Yeah.
Dr. Narendra Rai sir, are you there? Dr. Verma sir, please, if you can introduce Dr. Rakesh Parikh sir.
Yeah, good morning, everyone, and welcome Dr. Rakesh Parikh. He is fellow of American College of Endo, Royal College of Physician and Surgeon, College of Physicians, Surgeon of Mumbai, RSSDI. He is Treasurer, RSSDI, Rajasthan State Chapter, on editorial and reviewer board of various journals, over 50 publications, including textbook chapters, principal investigator on several global phase 3 trials. So I invite Dr. Rakesh Parikh for delivering his talk. Welcome, Dr. Parikh, sir.
Thank you, Dr. Verma, for a nice introduction. And thank you, Dr. Mayur and Team Hormone India for inviting me to speak on this topic. Are my slides, sir?
Yes, sir.
Okay. So I'll start with the topic. I'm sure most of you who are sitting here must have been through this generation where this was a scenario at various places, like for banking, for admissions in the colleges, for shopping, for ticket booking. Everywhere there was a crowd. And over the last 2 decades, since my school age, I have seen a huge transformation in the way these things work now. So in the banking, it is all on the mobile now. The admissions are online. Shopping you can do from your mobile. Ticket bookings you can do online. So all these things, in addition, you don't have the queues at the post offices. You don't need to wait for the cabs, food delivery. Everything is online. And the same way, the transformation should happen in the healthcare industry. We have been able to do some transformation, but still, if you see the scenario at the outdoor clinics of most of the government hospitals, it's like this. These are all crowded. The long queue outside the OPD is still visible in the government setup. Specifically, you will see that in the private setup also. The medical records are still maintained in such a situation where it is very difficult to pull out a file of patient and find or go through the records of the patient. And all this leads to a poor care for our patients, and patients land up in the hospital, leading to large number of admissions because of complications due to diabetes. Now, our country has got some specific problems. We know that we are the diabetes capital of the world. We have around 77 million people with diabetes in the age group of 18 to 79, as per the latest IDF Atlas. And the number is projected to rise by around 64% in the next 20 years. We have lack of trained doctors who are trained in treating conditions like diabetes. There is lack of awareness among the people. There are resources are lacking. We are not able to provide the best of care to all our patients. Most of the patients pay from their own pocket. The majority of patients are not insured, and these are specific problems in India. And there are tech solutions to address these questions or these problems to some extent. Telemedicine is now picking up, online EMR to address the issue of records, patient education and portal for patient education. We have a lot of portals and apps which are now available. Majority of these are now being supplied by the pharma companies as well. The patient just need to scan the QR code and they get all the educational material on diabetes. There are apps for specific purposes like for carb counting, for calorie counting, for dietary recall, and even for dietary advice. There are apps for exercise, for activity tracking. There are apps for reminding you about the pills that you missed, and these are supposed to enhance the compliance of the patient. So going through a few of these one by one, teleconsultation, I am sure many of you must have used during the COVID pandemic. And the best use of this is that the patients don't need to travel long just for a follow-up visit to you. The patients who are far from you can consult you online through video chat, at least in the conditions like diabetes where you don't need to examine the patient. The further developments are in progress by which you can even examine a patient through teleconsultation. Electronic medical records, I'm sure many of you are now using, and they make our life very easy. You can prescribe the patient, give them an e-prescription. There are several modules for managing your laboratory, for pharmacy, sending the reminders to patients. There are templates for each, so you don't need to repeat writing the prescription or the common advices that you need to give to the patient. So these two things are now being used by a majority of us. Online labs and online pharmacies are available. Patients don't need to go to the labs or pharmacies. They can order the medicines and the drugs from their own home just by using the mobile. But then there are several other areas where the development is still on, and the acceptance among the healthcare professionals and patients is still lacking, and there is a huge potential to work on that. So different areas that I can touch upon right now will be the developments in the field of glucose monitoring, insulin delivery, screening for complications, treatment of complications. There is a new area that is reversal of diabetes. People are working on that. Digital therapeutics is coming up now. Stem cells and gene therapy are still being tried, and there are newer targets for drugs which are being identified. So in the next 12-13 minutes, whatever is possible, I'll try to cover that. So as the development has happened, we have all gone through these different mobiles that we had earlier, and now we have the latest smartphones. Similar way for the glucose monitoring from glucose meters that we had 2 decades back. Now we have come to AGP and CGM. And I believe there is a separate session on CGMs, so I will not go through the details of this. But these are the common CGM devices that are being used. In the future, you will have ever since CGM in the country, and it is designed to work for 3 to 6 months. So you will have a prolonged period of glycemic profile of the patient that can be tracked just by putting one implant in the patient. But then CGM devices are a little costly, and not many people can afford it, especially in our country. So the other option, the poor man's CGM, can be the connected meters. So now the glucose meters, they connect with the Bluetooth devices, and there are apps which will not only record the values of the glucose, the timing of the glucose measurement, also the food intake or exercise, and then they can give you a profile of the patient for 24 hours if you do the structured SMBG. If you plan the SMBG in a particular way and advise that to patient, just by doing 7 to 8 times SMBG in a day, you can come very close to CGM by using the connected glucometers. So these are now available in our country. They are not very costly, and I would suggest that we all should start working or using these, at least in the patients where we can't use CGM because of finances. The other area is of insulin delivery, and in insulin delivery, again, we have moved along. Last 20, 30 years, there have been several developments. The development in the field of insulin have been already covered by the previous speaker, and the insulin pumps, again, this will be covered in the separate session, I think, after this session itself. So CGM and insulin pumps, I will not be talking about in my presentation. But again, insulin pumps are not very cheap. They are not affordable to patients. And in those cases, you can use these newer devices, which are smart pens and connected pens. So these are the simple insulin pens, but you can have either additional attachment to that pen, or you can use a smart pen, which will record the insulin dose that the patient has taken, the timing of the dose, the amount of insulin left in the pen, and it can connect to the meter, to the smartphone or the app, and again it can come little close to the insulin pumps that people may not be able to afford. In addition, there are several apps. So for carb counting or for tracking the food intake of the patient, now the apps are available freely in the Play Store and on the App Store. You can advise the patient to choose any of these apps that they like, and they can use it for not just carb counting. There is another app now, recently we saw that, in which the patients can just take a picture of their meal, and the app will use AI to tell the distribution of calories and distribution of proteins and carbs and fat in that particular meal. So these apps can be very useful for the patient's self-management. There are activity trackers that many of us are using now, so I'll not go into that details. These apps will tell you the time that you spend in exercise, the amount of calories that you have spent, and all those things. There are different apps with different glucometer bands, which also give you the glycemic profile over last few days based on the glucose readings that you have taken. They even give you estimated HbA1c based on the glucose values that have been charted. Then there are insulin dose calculators. So you don't need to calculate the doses manually. You just need to put up your ISF for once or total daily dose once, and then these apps will calculate the insulin correction doses that you require to be given as a bolus dose. Then there is a new area that is called digital therapeutics. So these are the products which deliver evidence-based therapeutic interventions to patients that are driven by high-quality software programs to prevent, manage, or treat medical disorders. And this is an emerging area in which a lot of companies that you can see on the slide, these companies are investing in this. So these are just software programs, but they are shown, or there is evidence to show that these improve the patient's glycemic profile and their overall life also. Then this area is also picking up, and we are now having several startups which are working on diabetes reversal. They claim that they can achieve reversal or remission of diabetes or cure of diabetes. So I'm a little skeptical about that, but at least it is true that by using different wearable devices, if you track the patient's overall digital zones for the whole day, you might give individualized advice to patients, and that might improve their glycemic profile. There is a new startup that is working even on patients who are pre-diabetics or patients who are at risk of diabetes, and in those also it's being used. Now, for the management of complications, the AI-enabled fundus camera is widely available now, and I'm sure many of the people sitting here must already be using it. So even a physician like us can now use this camera to take the photograph of the fundus, and the AI would help us in interpreting the fundus whether the patient requires a referral or not. Then this is a new thing that is coming up for the management of erectile dysfunction, in which the shockwave lithotripsy, shockwave which we use for lithotripsy, is being used for treatment of erectile dysfunction. It is a little costly and not very effective, but the people are working on improving the effectiveness of this therapy. Then peptide-derived growth factors are being tried for the treatment of erectile dysfunction. For the management of diabetic foot, now you have sensory insoles. So these insoles have got inbuilt sensors in them. These sensors will sense the temperature of the feet, the pressure points in the feet, and the sensor is enabled so that it will also transmit the data to the healthcare professional. The healthcare provider would always get the patient's data from the patient's feet, and they can monitor it and advise the patient telephonically for the care. And this has even been shown to reduce the risk of complications like ulcerations and amputations significantly if the patients are put on these sensory insoles. There are sensory socks as well. So this is a siren socks, which is normal socks only, but then it again monitors the patient's temperature of the patient's feet and can predict the development of ulcers in future. Then this is an AI-enabled multispectral wound imaging camera. This is a very simple mobile app and a camera. And when you have a foot patient who has got an infection, but you are not sure about the infection, whether it's gram positive or gram negative, this AI-enabled camera actually takes the photograph of the wound and tells you whether the infection is gram positive or gram negative. And it has got a sensitivity and specificity close to 90%. So you don't need to wait for the culture reports. You can start the treatment of antibiotics just based on this image as well. Now, there are several such things, and I just have 3 minutes more left. So I won't go into details, but we had a separate conference on diabetes and technology a few months back. It was again a virtual conference, and there were several such topics which were discussed for a full 2 days in 3 different halls. And there are several new things that are coming up. All these videos are available on DocTube, and you can go through this. I will highly advise you to go through these videos to be aware about the new things that are coming up in the area. In 3 minutes, I'll just try whatever I can finish. So this is a new thing, that is BioLink. This is again for monitoring the blood sugar levels. It is a CGM, but it doesn't have a needle. It just has got some micro needles. So these micro needles remain in the dermis itself. They don't go into the subretinal space, and from there, it is expected to measure the patient's glucose levels. Then there are non-invasive glucose monitoring devices which are already in the market. They are not very accurate as of now, Their accuracy is being worked on, but there are several options like these watches where you can just put a sensor on your watch, on your wrist, keep it changing every 7 days, and the watch would monitor the patient's glycemic sugars in real time. These are available in different models. Then this is a non-invasive CGM. So this is just like a CGM, but there is no needle involved. It doesn't need to be pricked, and it will keep on monitoring the patient's sugar for 7 days or 14 days. Then people are working on developing some POC devices, some small devices that can monitor multiple parameters, and you can just use your smartphone for testing these different lab investigations. This is a
Sorry, sir, only 2 minutes, sir.
Yeah.
2 minutes.
This is a skin patch which is developed by some students from USA, and this simple patch which is stretchable can be put on patient's skin, and it is supposed to monitor not just the heart rate, blood pressure, glucose, and several more parameters. The things are being still researched. It's not in the market yet. Then just like continuous glucose monitoring, people are trying to develop continuous metabolic monitoring, in which they will monitor not just glucose but several other metabolic parameters continuously. This is a new startup from India itself, in which they claim to have developed a thermal scan which just takes an image of the patient's face and tells about the metabolic health of the patient. That is, the name of this startup is IRO. Then this is an InSmart artificial pancreas. In this, the blue part that you see, it goes in the abdomen. It has got a glucose sensor. So whenever the glucose levels go beyond a threshold, only then this will release the insulin. The insulin can be refilled through the tube, and the part at the other end remains outside the body. You can just refill insulin there, and this blue part acts as a glucose sensor. Then eyelid cell transplantation is still not very successful, but to make it successful, people have developed a technology by which they ensure that the eyelid cells that are transplanted are provided enough of oxygen so that they can survive for a longer period. These are smart insulin patches. These are just simple patches, and they have microneedles. Every microneedle actually has got insulin as well as glucose sensor. So whenever the glucose levels go beyond a threshold, only then the patch will burst and insulin will be released. So this can again be something close to artificial pancreas. 4D bioprinting is being used for the treatment of diabetic foot ulcers, where if a patient has got an ulcer, then you can take the picture of that patient's ulcer, and you can actually generate a graft which is from the patient's own tissues, grow it in the lab, and then that can be that can be used, that can be applied to the patient through plastic surgery. And there are several other things which I will not go into details because of lack of time. Adipose tissue is now identified as a new target, and people are trying to develop drugs which can induce the browning of the bad fat tissue, and that will again improve the metabolic health of the patient. People are also trying to use some non-invasive medical technology to work on the brain stem, and through that reverse some metabolic condition. In the stem cell therapy or in the cure of type 1 diabetes, again, newer drugs are in the pipeline, but they are still in the phase 2 of the trials. So I think I am short of time, so I'll just stop my presentation here. Thank you very much for the patient listening. Over to chairpersons.
Yes, sir. Alok sir, please sir, you can continue. Or
Yeah.
if he's there, sir, please.
Yeah. Good morning, Dr. Jagar.
Good
I
morning.
welcome you in Hormone India conference. Dr. Jagar is a renowned diabetologist from Jammu and Kashmir. He has a Center for Diabetes and Endocrine Care, Highway Gulshan Nagar, Srinagar in Kashmir. He is former member Medical Council of India, President Endocrine Society of India, member Institute Body, All India Institute Medical Sciences in New Delhi, Chairman Department of Endocrinology, Director. For delivering his talk, we are eager to listen him. So please deliver your talk, sir. Welcome, sir.
Thank you so much, Dr. Verma. I must say it's a pleasure being here this morning with these brilliant youngsters, Mayur, Ajay, Kanaya. and listening to these bright young people in the morning, Priyanka and Rakesh, how, we started with those primitive bovine, porcine insulins, and today we are looking at a possibility of making a gram-positive and gram-negative diagnosis of an organism in diabetic foot on a tool, which was unimaginable even 10 years back. And I still remember, Rakesh, when first time in PGI time, somebody wanted to introduce us a glucometer, how disdainfully we rejected it. How can it be as good as calorimeter and things like that? And now, in the next 10, 15 minutes, I'll just be washing through, what has been happening to globe in our own lifetime. Dr. Trivedi was just talking about 50 years of his experience treating diabetes. Everything has changed topsy-turvy from concept to the actual happenings in these decades. And so is this diabetic in the young population. Now, what do we mean young population? Usually we, up to 18, we take it as a pediatric population, and beyond that, up to 40 years, a young population. And many studies have included also 45th birthday. Why is it different that it needs to be discussed differently? As I'll tell you in the next 10 minutes, obesity is slowly creeping in all societies, including ours. And surprisingly, it has been seen far worse in socio-economically lower people in the Western world, because the socio-economically higher people now have started getting educated themselves on lifestyle diseases. If you look at the Western world, looking at the United States, they say Afro-Americans, Hispanic Americans, Asian Americans, diabetes far more in them because they get hooked onto, because they are far more disadvantaged societies, and they are seeing first generation the pleasures of good eating, and it's giving them problems. So ethnicity, we in India don't need all this. We seem to be predisposed to it. Family history of diabetes and things like that. Now there is a global group which is known as Non-Communicable Diseases Collaboration Group, and we have been a part of it for a good part of a decade. And we've been looking at how these non-communicable diseases have been doing globally in the last half a century, 60 years, 40 years. And this is the data that we published in Lancet in May issue of 2016, which was a reflection of what was happening in the previous half a century in the world in terms of diabetes, in terms of obesity. Here we are fundamentally concerned about India. And if you look at it, just this slide, this will give you a basic inkling what is happening globally and what is happening to us, which is more irrelevant. Look on the left side of this slide, and you will see that in 1975, if you look in terms of absolute number of obese individuals, we were at position number 19. It means if you look at absolute number, the count numbers, we were at position number 19. And you must remember in 1975, also we were a huge populous nation. Even imagine, look at that position number 7, even Ukraine had more obese people. Poland had more obese people. Now look at 2014. Indian men stand at position number 5. It means proportionately, in terms of absolute number of obese people, the number is increasing. And if that wasn't sufficient, look at what is happening to women. In 1975, women also were at position number 19. But today in our country, we have the third highest absolute number of obese women after China and the United States. And this is what is new. And when we're looking at that epidemic of diabetes, it's important to realize for our youngsters, this is another study that the same group published in Lancet only in 2016, looking at how obesity has been behaving during this period. Now look at it. When I was a postgraduate in 1980, India had presumed 11.9 million diabetics. And this study showed that in 2014, we had 64 million diabetics, which have now ballooned to almost 80 million diabetics. But what is extremely relevant to understand Numbers have increased, there's no doubt in it. But what is happening as the obesity goes up, the diabetes occurs early. And the age at which type 2 diabetes is occurring is now much earlier. Now, when I'm talking about 80s and that 11 million, usually diabetes would occur in late 40s and early 50s. And life expectancy was 58. So the glycemic burden on the vascular system, on the body in totality, on glomerulus, on retina, on endothelium would be for a relatively short period of time because most of the people would be taken care of by infections. Now, today, the same diabetes occurring at 30 and fellow expecting to live up to 80 years. This glycemic burden on this body is going to be from half a century. And that's what is different. And what trend we have shown here of obesity, the same thing we showed, we thought it was a phenomena in Kashmir only. But we saw the same trend taking off from 20th birthday only. There's another paper that published on a World Obesity Day in Lancet, this global group. We showed that even in youngsters, diabetes is getting worse by the day. Now, what is most concerning? We published a paper in Nature just a year before this pandemic, in May 2019. Which shows now this whole gamut of obesity epidemic that was occurring primarily in the urban and semi-urban areas is now moving to rural areas. And in future, the most important driver of obesity would be increase in rural obesity. And we know predominant India is rural. And Rakesh just now showed you those crowds. And in those places, things have not become better. And once this epidemic of obesity translates into non-communicable diseases, hell is going to break out. Then every fortnight a visit, every month a visit, so poor understanding of different forms of health. So this is a recent paper that we published again in a younger generation. What trajectory is getting much worse every half a decade. Now that is one thing. Now this is something different. This data, which came from Chennai, a part of it come from Chennai, which fundamentally shows that one-liner. If you look at Western world, if you look at PAMA Indians whose diabetes is as bad as in Asian Indians, that is us, the true hardcore, the Indian. We have predominantly as pre-diabetes impaired fasting glycemia. They have predominantly pre-diabetes IGT. IGT is a reflection of initial insulin resistance, and IFG is an indicator of insulin deficiency. It means we start with insulin deficiency much earlier, right from the pre-diabetes state. And this is what I had shown 2 decades back. Much before this, 2 decades before this, impaired fasting glucose and impaired glucose tolerance, lack of agreement between 2 categories in a North Indian population. This was the first study on this globe which compared IFG and IGT. And we showed there's something different. That time I thought it's true probably for us Kashmiris only or North Indians. But today, as I showed you in this data, it is true probably for all of us. And this now look at it, 40 to 49, IFG 18.8%, IGT 2.9% only. Age above 60, IFG 20%, IGT 4.3%. And now look at this IFG 20% above 60, life expectancy increased. Now, insulinopenic state is already there. This will translate into a young and old epidemic of diabetes. This generalized obesity, this possible beta cell deficiency is likely to lead to huge change in the epidemiology of diabetes globally in general, but for our population in particular. Many times, with relatively less optimal healthcare in our country is going to be a challenge in younger population. Now we see young type 2 diabetics is 16, 17, 18. Those kids going to the school, those polycystic ovarian ladies, dropping in our clinics with a blood sugar of 130, 140, which was fasting. And differentiating between type 1, type 2 maturity onset diabetes is going to be a bit difficult. So people need to comprehend how to do that. Fibrocalculous pancreatopathy, which is fortunately becoming a bit rarer, is another thing that we'll keep in mind in areas where people are still malnourished. So there are ways and means of doing it. We have clinical ways of doing it, but now we have investigative ways of doing it. And thankfully, these investigations are now universally available, which can be taken care of. But from a simplistic point of view, from our own country's point of view, if there's a young diabetic, as a family history of diabetes, which is very positive, 3 generations of have positive, yes, then monogenic diabetes. If 3 generations are not there, but there is a history of diabetes, likely type 2 diabetes. If there is no family history and there's ketonuria in the urine, C-peptide is low, look at possibility of type 1 diabetes mellitus if ketonuria is not there. Just do a plain X-ray abdomen or an ultrasound and look for a fibrocalculous pancreatopathy. And there are a myriad number of endocrine disorders that can do so. We have been talking about ad libitum about cardiovascular outcome trials and the impact of different drugs. Unfortunately, there's a very little presentation of these relatively youngish population in those clinical trials. We don't have many people from those 20 to 40 years in those trials. So that data also needs to be generated. A lot of studies have shown in younger population, it's very difficult to rationalize treatment. Drug compliance is rather poor. Adherence to diet is poor. That all of you who are in the field, who are doing it, would know it. And this is a data that only published from Pune. We showed that in comparison to adult diabetes, young diabetics have a much worse control. And as a consequence of that poor control, complications are going to be more. A big chunk of people are going to develop complications rather early, which will be a cause of concern, because every time there's a retinopathy, huge morbidity and mortality, every time there is a renal dysfunction or a cardiovascular dysfunction, we have already been listening to the epidemic of coronary artery disease and those young deaths in our country. One of the reasons is dysglycemia, dyslipidemia, and early onset hypertension in people who are obese. And diabetes-related distress is much commoner. Acceptance of this presence of a disease is much less in people who are younger than in adult people. And you have, as a consequence of that, protracted depression and quality of life becomes rather difficult, and there are huge behavioral abnormalities that would need to be taken care of. In younger population, apart from everything else, sexual health is important. If somebody gets affected with some sort of a dysautonomia or neuropsychiatric disability leading to sexual dysfunction, that would lead to the rupture of the whole familial structure if a person is involved. And then another area that we need to look at. And, already we are aware of the increase in gestation diabetes. Now, many people with this sort of a thing occurring at 20, 30 would walk into the pregnancy with diabetes. And we know it not only means that you have to take care of that pregnancy meticulously, but also how it would entail, what impact it will have on the fetus. Now, data shows that whatever the maternal metabolic milieu, it not only dictates what is happening to fetus functionally, but also has a potential of dictating the structure of the fetus, the quality of the adipocytes, the quality of the insulin receptors. And that's something, all of us need to understand. And this is going to be a whole area that need to be looked into. So in conclusion, I know there are constraints of time. What I would say is, right from the beginning, firstly, this epidemic is already there. Everybody should understand it. We need to make an appropriate diagnosis of type 2 diabetes. That's one thing. And second thing is, we need to ensure that very early there is an aggressive management. There's no, the fellow is 22, 23, abhi rehne do, utna zyada nahi hai. That sort of an attitude, lackadaisical attitude cannot happen. We cannot have crores of these youngsters hovering through dialysis machines and angiographies. We don't have that wherewithal in our country, in spite of whatever is happening in past few decades. These complications need to be prevented to what extent possible and need to be earlier diagnosed. whenever possible. And this, all of us at every tier of functionality should not lose the fact that it impacts the psychological and social life. And many times we brush through it, that I don't sleep well, the wife complains of something. Please take a minute or two to listen to it, and it'll be quite rewarding, preventing a rupture in that family. Thank you so much. I was there was a bit more time so that, I could go at it a little bit more casually rather than rush it through. Thank you so much, Kanaya, and thank you so much, Alok.
Thank you so much, sir. It was a wonderful talk. Definitely, we come across lots of young diabetes populations in our day-to-day practice, and it's quite a challenge to start with them or anti-diabetic molecules. So with that, I also thank you, the Priyanka madam. I also thank you, the Parikh sir, for a wonderful session covering the basic of insulin and also the technology of the insulin. And tell you about the young diabetes, literally it is a good challenge. So I like the chairperson to introduce the Mangesh Diwaskar sir for the next class, next session. Yeah. Alok Verma sir, if you are there,
Yeah. Good morning, Mangesh sir, and welcome in Hormone India conference. It's our pleasure to listen you. Dr. Mangesh Diwaskar is well-known personality from Mumbai, diploma in advanced diabetology from Denmark, consultant physician and diabetologist. He has a Shilpa Medical Research Center, Mumbai. He's gold medalist, MD Medicine, MBBS, Biochemistry, Pathology, and Pharmacology. Editor-in-Chief, JAPI, on editorial board Medicine Update, and then a guest editor, Insulin Journal, World Journal of Anemia, 101 publications in peer-reviewed national and international journals, delivered more than 1,000 lectures at national and international conferences. So we are very proud on sir, and today he will deliver the talk on clusters of diabetes in India. Welcome, sir, and please deliver your talk.
Morning, everybody. I have already sent my recorded lecture, so I have a look. Thank you very much for those kind words of introduction, and I really appreciate the opportunity given to me by Dr. Agrawal and Team Hormone India. And next 15 minutes or so, I will be discussing with you the various clusters of type 2 diabetes and what is the Indian relevance. Now, I really like this topic because I believe that it's time to look a little bit different, analyze type 2 diabetes a little different than what we otherwise traditionally do in our day-to-day clinical practice. So thank you once again, Dr. Agrawal and the entire Hormone India team for this lovely opportunity. And for this talk, I do not have any conflict of interests. Now, this slide you must have seen, many a times in almost all the conferences. But I want you to have your attention to this point that I'm going to make. That is, that if you really look at the Southeast Asian countries, what is different than the other parts of the globe, and especially the Pacific group of the countries, is that the look at the rise in the incidence of diabetes. And by 2021, we nearly have, as an Indian subcontinent, around 74 million. But the rise in the Southeast Asian country is significant. And Southeast Asian countries, they consist of Bangladesh, Bhutan, Nepal, India, Mauritius, and Sri Lanka. Remember that Pakistan is not the part of the Southeast Asian countries. So the question is our phenotype of type 2 diabetes different? Why, despite of all the advances in the monitoring, in the therapeutic armamentarium, in the awareness and education related to the diabetes, why we are not achieving the goals? And we need to understand that Indians as a population, as an Indian, as a or a genotype or a phenotype, we do have got a difference between the fat proportion and the presence of the metabolic challenge. We can clearly see, look at the obesity, overweight, and the amount of the diabetes prevalence that we have. And this paper, which was published by Dr. Anup Mishra and Dr. Shashank Joshi, beautifully illustrated that Asian Indians, we have very high amount of body fat, especially the visceral fat. We have got high waist circumference, but still we are sarcopenic. We have got very high insulin resistance and metabolic situation or a syndrome, which ultimately leads to the disruptions like diabetes or classically Indian phenotypical dyslipidemia, like a very high triglyceride levels, a very low HDL cholesterol level, and a high small dense LDL cholesterol levels in comparison to the European population. And that makes us what we classically are known as Mon Indians or thin fat or tough Indians, thin from outside and fat from inside. And unfortunately, in comparison to the Caucasians or the blacks, you'll realize from this slide that Asian males or females, we have got a significantly lower muscle mass. So we are sarcopenic. And this paper, which was beautifully published in BMJ, demonstrated that. And the reason for this is usually the genetic bias that we have. Now we need to understand that in Southeast Asian population, we do have got an increase in coding of a gene which is related to myostatin, which is actually responsible for the skeletal muscle growth in utero. And that's how we ultimately end up in having the inhibition of this encoding of the myostatin and leading to low lean muscle mass. And hence, this paper, which was published by Dr. Chittaranjan Yagnik, ominously demonstrates that this omnious octet, which DeFranco talked in 2009 in one of the AD conference during his mentoring lectures, we need to understand this starts right in the utero as far as the Indian babies are concerned. Now, we all are aware that Indian babies are the smallest birth weight babies in comparison to the rest of the global babies born. But still, we have got a very higher amount of body fat, the visceral fat, and the organ fat deposition. So, we need to understand that Indian babies, right from the birth, they have a tendency to develop what is called as a metabolic derangement or metabolic syndrome. And it starts becoming evident in nearly the first decade or the early start of the second decade of the life. And we have got much higher insulin levels. In fact, one of the publications by Dr. Chittaranjan Yagnik again showed that in comparison to the Caucasian babies, Indian babies have 3 times higher cord blood insulin levels. So from the hyperinsulinemic thrifty gene hypothesis, we have changed ourselves to insulin resistant phenotype of the typical population. And hence, Indians are labeled to have what is called as a very high amount of insulin resistance syndrome, which is not completely untrue. But then, what about those young Indians? Are there any clusters of type 2 diabetes in Indian population which are different than Westerners? And let me tell you, I want to bring it to your notice one beautiful difference between this slide, which you must have seen in most of the conferences, which talks about the YY paradox, where on your left side of your screen is Professor John Yudkin from Oxford, and to the right side of your screen is Dr. Chittaranjan Yagnik from BJMC Pune. And look at the BMIs, identical BMIs, but look at the differences in the fat percentage. Dr. Yagnik has 21.2% of the body fat, whereas Dr. John Yudkin has 9.1. And this paper was for the first time, Dr. Yagnik talked in the Melbourne IDF in 2003. And now Dr. Yagnik shared me the latest picture of him with his one of the other Oxford colleagues. And look at the change of the body fat percentage of Dr. Yagnik with the growing age and the body fat percentage of his colleague from the Oxford again. So you realize that the patterns are changing. Now Indians are probably becoming a little more different. And there are a good number of publications. And one such publication which I want to mention is the INSPIRED study, which was published by Dr. R.M. Anjana and the team. And you'll realize that Indian subclass of the patient they talked about have some clusters of type 2 diabetes. In fact, I was also lucky enough to be a part of the same team where we reviewed the new and the unique clusters of type 2 diabetes identified, especially in the Indians, where we looked at the 8 different parameters. We looked at the age of the onset, the BMI, the waist hip circumference, the glycemic control. We looked at the dyslipidemia pattern, and also we looked at the fasting and the stimulated C-peptide levels. And we looked at the data, which was of nearly 19,000 patients. So apart from the classical Asian Indian phenotype, thin fat Indian, what we found out significantly was there are 4 different clusters of diabetes which are seen in the Indian population. The commonest one is the mild age-related diabetes, which is around 35%, where usually you get diabetes in the 4th or 5th or 6th decade. They do have got a normal HDL cholesterol. They have a fairly well-preserved beta cell function. They have milder diabetes, and they are at the low risk of the complication. And this is what we call it as a classical garden variety diabetes. But then comes the younger population in Indian subclass of the patient. These are called as severely insulin deficient type 2 diabetes, and their percentage is again around 26 to 27%. So 1 in 4 are probably severe insulin deficient. So gone are those days where we were talking about only insulin resistance in type 2 diabetes. We need to consider even the insulin deficiency in type 2 diabetic patients. And in these patients, you will get very high amount of diabetes presenting at a very young age. They present to you at relatively low BMI and low waist hip circumference, but unfortunately they have got a very low HOMA beta. That means the beta cell capacity is much lower, reflected by a low C-peptide levels, both fasting and stimulated, and they present to you with grossly uncontrolled sugars. And remember that this population is vulnerable to develop nephropathy very early in the life. Then the third cluster that we see, or a subtype of diabetes that we see, is what is called as IROD, that is insulin resistance, obese diabetes or obesity related diabetes. This is around 25% patients. They do have obesity, so they have higher insulin resistance, so they have fairly well preserved beta cell function, and these patients are vulnerable to develop diabetic kidney disease and retinopathy both way, but diabetes kidney disease is much commoner in these patients. And the fourth typical characteristic subtype that we see in the Indian population is what is called as a combined insulin resistance and deficiency diabetes. This is a much severe form of diabetes, presents to you at very low age or a younger age, and they are very highly vulnerable to develop complications. As far as the typical Indian population is concerned, apart from the insulin deficiency, IROD and the combined insulin resistance and deficiency diabetes are very, very unique to Indian population. As far as the young type 2 diabetics are concerned, as I talked, remember that I have spoken about the impaired beta cell reserve. You can clearly see in comparison to the Indians, look at the beta cell function in the Caucasians. Now we compare a lot of times to ourselves to Chinese, and look at the Chinese population, and you will realize that Indians are faring much lower beta cell function in comparison to the rest of the world. In this paper again by Dr. Anjana beautifully depicts, look at the age of the onset of the severe insulin deficiency and look at the BMIs. You'll realize that we manage rest very, very early. Another paper which got published in Diabetologia also showed that there is a distinct change between the Indian subclass and the European subclass, where Indians now have insulin deficiency as more commoner feature in type 2 diabetes in comparison to the Caucasians. And the reason is probably the story of the two tails. There is a clear divergence between the phenotype 2A and 2B, and Indians probably present through a phenotype 2B, where we have got a path of developing diabetes through an impaired fasting glucose, where we have got a very high fasting glucose level, and a smallest trigger will actually stimulate a very rapid decrease in the beta cell function, producing a severe form of insulin deficiency, and that's how we convert from fasting to the fully developed diabetes very, very fast. And always remember, this conversion happens very fast in India. So Indian type 2 diabetes are different in comparison to the globe, are that there is an evolutionary determined factors or epigenetics playing there, along with our unfortunately poorly changing waste toxified lifestyle, which is adding to the challenge. Now, last 2 minutes, I will be speaking to you about clinical implications, if at all are there. Yes, it is important to understand the relevance of this, primarily because that will help you in prognostication as well as the choice of the right therapeutic interventions whenever it comes to the management of diabetes. And hence, I strongly believe, and Dr. Anup Mishra in his paper beautifully mentioned, that we need guidelines which are India specific. Guidelines and algorithms need to be developed for our use in our country, for suitable for our country, our population, apart from the global guidelines. And why I say so? Because we, being Indian practitioners, have a tendency to intensify the oral therapies much more than the insulin therapies. And this paper from Dr. Borgarkar showed that no matter how much you increase the OADs, the glycemic controls will never be achieved to the targets. And hence, this paper by Dr. Anup Mishra probably has demonstrated that Indian population will require insulin much early in the management of type 2 diabetes. So to summarize, friends, there are distinct clusters of type 2 diabetes which we need to look at and proactively try and identify, which will help you in correctly choosing the therapeutic intervention. Always remember that we, being South Asians, we need to understand that we do have got insulin resistance for sure, but also along with that, we have got impaired beta cell reserve. We have got extremely high amount of ectopic organ fat deposition. We are sarcopenic, and we do have a distinctive insulin resistance and insulin deficiency combined diabetes as a feature of our diabetes population. So we need to have insulin intervention as early as possible, and we need guidelines and algorithms developed for the entire Asian population. I thank you very much for your kind attention, and of course, I would be happy to answer.
Thank you very much, sir. Just I want to ask one question. Can we change the cluster by modifying the gene or some genetic counseling or something?
See, basically, we have now started understanding the various clusters of diabetes. Our knowledge has just started evolving. We have started realizing the importance of identifying and clustering, and probably, we are trying to subclassify and try to now personalize the medicine at present currently. So currently, we are in that understanding phase. Of course, the role of epigenetics will definitely have an impact. So the lifestyle and the environmental factors, which are, also playing the role in very early diabetes in the Indian population, is bound to have some improvement as our knowledge about the various clusters are concerned.
Yes, Dr. Magnesha, this is Dr. Ajay.
Yeah, Ajay.
Just to continue that, like the current cluster classification is a lot of phenotype based.
Yes.
I think we are completely missing the genotype side, and any classification of diabetes in future, I think, must include that.
Yes, we'll start understanding more and more. See, if you really look at the French and the European data, if you look at the Scandinavian data, they have 7 different clusters of type 2 diabetes. Now, at least in our population, we have initially identified these 4 clusters as one of the prominent, and one very specific and a really scary, I would say, cluster of type 2 diabetes is the severe insulin deficient diabetes, which is very prominent. Now, it's almost 1/4 of the population. So 1 in every 4th young patient might be that kind of a guy who will require a very early and a very urgent intervention with insulin therapy. There is nothing which is going to help him otherwise. And the combined insulin resistance and the insulin deficiency is going to have another challenge for us. So as you rightly pointed out, Dr. Ajay, really we have started understanding the epigenetical or the environmental impacts. The genetic part of the story, the impacts are going to take time. Good morning, Bansi.
Just one quick question to Dr. Jaga, sir. Like this diabetes which is developing in younger age, like pregnant patient who are having impaired glucose in the first trimester itself. I think that is also more and more common, sir. Any your experience in that thing? Jargar, sir?
I'm not able to see Dr. Jargar.
Okay, I think we can move ahead with the next session. Thank you.
Thank you very much. Thank you, Dr. Mayur.
Wonderful.
Hi, morning, Amit.
Morning,
sir.
Morning, Bharat.
For the next
morning,
session,
Dr. Jha. Good morning.
Thank you, the chairpersons, all chairpersons, all the speakers.
Rakesh, that was a wonderful talk. Morning, Unni.
So thank you, Dr. Priyanka, Dr. Rakesh, Dr. Mangesh, Dr. Jagar. Now I will invite Dr. Mayur Agrawal for the next session. Dr. Mayur Agrawal is MBBS, MD Medicine from Bhopal. He is my colleague in DM Endocrinology from Sanjay Gandhi PGI, DM and DNB Endocrinology, and he's wonderful speaker and very young endocrinologist. He'll be guiding us through this session, and invite Dr. Mayur, please invite our chairpersons for this session.
Thank you for the kind introduction. And this is one of the most important session, I would say. CGMS, continuous glucose monitoring system, is actually the technology we are using and changing the way we are managing patient. So it's not very futuristic, and we are using it. That's the most important thing. So that is need to be discussed with our delegates, with our colleagues, with the doctors who are practicing. For this, I welcome our three chairperson, Dr. R.K. Jha sir. He is professor and HOD at SAIMS Indore. Dr. Narda Patel, he is professor at Ellen Medical College and Hospital, JK Hospital at Bhopal. Dr. Rajesh Bhakchandani, he is head at Critical Care Apex Hospital, Bhopal. Over to you, sir. Dr. R.K. Jha sir, please introduce our first speaker, Dr. Amit Gupta sir.
Thank you, Mayur sir, for giving this opportunity. And Dr. Amit Gupta, who is known figure, but this is the customary to introduce the every speaker. So he has done his MBBS, DNB, MN, MS, FS, RFR, SSDI, FICP, and he has so many fellowship. And he is a fellow Diabetes India, and he is director Center for Diabetes Care, Greater Noida, and he is co-founder for the Diploma Technology, fellow of Diabetes India and RSSDI. The member of Membership Advisory Group in the ADA, advisor to ADA, Public Health and Epidemiology, Executive Council member of National RSSDI, the ACP India, Joint Secretary, Diabetes India, reviewer in the endocrine practice, AAC case report, clinical diabetology, executive editor in Study Court International Test Book of Diabetes in second edition, and he is having the RSSDI proceedings 2022 40 national and international publication, program coordinator, RSSDI, Save the Fit, Keep Walking campaign, RSSDI Rotary 100 Village NCD project, Defeat Diabetes campaign of RSSDI, and so many things. And he has got so many awards like Diabetes Tech Advisory, Innovation Award, Care Award for the leading most successful diabetes campaign.
Thank you for the kind introduction.
Sir, you are having this so big introduction. If I will not say, I am failing in my duty. Otherwise, you are a known figure, and everyone of us.
Thank you so much. At the outset, I would like to thank Dr. Mayur Agrawal for inviting me for this conference, and this is something I think a very important session. And Dr. Bansi, Dr. Sandeep, and Dr. Unni Krishnan is going to speak on this topic, and the topic allotted to me is the evolution and the currently available CGM. So I thought when all the other speakers and the experts, they will be speaking on the other aspects of the CGM, I would talk on the evolution in the currently available CGMs. So this is something, I think my slides are visible to all of you. So CGM, we all know it is simply a device which can be placed on the body, and it monitors the blood glucose continuously, and there are many modalities by which it can be done, and it has evolved over a period of time, more than 40 years that people are trying to build up this technology of the continuous glucose monitoring, and many more things we are awaiting in the near future also. So just to set up the agenda, I would like to start with the journey of the CGMs. And in the 1999, the first CGM was approved by the FDA. And this system was the CGM system from the Medtronic MiniMed. And the device used to provide 3 days of glucose data, which was meant initially for a physician rather than a patient to review. So this was the beginning of the CGM era. And the device was intended to help physicians establish patients' glucose profiles and monitor insulin therapy. So this was the objective when the first CGM was approved in the 1999. It took patients reading every 10 seconds and while providing 5 minutes averages, and the sensor had a maximum life of 72 hours. Like many others that would follow, the device would require finger stick based blood glucose calibration. So this is about the first CGM device which was approved by the FDA in 1999, and it was from the Medtronics. Then this is interesting to know that the GlucoWatch biographer from the Cygnus Incorporation won the marketing approval for adults with the diabetes, and this was the FDA first real-time CGM which was approved in the 2001. This was the only system which used to provide a glucose readings to the patients when introduced. So this was the first real-time CGM which patient could see their readings. It was having an armband, and it was an armband device which was non-invasive. So it was not the device was not very widely successful because one of the side effects of using this device was the local site irritation. And the Animas, which initially acquired the rights for the GlucoWatch, and then its successor, the GlucoWatch G2 biographer, it stopped selling the technology in 2007. And then later J&J acquired Animas in 2006. So this is quite interesting that in even 2001, we had a non-invasive continuous glucose monitor. There were some limitations. I'm sure the coming years, we are going to see more and more of the non-invasive glucose CGMs. In 2004, the Medtronics won the first FDA approval for its Guardian CGM system. And this had, for the first time, this device had a property where it could warn users when their blood sugar any predefined dangerous levels. So the device would use values every 5 minutes. And so this was the beginning where some alarms could have been set up in the CGM devices. And in 2004, the Dexcom came into the picture, and it introduced its first real-time CGM, and which was known as the Dexcom STS, short for short-term sensor. The device shared glucose reading every 5 minutes. And like Medtronic's Guardian device, the STS could also provide alerts when glucose level dip or rise above predefined thresholds. And that device was again intended to be used only for the 72 hours. So this is how the journey of the CGM kept on building. In 2006, the insulin pumps, they started to couple with the CGM systems. And in 2006, the Medtronic's first integrated insulin pump and CGM system was launched. And this was for the MiniMed Paradigm real-time system, which Medtronic described as a milestone towards the development of an artificial pancreas. And the following year, the company expanded the indication for its CGMs to include patients aged 7 to 17 years. For the first time, the CGM indication was approved for the use in the year for the age group of 7 to 17 years. 2007, you see the Dexcom again is introduced the 7 CGM. And this device was the first approved for up to 7 days of use. So now the timing of the CGM started to improve. The duration of the CGM started to improve. And it was Dexcom CGM, 7 CGM could be used for 7 days. And this was the model with updated software known as the 7 Plus. And it introduced blood sugar trending arrows. And the trend arrows could help people with diabetes anticipate in advance when blood sugars are starting to trend high or low. So this was the first new feature that was introduced in the Dexcom CGM in 2007. In 2007, again, there was a very close competition. So Medtronic launched the Guardian real-time system with mini-link transmitter. And the standard personal CGM features a smaller transmitter that precedes preceding models. And the transmitter is waterproof to a depth of 8 feet for 30 minutes when connected to the glucose sensor. So this is the first, in 2008, the Abbott came into picture and it launched its first freestyle navigator CGM in the US. You could see the picture in this slide. With a sensor life of up to 5 days, the navigator provided patients with blood glucose values updated once every 60 seconds. So this was the freestyle navigator. In 2008, again, Medtronic introduced its next generation professional CGM, which was known as iPro. And this was, again, a physician-targeted device. It was smaller and lighter than the preceding models. 2012, Dexcom introduced the Dexcom G4 Platinum. and it was offering improved accuracy when measuring hypoglycemic blood glucose levels. The device also could work for up to 7 consecutive days, and the device also featured a consumer technology influenced design, and the company would expand its functionality in 2015 with the introduction of the Dexcom share receiver that transmits G4 Platinum blood glucose data via Bluetooth to a smartphone or iPod Touch app. So this was the change where the CGM started to integrate with the smart devices and the smartphones and the other things. And this functionality allowed a patient to share data with up to 5 designated recipients, and the Dexcom won permission to use the device in pediatric patient in 2015. And in 2013, the Medtronic introduced its second generation integrated insulin pump and CGM, and this was Medtronic's 530G Enlite. This was the first integrated insulin pump CGM to offer a threshold suspend feature to manage hypoglycemia. And when the blood sugar level, they tend to fall below a predefined level, the pumps stop pumping insulin for 2 hours. And this was again a sensor-based Medtronic pump. And this was using a second generation of the CGM devices from the Medtronics. In 2015, the Dexcom launched its G5 mobile sensor, and the G5 mobile was the first that enabled people with diabetes to manage glucose levels via smartphone. So this was again a game changer, and the device was approved for the adults and children as young as 2 years old. So again, the indication bracket came down to from 7 years to 2 years, and the device also supported the share functionality of its predecessor. So again, that reading could be shared again with more than 5 people. In 2016, the Abbott, we all know, in current generation, we have grown up with the system. The Abbott launched its Freestyle Libre Pro. It has the longest lifespan at that time, 14 days. And as with any other professional device, only the doctors or the professionals could see the data whenever the patient visited the doctor's office. And a physician using a Freestyle Libre Pro reader can access multiple patients' data. And the sensor, we all know, is again water resistant up to 3 feet for up to 30 minutes. So this was again an advancement in the development of the CGM devices. This is 2017 when the Abbott launched the Freestyle Libre for the US patient, and this device was factory calibrated. That means that it would not require any kind of fingerprint testing. And the manufacturer, they referred it to as a flash glucose monitoring system. And this patient-focused device could be worn for 10 days. In 2017, now we know that we have Freestyle Libre 2 also, and Libre 3 is also coming, where we can use it for more than 14 days. In 2018, the Dexcom launches the G6, and the G6 has many upgrades and features from the preceding models. And the sensor again has a 10-day lifespan like the Abbott Freestyle Libre, and it also does not require any kind of finger stick calibration, although such calibration is supported. The device also features more robust interoperability than the preceding models, making it compatible with insulin pumps and the mobile apps. This is again a game changer in the CGM monitoring for weeks, and again some kind of intervention can be done in the field of diabetes also. And the Eversense CGM from the Senseonics, it provides glucose data every 5 minutes for up to 90 days via implantable sensor. So this is the longest recording CGM device, and a transmitter and a mobile app is available in the system, and the company's system, which had a 180 lifespan, is awaited the FDA approval. And in 2020, we know that the Freestyle Libre 2 also wins the FDA clearance. So this is how the CGM device have been changing, and they have been developing, and a lot of them are now available for our current use. And the next speakers, they are going to talk about the glycemic variability, the other data, and the use of the CGMs and many more things in their talk. So I'm not going to cover that. But it is important to highlight that the development of the CGM is evidence-based, and 27 randomized controlled trials have assessed the outcomes of CGM in more than 3,800 patients, and they have been published till date. And there is a cumulative evidence that indicates that benefit of the CGM patients who are treated with either an insulin pump or multiple daily insulin regimes. The CGM device actually helps them a lot. Overall, RCTs have shown improved glucose control in patients with initial higher HbA1c and using CGM compared to self-monitoring of the blood glucose device. And it has been seen that the people who wear their CGM device most consistently, they benefit the most. So the time spent in the designated hypoglycemia range was reduced in some studies, particularly in those with patients who were selected for having a higher risk of hypoglycemia. So these are the certain evidence-based things for the CGM. I will not go into the details for the data because you can see the publication of the Beck et al., Lewis, and Gianni and Von Beers, and all these observational studies, and some of them prospective as well as a randomized open label clinical trials, and they have all found that CGM can actually improve the glycemic control and reduce the risk of hypoglycemia in patients. These are certain studies and data which has been published from the Indian authors, including Dr. Jyoti Dev Keshwadev, and some of the studies from the Dr. Mohan's group also. And these are again retrospective cohort and the prospective studies, and they have again found that some sort of CGMs in different study settings, they were improving the overall glycemic control. So just to talk about what are the current generation systems, we can classify them into two categories. One is the professional and the personal. So the professional available CGMs include the Dexcom G4, the Medtronic iPro2, the Freestyle Libre Pro, and the personal are the Dexcom G5, G6, Freestyle Libre, the Medtronic Guardian Connect, and the Medtronic Pump Integrated Eyelid Guardian. The professional CGM devices are those devices where patients wear without being able to see the glucose values, and only the provider downloads and reviews the data retrospectively during an office visit. While the personal systems, they are allowing the patient to see the readings in the real time, and retrospective review of the complete profiles can also be done by the care provider in the clinic or the remotely as well. So this is the difference between the professional and the personal. The professional CGMs, they are blinded and unblinded options are there. The personal CGM, the real-time feedback or scan for instant feedback. Short-term use 3 to 14 days. Personal is for the long-term use, and they all they are for the continuous glucose monitoring. If we look at the comparison of the available continuous glucose monitoring system, we have Dexcom G6, Libre 14, Libre 2, Guardian Connect, and the Guardian 3. In India, we don't have Dexcom till now, but we have about Libre and the Guardian Connect. So you see that one of the limitation is that in Libre sensor, you need to scan the data, and if you don't scan the data, you don't get anything out of it. And there are alarms in the Dexcom G6, but there are no alarms in the Libre, and the Libre 2 had some alarm, but the Libre 2 is not available in India. The Guardian Connect again has the alarm, and the Guardian 3 also has alarms. So these are this table actually shows the comparable features of the different CGM. So I think in the next 3 talks, we will become more and more wiser about the use of CGM. So this is the journey and the evolution of the CGM and the currently available CGM in India. So thank you very much for your patient listening. So I would like to conclude my presentation here.
Thank you, sir. Thank you for the very nicely delivered lecture from past, today to future, covering all the things. And thank you for accepting invitation. Thank you, Dr. R.K. Jha, sir. And we'll move to next session, and we'll discuss the question at the end of all the 4 CGMS lectures. So I welcome Dr. Narta Patel. Please introduce our second speaker, Dr. Sandeep Suri, sir. He'll be speaking on glycemic variability.
Good morning, everyone. So I have a privilege to introduce Dr. Sandeep Suri, sir. He is MD Medicine from PGI MS Rohtak, Fellowship in Diabetes Management from CMC Vellore, Fellowship in Diabetic Food Management. He is recipient of Gold Medal at CMC Vellore, recipient of the Diabetes Awareness Award at Diabetes India 2018. He is a life member Society of India of various reputed society like API, ESI, RSSTI, DIPSI, DFSI, and ISCCM. He is a member of International Society. He is also regional faculty at CCBDM, CCGDM, etc. And he has published several articles in various international and national journals like Indian Heart Journal, Indian Journal of Endocrinology and Metabolism. So I welcome Dr. Sandeep Suri, sir, to give his very important talk on the topic of glycemic variability.
Thank you, Dr. Patel. Thank you. Thanks to Dr. Mayur Agarwal for making me part of this prestigious Hormone India conference, and the opportunity given to me to talk about glycemic variability. And we had a very excellent talk in the morning by Dr. Parikh, and now Dr. Amit has given a great overview of techno-diabetes, which is going to happen in near future. Let me share my slides. The slides are visible?
Yes, sir. They are visible.
Okay. So topic, glycemic variability. Indices, practical utility in the management of diabetes. We have heard from Dr. Amit how technology is going to change all of our practice of diabetology. And now we are going to learn something that how we can use this technology in practical aspect. No conflicts, no financial disclosure for this presentation, only thanking to Dr. Mayur for the academic opportunity. So what we see, blood glucose level in non-diabetic, normoglycemic, normoglucose tolerance person, and we think that it's a dynamic flowing blood with a glucose that is there, and that's maintained within a narrow range of 70 to 120 milligram per deciliter, and that is maintained, and it is known as homeostasis. But what happens when it is type 2 diabetes? In people with type 2 diabetes, there can be marked waves like fluctuations. And when uncontrolled diabetes there, you can have tsunami-like of situations. Peaks and nadirs can be there. And more marked in amplitude, duration, frequency in type 1 diabetic patients. So we are talking about glycemic variability, that is fluctuations. So what is glycemic variability? It refers to fluctuations in blood glucose levels, both peaks and troughs. It can be intraday, that is within day, or it is day-to-day variability or an intraday variability. But it leads to high oxidative stress. Each and every fluctuations leads to high oxidative stress, whether it is upward or whether it is lower. It leads to increased risk of severe hypoglycemia. So the one thing that is more important to remember, we are having target blood sugars. We are in the range, but you can see even when you are in the range of glycemia, we are well-maintained target range, still you can have highs and lows. So this is very important to know. But why this happens? Why this is high and low, which happen? Why it happens? It can be due to 4 reasons. There can be circadian rhythm of hormone sensitivity, that is insulin and counter-regulatory hormones. Both of these two type of hormones, insulin and counter-regulatory hormones like glucagon, catecholamines, cortisol, growth hormone, they have got a tussle of balance and influence. And there is a circadian rhythm of their sensitivity. What are the organs which are involved? The second issue is organ receptivity to these hormones, liver, muscle, adipose tissue. And the third, very important, there is independent physiological influences that can happen by the food, type of fiber, amount of carbs, at the time of food consumption, exercise, age, illness, adiposity, and very important organ dysfunction. There can be chronic liver dysfunction or CKD. All these can lead to increased fluctuations. Then the fourth very important is pharmacokinetic and pharmacodynamic and time action profile alteration of glucose lowering drug and specifically insulin. So all these things contribute to glycemic fluctuations. So friends, variations are the rule. Like it is a glucodynamic word. It is a glucodynamic word. That means a dynamic, and it is a flowing thing. So it means that you can have patterns, you can have trends, you can have ranges, and you can have directions also. And these variations can be hours to hours and days to days. So glucose variations are not limited only to postprandial excursion. There can be highs and lows also. Such fluctuations are specifically very, very marked in type 1 diabetic patient, but lesser degree in type 2 diabetic patient. And importantly, peaks are usually corresponding to maximum values after meals, particularly mid-morning, while troughs are observed over interprandial period. So dysglycemia of diabetes includes 2 components. Our age-old known fact of chronic persistent hyperglycemia that can lead to both excessive protein glycation and activation of oxidative stress. And there is more focus, recent focus on acute glucose fluctuations that is known as glycemic variability. And it is believed that frequent or large glucose fluctuations may independently contribute to diabetes-related complications. And these complications have got more deleterious effect than sustained hyperglycemia in the development of diabetic complications. So there can be a consequences of glycemic variability really very deleterious. There can be cognitive impairment, there can be cardiovascular damage, there can be arrhythmogenicity, QTc prolongation can be there is increased mortality. Also, ICU mortality has been reported to be increased when there is more glycemic fluctuations. Cognitive impairment already talked, and reduced quality of life that is there, and negative mood. But very important to learn, glycemic variability is just proportional, or it increases the multifold effect of hypoglycemia. Both the amount, duration, and number of hypoglycemia gets increased. Only to show you that long-term glycemic variability or short-term glycemic variability increases neuronal damage. It is a pan-neuronal damage which can happen with glycemic variability by increasing AKT pathway, reactive oxygen species increase, protein kinase C pathway getting upregulated, NKF beta pathways upregulated, and then inflammasomes are getting upregulated. All can lead to pan-neuronal damage. So it is very essential to mitigate glycemic variability, and very important, glycemic variability increases future risk of hypoglycemia. When you try to come back to the normal glycemic range or the target range, your glycemic variability increases. So it's a very important, very essential to mitigate glycemic variability. So there is a lot of literature which is linking glycemic variability to hypoglycemia. And how we are managing, how we are monitoring diabetes, because monitoring is an essential part of management of diabetes. Traditional static markers, or you can say the snapshot markers, or I always say it is a then and there type of parameter. It is then and there type of parameters like HbA1c, fasting plasma glucose, and postprandial glycemia. And we get these from SMBGs or hospital lab values, and there can be visit-to-visit variations that can be there. So that was the older version of monitoring of diabetes, that is glycemic triad. But now we have moved on to Hexstat. We talk about HbA1c, fasting plasma glucose, postprandial glycemia to be under control. Hypoglycemia overall should be decreased, nocturnal hypoglycemia should be decreased, and importantly, we should target glycemic variability. So we are moving from triad to Hexstat of monitoring of diabetes. These are our age-old, you can say, the first year of MBBS of biochemistry that you can see here, Benedict test of color changes, which we are tuned at that time to look at the level of glycemia in the urine. So that was the Benedict test. And now Dr. Amit has clearly shown that Guardian 3, Libre 2, and then Dexcom G6, and ever since E3 are already coming up, and we are all into this type of utilization for looking at the glycemic variability. These are the parts of CGMS. But importantly, what is SMBG and CGMS? How they are different? SMBG, that is self-monitoring of blood glucose, measures capillary blood glucose, and it gives you a snapshot or sporadic data, whereas continuous data comes from CGMS, 5 minutes or 15 minutes data that is coming from CGMS, and CGMS measures interstitial glucose. So here, the two are different. There is a transmitter which is there in interstitial fluid, and that measures glucose from here. And you have got blood glucometer that measures glucose in the blood directly. But important to learn here, there is a lag between finger stick and continuous glucose monitoring levels. Once everything is normal or stable, glucose level remaining stable, both are same, whether you are dealing with CGMS or SMBG or finger stick level of blood sugar. But once it is rapidly rising glucose level, CGMS may be lower than the finger stick levels. And once it is rapidly falling glucose, CGMS may be higher than the finger stick level. And there is a lag period of 10 to 15 minutes that can be there. See, SMBG will give you various level of glycemia at the sporadic or snapshot value. But what is happening in between hypos and increased blood sugars, hyperglycemia, you get from CGMS value. About HbA1c, gold standard of chronic hyperglycemia, undoubtedly we are believing this and we are using this modality also. But here there are certain things which has to be borne in our mind. For patients, HbA1c means it can guide you to treatment, how your quality of diabetes care is there, and what type of treatment you are getting, or what type of quality of treatment you are having. That is HbA1c for the patient. For physicians, it has got diagnostic value. Risk of complications linked are to the HbA1c value, and also our algorithmic changes which we made for the management of diabetes is also based on HbA1c value. For regulators, a drug approval is based on HbA1c, and it gives you the efficacy model for the drug that is working, that is HbA1c. But there are certain issues. We know that HbA1c has been validated right from DCCT trial to UKPDS, and also Advanced Accord, VADT, and recent CVOTs all have looked at HbA1c also. And very clearly, 1% decrease in HbA1c leads to 35%, around 35% decrease in microvascular complication. And long term, there is benefit also in macrovascular complication. But there are a lot of fallacies in A1C. So A1C depends upon three things: lifespan of RBC, number one, then glycation kinetics, number two, and there is ambient glucose level, that is chronic glycemia, that is replicated by A1C. And this list of fallacies in A1C is not complete. There are a lot of things which influence the HbA1c values. Either it can lead to high HbA1c fallaciously, or it can lead to low HbA1c value fallaciously. So we have to look at all these things. There are certain limitations: limited ability to reflect short-term glycemic changes. It is a mean plasma glucose and long-term chronic hyperglycemia that is being replicated by HbA1c from 90 to 120 days. Cannot reflect postprandial hyperglycemia and fasting hyperglycemia separately. What to do with HbA1c of 8%? We don't know. HbA1c value less than 7% may be a subject to glycemic variability and postprandial hyperglycemia. Then you can have similar number of same type of patient 1 and patient 2 with similar HbA1c, but you can see the glycemic variability is very much different in patient 1 in comparison to patient 2. So what HbA1c tell you? It will tell you only the mean plasma glucose. It is not able to address the hypoglycemia and not able to pick up the glycemic variability. So only it tells you the mean glucose reading. So we have to look at something else. So the talking about glycemic variability should be there even when you are able to achieve glycemic control. You are moving from 9.4 to 7.45 HbA1c, but you can see the glycemic variability persists, rather it increases when you reach near to the targets. So how we can measure glycemic variability? There are various parameters, there are various indices: standard deviation, mean amplitude of glycemic excursion, and MOD, that is a mean of daily difference between day-to-day variability. So we have got, and there are other parameters like percentage CV, that is coefficient of variance, the CONGA, ADRR, LBGI, HBGI, MAG, interquartile range, and AGP, average glycemic profile. I'm going to touch about all these in a brief way and making it more practical. So you have got two type of parameters, two type of indices. One is amplitude matrices, that means how much it increased from mean plasma glucose, and time-based matrix, how much duration it has increased. So it is amplitude-based matrix or it is a time-based matrix. It can be intraday variability or it can be interday variability. So these are indices which we use. For short-term glycemic variability, to talk about intraday variability, you can use standard deviation, coefficient of variance, MAG, CONGA, ADRR, LBGI, HBGI, MAG, and time in range. For short-term interday variability, MOD, ADRR, AGP, or interquartile range that can be used.
Sorry,
long-term glycemic. Yes, sir.
2 minutes remaining.
Okay, sir, fine. So glycemic variability long-term, we talk about HbA1c, fasting plasma glucose, and D. So the MAG is basically diabetes-specific matrix of amplitude of glycemic excursion, mean of glycemic excursion from nadi to peak, but it has to be there more than one standard deviation. It takes into account glycemic peaks and nadirs occurring daily, but does not account to total number of fluctuation. Standard deviation is variation around the mean plasma glucose, and if you divide standard deviation by mean plasma glucose and multiply it with 100, it is coefficient of variance, and it should be 36% or less than 36%. LBGI only talking about low plasma glucose or hypoglycemia excursion, whereas HBGI talks about hyperglycemia and it is not talking about hypoglycemia. But more importantly, we are using time in range, and that is more practical approach to look at the glycemic variability. This is time in range, which refers, and there are two things. One is time in range, that means how much time you spent out of 24 hours into this range. And there is a target range, and standard target range is 70 to 180 milligram. There are various, this is for the first time in 2019 February, when ATTD guidelines, they come up and they simplified the issue and made much more practical or actionable and interactive way of presenting glycemic variability. And they give this 10 key metrics, and that I have already enumerated, that these are the matrices which are used. It is mean glucose and number of days CGM has to be bound for 14 days, percentage of time CGM is active, at least recommended 70% of the data from 14 days. Then mean glucose management indicator, glycemic variability, it has to be percentage of coefficient of variance less than 36%, time above range, time below range, and there are various patterns that has been seen that I'm going to elucidate here. Type 1, type 2 diabetes, routinely the range is 70 to 180 milligram. You have to spend more than 70% of 24 hours. That means 16 hours to 48 minutes should be there in time range in routine type 1, type 2 diabetic patient, older patient, high risk type 1, type 2 diabetic patient, and high risk of hypoglycemia. You target range remains same, 70 to 180, but spending time should be 50% or more than 50% of the time. In pregnancy in type 1 diabetic patient, it is 63 to 140 milligram per deciliter is the range. More than 70% you should spend time in this. And the pregnancy in GDM type 2 diabetes, still you have extrapolated from type 1 diabetic pregnancy targets of 63 to 140. Time above range is from 170 to 180 to 250. That is the first stage, less than 25%. In routinely, from 250 beyond, it should be less than 5% time that I should spend, that is time above range. And for older patient, you have got certain liberal targets. For hypoglycemic patients, certain more frequency of hypoglycemia, more liberal target can be there. For pregnancy, again, it's very strict, no, above 140, less than 25% of the time. And for time below range, it is 70 to 54 is the cutoff, one cutoff, and next stage is below 54. So it should be less than 4% and less than 1% respectively. And for hypoglycemic, more patient having more hypoglycemia, so there can be lesser time. It should be minimized to spend time in time below range. So this is the appropriate way to present the glycemic variability. ADA also had updated its living standard of medical care, and there are many publications and trial publications which are there, and I'm very happy to see that our next speaker, Dr. Bansi Sabu and Dr. Unni Krishnan, are right there at the top on these in these publications. And again, you have got a multinational panel reporting time in range with individualizing time in range in various data of patients having hypos, microvascular complication, macrovascular complication, and communicant infections. And there and this time in range has been clearly validated in various trials. 10% decrease in time in range, 60% increase in retinopathy, 40% increase in micronuria, 25% increase in diabetic peripheral neuropathy. And this is newer version, which we are all following for last 3-4 years. That is ambulatory glucose profile. It gives you 4 pattern, that is there can be 10th percentile or 5th percentile and 95th percentile, that is light blue lines, 25th percentile and 75th percentile, that is dark blue line, and median line is 50th percentile. Only thing you have to see how much width is there in between the lines. Lower the limit, lower the width, lesser the glycemic variability, and that is the most important dictum which we can follow here. So there can be this is the best way to represent, or you can say that it is the most actionable visual indicator. Color marking is there, and patient involvement is maximum when you put these things in front of you, and your patient is also involved in management of diabetes. So there can be various where we can use basically when there is disparity in type 2 diabetic patient, type 1 GDM, no issues, and various complications, there is no issue. But in type 2 diabetic patient, disparity between fasting plasma glucose and postprandial glycemia and HbA1c is there, then CGMS or AGP is the answer. At risk patient for hypoglycemia, AGP is again an answer. Need for patient education, non-adherent patient, non-compliant patient, and patient not going for insulin. So this is the best way to show him that this amount of hypoglycemia is there, and that can be managed very nicely with insulin. So it can add to your insulinization when you use this thing. Then again, I'm going to just have 1 or 2 things, 2 slides more, that there is a glycemia glucose management indicator also. And if there is a discrepancy between A1C, CG, and GMI, if A1C is on higher side, then your GMI risk of hypoglycemia is high. And look also for fallacious A1C value. If GMI is on higher side, A1C is on lower side, set for lower A1C target, hyperglycemia risk can be on higher side. So you can be more aggressive here. This is regression line plot indicating that 19% time it is a concordance between GMI and your HbA1c CGMS value as mean plasma glucose and HbA1c value. So if there is discordant, then answers can be very easily can be given. So another thing which is coming up, glycemic risk
we are
index.
running late.
Yes, but only last slide is there. So this is that if you are looking at time in range, also look at time below range. So it's a very important. Time in range should be clubbed with time below range, and that makes a sense for glycemic risk index that can be calculated here. There is an equation, and which has got more weighted for very low than low, and less weight for very high and high glycemia. So lower hyperglycemia or hypoglycemia should be picked up when you talk about time in range also. So concluding my talk, concept of variability is often used in a negative sense when referring to human pathology. However, variability plays a fundamental role in all primary control systems in our body. Glycemic variability is not always negative because changes in glycemia are physiological consequences of various issues. Certain degree of variability is also observed in subjects with normal glucose tolerance, but once it is impaired glucose tolerance, type 2, type 1, it increases like anything. So increasing use of Cgms will certainly promote better assessment and management of glycemic variability. HbA1c is a biomarker. Remember, it is a biomarker, mean plasma glucose biomarker of chronic hyperglycemia. Whereas time in range is more actionable, more intuitive, more accurate, more realistic marker of glycemic variability that has got causal role in diabetes complication. So it's a time to shift from time in range, but we should have both SMBG for the best control of glycemia and also look at time below. Thank you.
Okay. Thank you very much, sir. Thank you for covering the topic, such a tough topic in such an easy way and covering all those numbers which are really important. Thank you, Dr. Narta Patel, sir. Now I welcome Dr. Rajesh Bhakchandani. He'll be introducing our next speaker, Dr. Bansi Sabu, though he doesn't need any introduction, all of us know him. He would be talking on TIR, whether it's a replacement for HbA1c or not. Over to Dr. Rajesh Bhakchandani, sir.
Yeah, thank you, Mayur. Definitely, as you said, no need to introduce Dr. Bansi Sabu. He is the chief diabetologist and chairman diabetes care.
So Rajesh, we can close the introduction earlier because I don't want to waste my 1 minute more.
I'll just have 2 words that everybody is eager to listen Dr. Bansi Sabu, so I will not go, and all the credentials are known to everyone. So welcome Dr. Bansi Sabu once again, and we are very happy to have you on the chair. Thank you.
Thank you. Thank
Please
you,
go
Dr.
ahead.
Rajesh. Thank you, Dr. Mayur. I can see many of my friends here. Saurabh is smiling. So, and Bharat, let me share my screen. Can you see my screen?
Yes.
Yeah.
Or it is coming something else. Yes. Full screen.
Yes, sir. Perfect.
Thank you, sir. Thank you. I'm just trying to. So let me start with thanking Dr. Mayur, very close friend, very upcoming, very eminent endocrinologist from central part of India. He had asked me to give a talk on a time in range, which can be considered as a replacement for HbA1c. So in next 15 to 20 minutes, I will end without any disclaimer. I don't have any financial disclosure for this talk, except that the term is time in range and the consensus which was made in Paris for continuous glucose monitoring, and then in Berlin again in ETTD meeting in 2019. In both the expert group, I was part of it, and I was one of the author for that. One very important thing in diabetes, I think this goes very truly, that if you cannot measure it, you cannot improve it. And this is very, very important when we are talking to our patient, if they are not measuring it. Here, I'm not just talking about the time in range, but overall sugar monitoring, overall monitoring for A1C, getting the doctors on regular follow-up, and even monitoring for the complication. Also, if we don't do it, we can't improve the care for diabetic patients. And one of the reasons for our patients not to have a good control, that as we have the different data to show that 2/3 of our diabetic patients are not under good control, one of the important reasons for them is they are not measuring. I mean, the continuous glucose monitoring or self-monitoring, people in India are not monitoring regularly. Now, there are 3 pillars to manage dysglycemia. As we know that it's a chronic hyperglycemia, which is very important. It's a diabetes treatment is required. It was DCCT and UKPDS for type 1 and type 2 have clearly demonstrated a direct link between A1C and development of diabetes-related complications. So we understood that a hyperglycemia in a diabetic patient is to be treated, and we should try to achieve a good glycemic control. And at that point of time, the good glycemic control, the parameter was A1C. That was decided, and it is well-established parameter since last 25 years. But one of the limiting factor for a tight glycemic control was always a hypoglycemia. Just before Dr. Sandeep talked about glycemic variability, this is a third pillar of managing diabetes or dysglycemia. It is just not the HbA1c good control. It is just not about the prevention of hypoglycemia, but at the same time, we don't want our patient to have a glycemic variability. And that's how this time in range concept had come out, because even the patients who are having good control of diabetes, still they may have a higher glycemic variability will lead to more complication. Let me start with one example. You may have a patient who is multiple times monitoring, like routine type 1 diabetic patients. Many of our patients who are monitoring their sugar 3 times, 4 times in a day. You can say the fasting sugar, pre-lunch, pre-dinner, or post-dinner or bedtime. Most of the sugar reports are normal, or at least out of 4, 3 of them are absolutely under good control. But if I do continuous glucose monitoring for the same patient, you will find that actually this patient is developing hypoglycemia pre-lunch. Post-lunch, there is a hyperglycemia, and midnight, there is a hypoglycemia too. So it is the continuous glucose monitoring. It is the CGM that can detect it. It is not just a random blood glucose monitoring. Even somebody is doing 3 times, 4 times, or even 7 times in a day, still there is a possibility you may miss. It is a random blood glucose monitoring is like taking a still photograph, while continuous glucose monitoring is like taking a videography. You can definitely see continuously that when somebody is developing hyper or hypoglycemia. So is HbA1c alone is enough for managing diabetes? And that's an important question which we are going to discuss, that whether we can replace it or even HbA1c alone is enough for managing diabetes. You may have 2 different type of patient. Just now, Sandeep had talked about the glycemic variability. You may have 2 different type of patient with same A1c. One may have a lot of glycemic variability, a lot of glycemic fluctuation. The mean amplitude of glycemic excursions are very high. But other side, a patient, you may have less glycemic variability, no hypoglycemia, and still the A1c, both the patients may have same. So these 2, when we are comparing, will definitely tell that A1c alone is not enough for managing diabetes. Let me give one more example. These are the 4 different type of patient, with all of them have HbA1c of same, 8 A1c. But if you do that continuous glucose monitoring, even managing them will be also different. The patient first, you will find the fasting hyperglycemia. The other patient with even the 8 A1c, there is a fasting hypoglycemia. The other patient with the A1c is a post-breakfast, post-lunch, and post-dinner. All 3 sugars are high, still the A1c is 8. And last patient, where with the 4th one, it is only the post-dinner sugar which is very high, and still the patient A1c is same. So you may have these different type of patient with A1c same, but all these patients, if we just target A1c to get control, and you try to treat these patients with the similar type of medication, because you want to achieve A1c below 7, from 8 to 7, I think all these 4 different patients will require 4 different type of management strategy. They cannot be just increasing the dose of whatever the medication which they are taking, or by adding the medication, probably may not lead to a perfect control for these patients. You may have the first patient where you're long acting or something to take care of fasting hyperglycemia, and the other patient, you have to reduce the dose of something which is actually causing fasting hypoglycemia. So A1c alone may not be sufficient in many of the situations when you want to precisely control the diabetes, and when you want to achieve A1c control from 8 or 8.5 to 7 or 6.5 without getting hypoglycemia, unless we do continuous glucose monitoring. So where the rationale is, do you think that all the patients need CGM? Yes, roughly we can say everyone, if we can have it. But the reason why we want continuous glucose monitoring, because A1c does not track glycemic excursion. 60% of the low, which is hypoglycemia, may not be revealed on random blood glucose monitoring, and it's a continuous glucose monitoring. identify 4 times more glucose excursion than SMBG. So, I mean, you can get all the excursion only through CGM2. CGM is beneficial for those who are not meeting their A1C goal, have frequent low glucose, are unaware of their low blood sugar, want to reduce their A1C target, hypoglycemic events, and have widely variable blood sugar level, and are children or adolescents who are willing to use. So at present, we have more data to support that for type 1, for patients who are more on insulin, there are more risk of hypoglycemia, primarily to prevent hypoglycemia, then to achieve a good glycemic variability. They are the one to whom we need the continuous glucose monitoring. Unless we do CGM, we will not able to get the time in range, that concept which we are going to talk. So the classification, do we have a different type of CGM? Luckily, in our country, we have all variety of CGM. We have real time, we have FGM, which is intermittently scanned CGM. We have professional CGM with, again, a patient can be put on this and patient has to come back to the clinic or to the doctor to get the continuous glucose report. And we have even integrated CGM when it is along with pump. The CGM system is there and you can see the continuously glucose monitoring on your pump system only. Now, do we have data that a CGM can reduce significantly the risk of hypoglycemia? Let me go back. For the DCCT, 1983, this trial was done. And to achieve HbA1c of less than 7, that was the primary target for all these type 1 adolescents and young adults. Type 1 diabetic patients, the mean A1c of these patients was 9. And they could reduce it to 7.2 by intensively monitoring them 4 times in a day and giving them insulin also. But at the risk of, with the severe hypoglycemia rate was 62 per 100 patients here in 1983. After 25 years, in 2008, almost similar type of patients, mean A1C of these patients were 7.6. They could achieve their A1C 7.1. It was only difference. The major difference was between these 1983 to 2008. Other than that, newer insulins were used in that. It was CGM used, and these patients could achieve that A1C from 7.6 to 7.1. But the risk of hypo, which was in DCCT, was 62 per 100 patient year. It decreased to 20 per 100 patients year. After 8 years, the pivotal trial where this was integrated CGM, it means the pump was also used in these patients and the risk of hypoglycemia could reduce to 0. So you can understand how this technology, how this continuous glucose monitoring can help our patients to achieve not only a target A1C, but for better glycemic control without getting hypoglycemia. Now, do we have data for type 2? And this is the paper from Unni. Unni is also there. That can we have the using continuous glucose monitoring or the ambulatory glucose profile, which we are using more often in our country, which is a professional CGM, EZP in patients with type 2 diabetes, and they are not on even insulin. Can we have that? And in that consensus, Unni, myself, Shashank, many more were the part of it. And it was published in JAPI, where we had put the consensus that yes, we can use the EZP for type 2 diabetic patients, for even oral anti-diabetic agents, and how it is useful for them to achieve a good control and less glycemic variability. Using retrospective, even optimizing and managing type 2 diabetes, one more paper from B. Mohan, we were again the part of that group. And this was the international consensus, which was in 2017, where I was part of it. And there we talked about where we should use CGM. Definitely all across the world, it was in consensus that all type 1 diabetic patients, if they can have, should use continuous glucose monitoring. Those who are type 2 on insulin or on hypoglycemic agent, they should be also. Hypoglycemic agent means like sulfonylurea, which can lead to, because primary purpose of using CGM was to have less glycemic variability and less hypoglycemia. That was the primary purpose. And it was after 2 years, they have come out with a target that if we are doing a continuous glucose monitoring, can we have a range? What range which should give to our patients or to the clinician? And all over the world, all associations have endorsed that we should use time in range, a concept for those patients who are using continuous glucose monitoring. So I can say if somebody is using CGM and getting TIR regularly, then they can be replaced. They can replace. But in India, as all our patients are not doing CGM continuously, unless you do CGM continuously and every time you achieve time in range, and then you can have, you can replace A1C. Now, this is a routine garden variety of type 1 and type 2 diabetic patients, more than 70% of the time, their sugar should be between 70 to 180. That is what the target is. But it is not acceptable for more than 5% if they go in hypoglycemia less than 70. It is not acceptable if more than 25% of the time their sugar goes more than 180, but it is not acceptable if more than 5% of the time their sugar goes more than 250, which is grade 2 hyperglycemia. So we had come out with a green box, we had come out with a yellow and red and dark red and dark yellow, just to teach that what is grade 1 and grade 2 hyperglycemia, similarly grade 1 and grade 2 hypoglycemia too. But those who are elderly, higher risk for hypoglycemia, hypo-unawareness, there also, even more than 50%, it is required to achieve a time in range. And those patients, because they are at higher risk of hypoglycemia unawareness or elderly and frail patient, it is not acceptable for them to go even for 1% of the time, more than 1% of the time, going below 70. And it is not acceptable for them to go below 54 by any condition. If this happens, you have to change the therapy. In pregnancy and type 1 diabetes, the glycemic targets are slightly more controlled, which is between 63 to 140, while with pregnancy and gestational diabetes, the 63 to 140 is almost for 92% of the time. So in GDM or hyperglycemia in type 2 diabetes patients, hyperglycemic pregnancy or type 2 diabetes patients, more than 90% of the time, they should be in range between 63 to 140. This is one paper which I have written, the time in range is a target in type 2 diabetes. So we have a lot of evidence for type 1, but do we have evidence for type 2 diabetes? Also, to consider them, can we give them a target that if they can also achieve 70% of the time, can we replace A1C for them? As most of our type 1 also in India who are not using because of affordability issue. In type 2, we are actually using intermittently. And that's the reason we had also come out with a paper which I will show that how frequently one should do continuous glucose monitoring in type 2 diabetic patients too. We have a data to support that if somebody have a better time in range, there is a less microvascular complication. Similarly, lesser the time in range, a patient will have more complication too. In 2019, time in range concept was published in Diabetes Care. It was the American Association of Clinical Endocrinology first society in 2020. In their guideline, they have put that CGM should be considered as a comprehensive management for type 2 diabetes. As I'm telling you that we have a lot of data to support that type 1 diabetes across the world. Everybody accepted that in type 1 diabetes, if we can do CGM, if we can get time in range, we can even replace for them even A1C, and we should do continuously monitoring for these patients to achieve a good time in range. But for type 2 diabetes, it was the American Association of Clinical Endocrinology first time in 2020, immediately after 1 year of publication, they had come out that CGM should be considered whenever indicated to assist patient in reaching glycemic goals safely for type 2 diabetic patients. These are some of the papers which we have also written in JAPI and Diabetes Metabolic Syndrome and Clinical Research and Review. This is one recent paper that how frequently one should do a continuous glucose monitoring. So I will not put that A1C can be replaced, particularly for South Asia. What we had written in this particular paper, that all three are complementing each other. It's not the CGM or continuous glucose monitoring, achieving time in range, getting a time in range value can replace A1C, because our patients are not doing continuous glucose monitoring 24/7. Every 15 days, they are not changing. Rather, we are asking them once in 3 months, once in 2 months, once in a month, depending on their how sugar better control or not good control. We ask our patient to do random glucose monitoring, A1C, and intermittent using continuous glucose monitoring. So all three are actually complementing each other and they all are essential. Let me give an example for a type 2 diabetes and how precisely we are treating diabetic patients or in a precision diabetology. This is one of our patients with 9.2 A1C with triple drug combination, with a gliptin, with a metformin, with a sulfonylurea, with a full dose of sulfonylurea. Patient was asked to put on insulin because 9.2 with a triple drug, patient had already gone to 2 diabetologists, endocrinologists. Patient was not ready that I will go for the insulin. We explained the patient that it is your sugar is really very high, but still your diet is also very uncontrolled. Let me put you on a CGM on an ambulatory glucose profile, and let me see that how your sugar is. On 5th day when patient had come back, we had seen that his sugar are always high, post-meal sugar are very high. We asked the patient, let us change. We should give only injectable because insulin, if you don't want, because of your dietary habits, let me put you on GLP-1, SGLT2, removed his gliptin, and we reduce the dose of glimepiride also. And we ask the patient every alternate day, please check your fasting sugar and call us. So from the 2 milligram of glimepiride with GLP-1 and with SGLT2, patient alternate day was calling. From 2 to 1 milligram on 3rd day we have done. Again on 3rd February we have done to 0.5, and when patient had come back to on 4th Feb to us, we stopped his 0.5 milligram also. And now the patient is only on GLP-1, SGLT2 and metformin, and you can see his last 4 days report was absolutely well controlled. So you may have with a guideline based therapy, what would you like to give? Patient has to be given insulin because that is what 9.2 A1C, sugar is uncontrolled. Patient is already on triple drug therapy, but precisely while doing continuous glucose monitoring, you can convince the patient also to start a newer therapy. You can also convince the patient and educate the patient for his good dietary control, and that's what the result is here. And for 2 years, patient had continues almost all 3 things, and he has reduced his weight by almost 15% with A1C keeping less than 6. And now we had stopped the patients even from that also. He is only on metformin for other 2 years and is still maintaining the HbA1c of less than 6. So it is almost like a reversal with 15% of the weight loss. A patient whom we were starting with the insulin with 9.2, you can see how this continuous glucose monitoring and how to, a time in range concept has change the therapy. It is completely like a paradigm shift in managing type 2 diabetic patients. Also, you may have different type of patterns when we are doing continuous glucose monitoring, explaining the patient that even your A1C is very well controlled, but still in time in range concept, you will say that your post-meal glucose level, particularly post-breakfast, is very high. And here you are getting somewhere hypoglycemia. So these are the things we can change by putting the patients on continuous glucose monitoring. Different examples we can give. We can explain the patient that how we can change your therapy by showing them the graph of continuous glucose monitoring and explaining them in time in range. I usually use the word when we are explaining the patient, your glucose is in range. That on a continuous glucose monitoring, how much time your glucose is remaining in range, that is what we call them as a time in range. With that, continuous glucose monitoring actually assisting us discovering unknown hyper and hypoglycemia, which may be silent or asymptomatic or symptomatic. It also gives us the observation of glycemic variability. It assesses the patient for how much time they are in out of range or in range or below the range. It is also giving us the idea about the severity of hypoglycemia and hyperglycemia during day and night time. It provides actionable information which is derived by continuous glucose monitoring report. It highlights the impact of behavioral variances. It analyzes glycemic effects of new intervention effectively and efficiently. It gives us the even digitally, we can monitor these patients if the continuous glucose monitoring is put somewhere and patient is sending the reports on mobile. We can do the care of diabetes even digitally or remotely also controlling the diabetes, and continuous glucose monitoring enhances patient self-management, adherence, and confidence in diabetes management. With this, I once again, thank you, Mayur, for giving me an opportunity. Thank you very much.
Thank you, sir, for that talk. And it was really nice to hear from you, especially those examples that made us really wise. And we have few questions, but we'll come after the next session, after this complete CGMS sessions. So thank you, Dr. Rajesh, sir, also for chairing the session. I welcome next speaker, Dr. Unnikrishnan, sir, from Pune. He'll be talking on clinical impact of CGMS. And then we'll have the questions in the end. Tech team, please, CV, please. Those that doesn't need an introduction, but he's in DM endocrinology, DMD endocrinology. He works as an head of this endocrinologist at Chelaram Diabetes Institute. He has various publications and he's been involved into the academics. He has received many orations and many awards. And without delay, I'll just hand over to sir, so that we become more wise with the clinical impact of CGMS.
First of all, let me ask if my slides are visible and if I am audible.
Yes, sir.
So let me take this opportunity by thanking Dr. Mayur Agarwal's very kind invitation for this wonderful program. And I'm going to talk about just some cases which illustrate clinical impact of CGMS. I always like to call CGMS as a moving selfie of blood glucose levels because it can predict a low glucose as shown here. It can predict a high glucose. It can give you lots of information, and it can give it to you on a reader, a phone, a watch, or on several other media. So this is a 64-year-old gentleman, hypertensive, asymptomatic ischemic heart disease, has type 2 diabetes for 27 years with severe peripheral neuropathy, proliferative retinopathy, has been on insulin for 9 years, and has been on Dexcom glucose monitor for the last 4 years. His fasting levels are all between 98 to 140. The postprandial levels are between 140 to 180. And the HbA1c is 8.2%. So you can see the fasting isn't very high. The postprandial isn't very high, but the HbA1c is certainly very high. So this was his data in 2017. You can see the blood glucose levels. Within the green color shows the time in range. For this patient, I had set the time in range as between 80 to 130. Each color of the graph is for a particular day. For example, the red is for Sunday, yellow is for Monday, orange is for Tuesday, so on and so forth. You can see that just on one day, on Sunday morning, he has a hypoglycemia, but otherwise he doesn't really have hypoglycemia. But what is apparent is that on regular insulin and Degludec, you can see that his post-breakfast levels are high, post-lunch levels are higher, and there is a lot of variability that sets in by evening. So this particular gentleman, I stopped the regular insulin and I added Lispro, and what you can see is that if you see the previous reading and look at this reading, what is immediately apparent is that most of the glucose levels have come into range. In fact, the variability is much better than before. You don't even have to look at the time in range to see these values. These values show that the glucose variability has come down, but at the cost of a little bit of hypoglycemia. And this is the beauty of continuous glucose monitor, because it can give you data that directly show you the benefit. Now, we all know that type 1 diabetes shouldn't be treated with premix. But this was a patient who visited our hospital for the first time, and he was on premix insulin and refused to change. And when we put him on a CGM, this was between 10th of July to 24th of July, you can see that the time in range is almost 10%, because the median values are above normal. The normal is between 70 to 180. The intraday variability as given by the median shows a lot of variability. The interday variability as shown by the shaded areas again shows a lot of variability. And this opened his eyes and it allowed us to put him on basal bolus insulin therapy. So you can see that the glucose management indicator is 12.4% and the daily average is 308, and the time in range is really low for this patient. Now this is soon after starting him on basal bolus therapy. You can see that his average glucose was 308 and glucose management indicator was 12.4. 12.4, the GMI has come down to 9.8 and 300 plus has come to 235. This is just in a few weeks, and you can see the median showing better control. It isn't good right now, but what it is that the time in range has certainly improved. But remember, he's injecting glargine U100 at night, and the glargine U100 at night is lasting till about lunchtime, and after that the basal requirement is really going up. So if you go back and see this gentleman, the time in range has improved from 11% to 30%. The time below range has gone up, but not unacceptably, and the time above range has come down. This was his earlier CGM at the Chalaram Diabetes Hospital. And you can see that injecting the glargine at night, U100, means that its effect is tapering off by lunchtime the next day, which means that you've got to inject glargine twice a day if you want to control the blood sugar better, or you have to inject glargine U300, or you have to inject Degludec for better 24-hour control. So this would help him in future. There's nothing wrong with HbA1c, but HbA1c is like a teacher who sees people talking in the class, but really doesn't see the student who's sleeping in the class. So HbA1c is like a teacher who detects hyperglycemia, but never detects hypoglycemia. And you can see that both these patients have the same HbA1c, but the patient on top has got lots of hypoglycemias. Now, this is a paper we published just a few months back, which looked at time in range in people with diabetic retinopathy and without diabetic retinopathy. What you will see that is that the time in range is higher in people without retinopathy and lower in people with retinopathy. The time below range is more or less the same. The time above range is higher in people with diabetic retinopathy, showing you that a low time in range correlated with more diabetic retinopathy. This wasn't statistically significant because of the small sample size, but let me point out is that even with this small sample size of about 37 people, the HbA1c still turned out to be statistically significant. In other words, my belief is that the HbA1c is a stronger determinant of diabetic complications than is time in range. This is not to say that time in range isn't a good marker. It is a good marker. This is just a pilot hypothesis generating study, just to show that time in range is lower in people with retinopathy. We also found that it was difficult to reach time in range targets in people with retinopathy who were more than 65 years old. And when you look at such people who are 65, 70, 75, this is a gentleman, and this is my last few slides, a 75-year-old gentleman who's been on CGM for years now. And you can see that his time in range is very good. You don't even have to look at the time in range. You can see it's almost a straight line, but you can see there is hypoglycemia. His glucose management indicator is 5.6. His daily average is 114. This slide of good glucose control doesn't make me feel very happy at all. In fact, it makes me feel very worried because the time in range on some of the days is 60%, which is okay for this gentleman, but the time below range on some days is 40%. Some days it is even 65%, suggesting that this is a case where if you had not done a CGM, if you had not quantified time in range, if you had not quantified time below range, you would have missed the hypoglycemia because it's quite asymptomatic in this elderly gentleman with long-standing diabetes. And this is a case for de-prescribing and de-intensifying therapy. Technology is not without its problem. I have at least lots of patients on the so-called artificial pancreas 780G, but it's out of reach for most Indians. It's very expensive, the 780G. And second is, as I mentioned, the data of time in range with complications is not there completely to say at best. So I think we need to debate this further. The device is imperfect. There is device failure. There are a lot of alarms, and alarms lead to alarm fatigue. And patients are now complaining that too many alarms is actually distracting them, making them anxious. So you're required to reduce the number of alarms. And all this technology is making us a little glucocentric, making us forget diabetes is a disease of obesity, hypertension, dyslipidemia, cardiovascular disease, good medical management of infections, management of NAFLD, and all that is being drowned in the C of glycemic variability and this attempt to be glucose-centric. Having said that, technology is likely to get better with time, and we are likely to take care of our patients better with time. So CGM helps us to analyze patterns, predict variability, predict hypoglycemia, a timing range of 70% for values between 70 to 80 is a desirable goal. And we might in future get affordably excellent devices which are affordable, at the same time, devices which are excellent. With that hope, let me end my talk and once again thank Dr. Mayur Agrawal for inviting me to speak.
Thank you very much, sir. Thank you for explaining so deeply. And actually, technology we are using for the patient outcome, for the patient betterment, and your explanation justifies that. We have now close to almost 2,500 registration, and we have many questions, but we are already lagging by 30 minutes. So I'll just take two quick questions. First question, Dr. Bansi Saboo, sir, whether from SMBG, how to derive TIR and what is the practicality in today's world? And for Dr. Unnikrishnan, sir, what is your take on this Meow Meow and Glucon? Have you used it, and what's the practical utility? Sir, unmute, sir, please.
So I think the question to me is, I think the first question is to Dr. Banshi. So after that, yes, I'll take my answer.
I'm sorry, actually, I could not listen.
Sir, the question was how to convert the SMBG data into TIR and what is the role in today's time for that? Because CGM is not very well affordable for all our patients.
I agree with you fully, but there is no such data that you can convert your SMBG into time in range, but we call it points in range. This time, I have presented one paper also in ADA that was talking about that can we, using a patient who is doing multiple times continuous, random blood glucose monitoring, more than 20 times in a week, and we consider it that out of 4 or 3, how many times his points are in range between 70 to 180, and we can call it points in range. That was a new terminology which was used for that. Recently, one company is also doing 321. I'm sure you must be using in 3 days, doing 7 times in a day sugar, and in 3 days getting 21 reports. And you are trying to get roughly a graphical picture and then try to show that whether it is coming in a time in range, or again, you can call them as a points in range. That sort of thing can be done. As I already shown my second or third slide only, that many of our type 1 diabetic patients who are doing even 4 times or 5 times in a day sugar also, 3 to 4 times. But still, when we put them on a continuous glucose monitoring, you will find that they are getting actually hypo and hyperglycemia too, that it is not the perfect way of doing it. It's like doing a photography, still photography, and then doing a videography. Like, in between I had started seeing the patient, but you were seeing that I'm actually on the board. So it is a continuous glucose monitoring. If somebody is putting CCTV in my clinic, then you will find that whether I'm on the laptop or whether I'm seeing the patients, or in between, if you are just doing random blood glucose monitoring, you will find me every time on the laptop that you can see that, yes, I am there for 2 hours for your meeting. So that's a significant difference, that whether you are developing hypo and hyperglycemia only by random blood glucose monitoring is not possible. But yes, I still agree that all our patients are not affording. They can't afford. Many of our type 1 diabetes, we do ask them to do multiple times monitoring. We all know that by doing it, roughly you can get that points in range, and still you can have a good control. And that's the reason I always say it is like complementing all 3 monitoring modules for one patient, because they can't afford. This gives you predictability of continuous glucose monitoring of a glycemic variability for 3 months. So you can use it and you can see that how his glucose level is fluctuating, or how it is showing the variability. Accordingly, you can change the diet and pattern and everything.
Okay, I think that gives a good explanation. It's like an Indian jugaad, but cannot be comparable to CGMS.
Yes, but we do it. We all of us, yes, we do it.
Yes, Unnikrishnan sir, your question was on Meow Meow and Glucon.
So, well, as doctors, as you know, Meow Meow and Glucon are not really approved technology, so we can't be advising them. But I have seen patients who are using both Glucon and Meow Meow 2. Now, if you see the Meow Meow 1 versus Meow Meow 2, the Meow Meow 2, for those of you who are completely new to the concept, it's a small piece that you attach to the sensor, which converts the intermittently scanned sensor into a real-time sensor. In fact, yesterday a patient was asking me about it because it is not available online to buy. It has suddenly run out of stock. So what these things do is that instead of it converts an intermittently scanned CGM into a real-time CGM at an affordable cost. It's a Chinese technology, the Meow Meow 2, and it is adopted by Glucon and others, including, I think, a company called Ambrosia.
Yes.
But what I understand, again, these are the whispers that I'm hearing, is that the use of these technologies are going down because, number one, there is a new and better sensor available. And number two, the Abbott's original reader, which was a problem, is now little more available in the market. So that has undercut the use of these add-on devices. There's one more called Ultrahuman, but they have got a tie-up officially with Abbott. So they are still doing reasonably well right now. But yeah, I think Dr. Banshi is showing the Ultrahuman there. I like the name Ultrahuman because it's very interesting. So I think these technologies let us try to stay away from this to the extent possible. But if our patients are using this and if they love to use this technology, let us help the patient use the technology. That is my take on this.
Okay.
In between, they opened the office in Delhi. And if you take from Ambrosia Glucon, you can get it from Delhi also, because otherwise, if you import it from US, you have to pay the import duty. So it costs like 12,000, but again, the import duty will be costing another 12,000. So try to, those who are the doctors and their patients might be asking, try to get it from Delhi office, because they have now India office also, where the cost will be half for them. If they do it from Amazon, it will go to US office directly, and then importing, it will show here only 12,000 rupees in Indian rupees. But once it will come, you have to pay again the import duty for that.
Yes, sir. Few of my patients are using around 14,000 is the cost approximately online from India. So thank you, sir. And thank you all the speakers and all the chairperson for making this session so interesting. And it was really nice to discuss on the CGMS, which is really important in today's time. So we can move on to next session as we are already running late. I welcome Dr. Priyamvada Tyagi.
Thank you, sir.
Thank you, sir.
Thank you, Dr. Thank you all.
Thank you.
So Dr. Priyamvada Tyagi is working as a consultant at Hormone India, Noida. Please introduce chairperson, Dr. Priyamvada.
Hi, good afternoon, everybody. So for this session, I would like to invite the chairpersons, Dr. Ritu Gupta. She's professor and head on medicine department at NSCB Medical College, Jabalpur. We have Dr. Yashasvi with us. She is consultant endocrinologist at Jaipur. For the introducing the first speaker, I would like to invite Dr. Jyoti.
Dr. Ritu Gupta, ma'am, are you there?
Dr. Ritu, ma'am?
Yes, good morning.
Good morning, ma'am. Yes, ma'am, you are audible.
Good morning. It's my pleasure to be a part of this session. I welcome Dr. Jyoti Dev Keshav Dev, sir, who has been so much, he has done his MBBS and MD from Trivandrum, and he is being a chairman of Jyotirdev Diabetes Research Center, Trivandrum. He is the managing trustee of P. Keshav Dev Trust, engaged in charity and literary activities. He had conducted many monthly diabetes education programs through various programs, and he had published a monthly internet-based free diabetes newsletter for the past 13 years. Sir has been a pioneer in the cost-effective treatment of diabetes with the use of telemedicine and technology. JDC is an IDF recognized Center of Excellence in Diabetes Care and Center of Education. So as we are proceeding today, from the start of use of insulin about 100 years back with the development of HbA1c and glycemic variability to CGM, and to achieve, and now our target is to achieve TIR. And with this, we proceed to the use of insulin pump therapy. And over to Sir, Dr. Jyotidev sir, for his talk.
Team, please play the video. Sir is in Sweden, so he could not join live. He sent a recording. Tech team, please play the recording.
Hello, dear friends, and greetings from the city of Trivandrum in Kerala. So let me congratulate our dear friends, Dr. Mayur. Dr. Tony is from my own city in Trivandrum. So anyway, congratulations for the very successful Hormone India convention. And I'm grateful that I am also given an opportunity to be part of this very prestigious educational event. So I am given the task of discussing the evolution of insulin pumps. And this is more or less the discussion of not only the history of evolution, but also on where we are currently exactly positioned. The journey from 1974 to 2022. So these are my disclosures. Our dream has always been a device for automated insulin delivery which is affordable for the government. So patients always used to ask us, do you have something to offer for the government? And now in India, we are fortunate to have our own patients experimenting, re-engineering, using DIY artificial pancreas, some of them even using connected devices. And we do have our own innovations in diabetes technologies. And it all started with the discovery of insulin. In 1922, before insulin was infused, even Leonard Thompson was offered, only the starvation died. And the diagnosis itself used to be a death parent. But when you are going back to the evolution of insulin delivery devices, it was in 1963, Dr. Arnold Kadish came up with this model. And this used to be a very big device, a cumbersome one, but this could be regarded as a prototype of an insulin pump. The 1974 discovery of biostator from Dr. Ernest Frederick, I will consider, is probably the first ever device which gave an idea on automated delivery of insulin. But the results, which were so successful within the hospital, couldn't be replicated in the free living environment. In 1979, from South Korea, Dana pump was launched. Of course, it was not popular in the international market, and hence, in the documentations, including in the chapters and the textbooks that we have written, in the journal articles that we have written, we do have documented Minimed, Medtronic as the first ever insulin pump, and that was the Minimed 502 in 1983. Since this was one of those devices within the DCCT clinical trial, it became so popular. It became so popular with intensive management of diabetes, resulting in substantial reduction in the development of complications. How many of you know that insulin pens were launched after the official launch of insulin pumps? And this is the first insulin pen, the Nova pen. For India, insulin pumps were launched officially only in 2004. And we all started using initially the refurbished pens, and soon, within a year, Medtronic made available the most recent devices. And these are the paradigm insulin pumps that we started using in the year 2004. This slide, I would say, is very important, especially for those students in medicine attending the Hormone India Convention. The stages through which the insulin pumps have advanced from the earlier standalone devices to the stage 1 of automation, and that was a threshold suspend. When insulin will be stopped or the pump will be shut off when there is hypoglycemia. Stage 2 is predictive low glucose suspect. That is when the glucose is going to be low, then the algorithm will decide to automatically stop the delivery of insulin. Stage 3 of automation will be automatically adjusting. So the basal delivery will keep on changing once in every 5 minutes in response to the sensor glucose values. And the stage 4 of automation is where we are currently positioned globally, including in India. So we are very fortunate to have the stage 4 of automation. And that is in addition to basal automation, even the bolus delivery can be partly automated, especially when the glucoses are high or when the glucose is low. And stage 5 is actually our dream. It can be insulin-only devices, or it can be multi-hormonal devices when it is even able to detect the meals automatically deliver both the meal boluses and also the correction boluses, completely eliminating the carb counting, the manual meal bolusing, and so on. That is a dream of future, and that is going to be the completely closed loop system. There are 2 types of insulin pumps. One which is available in India are the tethered insulin pumps, and this is an example of patch insulin pumps. Omnipod is the one currently popular all over the world, but from 2009 onwards, there used to be a solo micro pump. Currently, this is the property of Epigenetics, and soon, maybe in another 6 months to 1 year, we are anticipating the arrival of solo micro pump, and that is probably going to be the first ever patch pump in India. And they are also planning to have this integrated with a continuous glucose monitoring device so as to make it a closed loop system. So from 2010 onwards, we do have in India and for the developing world, the insulin pump guidelines, whom to deploy an insulin pump and whom not to, the indications, the contraindications, and so on. However, the technology is now rapidly transforming. It is transitioning. And we do have the closed loop system. So what is a closed loop system? So in a closed loop system, in addition to the insulin pump, which is delivering continuous subcutaneous insulin continuously, and in addition to an advanced continuous glucose monitoring device, because CGM is also progressing, and now we have the generation 7 of most of the CGM devices. There is a very sophisticated control algorithm. And the control algorithm has resulted in automation. So 640G used to be the most popular first-gen artificial pancreas for the last 7 years. And then you have the 670G, which is a hybrid closed-loop system with automated basal delivery, which was not available in India. And this is the Diabloop hybrid closed-loop system, 2018 innovation, especially in Europe. So if you are an interested doctor or an interested medical student who would like to go through the progression or evolution of insulin delivery devices, I would request you to go through one of the reviews that we have published in the year 2020, starting with the use of Arnold Kaddish, the insulin pump that I have shown in the beginning, culminating in 2019 with 780G, and then in 2018 with Omnipod Dash, Tandem Control IQ in 2020. So this is the Omnipod Dash, and that is in 2019. And then you have the advanced hybrid closed-loop system, that is the AHCL. And I would say that this has been one of the dreams come true for everyone in India, because we never thought that 780G will arrive in India that very soon. And there are probably more than 500 subjects now using 780G in India. This automatically adjusts both basal and also bolus once in every 5 minutes. So in case you forget to bolus before a meal, this is the only device currently officially available in India which can even automatically bolus. And these are the devices promising, with the help of these algorithms, time in range which is almost close to even 85 or 90%. So there are 3 different types of algorithms. The PID, that is proportional integral derivative. MPSC stands for model predictive control, and the fuzzy logic, which is especially useful in the wake of automated bolus delivery. So at the click of a button over here, and this is a home screen, you can even display the percentage time in range between 70 and 180 milligrams per deciliter. And this is even without downloading the data from the pump. And the same is visible in the screen in the mobile phone, which can again be shared with multiple other partners, including the family members. And this is a recent study which has been published in Lancet Diabetes and Endocrinology, and this is the adaptive study with 780G advanced hybrid closed-loop therapy in contrast to the conventional management in type 1 diabetes using the insulin pumps and intermittently scanned continuous glucose monitoring device. And these are the same results that we are also obtaining in our clinical practice with the help of 780G and the advanced hybrid closed-loop algorithm. This is the reduction which is expected and realistically happening in the real world. 1.54% reduction in the hemoglobin A1C. And in many patients with uncontrolled diabetes with a hemoglobin A1C of 11 or 12, it can even be a reduction up to 3 to 4%. And this is 0.2% reduction in the other group. So this is quite obvious that this is going to be, and this is the innovation which has resulted in a rapid transformation in the management, especially of type 1 diabetes. And no wonder, this is a celebrity film actor and the ex-member of parliament gifting a 780G to a person with multiple episodes and hospitalizations due to diabetic ketoacidosis from Kerala. And this is the same person with type 1 diabetes. You can look at the video over here. And within 3 weeks of deployment, this is the time in range, 100% time in range. And this is our own team. And these are the members of the team. And look at the comments made by the parents and the patients with type 1 diabetes. I cannot believe that this is an insulin pump. Call it only by the name 780G, because this is not an insulin pump. Insulin pump used to be the standalone devices. And this is a device which has resulted in a rapid transformation. Many patients have commented that this is the first time ever since the diagnosis of diabetes that they are having a peaceful sleep at night. And this is worth the cost. But my worry is, this is another parent. The TAR always used to be around 50% with standalone insulin pumps and continuous glucose monitoring. But with 780G, it is always between 85% and 100%. This is beyond the expectations. And this is, I would say, even beyond the current recommendations. The device is worth the cost, but the only worry is how many people can afford it, because it is so expensive. It is so expensive. So these are some of the solutions. Of course, these are not approved by any scientific organization or by any government. This is do-it-yourself artificial pancreas. So if you are interested in how you can support your patients, please go through this very, very detailed review on the classification, on the available devices, on how to use the Riley link, how to establish a communication between the pump, the continuous glucose monitoring devices, the re-engineering, the already available devices, downloading the algorithms from open source and so on. No wonder our review on DIY artificial pancreas, though it is not approved, is referred to by the ADA, the EAST, and even the 2022 American Diabetes Association practice guidelines. And please remember, the reason why this unapproved DIY is referred to by the American Diabetes Association, we cannot discourage our patients from using this. And if in case we need to troubleshoot, we need to have some knowledge, know-how on how to use it, so that we can assist and be a support to those patients using this. And this is Jasethi. Jasethi, the first user of do-it-yourself artificial pancreas, and has demonstrated, documented 100% time in range with the use of devices. So we from India, we are also having our own solutions on cost-effective use of technologies in diabetes. But the take-home point is, whoever is eligible, whoever is affordable, or whoever it is going to be a life-saving device, please initiate at least a conversation with your person, because they will find some way of using it. Because ultimately, these devices are going to be life-saving. So thank you very much, dear friends, for giving me this opportunity, and I wish the convention every success. And unfortunately, I couldn't join physically since I am traveling currently.
Thank you, sir, for this session, and thank you, Dr. Ritu Gupta ma'am, for chairing this session. For the next talk, we have Dr. Saurabh Mishra, sir. He will talk about practical aspect of insulin pump adjustment. I would like to request Dr. Aparna Soni ma'am to introduce Dr. Saurabh. Dr. Aparna, ma'am, are you there?
Dr. Priyanka, you can go ahead. You can go ahead and introduce.
Okay, so we have Dr. Saurabh Mishra. He is emergency in charge at Regency Hospital in Kanpur. He's consultant physician and diabetologist in Unnao. He has several national and international papers to his name and has multiple presentations at international conferences. I would like to welcome Dr. Saurabh Mishra for his talk.
Kindly unmute. Dr. Saurabh, yes.
Yeah. So thank you, Dr. Mayur, Dr. Ajay, for this wonderful insight through the platform of Hormone India. And I think so it is it will not be unless that you both will rise the same type of with the physical presentations also. So thanks for the first virtual presentation, and you have invited me to talk upon insulin pump therapy. As after Dr. Jyoti Dev very nicely enumerated the evolution of insulin pump. At present in India, we stand at the same. So just not taking much time, as my slides may take some time, we can start. So, are my slides visible?
Yes, they are visible and you are well audible.
Okay. So the topic allotted to me today was practical aspect of insulin pump adjustments. Till now, we were listening about parts, pieces, aspects, how it looks, what were the guidelines, but real insight. I think so Dr. Mayur thought, let it be a practical one. So practical never will be a theoretical one. There will be calculations. Assumptions can never be a part of practical system to get through. So I think so if all my colleagues, they may just cope and excuse me if some calculations are misjudged, and they can ask the questions in last. So the objective of today's talk will be, in this presentation, you will get an important information on how to start a patient on insulin pump therapy. At the end of this presentation, you will know the initial setting needed for pump to start, methods and formulas to calculate initial pump settings, and you can also gain first experience by calculating initial pump settings, for example, which I have said. Moving forward, pump specifically has to be understood by these few things, that is total daily dose, total daily basal dose, basal rate per hour, then total daily bolus dose, which will be also having two important components in action. We always use it when we are giving MDI or people keeping on insulin. So insulin sensitivity factor, we all know. Insulin to carb ratio, we all know. But what about pump? What settings will be changed when we will be converting our friend from MDI to insulin pump therapy? Time active insulin and blood glucose target in range. These are some specific points. So to start with, pump in total dose, pump total daily dose. What it is comprising of? It is comprising of total daily basal dose and total daily bolus dose. Now, this bolus will be in turn will be calculated by help of insulin sensitivity factor and insulin carbohydrate ratio. So total daily dose of insulin which will be required will be comprising of basal plus bolus both. So how to calculate it? I think so. We all understand the basal. Basal is the insulin which is secreted all throughout the day. And for bolus, we have to see what breakfast, lunch, and dinner is being served in terms of carbohydrate calculation. And accordingly, the bolus correction and bolus is delivered. So how to start with? At least we should know when we are delivering, we are transferring patient from MDI. It is important that he knows the use of insulin. It is sometime that we are transitioning people direct on insulin pump. When we are transiting people direct on insulin pump, there the facility must be having a backup support with a diabetic educator, insulin pump educator, a proper qualified team which can take look over the sudden hypos or hypers and the anxious nature of people. So this technology should be handed over to those people who are having realistic approach. While starting the dose, we have to reduce the dose by 10 to 30%. What I do in practical is I reduce by 20%. Suppose a person is taking 15 units in MDI, I reduce by 20 units and start with 40, and then further we go on calculating. So the total daily dose can also be calculated by the formula. The injection dose multiplied by 0.7 to 0.9. That may be ranging for indifference with expressive people having hypoglycemia or not. Then weight dose can also be generated for people whom we don't have exact value, how much MDI they are using. We can simply multiply by 0.5 and into the kgs. So the daily dose may be calculated. Now, this daily dose, which is comprising of basal dose and bolus dose, specifically has to be calculated very properly. So it has to be managed in two ways: basal dose and bolus dose. The basal will be comprising of 40 to 50% of the total daily dose, and rest of them will be the bolus one. So the calculations are to be calculated. Total daily basal will be multiplied. The pump total daily dose will be multiplied by 0.4 or 0.5. It will be total daily basal, and the rest of it, that is total daily dose minus by total daily basal, will be the bolus one. Now, basal rate specifically, basal rate can be programmed to increase or decrease at the different time during the day to match the patient's diurnal variations. And mind you, it can be adjusted every 30 minutes. So can you imagine 48 basal rates can be managed with this insulin pump? So definitely this insulin pump technology is going to mimic the natural which Dr. Jyoti Dev sir was calling. The future is of bionic pancreas, where glucagon and insulin, both reservoirs are being used. And at a time, the things can be completely automated. Now, purpose for basal insulin rate are given to match and cover endogenous hepatic glucose production. The goal was to maintain glycemic stability during the fasting states, during sleep, and between meals. An advantage for this basal rate allows lifestyle flexibility, sleep late, eat late, skip meal, and then still managing the glycemic controls. So this is the beautiful nature of basal. Now, basal specifically, what were the researchers tell? In 2005, it was published that approximately it is possible to meet the basal insulin requirement with single rate or multiple basal rates. So it is approximately 5 basal rates. I always suggest to be sometime when there is a hypoglycemia due to exercise, sometimes dawn phenomena, sometimes you are late in night, your supper is not being served, or you are late in night awakening. There the flexibility of basal rate reduction can be there to prevent hypoglycemia. Now we have new pumps, specifically this 740G. It is automatically calculating, and these all insulin sensitivity factor, carbohydrate ratio, these are automatically corrected, but you have to feed on the first time. So this mandatory calculation of carbohydrate ratio cannot be skipped whatever model pump is being used. These are two basic elements which we should explain to our friends in a practical approach which we are learning today. The number of carb grams or exchange covered by 1 unit of insulin required is known as insulin to carb ratio. We all know the definitions. How to calculate in respect to pump? We have to multiply it by 1.2. Suppose 1 unit of insulin is managing 10 carbohydrates. So you have to multiply it by 1.2. And when we are starting pump setting, it will be 12. So 1 unit of insulin will be managing 12. So definitely, if you don't have your predicted ICR values in MDI, you can directly go with the formula 500 divided by total pump daily dose. So you can get insulin carbohydrate ratio. Now we will talk about insulin sensitivity factor. These are some small brushing ups which, because it has to be taught in practical aspect to the person who is using pump. If it is not done, the exemption can never be exempted and we cannot get the exact values in automatic pumps also. So pre-pump insulin sensitivity factor divided by the multiplied by the same 1.2, you will get the pump sensitivity factor, insulin sensitivity factor. Or if it is not available in MDI, then the same formula, we will divide 1800 by the total daily dose and we can get the insulin sensitivity factor. Now the important thing is these guidelines for setting the target range, specifically target rate setting guidelines. Normal awareness 90 to 100, then hypo who have hypos unawareness 100 to 120, and nighttime 110 to 130. In pregnancy, if you are using insulin pump, 80 to 90 and 90 to 90 mg per dl. So definitely the targets have to be set and accordingly bolus wizards can be used. Bolus wizards are automated systems which are available on the advanced pumps, which use the AI intelligence and algorithm to manage the hypos and hypers as so. If you miss one bolus also, the same way algorithm design will try to judge and will inject the insulin. Now above range, according to the above range, if suppose the value is 160, so the correction will be 1.3, which has to be given for managing this. And below ranges, then you have to suppose it is 70, then 0.4 units can be subtracted from the meal bolus. The same way, if blood glucose goes down, you have to manage the hypoglycemia very sincerely. And you should not replace it by any type of other carbohydrate, only manage it by glucose. Now it is very important from over here if you want to understand the practical guidelines. So I have used a patient system to demonstrate the dose calculation and initiation. Asha is a patient, she is 14-year-old female, type 1 diabetic, HbA1c 8.2. With frequent hypoglycemia, she is currently using insulin rapid acting, that is 646, breakfast, lunch, dinner, and morning amylin non-acting insulin. Total insulin consumption is 30 units. So her insulin sensitivity factor will be 1:30 and her carb ratio will be 1:20. And when we will put it into the formula, now each and every person who is listening, a beginner or something, or any person can take the snapshot of this slide so that you can use these. These are the only calculations in insulin or insulin pump therapy all throughout the world. So in pump, daily doses can be calculated. I think so some fonts are overlapped, but if you put the exact values, you can see by weight the total daily dose comes to be 22.5, and with this it is 24 for Asha. Then when we go for total daily basal rate, it is 9.2 on the formula. Then we go with the specifically total daily boluses. It definitely, when we are going to divide 13.8 for further 3 times, we can specifically rotate with 3 meals, how we can adjust. Then carb, specifically insulin to carb ratio was calculated, and that also is similar from the both formula. And the same way insulin sensitivity factor, if it is available for the pre, then you can go with specific. If not, then you can calculate by dividing from 1800. So these were some formulas, but now from the important things. Role of physician, what is our role? To insulin dose adjustment, basal rate testing, bolus type guidance, correction formulas, carb factor calculation, avoiding overcorrection by hyper and hypos, pump and exercise have to be explained, pump and sickness have to be explained, cannula site examination has to be done. Basal basic 3 things which we should look in pump is basal review, bolus history, and priming history of that person. 5 principles to be remembered for successful people. Every meal to bolus has to be corrected. Choose right bolus type. Keep 3 hours or more gap between boluses. Avoid frequent correction and thus insulin taking. And treat hypoglycemia only by glucose. Don't supplement any type of diet and don't suggest anything because type 1 people have to be managed very nicely. Then patient follow 5 rule of success. 72 hours the cannula should be changed. Don't use more than that. Rotate cannula sites. SMPG has to be done. And each meal has to be covered by carb calculations. Never suspend pump for more than 1 hour. With this, as time is always a limitation, but science has to flow forward. Napo to jano, shakkar se zyada meethi hai zindagi. Check to know life. Thank you.
Thank you, Dr. Mishra, for this excellent talk. I think practical aspects are something that we all need. So thank you for this wonderful session. Now we shall move on to the next talk for the day. This talk is by Dr. Archana Sarda on type 1 diabetes insulin pump case-based discussion. I would like to request Dr. Ritu ma'am to introduce the speaker. Dr. Ritu Gupta ma'am, kindly chair the session and introduce the speaker.
It's my privilege to introduce Dr. Archana Sarda Madam. She is Director, Sarda Center for Diabetes and Self-Care, Aurangabad. She is founder of UDAN, an NGO for the underprivileged children with diabetes. She is convener for National RSSTI TI1 Task Force. She has been working on 20 years for innovative diabetes care in rural areas. She is being a co-author for ISPAG guidelines in the limited resource settings 2022. Over to Archana Sarda ma'am.
So this is a recorded session. I would request to please start the session.
Hello, everyone. We have been going through a very, very interesting session on insulin pumps. We have seen the whole journey of how pumps were evolving over time. We have seen all the practical usage of how to actually use a pump, how to effectively use it for dose titration, perfect dosing, etc. Now, I am going to take you in the next 15 minutes, just a few interesting cases of people with type 1 diabetes who are using pumps. Now, this case-based thought that we are having, that we are going to talk about, is just 1 second, please. Yes, I chose these cases because we are very enthusiastic about using the pumps. It's a lot of technology. We have seen the way we can solve issues, and that enthusiasm sometimes becomes misplaced, either because of our misjudgment or the way the patient is wired and their family. So it is an individualization, which I want to emphasize, and very strange kind of scenarios can be created, which are the cases that I am going to highlight today. So one size does not fit all, and that is very, very important. I have so many children and families with type 1 diabetes, and seeing all the social media posts, seeing a lot of science, reading, all of them for them, especially from the lower socioeconomic areas, it has become an aspiration. It has just become something very, very cool to have. And unless and until it goes beyond that, it will probably not be the right thing to have. And unfortunately, I also see in this part of the region where the prescribing doctor is not also very sure who is the right candidate or how to prime a person to go on to a pump. And so these are the few cases that I want to showcase both the sides of it, a good use as well as not so good use, simply for the purpose of practical learning as we go into the journey of the insulin pump. And this is specifically for people who are not well versed with it, who are not using it every day in their clinics. Those who are experts are already very well versed with the various aspects of pump care. So my first case is Farzana, and Farzana came to us with she's a 12-year-old girl. Her parents have big businesses. Money is not an issue. She was started with us. She came with a very high HbA1c, and she was started on the MDI basal bolus therapy. She was enrolled for structured education. But from day one, the attitude of the parents were, we don't want pricks for my daughter. Oh, my daughter's fine skin. She's so fair. Her skin is so, all that kind of aspect. There was very little focus on her growth, health, future. And we kept on trying to bring it back to them with our entire team, with all the experience we had, but we found us failing because the entire focus was that, why is my daughter getting pricked? And when we enrolled them for the education part, the response was not very good. They were very upset with us. They did not like us. And in the third visit, which is like within a month of their being 1.5 months of being detected, the patient, the family, the parents, they came back with the child already on a pump. And they had found out, we have the whole internet, they found the company person, they bought the pump outright, they got it installed, and it was being titrated or something. Some support was being given by the company person. Now we said, okay, this is done. Let us now, educate you regarding how we use the pump. But the parents were very busy. They had big businesses. Both the parents were traveling all the time, and they felt now their daughter is safe. She is on a pump. They were not interested in the fuss that we were creating about how do we adjust the doses, how do we eat, all the other aspects. Were not interested. They felt we were very fussy about everything. They were just happy that there are less injections. 6 months later, we met her again. And because obviously they were not very happy with us, so they're not coming to us. And HbA1c was still 11.5. So my point here is the pump is definitely smart, but we always think of a person with the pump is smarter. To use a smart pump, we need a smart person, and definitely a person who is using its smartness for the right reason. So with all the money and education and availability and support, yet Farzana even today is not doing well. Now it's almost a year, and I do not know whether it's our counseling skills or what, but so far they are not motivated to use the pump effectively with the magic that it can do. It is not being used. We have Shaurya. The second case I would like to talk about is Shaurya. Shaurya's parents are school teachers, and they live in a very semi-urban town near Aurangabad. Shaurya is 5-year-old, and they shifted the child to their own school once she had type 1 diabetes. They spent 3 months with us, attending every class, the online classes, the physical classes, the one-on-one training. And once they realized the kind of care she needed, they actually pulled in, took money out of her, advance out of the Provident Fund, and they bought a pump and a CGMS. They learned the details. So these are not really very rich people. They work in small schools in a semi-urban town in Marathwada, but they prioritize the care they wanted to give their child and realize that she has a whole, 2 decades growing up, and that is a time that she needs perfect control. Her puberty has to set in. So all those things, they appreciated that. They learned the nitty-gritties of carb counting, dose adjustment, and the optimal use of pump. They keep reading, they keep asking questions, we keep referring them to anything new that we have, we keep sending them links. Now she maintains a beautiful HbA1c. She is 10 years old now, and she knows her pump very well. She is a sprinter. She takes part in every possible sports activity in the school. She's into athletics, and also we keep teasing her that she's really good at maths. So she is really ready to move on to the next model. She comes up with new things all the time, and I see the potential in her that we're going to talk about the DIY things and all kinds of things. She has questions, answers, and she finds a lot of creative ways, and she sees those numbers as a challenge, like a maths problem, and she is doing well. So this is another way in the same scenario, but with a lot of insight into why they are on a pump, and that is what made a difference. So money is not a limiting factor, is what I learned here. It is the attitude. Those parents, Farzana's parents, had a lot of money, but their attitude was simply to use the pump as a way of limiting the prick, the number of injections that their daughter had. They were not willing to understand what the child needs, and hence invest time at all. I mean, not even when we were trying to handhold them on the phone, we said, we'll do online classes for you, but nothing. They just did not want to do that. So they were in a phase of denial. Hopefully they will learn before it's too late. And on the other hand, Shaurya's parents, maybe being school teachers, help, but they actually pooled all their resources, and they are trying to bring up a daughter who is very self-reliant, capable of taking care of herself. So attitude really matters. Every person who can afford should be on a pump. Would not work without all these little factors. Another very interesting case that I would like to highlight in insulin pump users that I had seen recently is Asha. Asha says she wanted a baby, right? She's 29 years old. She's living with type 1 diabetes for 7 years. She had type 1 diabetes a year after she got married. So she was an adult. She got married at the age of 22, and that is when she had type 1 diabetes. Her husband took reasonably good care of her. And why am I emphasizing this? This is what we learned in history, that even throughout the time, it was the husband who took care of her. So she always used to say that my husband took good care of me. She was on MDI, basal bolus insulin, but we saw her past record and the HbA1c was never below 8, but they were sort of satisfied that life was okay. Till she became pregnant, and he was working, he could not handhold her throughout, they could not manage the diabetes and probably other thing, and they lost the baby. Again, she became pregnant. We do not have a record of what happened, what the doctor said, was she counseled, but from whatever I could understand from talking to her, because there was no paper record, but some sort of counseling was done, specifically saying that your blood sugar levels should be controlled. That was the only thing that they knew, but how was another thing by itself. So she became pregnant again, and then she was told by the gynecologist, your sugar has to be very well controlled. So they went to a doctor, and the doctor said that one way of controlling the blood sugar levels very well is an insulin pump. Now she went on to the insulin pump. The husband is not that rich, but yes, for a baby and not wanting to lose another baby, he actually invested on the pump, but he did not have time to handhold her with the pump. Right? So he gave her the pump, and she was on the insulin pump, being treated, some doses adjusted by the people who gave her the pump, but they did not have a proper pump training. Nobody was really there to know what to do with it except deliver the insulin, which was initially being delivered by a device or a syringe, and that was done by the pump. So not much really happened, and she again lost her baby with haywire sugars. And this was so sad, and this is what we came to know when she came to us. When she came to us, she was again pregnant 6 weeks. For some reason, planned pregnancies, good control was just not happening. I'm sure the doctors had guided her, but she could not follow that. Then we realized when they came to us that the couple had very, very little knowledge of diabetes self-management, and the husband was smart, but he was very busy. They're young, they had a business to do, and he was now frustrated that his wife is not able to bear a healthy baby. He kept on saying that because of her diabetes, she's not able to have a baby. But then we showed her so many other girls around us who have had healthy and happy pregnancies in type 1 diabetes, and that sort of gave him hope. And then after talking to Asha, we realized that her IQ was actually low. She was not being careless, because the husband kept on blaming her. She doesn't do this, she doesn't do that. I bought her a pump and she doesn't manage. She does not check enough. She doesn't adjust her doses. But after talking to her, we realized it is not about not wanting to do. She was wanting to do. She did make an attempt, but her basic IQ was low. She was not capable. I mean, we did all kinds of testing with her, and we realized that she could not interpret or take an action to the readings that she saw. While she could actually see them, but she did not have the intelligence to interpret and take an action. So we continued her on her pump, added flash monitoring because she was on a basic pump, and then gave her a 24/7 helpline support. So with that, every day, I mean, literally till the baby was in her arms, and of course after that as well, she and our diabetes educator were 24/7. It became a joke with us that there was umbilical cord between the three of them, not just the two of them. And it was a 24/7 kind of support because there was absolutely no way. So she could just send snapshots, and that is how she was being taken care of. Snapshots of her meals, snapshots of her flash monitoring screen, all that happened, and she delivered a healthy baby girl. But post-delivery, for another month, we continued same way, but later on, then we shifted her back to MDI because this kind of 24/7 hand-holding would not be practical. She was not at all able to handle the pump on her own. She does her basic care. She has been given warning signs of the minimum and maximum, and weekly she reviews with a diabetes educator online, and she is doing very well and very happy with her daughter growing up very happily. So my take, why did I share this case? That a prescription is not enough, right? So we as physicians, as clinicians, as diabetologists, somewhere we get very excited with technology and we want to see this as a solution. We want our patients very well controlled, but prescribing an insulin pump gives the patient hope and they would buy it, invest it, but that's just not enough. So in part of the country where I live, there are very few training centers. There are very few people who would assess, then prescribe, and then handhold them till they are trained, and then what happens. So that whole process is very important. And like we said, Asha, she just could not have handled it. So it's very, very crucial that pump be used in the right person at the right time, as that is again a point to that effect. One of the cases that I would like to share is Anil. Anil came to us with total desperation. He said, this is the worst disease ever. Nothing in the world can control me. And he was not even interested in listening to us because he said, I've been to so many doctors. This is hopeless. Somebody caught hold of him and brought him here. He's 38 years old, has IBS and had a very, very rapid gastric emptying. He was being treated by the gastroenterologist for that. Repeated hospitalizations with severe hypoglycemia, which had really made his life horrible, which you can all imagine. And he also has hypoglycemic unawareness with 25 years of type 1 diabetes. And of course, repeated hypoglycemias had made him totally unaware. So he would go into a very, very, very low sugar and just collapse and then go to the hospital. So his life was totally in and out of hospital for last many years. He lives in a small town and he went to various places, big town, showing doctors. Everywhere the focus was on his stomach, quote unquote stomach. So everyone sent him to different gastroenterologists. All investigations were done, but everything was done in track with his IBS rather than any aspect of control on diabetes. So whatever was talked to him about diabetes was take care of your diabetes, take care of your diabetes. But he was not he was clueless that what can he do when he is in such a situation. So first we went one step and put him on continuous monitoring, and then later on to the insulin pump. He was initially very hesitant, but when he did continuous monitoring, then he realized, strangely, I mean, I'm very sad, but strangely, maybe 5 years back, it was not such a big thing, but he was not advised that he could be on continuous monitoring. And then he was on Cgns, and then he realized what it can do, that he can actually see his sugars, he can take some action, but yet hypos were occurring, and because he could not take appropriate action, and then we asked him to do an insulin pump trial. So, and he, with his insulin pump and continuous monitoring, he is now 3 years. He had one hospitalization. Of course, he still had hypoglycemias. There still episodes happen, and he's able to, but two severe hypoglycemias, one hospitalization in 3 years. His quality of life has become amazing. I mean, that man who never went anywhere, had no social life, would not smile, that person is a transformed person right now. And now with the new pumps coming in, with the whole connectivity and the algorithms, and so he is now very willing to explore the latest in technology, and now he knows much more than I do about pumps and CGMS and technology, because he reaches out, learns the latest, finds out, and he knows what he wants, and he wants to perfect his own diabetes care to suit other ailments. So this is one very specific case which made me want to present this, that special people need special solutions. So there are so many reasons we prescribe a pump. This is probably one of the beautiful outcomes I saw, because it was not just a control, but it is an entire quality of life of that person changing because they went into the insulin pump therapy. The last case I would like to share is, I've called a doctor and a patient, because Geeta is 42 years old and has had type 1 diabetes for 22 years. She herself is a physician and managed very well on MDI till now, and was not interested in the pump. Whenever we talked, we had an interaction, she would say that, no, I am so good. I know my body. I know how to do all those things, and I know the calculations. And why do I want to invest in a pump? And it's just one fancy gadget. There's no value addition. When I'm not getting nocturnal hypoglycemias, why do I need that? So all the way she was very not keen on the pump, and and we also did not insist because she actually did take good care of herself. But then, because she was married to a physician, both of them decided to start a new hospital. Then their work hours really got crazy. Getting good control and especially not getting hypoglycemias became more and more difficult with time, with the construction, with the patient, with the ICU, admin. We all know what happens. And but for a very long time, she was resistant because for her, she felt very capable. She said, I don't need a pump. And she was not very, she felt that using a pump is like, I need help. And that was another very interesting attitude I saw in her. And I don't need help. I can do this myself. But then we convinced her to do a trial. And today she's a hardcore fan. She swears that her efficiency has actually doubled. She loves the way she manages herself. She loves the way how carefree she is, how the same inputs that she had, the same knowledge that she has, gives her such better results with a better quality of life and efficiency. And she often wonders, whenever she meets me, she always says, why didn't I do this before? Why didn't I listen to earlier? And she probably looks out for all her patients who can be on a pump, and she would be happy to prescribe. So a little nudge can often go a long way. There are different reasons for people wanting to go on a pump. There are different reasons they should go on a pump. And there are different reasons why people resist going on a pump. So short of always talking about not having adequate money, which is not the only limiting factor. There are so many aspects where even in lack of money, it would make sense. For example, that person with IBS, I mean, the number of hospitalizations that person had gone through, that Anil had gone through, is crazy. The amount of money he would have spent on hospitalization is just unbelievable. So that pump was nothing as compared to that. So it's a very relative amount. So these were a few cases that I wish to talk about. And my message here would be that every person with type 1 diabetes should be aware of the pump. It's a very, very individualized approach, a capability of a person, not just financially, but mentally, emotionally, socially, and especially the willingness to take part in the process of learning and implementing, taking actions, without which it would not really have the impact that we are wanting to have in our patients. And there are so many special situations. And there are some situations where nothing is a problem, but it just takes you one notch better and gives you a better quality of life. And with this, I would like to say thank you, and let us all use pumps effectively and not deprive a person where needed. Thank you so much.
Thank you, ma'am, for this wonderful talk. Thank you, Dr. Ritu Gupta, ma'am, for kindly agreeing to chair the session. So now coming to the last talk in today's this segment is by Dr. Santosh Chaube. He will be talking on DIY pumps. For introducing him, I would like to kindly invite Dr. Ajay Shukla.
Thank you, Dr. Priyamvada. Dr. Santosh Chaube is senior endocrinologist right now based in Australia, Cairns, and he's senior staff specialist in oncology department of endocrine and diabetes, division of medicine, Cairns and Hinterland Hospital and Health Services. I welcome Dr. Santosh Chaube. You can go ahead, sir. Dr. Santosh Chaube, sir.
Thank you. Thank you, Ajay. Good to see you.
Yeah, thank you, sir.
And thanks, Mayur and Tony, for organizing such a wonderful conference, which is, I can't believe that you guys managed to pull it through like such a big and, wonderful program. It was fantastic to hear all the speakers, starting from Dr. Jyoti Dev to who discussed about, the pump. And I am aware that he has been working on this population for long and quite extensive experience he has. You need to excuse me for this technical issue, because sometimes this screen sharing does create a bit problem with my laptop. I don't know how. If that happens, then may I request Dr. Mayur to help me? I did send him.
Yes, sir. Yes, sir. We have started.
Because it happens before, so I thought I will probably be better asking help. So we can still be the first slide. First slide is fine. First slide is fine. The introduction, first one. Yeah. So before I speak anything here, what I would like to say, I did my my MD in Lucknow, KGMC, which is my city now, and then I came to Australia and did again basic training and advanced training, endocrinology, etc. And in 2008, when I joined, my first year training in endocrinology, we had 250 patients on pump at that time, which is not a lot actually. Looking at the uses of pump in Australia, and when I went back, it was such a difficult task even to enroll one patient because of not only financial issue but also the awareness. And I'm very happy to see that this is now being taken care of and more people are aware about this pump. And as Dr. Shada just mentioned, that the indirect cost of not using pump is probably higher than the cost of using pump, especially with the closed loop system. It is going to help people gaining years. Now, the pump here is mostly being taken care by diabetes educators and the registered, there are diabetes nurse practitioners type of model. So we see the patients once in 6 months or so, if they are on pump, because we have to just look into the complication part, because you don't want to, of course, you don't want to be just glucocentric. So you want to look at the complication part and the, other stuff. And the people like the nurse practitioners, the psychologists, the podiatrists, the educators, they're all working in the team. So in spite of all that, I see every week there's someone who's coming to the emergency department having pump, but is still coming with decay because of the cannula issues or the sensor they didn't change, and other factors which is more personal related factors rather than the pump related factors, alcohol, drugs, etc., etc. The people who have been using pump, the NDSS here provides the support, so they don't have to pay anything for the consumables, but for the pump, they have to be on private health insurance, which is, around 50% of patients do have that. So I'm not using DIY pump here, but Ajay asked me to, discuss about DIY. I think the important thing from here, from our side, is that what is the status of DIY and what we need to know as a doctor, because we are not going to program and help our patient programming DIY. It is useful if you see, means you can't, as a clinician, you won't be recommended that, you won't be recommending this, because there will be medical legal issue if you say so. And in fact, if you are seeing a patient who is using DIY, you will be looking at, of course, all the clinical issues and trying to help your patient. But at the same time, at least here, it's legally important that you warn your patient that this is something which has not been studied well, and probably uses may involve some risk. Having said that, I have a doctor working with me at the moment who has type 1 diabetes, and she's using DIY as well. So there are people who have their choices and they do it. So the question is why we want to use that, because before the 780G, which is now there, and the other pump which we are started using a lot here now is the T-Slim. I don't think T-Slim pump is available in India, but here around 20% patients are on T-Slim because that has control IQ. And 80% are still Medtronic. Medtronic has captured the bigger market, and they have been traditionally being the big boss here. So the patients who have been using loop, they have been using it because, or their parents or carers, because they want to avoid the most important thing is avoiding hypoglycemia, at the same time managing hyperglycemia, and probably, trying to achieve the better quality of life. Next slide, please, if you can. So the question is that how it is done. So before we go that, I already mentioned that it is not FDA or other drug regulatory authorities approved. So we have to be careful. The patient really has to have the tech-friendly status. So they have to be very good in technology. So they have to be good in like the patients of Dr. Sharda, who was pregnant third time, she lacked the basic understanding. So those are sort of diabetes per se. And if you look at the number, like if you look at the number of people who has IQ less than 85, there are 15% people, 15, a lot of voters. So 15% people doesn't have the IQ more than 85. Now, if you use, suppose, pump in that 100 people, that there will be quite a few people who will not understand, how to run it through. The same time for DIY, again, one has to have the very good understanding, probably normal or more than normal IQ. And also they have to have the dedication, the focus to deal with that. It is not very cheap as well. It doesn't, DIY doesn't mean that it's going to be very, pocket-friendly affair. There has been good or bad stories which we have encountered, and but yes, it is still in use and probably will remain in use for long. Next slide, please. Next one. So what we need here, the basic stuff which you need is, you need CGM, because for pump to have listen to something, of course, it needs something to get the sugar monitoring done, because pump is not going to monitor the blood sugar itself. And to have a discussion between CGM and your pump, one need to have the computing hardwares, which includes, there are like, like Dr. Jyoti mentioned, the Riley Link device, which is a single board computer, or even the iPhone or Android smartphones. They all have capacities. With different pumps, it's very complex, but with different pumps, there are different gadgets which are friendly and can be used. Next slide, please. So this is a picture. Actually, I took it from the publication, in which the patient, of course, was a part of the publication. This is his picture, in which, as you can see, the first on top left-hand side corner, there's a CGM device, which is Freestyle Libre, followed by, you see a phone. So data is being transferred from there to the iPhone via Bluetooth. And then there is an algorithm which is being used by the app in the phone. And that data is being processed through Riley Link or the cloud-based system. So if you have the cloud-based system, so there's a Night Scout, which can work in the same way. And then it is being transferred to the pump to adjust the boluses and the basal. So that is basically the snapshot. So the patient has to carry these four things with the pump, of course, the CGM, as well as a phone, plus minus a Riley Link or some other single processor unit. Next, please. Now, the compatible pumps, which are there, the Dana R and Dana RS, it's a pretty old pump. It was designed by a Korean endocrinologist. And, it's good to see that, because I know that Ajay himself has a lot of interest in technology, I think. So he may be the next pump designer for India. Anyway, let's see. And then Roche and the old Medtronic and Omnipod. So these are the pumps. Like Omnipod, of course, is the only patch pump. as we know, which is available. This has been available in US for a long time, but recently came to Australia as well. So we are trying to get some more experience with Omnipod. It is yet not available with the closed loop system, but I hope it will come soon. The CGM system which are compatible, which people use in DIY are Dexcom, which is now G6, as we know, and Medtronic, of course, the Medtronic Enlight and the Freestyle Libre and Mayo and Guardian and all these things, they have been compatible to be used by as a CGM system in DIY. Next, please. So there are only two systems for synchronization. I mentioned the cloud-based, the Night Scout and Mayo. Next, please. And the interface devices means the hardware. I think we discussed about that. The hardware can be a small computer or your Android or iPhone. And next one. So if you talk about interface devices, there has been now the Apple smartwatch and the Pebble smartwatch. People are using that. For the Bluetooth-based interface, the parents are using. They're making their own website, and they're using the Windows or Mac to monitor the blood sugar of their kids, and even microbolusing for hyperglycemia while the kids are in the school, which has been fantastic. So I think this is the such a wonderful thing with technology and Sabun, and hopefully it will be more refined. And by doing so, there are less chances of hypoglycemia, as we know that recurrent hypoglycemia is a risk factor for the neurocognitive development. So you do not want very tight control of like 6.5% or something for the kids who are like 10 years of age, because that neurohypoglycemia or neuroglycopenia may ultimately lead to behavioral disorders, which is not so uncommon in type 1 diabetic kids, and also the drop in the IQ, which has been well studied. And if you want to assess the efficacy, Dr. Unnikrishnan did mention, of course, about time in range, and glycemic variability was mentioned earlier in the talk, which is all there, and we have to assess the efficacy based on that number. So once you have the number, it is easy to assess and easy to compare. Next, please. So just a cautionary tale, it is probably my second last slide, that the evidence for hybrid closed loop system using open source code is limited to observational studies, and it is self-reported patient outcomes and anecdotal reports. Hence, we need to be very careful in prescribing, advising, and there may be the medical legal implication and insurance issues, and there may be issues with the gadgets as well. Next one. So what we need to know, that it has not been approved or appraised by the regulatory bodies. But if the patient comes to us, we can't say that, okay, you should not be using that, and no. I think it is a good idea for advise them, help them, let them know that, okay, this is the way we can help you, but be cautious. Thank you very much. I think I finished on time.
Okay, thank you, Dr. Santosh, sir. So, sir, like, I think you had a colleague with DI.
Okay, sir. It's okay. Okay, thank you, sir.
Yeah, Santosh, sir.
Yeah.
So like, can you share the practical implications he's facing, like how it is functioning practically?
So she is a public health physician, number one. She has the insulin antibodies. So she has trips of hypoglycemia and erratic hypos and hypers. So she has quite a bad, challenging type of issue. And and she started using DIY, I think 7 years ago or something like that. So she had been using for long, and of course, what she mentioned that she's comfortable. She was not happy. Now with the Medtronic, the 780G, the target has come down, but initially the target was different. She was not very happy with the target. She wanted to be lower. She wanted to avoid all those. No, she's young, so she long-term complications. So I think she is very happy, but the amount of time she spends in managing her diabetes is something which is not everyone can afford. And of course, her understanding about diabetes and her basic intelligence is a bit higher than most of the people who have type 1 diabetes. So I will, if you ask me to advise someone DIY, I will still discourage that. I should probably go for 780G. That is better. Why to worry about DIY? It's more practical advice.
Okay, like this limitation is also limited to related to the CGM device. Like more and more they become accurate. I think the accuracy of these systems will increase. The main factor is that once you made them automate, because there is range of variability in this data also. So that is what making it more challenging.
Your pump is as good as your CGM devices if the pump is based on CGM.
Yeah.
So the CGM has to be good. But Medtronic, I don't think there's a problem with CGM. I think the Guardian is pretty good. Okay. So there's no problem. And it requires calibration. So that was the thing. But anyway, it's working fine.
Thank you, sir. I thank all the speakers in this session. And we had a wonderful discussion. And we'll move to the next session as we are running short. Thank you once again. I invite Dr. Adarsh. Can we have a slide?
Hello. Good morning, everyone. So welcome to the fourth session of today's Hormone India conference. So this session will be on prevention and remission of diabetes. We have 4 speakers, and I would like to welcome our chairpersons. First, Dr. Rita Saxena, who is Associate Professor, Medical Mahatma Gandhi Medical College. So I would like to invite her and hand over the session to her to take forward by introducing the chairperson.
Till we have slides. Thank you all the chairperson and speakers for joining. And now we are also opening with Hall B after 10 minutes. There we will have a topic of frequently encountered and infrequently discussed, those topics which we frequently see in our clinic, but are not so much discussed between the doctors. So for that, we have a Hall B along with the obesity workshop. Okay, over to you, ma'am.
Hope I'm audible. Good afternoon, everyone. Yeah. Well, the session is a very exciting one. It talks about prevention of a disease. We all are like eagerly waiting for the studies and research and results so that we can do something to prevent the disease. So our first speaker for the session is Dr. A. Ramachandran. He is currently President, Indian Diabetes Research Foundation, and working as chairman of Dr. A. Ramachandran's Diabetes Hospital, Chennai. He is internationally renowned for his work on epidemiology in diabetes. His projects, the Indian Diabetes Prevention Program, has been appreciated internationally. His pioneer work on use of mobile technology in primary prevention of diabetes is very well known. And he has published a lot of more than 400 original research papers. Over to you, sir.
Thank you. Thank you. And congratulations, Dr. Mayur Agarwal, I'm sorry, for such a organization of such a fantastic meeting. I've been listening to a couple of talks before this. Let me share the slides now and see whether you can see my slides. You can see my slides now?
No, sir.
Can you?
Yeah, no.
Yes, sir.
Great, fantastic. So you wanted me to talk on primary prevention of diabetes, lessons learned. Well, I think it will be really a fantastic Herculean task to do that in 15 minutes, but I'll try to do what we can do in the next 15 minutes to tell you about the clinical trials and the randomized control trials on primary prevention. And I'll try to probably talk only about the Indian trials so that we can save time. As you know, there have been major number of primary diabetes prevention trials. The first one was actually the Chinese one, and then came the DPP. Then came the Finnish trial, but Yakotumulato in 2004, 2001, and then came the DPP. So you had two on the white populations and one on the Asian population. And then was the one which the first trial on Southeast Asia was the trial that we did in India called the IDPP1 or Indian Diabetes Prevention Program. And then we had the SMS trial, there's a DCLIP trial, and a Kerala prevention trial. I'll try to touch upon the Indian trials as much as possible. So the agenda would be to talk about the IDPP and the SMS trial, and let's see whether there's any post-trial sustainability of the trial results. And a couple of minutes on concordance of oral glucose tolerance versus HbA1c for detection and for screening people for pre-diabetes. Lastly, I'm going to talk to you about something new, and that's called the inflammatory adipokines in diabetes. And we have done work on inflammatory adipokines in pre-diabetes and how it can predict diabetes, showing that actually diabetes is an inflammatory disease, producing one of the reasons for a causative association for complications of diabetes. For those who have not been familiar, this is called the Indian Diabetes Primary Prevention Program, in which we took people with impaired glucose tolerance. There are about 531 people who were recruited in the study, and they were randomized into 4 arms of the study. One is a control group, and then we had the lifestyle modification. Then we had a group on metformin alone, and we had a 4th group, which was a combination of lifestyle modification and metformin. So it is a little different from the DPP trial. And the primary outcome was the development of type 2 diabetes. This was actually done for 3 years. After it took about 1 year for recruitment of patients or subjects, and it was a 3-year follow-up. And that shows you the results of the study, which is showing that the control group, the cumulative incidence of diabetes in 3 years was 55%, while it was in lifestyle modification, it was 39.3, in metformin, 40.5, and in the combination of the arm with lifestyle modification and metformin, the cumulative incidence was 39.5%. So in other words, conversion to diabetes is significantly reduced, as you can see the p-values here, by lifestyle modification by 28.5%, by metformin 26.4%, and a combination of these two together 28.2%. In other words, there was no additional benefit of combining 2 strategies for primary prevention of diabetes. So the lessons learned from the primary Indian diabetes prevention program was that lifestyle modification, even in moderate nature, will reduce risk of diabetes. The reason why I'm talking about moderate nature is because it is very much moderate compared to the very effective and very, very strict lifestyle modification, which was implemented in the American DPP as well as the Finnish trial. Lifestyle modification works even in subjects without obesity and even without weight loss. And that is for the first time we are showing in the Indian primary prevention trial. Of course, a combination did not show additional benefit. The other study, which I'm going to tell you, is called the Indian SMS study, in which we use the mobile phone technology in order to change the behavior of people to see whether we can change the behavior of people to prevent diabetes. So what we did was we took about 400 and odd people who were screened for impaired glucose tolerance using oral glucose tolerance test, and they were randomized in 1:1 ratio into 2 groups. The control group had a standard care in which they were all given education regarding the prevention of diabetes, the importance of diet and exercise, while the intervention group also, after getting the standard advice, also received motivational messages using SMS on their mobile phones on a very regular basis for the next 2 years. And the SMS messages were already done from a pilot study. It was given 2 times a week and mostly on diet, exercise, and lifestyle modification. That was the technology about this. We were happy that we also got a software donated by Texas Instruments. And what we did was the subjects were given the messages, and when they were changing their behavior, we will try to change the strategy according to what is called adult change in behavior. It's called trans-theoretical model of behavior, because in the beginning, you have to make them prepare for the change in behavior, and then there will be pre-contemplation, contemplation, action, and then sustain that same behavior for preventing diabetes. Some of them may relapse, and so they have to be recruited back by reinforcing the advice. So it was very heartening to know that within 2 years, there was a 36% relative risk reduction in the development of diabetes or incidence of diabetes in those subjects who received the SMS, showing thereby that by giving SMS messages on the phone, we were able to change the behavior of subjects in order to prevent diabetes. That shows you the absolute risk reduction was 9% because control group had 27% incidence, and in intervention 18%. So the absolute risk reduction was 9%, which is pretty powerful intervention. So relative risk reduction was 36%. The number needed to treat to prevent one diabetes within the trial period was 11, which just shows that this intervention is pretty cost effective. Another study, which was also done in Chennai called the DCLIP study, was a different study where people with impaired glucose tolerance, as well as with IFG, were actually randomized into a number of groups, and they were given metformin after their lifestyle modification was not powerful. 1 minute, just take this one. 5 o'clock, 1 minute. People will learn. Now we 2 o'clock. That's it. VA people call. So one of the things about the DCLIP study was that they used lifestyle modification, and then when the response was not good, then they were put on metformin. So it was what is called stepwise intervention. And in fact, 65 to 70% of subjects required metformin as lifestyle modification was not giving the desired response. The other thing about this was they found that if there is a combination of IFG and IGT, that was relative risk reduction was 36%, isolated IGT was 31%. It's pretty similar to the Indian Diabetes Prevention Program. But if they had only isolated IFG, then the risk reduction was only 12%. In other words, people with impaired fasting glucose are more resistant for primary prevention. The next question is, when you do a primary prevention trial for a period of 2 years or 3 years, is there a sustained effect? Is there a post-trial effect? One of the studies which has shown very, very excellent post-trial effect has been the Chinese prevention trial, where they found they have actually followed up these patients, these subjects up to 23 years. They not only found that there is a sustained effect of the intervention during the 6 years of trial period, but also found that there was a decrease in cardiovascular events and mortality even after 23 years after the prevention trial was terminated. So we did similar thing, whether in Indian patients, when you do a prevention trial, is there a sustained effect of prevention of diabetes after the trial was over? And what we found was that this is at the end of 2 years, there was a 36% relative risk reduction. But then these people, after the trial was terminated, we followed them up for the next 3 years and total a period of 5 years. And it is very interesting to see that the effect or the efficacy of the intervention are sustained, and the relative risk reduction continued to be 30%, which is not different from 36% statistically. In other words, there was proof that there was a continuous sustained effect of intervention in the randomized controlled trials. Well, 2 years of intervention has long-term sustained effects up to 5 years. We now did another study in which we looked at, because we were also doing HbA1c in the HbA1 during the SMS study. So we wanted to know whether, because at this time, the American Diabetic Association was giving a guideline that HbA1c could be used in order to diagnose diabetes as well as pre-diabetes. So we want to know there was a concordance whether you use oral glucose tolerance test or HbA1c for detection of pre-diabetes and detection of diabetes as an outcome of the prevention trial. So there were 2 cohorts. In one, OGTT was used for diagnosis, both for pre-diabetes and diabetes. And the other cohort, HbA1c was used for diagnosis of pre-diabetes and diagnosis development of diabetes. 6 to 6.4, which was the upper part of the upper decile of the HbA1c was used in order to detect diabetes. So what we found was fantastic. There was no difference in the incidence of diabetes, whether at the end of 12th or the 24th month, whether you use HbA1c or OGTT for screening or detecting pre-diabetes, as well as detecting or diagnosing type 2 diabetes as an outcome. As you can see, there was no 15.7 in 12 months with 17.8 in cohort 1 and 2. 2 is the HbA1c, and 25.3 versus 27.5. Both are not statistically significant. So there is no difference in the incidence of diabetes among pre-diabetes recruited either by OGTT or HbA1c. Well, I'm going to take you into a new territory called the biomarkers in pre-diabetes. There have been a number of studies on biomarkers, but now we have done the Indian patient. One of the first things we looked at was that, that there is usually a talk about association between NASH and diabetes. That is, how hepatic tissue or liver is involved in the pathogenesis of diabetes. So we did the study, the association of baseline GGT and alanine transaminase with incident diabetes among men with impaired glucose tolerance. And what we did was that we found there was almost a 2-fold increase in the incidence of diabetes if the GGT was higher, that is, the liver enzymes were higher at baseline. And the model 1 is what you see is that GGT is adjusted for age, body mass index, family history of diabetes, smoking, drinking, etc. Model 2 is further adjusted for baseline 2 oral glucose tolerance test, HbA1c, triglycerides, even HOMA-IR. In other words, it looks like liver enzymes are independently, raised liver enzymes can be another marker for risk of diabetes in people with pre-diabetes. We also did one more thing, and that is we actually combined fasting plasma glucose in order to increase the power of prediction. So what did it do? This confirms that the liver plays a role in the pathophysiology of diabetes. And the next question is whether correction of this metabolic abnormality could prevent the onset of diabetes is another question. We also looked at some other adipokines like adiponectin, leptin, and interleukin-6. And as you know, adiponectin improves peripheral insulin sensitivity. So a low adiponectin shows insulin resistance. Interleukin-6 alters insulin signaling in both hepatocytes and adipocytes and impaired energy regulation in the central nervous system. Leptin is related to insulin resistance. So what we did was we found that there was a negative association, significant negative association between baseline adiponectin and the incidence of diabetes, a 45% increase in incidence. Interleukin-6, 2.27, again a positive association. A raised interleukin-6 gave a 2.3-fold increase in the risk of diabetes. Again, this is adjusted to other variables. Leptin was not actually associated with incidence of diabetes. When you combine islet these two biomarkers, then you give a higher, very much higher one. And that's very important, because when you see that two of them can be combined, you can increase the sensitivity and specificity of predicting or incidence of diabetes. Lastly, I want to give you some of the new biomarkers called visfatin and fetuin A. And let me just explain to you what is visfatin. Visfatin and nicotinamide is actually a visceral adipokine, visceral adipose tissue adipokine, and it has got biological significance related to the cytokines and hyperglycemic state. Fetuin A is actually not exactly from the adipocytes, but it's actually from the liver. So it's called a hepatokine. So we can say visfatin is a visceral adipokine and fetuin A is a hepatokine. And what we did, we actually looked at the tertiles at the baseline to actually predict the incidence of diabetes in the next 2 years. And as you can see, in the tertile 3 of visfatin, there is a 54.2% incidence of diabetes compared to only 13.9 in tertile 1. So what you find is that this is a very powerful inflammatory marker for showing the incidence or predicting the incidence of diabetes. The other one is actually what you can see, the baseline fetuin A, which also showed that in the tertile 3, there is almost a 56% incidence of diabetes compared to only 12.5 in tertile 1. In other words, this is another biomarker or is kind of called a hepatokine, which actually predicts diabetes. Interestingly, when you combine these two together, you can see that if you combine visfatin and fetuin together, and then you get an odds ratio of 12.6, pretty powerful. So if you have these two biomarkers elevated, then you have a 12-fold increase in the risk of diabetes within 2 years. And that shows that not only that the role of biomarkers in the pathophysiology of type 2 diabetes, inflammatory marker of diabetes, that also shows that diabetes is an inflammatory disease. Another interesting paper we published very recently, as you can see, this was published in 2022. And what did we do was that we actually wanted to see whether we can have non-invasive technique of measuring adipokines. So we looked at salivary adipokines, very interesting. And as you can see here, you can see there is a very good correlation between the levels of adipokines, adiponectin, visfatin, apelin, and visfatin in the saliva with that of and we find that it is increased. Both saliva, this is the serum on the top and in the saliva. So it looks as if saliva seems to mirror the elevated adipokines in the serum. So you can actually take saliva and measure it. So what we found in this cross-sectional analysis, we analyzed association of adiponectin, visfatin, apelin, and vaspin with type 2 diabetes in saliva and in the serum. And what we found was that in those who had lower concentration in serum, it was also lower concentration in the saliva. The good thing is that it is clinically a significant step, as it does not need phlebotomy, and salivary adiponectin visfatin measurements may be useful in studies in type 2 diabetes. In fact, it is opening up a new, absolutely new area of research. The highlights of the study to describe to you, which was published very recently, adiponectin, apelin, visfatin, and vaspin were measurable in saliva. Salivary adiponectin was low in type 2 diabetes and mirrored its serum levels. It has the advantage of non-invasive sampling, EC collection. So to finish my talk, prevention or postponement of diabetes is possible. Lifestyle modification and metformin are very useful, even in people who are in India, who are thin and lean and who are not obese. Well, you can also use mobile technology as a preventive tool in order to change the behavior of people. We also found there is a post-trial effect up to 5 years. Primary prevention study, all the mobile technologies in India and UK, of course. There is another one which I didn't show you this time, some differences in ethnic differences. Lastly, the pro-inflammatory adipokines, both hepatokines, are elevated even in pre-diabetes, showing not only their role in the pathogenesis of diabetes, but also showing that diabetes is perhaps an inflammatory disorder. That's my team here in the hospital, and I must thank our research team, my clinical team, as well as my collaborators from Finland, United Kingdom, both from London and Cambridge. Thank you. Sorry for the interruption of the phone call.
Thank you, sir.
Thank you very much for the wonderful lecture, sir. So now I would invite Dr. Ashish Sharma to take forward this session with introducing our next speaker.
I need to go now because I got an appointment at 2 o'clock. Yes, yes, Ashok.
That you showed the data on the GGT, absolutely fabulous and new data from Nandita. But I really appreciate that you have done it, because the Rafsanjani study from Iran, they said all the three, ALT, GGT, and ALP, all the three are related as a biomarker. But you have shown for the first time GGT is the most correlated. That's the beauty of the study. Absolutely.
Absolutely.
Yeah. Over to
you, Ashok.
Thank you, Ram.
Bye.
Wonderful talk. Wonderful talk. I really enjoyed. Yes, doctor. Please continue. Invite Rajesh Rajput. Rajesh. Rajesh is here.
Yes, sir.
So,
good afternoon, sir.
Good afternoon. Your biodata is long, so we'll go to your lecture.
Yes,
highlights you can say. Now, Dr. Saab is the head of the Fortis in the Rohtak, and that is the latest. All the things, all things we know. After superannuation from the Rohtak PG Institute, he is now the head of endocrinology, the famous Fortis. Yes.
Tech team, please play the recording. Sir will answer the question.
Good afternoon, everyone. At the onset, I'd like to thank Dr. Mayur for inviting me to deliberate on the subject of reversal of diabetes, which is very interesting and very important for physician community to know that what are the facts, whether we can achieve reversal of diabetes or not. Now, when we are talking about the concept of reversal of diabetes, we have to understand that there are two important terms, remission and reversal of diabetes. What are the differences? Reversal is defined as restoration to good health, while remission is defined as abatement or disappearance of signs and symptoms of disease. Now, for a disease like diabetes, which is a chronic disease, it may be more accurate to use the term remission than reversal, which actually means cure of the disease. So henceforth, we have to understand this difference, and we will be largely talking, whatever we are discussing means remission of diabetes. Also note, in type 1 diabetes, there is no concept of remission or reversal. Now, when it comes to remission of diabetes, there are three important terms as far as definition is concerned: partial remission, complete remission, and prolonged remission. Partial remission is defined as when an individual is having blood sugar that does not meet the criteria for type 2 diabetes for at least 1 year, while not taking any medications to lower glucose levels. Complete remission when glucose levels are within normal range for at least 1 year while not taking any anti-diabetic medication. And once this is for prolonged period, that is maintaining a normal glucose value for at least 5 years without taking any medication, it is known as prolonged remission. Now, what are the important questions which we are going to answer during this webinar? Are beta cells really gone at diagnosis, or they are just dormant when we are talking of concept of remission? Can they be brought back to the function again? If yes, then what are the strategies? Do we have clinical evidence of remission? Can it be used as a therapeutic strategy? Whenever we call the concept of reversibility or remission, we have to understand that there is a known concept of glucotoxicity and glycotoxicity in patients of diabetes, which is responsible for decrease in pancreatic beta cell, as well as decreased utilization of glucose in the peripheral tissue. Very recently, the twin cycle hypothesis has been given to understand or to take care of this concept of lipotoxicity and beta toxicity, and obviously beta cell de-differentiation. Now, what is twin cycle hypothesis? Ross et al. Has given this concept that when a person is in positive calorie intake for a long period of time, which is currently the environment in which we are living, this excess of calorie intake will lead on to excess accumulation of fat into the liver. Now, once liver is loaded with lots of fat, it spills over into the blood in form of increased VLDL triglyceride. Now, later on, these excess of fat, which actually should only be stored into the adipose tissue, overwhelms the capacity of adipose tissue, goes to the tissue where it should not be, like pancreatic islet cell, which is normally free of or very minimum less than 2 grams of fat. And when there is deposition of fat in the pancreatic islet, it will result in decreased insulin response to ingested glucose. The result in a rise in plasma glucose values. When there is a rise in plasma glucose value, it will result in a vicious cycle and ultimately glucotoxicity, lipotoxicity, resulting in decreased function of pancreas. At the level of liver, increased resistance to the action of insulin will result in rise in fasting plasma glucose. When this excess of fat is deposited into the muscle, it is known as marbleization of the muscle, which will result in decreased utilization of glucose by the muscles. Moving forward, what are the key observational changes which support actually twin cycle hypothesis as a cause of type 2 diabetes? Remember, weight gain is the strongest modifiable risk factor for type 2 diabetes. If you screen patients before they develop type 2 diabetes who are obese, the rise in ALT and GGT concentration, which are liver enzyme, occur at least in 2 to 3 years before they develop type 2 diabetes. Usually, as I have told you, pancreatic beta cells are free of fat. In patients of type 2 diabetes, it has been shown that there is presence of lots of fat inside pancreas. First phase of insulin response is impaired in patients of type 2 diabetes, and excess fatty acids are known to bring about beta cell de-differentiation and inhibit insulin release. Moving forward, can we reverse this twin cycle? Now, again, it has been shown that when obese type 2 diabetic individual, they are given a very low calorie diet, which means diet containing less than 600 kilocalories a day are given to these individuals. Within 24 to 48 hours, there is a decrease in fat flowing to the liver, result in decrease in output of fat from the liver, which will result in mobilization of ectopic fat, which is deposited in pancreas as well as muscle and other tissue. All this will result in restoration of normal response of pancreas to the glucose as well as utilization of glucose by the peripheral tissue. So it is possible that reversing the twin cycle by giving a very low calorie diet, which means a negative energy balance, can effectively improve beta cell function. So if we see the evidence again for reversing twin cycle, intensive weight loss by any method actually can reverse type 2 diabetes, including in those patients who are taking insulin therapy from a short period of time. Plasma ALT and GGT concentration decreases in parallel with weight loss and glucose reduction. There is normalization of hepatic insulin sensitivity. As pancreatic fat decreases, there is restoration of first phase of insulin secretion, and there are evidences that it will result in beta cell recovery with restoration of insulin production capacity. So this is twin cycle hypothesis. Now, do we have evidence? Let's look at evidences. There are 3 very important evidences: counterpoint study, counterbalance study, and direct study. What is counterpoint study? Counteracting pancreatic inhibition of insulin secretion by triglyceride. Counterbalance study stands for counteracting beta cell failure by long-term action to normalize calorie intake. And direct study is diabetes remission clinical trial. If we look at counterpoint study, it is basically done to test a hypothesis, twin cycle hypothesis, that both beta cell failure and insulin resistance can be reversed by dietary restriction of energy fat. 11 patients of type 2 diabetes were given 6 diet. What are the results? As you see in this cartoon, by using 600 kilocalories of diet within first week, fasting plasma glucose improves substantially. Along with improvement of this fasting plasma glucose, as you see, there is marked decrease in liver fat and improvement in liver insulin sensitivity. If you look at pancreas, it is at week 8. There is a decrease in pancreatic fat, and along with improvement, decrease in liver fat, simultaneously there is restoration of first phase of insulin secretion. So the counterpoint study concluded that it is possible to normalize both beta cell function and hepatic insulin sensitivity in patients of type 2 diabetes by dietary energy restriction alone. This is associated with a decrease in pancreatic as well as hepatic fat accumulation, and abnormalities of type 2 diabetes can be reversed. The next important question comes, can we replicate, can the findings of counterpoint studies, can people with a longer duration of diabetes, they can have reversal? And if is reversal of type 2 diabetes is durable if body weight remains stable? So counterbalance study tries to answer these two questions, and it has been shown that in those who are having shorter duration of diabetes compared to longer duration of diabetes, the results are better in those who have short duration of diabetes. The restoration of fasting plasma glucose is also much better in those with short duration of diabetes as compared to long duration of diabetes. If we see and segregate patient according to the duration of diabetes, as you see again this cartoon, less than 4 year, 4 to 8 year, and more than 12 years of diabetes, those less than 4 years of diabetes, almost all of them have remission of diabetes, in contrast to a very few patients with duration of diabetes more than 12 years. Then the third important study is diabetes remission clinical trial, that is direct study. Now it has been done to understand whether the results of counterpoint and counterbalance study can be applied in a routine clinical practice by a primary care practitioner. So the study is done in 49 primary care practices in Scotland and England. And as you see, average duration of diabetes is 6 years. Intervention is basically withdrawal of anti-diabetic and anti-hypertensive. When patients were given 825 to 853 kilocalorie formula diet for 3 to 5 months. What are the results of direct study? Direct study shows that weight loss of 15 kgs or more in 36 patients, that is 24% in the intervention group, and there is a remission of 46% participant in a remission group as compared to 4% in control group. Again, highlighting the fact that calorie restriction will result in a remission of diabetes. Now this slide actually tries to compare all the three important studies, that is counterpoint, counterbalance, and direct study. But the key learnings which I will try to summarize for you for the three studies are that 40 to 45% of patients can achieve remission, and durability of remission has been demonstrated for at least up to 1 year. Younger patient, that is less than 50 years, as compared to those more than 59 years with a relatively shorter duration of diabetes, are able to achieve remission more. Individuals who are needing lesser number of medication at baseline, having lower fasting plasma glucose and lower HbA1c are more likely to benefit. And response actually neither depends on absolute weight loss or nor at baseline weight or BMI. Now this is very important. There is no change in muscle insulin resistance on diet restriction. The reduction in hepatic glucose output again was comparable in both responder and non-responders. What is most important improvement is beta cell function. It improved markedly in responders as compared to non-responders, and weight loss of 15 kgs from baseline was established as a potential threshold for remission of diabetes in all these three important trials. Moving further, very recently we also come to know that there are different phenotypes in type 2 diabetes. So what are the types of type 2 diabetes mellitus which can have remission? Now we can have patients of type 2 diabetes with severely insulin deficient, those who have combined insulin resistance and deficiency, those who are having severe insulin resistance, those who are mild age-related and obesity-related diabetes. Now these three subgroups, except those who are having severe insulin deficient diabetes, they have least chances of remission. In contrast, those who are having insulin resistant predominant or obesity related or age related type 2 diabetes, there we hold a very good chance of diabetes remission with calorie restriction. Before I end, there are very important future questions which needs to be answered before the concept of diabetes remission can be practiced by lots of us. How best we can maintain the initial advantage which is provided by a low-calorie diet? Can we prescribe a same type of low-calorie diet to every individual? And if yes, is the response going to be same, or we need to have an individualized, tailor-made diet and response? Next, genetics seems to play a very important role. It has been shown that 72% of the individual with BMI more than 40 do not develop diabetes. Why this is happening, which means genetically strong beta cell protect against development of diabetes. In all these trials, 16% of those who were more than 55 years of age and 10% of those between 16 to 14 years, they have BMI less than 25 kg per square meter body surface area, which means they are not obese. Is this intervention is going to be helpful in such type of patients? All the studies on remission of diabetes involve only obese individuals. What about those who are non-obese? Then what are the beta cell factors that actually prevent return of plasma glucose even with a weight loss of more than 15 kgs? It has been shown that 14% of, that is 5 out of 36 patients, does not have remission of diabetes even with weight loss of more than 15 kgs. Again, it has been shown that with a weight loss of more than 25 kgs after bariatric surgery, there is no remission of weight loss. So it is more than what we have presently known about the concept of remission. Lastly, duration of diabetes seems to be a major determining factor, and a weight loss of even more than 20 kg is not associated with a higher degree of remission. What about ethnicities? Most of the studies are done in those who are European in ethnicity. Whether these findings can be replicated in those with Asian or South Asian ethnicity, which have a different susceptibility to diabetes. So these are all the future questions which needs to be answered by doing more research into the field of remission of diabetes. So friends, to conclude with, type 2 diabetes is a condition where people consume calorie in excess, more fat than the individual body needs, actually deposit at ectopic places in liver, pancreas and muscle, which will result in onset of diabetes. Negative calorie balance is known to cause reversal or remission of diabetes, at least when we pick up such patients in early stages, but partial remission or reversal is possible at probably all stages of diabetes. Thank you very much.
Sir, you are not audible.
I think, Rajesh, wonderful talk, and the way you classified and presented and also referred to the various cluster of diabetes very useful is superb. Great start. Great talk, Rajesh. As usual.
Thank you. Thank you, sir. So if there are any questions.
I think, sir, you have explained very well. There are no questions.
Thank you, Mayur. Thank you.
Okay. Can we move to the next session? Yeah, Dr. Adarsh.
Yeah. So, can I invite Dr. Vimlesh Patidar to introduce our next speaker and take forward the session ahead?
Yeah, Dr. A.K. Das sir has some important issues, so we are preponing his session. His session was between 1 to 1:15. Actually, it is late.
Okay.
Yeah, so A.K. Das sir would be speaking next.
Okay, fine.
Dr. Vimlesh Patidar sir, please introduce Dr. A.K. Das sir.
I think your introduction not necessary. Patekar sir, I think we can go to the talk. We'll save time. I'm currently. I have put my own designation in my talk. Current designation.
Okay. So nice of you, sir. Yes.
Nice.
Suspect that this patient might be having insulin concern.
Okay. So I'll be sharing my screen and I'll take 14 minutes. I have timed it. Dear friends, my dear respected chairperson and my dear friends, I'm going to talk on a topic which is of very contemporary importance: genetics of type 1 diabetes. And this currently I'm the Professor Emeritus at the Mahatma Gandhi Medical College Research Institute and the Balaji Vidyapith. And this presentation comes from the medicine department of that particular institute. Dear friends, I must hasten toward that the work that I'm presenting just now is the work done at the Department of Molecular Endocrinology at Karolinska Institute in Stockholm, Sweden, which is going to host the EASD this year. And day after tomorrow, the EASD starts there. It was inducted in my good friend, Dr. Karini Sanjeevi, who is well known in our country. It was supported by a senior research fellowship awarded to me for 1 year in his lab. And this all has found a place in a pediatric diabetes book edited by Sanjay Kalra and myself. And this chapter 29 is the one which talks about genetics of type 1 diabetes. And I will also take some data or speak some data from I chaired the Diabetes in the Young Registry for the Government of India. I just give preliminary data, published data only, and also 2 papers published by us in the Proceedings of the National Academy of Medical Sciences, USA. One, the genetics data, other the vaccine data, and the BCG vaccine data, which is very revealing. Dear friends, type 1 diabetes, but to one confession that I'll be a little fast, and I'll only speak the things that are important. Type 1 diabetics is an immunogenetic disease. You must have the correct genetics, and you must have the current autoantibodies to have the disease. So it has been called a geneticist nightmare, but currently it has been described that it's nobody nightmare. It is common in childhood, and it is characterized by the immune-associated destruction of the insulin-producing beta cells of the pancreas. It's a complex disease. The 3 things play a role: genetics, epigenetics, and the environmental factors, which I'll show in a minute. It is rising today, and people have said minimum it is rising about 3% per year. So the number is increasing very steadily. And historically, it was thought to be disease of the children, but it can be found in the adults at any age. But mostly, 87% disease occurs in children from the data we have from the Young Diabetes Registry. Dear friend, all that is diabetes in childhood is not type 1. We have type 2 diabetes in the young children. We have so many other things which I'll not go in detail, like pancreatic diabetes, like malnutrition, modular diabetes, not yet accepted as a separate class, but we have it in India. But about 63.9% from the latest diabetes in the young registry of government India are type 1. So all that I mean to say that type 1 diabetes is the most common problem in our country, according to our registry. in the diabetes in the young, and it's about 64%, 63.9, followed by today type 2 diabetes in the young children, young OB children, is almost about 24%. Dear friends, I have given the epigenetic risk factors like histone, post-translational, DNA methylation, and non-coding RNAs. I've given the genetic risk factors, which I'll describe in little detail. The predisposing factors, which are the like the type 1 diabetes in an affected twin, one of the co-twins, and Eyelid autoantibody positive family members, altered methylation, and altered expression of various mRNAs. What is most important, they do not occur unless we have the infection by the viruses. Dietary factors like the bovine serum albumin from the cow's milk, it has been postulated, not totally proved. Intestinal microbiota also plays a role, and antibiotics also play a role. The predisposing factors include environmental triggers for beta cell autoimmunity and various other factors which I will not go into details of it. This is very important. 40 loci of genetics are known to affect the disease susceptibility. They are the HLA, DQ alpha, HLA, DQ beta, HLA, DR, pre-proinsulin gene, and the PTPN22 gene. So this may appear little difficult for the people who are not involved in type 1 diabetes study. All that I mean to say, one must have the perfect genetic makeup of the HLA, DQ alpha, DQ beta, DQ, HLA, DR to have type 1 diabetes, even if they have autoimmunity. Now, if you come down from the Norway down to Japan, you will find the prevalence of type 1 diabetes comes down gradually. India, Japan being the lower end. Now, it is because of the fact the genetics also improves with protective genes. Now, beyond these genes, there are also interferon induced helicase, which also plays a role. And few other genes also important. Now, if the mother has type 1 diabetes, the children of type 1 diabetes positive mother have a 2% risk. But if father has type 1 diabetes, the children have almost 7% risk. Now, this cartoon shows the beta cell autoimmunity. It shows the various environmental factors which can occur in the genetically susceptible children. Now, they include the macrophage, the dendritic cell. But what is most important is the role played by the environmental factors like the various autoantibodies I'll describe in a minute. Beyond that, the endoretroplasmic stress, viral infections, etc. also produce great deal of onslaught. I'll come in a minute. Now, this HL antigen locus is present in the short arm of the chromosome 6. Now, this is the basics. Beyond this, there are so many other genes. The concerned genes are class 1, HLA A, B, and C. Class 2, HLA DP, HLA DQ, HLA DR. Amongst these, HLA A, B, and C, DPA1, DPB1, and DQA1, DQB1, and DRB1 are highly polymorphic, and they're responsible. And these polymorphic genes play a role in the immune response. Now, the high-risk HLA class 2 genes represent the strongest genetic association, almost 50% of the total genetic contribution to disease. A 20-fold increase has been shown in the type 1 diabetics, relatives, twins, the family members, those who have HLA DR3, DQ2, or DR4 and DQ8. Dear friends, I must tell you that in India, we have just started in the diabetes registry the work on the genetics, which has just started. So we'll be having data at the end of 1 year. This data is the data which we have gathered from the immunomolecular lab at the Karolinska Institute. And these are all published data that this is important for the genetic study point of view. Now, how this DR and DQ genes produce type 1 diabetes? They produce because of the peptide binding activity of the HLA class 2 molecules, and they face the antigen presenting cells producing T lymphocyte peptide recognition, that is called CD4 plus T cells. Not all DRB positive 03DQ2 haplotype predisposed equally to disease, 2 conjugate haplotypes and 1 ancestral were associated with the diabetes susceptibility. So it suffices to mention that there are some genes which provide the susceptibility and some genes also provide the protection. Like HLA-A24 is found to strongly associate with T1 diabetes mellitus with a very rapid destruction of beta cells. Whereas A03 allele is shown to have a protective role against type 1 diabetes in children with HLA. Even if they have DR3, DR4, this A03 allele provides a great deal of protection. Now, haplotype of the MSC class 2 loci also confers strongest protection. Now, in Japanese, it is protective like the DRB1, 1501 and DQ6. There are a few non-human leukocyte antigen genes beyond. They are also been tried to be correlated with the genetics of type 1 diabetes. Now, what they do is that they increase the cell autoimmunity. It has been said and shown that it increases 16-fold autoimmunity in the family history of type 1 diabetes if there is HLA-DR3/4 or DQB1 and 302 genotype. And this susceptibility varies with various types of genotype. Now, it has been also shown that in certain types of the non-human leukocyte antigen genes, this susceptibility can rise as far as 40-fold. To make a long story short, I must tell you that it is related to both HLA genes and non-HLA genes. And therefore, it is up to the genetic structure that we have. We can have the disease, but one cannot have the disease unless there is autoimmunity. That is also related to the insulin gene. Insulin is a major cell autoantigen to type 1 diabetes mellitus, located in the 11p15.5. And this codes for the pre-proinsulin. This is pre-proinsulin converted to proinsulin, which is further converted to insulin. The INS gene is transcribed and translated in the thymus. It has been shown that the INS promoter region, which has IDDM2 loci, also plays a role through the VNTR, the variable number of tandem repeats. I will not go details of it, not necessary for this talk today. Now, it has been also shown that even though one has this type of genetic predisposition, one must have autoantibodies. The autoantibodies that are important are the ICA 512, insulinoma antigen 2 autoantibodies, and GAD65, Imogen 38, and the HSP, heat shock protein. So these autoantibodies have been all worked out in various parts of the globe, including in our lab in the Stockholm. Now, beta cell specific autoantibodies that has been discovered, not new, about 10 years back, are the zinc transporter 8, which has been also extensively studied in our country and has been found to be correlated to the autoimmunity in type 1 diabetes. And there are other things like IAP, Eyelid amyloid polypeptide, and the chromogranin has been also correlated. Now, if the number of autoantibodies present and the higher the titer can be considered as independent predictors of type 1 diabetes. If somebody has IA2 and GAD antibody, is more susceptible than having only IA2 and the quantum of the antibody. Now, insulin autoantibodies are highly specific and sensitive, but they need a large volume of serum to find out these autoantibodies. Therefore, it is not routinely done. Whereas the GAD autoantibody is found in about 70% of the newly onset type 1 diabetes. As the time passes beyond 5 years, it has been shown to be less than 10%. Now, there are a lot of epigenetic phenomena like deoxyribonucleic acid, methylation, histone demodification, which also play a role. What are the clinical implications of the genetic study? I'll just not go through the slide. I'll tell you that the risk group who can have the disease that we can predict, and as you heard Ram speaking about preventing type 2 diabetes with metformin, this type 1 diabetes, genetically susceptible people can be prevented. If you have the gene and if a family member has the autoantibody, one can look into the autoantibodies, it can be prevented. So it has been shown to prevent in the fast relatives of the type 1 diabetes, in the GDM mothers with autoantibody positivity, and children who are born to older mothers who have a chance to develop type 1 diabetes than general population. Now, the various studies which have shown the genetically induced or genetically related prevention studies are the DPT-1 trial in the Finland, European nicotinamide diabetes prevention trial, ENDIT trial, and the type 1 diabetes prediction prevention study called DIPP study, and Finnish Diabetes Association and trial to reduce type 1 diabetes in genetically at-risk children, that's called 3GR studies. So these are the studies. So the genetics provides the avenue for prevention. Last part of my study, do we have vaccine today to prevent type 1 diabetes? The answer is no. But the various vaccines that are undergoing trial are divided into 4 types. The vaccine who can provide induction of tolerance to the antigen so that the disease will not occur, developed or peptide-based vaccine strategy. I'll describe one which was developed in the Stockholm lab, DPP-27, deoxyribonucleic acid vaccine, and adjuvants of vaccine in which BCG stands out prominently. We presented the data in the New York Academy of Medical Sciences about the BCG vaccine, and we said that may be one of the factors, with evidence we said, can be one of the factors of less number of type 1 diabetics in India. I'll just come to a minute. Now, how do you induce tolerance? One of the methods used is to induce tolerance by administering oral insulin conjugated to beta subunit of the cholera vaccine. So oral insulin conjugated to beta subunit of the cholera toxin 31, which can suppress systemic T cell reactivity, and cholera toxin B subunit carries the insulin to the intestine and helps in the transfer of insulin molecule across the intestinal barrier. This helps in the reduction of the insulin doses administered orally without causing hypoglycemia. I told you about this vaccine developed in Sweden. An immunomodulatory peptide vaccine called DIPEP-277 has been passed phase 2 study by mechanism of glucagon-mediated C-peptide production, and is called Diamide. It is commercially available today, Diamide GAD65 vaccine. It acts by preventing beta cell destruction, and they're the 2 vaccines used today in the investigation to prevent type 1 diabetes. Therapeutically, it has not yet come to the market. Now, there are various deoxyribonucleic acid vaccines administering the GAD65 gene in a plasmid vector intramuscularly. So the GAD65 protein is produced in the body that can induce tolerance to type 1 to the GAD antigen and can produce some amount of immunity. BCG vaccine has been tried in the prevention of type 1 diabetes by shifting the T cell response from destructive to non-destructive and has been rather successful. Dear friends, to conclude, type 1 diabetes is a polygenic disease where we have multiple genes. At the same time, we must have autoimmunity and we must have the epigenetic factors, in which the environmental factors like the virus triggers autoimmunity in genetically susceptible individual. So for the beginners, one must have genetic susceptibility, one must have the autoantibody, and the viruses make these autoantibodies more auto-generated for the diabetes, thus leading to the cell apoptosis and hence insulin deficiency. Majority of the type 1 diabetes patients are test positive for autoantibodies, which destroy the cells of the pancreas. These autoantibodies develop under the influence of HLA and non-HLA genes and various epigenetic modifications. Amongst the non-HLA gene, insulin gene and PTPN22 have gene-environment interaction with the enterovirus, and the cow's milk, the bovine serum albumin, is one of the issues being investigated today, whether they can produce diabetes. Last slide, various strategies have been used in patients with islet cell autoimmunity to prevent development of type 1 diabetes or occurrence of, if not total diabetes prevention, they don't get into diabetic ketoacidosis by modifying the natural course of autoimmunity with less promising results. They do not totally prevent, but they can reduce the severity of type 1 diabetes in the susceptible children. Genetic testing routinely is not clinically indicated in these patients, but in future may help to identify the siblings or the first relatives of type 1 diabetes mellitus cases with high risk HLA haplotypes. Therefore, the genetics helps in identifying the high-risk haplotypes in whom one can consider the vaccines, one can consider developing immune tolerance, or giving the drugs like cyclosporine and steroids. Both have been used. But I must hasten to add, the results have been up to 2 years. As long as you give this cyclosporine or steroids, type 1 diabetes stays under remission. But once the drug is stopped, one has to go back to the dose of insulin. It may be a little less dose required, but the disease comes back in a milder way. Thank you very much for a patient hearing. Thank you. I wanted to make it very short, Mayur. I told you that it will be interesting for the people who...
Yes, sir. It was really very nice and a very tough topic explained in a very easy way and new light shed on type 1. So genetics of type 1 is really growing and it's actually should be known but difficult to remember, I would say.
I mean, it is for the people who work in this field. Important to remember that if you know they have perfect genetics, perfect autoimmune and autoantibodies and epigenetics, one may get the disease. And in India, we are luckily protected, but it's slowly increasing. Thank you.
I think we don't have any question in the chat box, so we can move on to next session. Thank you, sir, for coming live, though you had a very tough schedule, tight schedule.
We have some meetings today. Thanks. Rajiv is here. Rajiv, welcome, Rajiv.
Hello, sir. Good evening. Good afternoon. Hi, Bharat. Hi, Mayur.
Hi, sir. Good
afternoon.
Hello,
sir. And first of all, welcome and thank you very much that you allowed to squeeze in Dr. A.K. Das, sir. And also thank you very much.
Rajiv, thank you very much.
Mayur should not run a medical conference, but an entrepreneurial program.
Thank you for the appreciation. And we really appreciate you that you being in Sweden still could come live. Thank you very much.
Thank you. Thank you, man.
Okay,
and
so
one of the perfection, Rajiv, each is ideas, new ideas. Each idea he can sell for $10 million. But if it's Rajiv, lunch is assured. Madam is getting the lunch ready. So no motive in telling you that you are the person with lot of original ideas. Am I correct, Mayur?
Yes,
whether it is Rang De Nila, whether it is Rodinar, whether it is beyond Rodinar to go into one new things is Rajiv's.
Thank you so much, sir. Thank you.
Okay, so let me take the privilege to introduce Dr. Rajiv Kovil, though he does not need any introduction. So he's working as a diabetologist at Kovil Diabetes Center in Mumbai.
Mayur, let's start because we are already behind schedule. Let's start.
Okay. Yeah. Sure. Thank you. Thank you very much.
Thank you. I hope the best wishes for this Hormone India conference, and I hope it continues to grow bigger. Next time will be face to face. Thank you, Mayur, for calling me.
Thank you.
Thank you for also giving me giving me a topic which I'm not so comfortable. We are very happy talking about SGLT2s and insulins and all these things. So metabolic surgery.
Yes, sir. So we have tried to make the conference almost like a scientific, not the Dapa Sita Vilda.
Exactly. Thank you so much. So I hope my screen is visible. I'm talking about metabolic surgery for people with diabetes. Again, whether, we keep on trying to look at a solution and we create more problems by trying to do the solution. The agenda is this. I'm going to talk about the problem of obesity, about obesity in diabetes, with the metabolic surgery in diabetes, and I would conclude then. It's important to realize that the glucose homeostasis is very well controlled, and right from 30 years, we know about the chicken and egg story about insulin resistance and beta cell failure. Now we have progressed a lot, and now we know that there are more than 8 and maybe 12 pathophysiological defects. And a lot of these defects are governed by certain hormones and which are made by certain glands, and they tightly control glucose homeostasis. And today there's a raging debate across the globe that whether weight loss is important or just the sugar control is important. Not only people with diabetes, but many other people with pre-diabetes as well. And there are a lot of abnormalities in our people with obesity and overweight, metabolic abnormalities, that drives diabetes, cardiovascular disease, even kidney disease, and so many other problems as such. So again, if you look at data relating to obesity studies in people with diabetes do not lose the amount of weight with people without diabetes lose. So whether you go to the scale group of studies or even to the step group of studies with liraglutide and the step with semaglutide, the reduction that one gets with in people without diabetes, we don't get with people with diabetes. So you get close to 7 to 8% with liraglutide and somewhere between 10 to 11% with semaglutide. But as compared to people without diabetes, you have much better reduction. So probably there's some compensatory mechanism which acts. And here we are evolving into multi-disciplinary approach of people with diabetes, where weight is the paramount importance. And we all know that people with higher BMI develop diabetes. Life expectancy goes down just with increase in BMI. If you can look at it, that when you are at a BMI of 40, you have a 50% chance of reaching an age of 70. That should trigger a lot of people. Apart from that, we all know that we have a lot of these disorders which are triggered by obesity, with NAFLD being one of the most common one and being the kingpin in this metabolic blunder, followed by GERD, sleep apnea, hypertension, knee problems. So a lot of things are triggered with obesity. And India is a country of the underfed and the overfed. People die because of malnutrition and obesity related disorders. But what we see is that among adults between 20 to 69 years of age, obesity is going to increase threefold. And that's an alarming worry in a condition in a country which is still fighting for its basic needs. So diabetes in India, as you can see, 67% of people with type 2 diabetes have overweight. And the odds ratio is that obesity is moderately associated with type 2 diabetes. Obesity contributed to almost 36% of overall diabetes disability adjusted life years in India. So what is so different in people with diabetes in India? Again, NAFLD is more common. We have the lean NAFLD. We have high triglyceride, high CRP, high wastage ratio. We have premature amount of diabetes, hypertension, coronary artery disease, and multiple other cardiovascular disorders, which are mainly triggered by obesity, which seems to be the mother of all these NCDs. Now, if you look ahead, also the impact of percentage weight loss on HbA1c. Yes, weight loss does cause a reduction in blood sugar as well as HbA1c. Now let's look at certain surgeries and indications. These are the various societies which govern this metabolic space of obesity and diabetes and endocrine. And if you look at the indications for bariatric surgery, if it's indicated in people with more than 35 with comorbidity of a BMI of more than 40, eligible patients have a poor quality of life due to their obesity and its treatment complications, typically only concerned only after other methods have proven to be ineffective. If you look at the IFSO and the ESO guidelines on metabolic and bariatric surgery, this is almost 7 to 8 years back. It says that a laparoscopic technique should be considered as a preferable option in operation in bariatric surgery. A decision to offer surgery should follow a comprehensive interdisciplinary assessment. Psychological assessments of behavioral, nutritional, familial, and personality factors should be an integral part. After bariatric, all procedures require lifelong qualified surveillance. And upon failure to lose weight or to maintain weight loss following bariatric surgery, if medically indicated and if patient is willing, further bariatric surgery should be indicated. What does the ADA and the ESD consensus say? Very similar, is that more than 40, obviously go ahead. 35 to 39, if you're not able to achieve weight loss and improvement in comorbidities, including blood sugar with non-surgical methods, go ahead. 30 to 34.9 BMI, again, similar. ADA, ESD consensus is also very, very similar. If you look at IDF task force recommendation, it says that you could put patients on anti-obesity drugs for more than 27 BMI. Bariatric surgery for Asian population should be, the cutoff should be 32.5 and not 35. And again, people within the Asian population with diabetes and other comorbidities, you could consider from 27.5 to 32.5 as well. If you look at indications for bariatric surgery and the comparison of guidelines for saving time, I will look at all of them together. So very, very similar, except that between 30 to 35 BMI, it's only the stages which is looking at South. This is the South Asian guide gastroendoscopic group, which looks at doing a bariatric surgery. So that is the little bit gray area, but I would say that any BMI with 30 to 35 with comorbidity like diabetes or sleep apnea or documented NAFLD should undergo the NICE for bariatric surgery. This is the metabolic surgery group from India, which came up with these guidelines in 2016. These are the various procedures. LAGB basically is a laparoscopic adjustable gastric banding, laparoscopic sleeve gastrectomy, laparoscopic Roux-en-Y, BPD with duodenal switch, which actually saves or leaves the pylorus, and a laparoscopic mini gastric bypass. Now, indications are again, frank indications are 37.5 without any issues, 32.5 with comorbidities. Again, here some of the insurance have taken it up, so you actually don't need much of an indication because patients are paying through the pockets. But patients should have be motivated to lose weight, not considered in the age groups, below 18 and above 65. Above 65, only in the presence of severe obesity and obesity-related comorbidities can be considered. Below 18 after a pediatric endocrinologist certification only, and after attainment of puberty or completion of the skeletal maturity. So again, contraindications according to OSI is drug or alcohol abuse, pregnancy after bariatric surgery. Importantly, pregnancy has to be planned at least 15 to 18 months after bariatric surgery, and ART can be initiated only 12 months after bariatric surgery. I have 4 to 5 women in that childbearing age group whose indications for bariatric surgery was diabetes and PCOS, and because they wanted to plan a family. And this is a very important thing, that 15 to 18 months after bariatric, consider pregnancy, and artificial reproductive therapy only after start treatment only after 12 months of bariatric surgery. Types of surgeries we have the adjustable gastric band, which is an inflatable band, is used to create, as you can see, a small pouch outside which limits food consumption. Weight loss is around 15%. It's very small, and today not much of gastric banding is occurring. You have the Roux-en-Y and vertical sleeve gastrectomy, which is majority of the procedures today. Biliopancreatic division, where you retain the pyloric valve, is not done by many surgeons, slightly more specialized. So Roux-en-Y is where majority surgeons venture upon, creates a smaller stomach and bypasses the part of the intestine, and hence you have an increase in GLP, and that's why you have a good amount of weight loss. Vertical sleeve gastrectomy, as you can see, it leaves just a sleeve of the stomach, a sleeve pouch, and results in reduced ghrelin, which is the hunger hormone, 20 to 25%. And a lot of sleeve gastrectomy and is occurring. BPD, not much occurring, and very similar, but a variant called as a duodenal switch retains the pyloric valve, which occurs. Benefits of bariatric surgery. This ADA also, there was a publication which looked at long-term remission of diabetes after bariatric surgery up to almost 15 to 20 years. And there's a higher rate of remissions with the gastric banding, but it's not so popular in India. So if you look at the data and the kind of remission after bariatric surgery, the major studies on long-term outcomes, so if you very closely look at it, the remission is highest in the Roux-en-Y or the biliopancreatic diversion as compared to the other. And if you look at LAGP, it's weight loss at 10 years, you have almost 39.5%, which is fairly good. Again, challenges with existing intervention is that the effectiveness is poor, and that is why bariatric surgery or metabolic surgery comes, especially in people with comorbidities like diabetes. And you can see that pharmacotherapy can reach only 3 to 15%. Maybe the twin cretins may go up to 22 to 23% and come very close to a gastric sleeve and not closer to a Roux-en-Y bypass. But you can see that gastric band, gastric sleeve, and gastric bypass can give anywhere between 20 to 35% weight loss. And we all know that almost 10 to 15% weight loss in people with diabetes is enough to cause remission. Risk associated with these surgeries, operative list around 10%, which is bleeding, pneumonia, stenosis, ulcers, peritonitis, death can also occur, but less than 1%. Long term is obviously the nutritional deficiencies, protein deficiencies, gallstones, and weight regain. Complications, we all know that there is dumping syndrome, and recently a formulation of glucagon to treat dumping syndrome and the hypoglycemia associated with dumping syndrome has been approved. You have the hyperinsulinemic hypoglycemia, which is also seen in bariatric surgery. Again, a lot of nutritional issues, especially related to fat malabsorption and nutrient deficiencies. Cholelithiasis, a sudden change in influx of nutrients will cause cholelithiasis. So those are the complications of bariatric surgery. If you look at the comparison between the 4 types of intervention which is available, you will see that the gastric bypass is the one which is fairly one which is used, and sleeve gastrectomy being followed by the gastric bypass. There is complication rates, especially to earlier on related to vomiting and dumping and on all the others. But death on table is very low, and the hospital stay for all these is very low. So if I could conclude saying that bariatric surgery results in complete and durable remission in carefully selected people. Best outcome should be for people who are insulin independent. They have adequate C-peptide, shorter duration of diabetes. Surgery as compared to standard of care is a very safe and cost-effective treatment modality. Thank you, Mayur. I'll hand it back to you to continue the proceedings.
Thank you, sir, for speaking on such a tough topic and offbeat topic. Really covered very well.
And also in 15 minutes, Mayur, to cover the entire topic, Rajiv, you have done an excellent job. Excellent. Mayur, can I ask one question? Because without discussion, such a good topic will not be, we've done justice to Rajiv.
Go on, sir.
Rajiv, just wanted to know, with the advent of oral SEMA of, say, 25 and 50, Pioneer 8 trial, and with the available of the 2.4 injectable, nobody knows the future, but do you think that they will be an answer to the 25 to 30% weight loss you spoke about?
So very good, sir. So if you go back to the scale study, liraglutide, not much of weight loss, especially in people with diabetes. If you look at STEP with 2.4, decent amount, 10 to 14% weight loss. But if you look at Surmount, they presented the 72-week data this year at the ADA, and Surmount has a subgroup of pre-diabetes, and there was 95% remission with 24% weight loss in that subgroup. So they've extended that for a 52-week further period, and a 22% weight loss in people with obesity and pre-diabetes can really be the answer and to the problem. So I think that the twin cretins actually promise a lot. Only problem would be that, how many will tolerate it. Otherwise, 20% weight loss in 1.5 years is equivalent to a bariatric surgery. And again, it's you can tweak based on many things. So it becomes very, very important. And probably in future guidelines, we will get guidelines as we have A1C less than 7%. We will have guidelines that weight loss should be a part of targets for people with diabetes.
Absolutely. Brilliant answer. Thank you, Rajiv.
Thank you so much, sir.
Yeah, do we have Dr. English, sir? Okay.
Vijay?
Yes, sir. Can I start sharing?
Sir, yes. Everybody knows you, Vijay. Huh?
Good afternoon, sir, and we welcome you. RX1, please the slide, CV slide.
I will share. I will start talking because in the interest of time. Thank you, Mayur, for your kind invitation. And the topic given to me is the pharmacotherapy for pre-diabetes. And this is what the people say, that diabetes become an epidemic, especially when people are using too much of spam and cookies from the internet. And that's the reason why we are seeing the explosion of diabetes globally. And this is the definition of pre-diabetes, which is also called intermediate hyperglycemia, where the blood glucose is more than the normal levels, but lower than the cutoff values for the diagnosis of diabetes. They were first described in 1956 in connection with GDM, where pre-diabetes was detected and described, sorry. And here you can see the natural history of diabetes. Before the onset of diabetes, there's a long phase of pre-diabetes where the intervention at this time can be any useful in reducing the incidence of type 2 diabetes. Is that today's question? And we can see here, and that is a prandial sugar which rises first, and then the fasting sugar rises subsequently. And if you look at the definitions of the ADA and ACE are identical. Both say that between 100 to 125 is the impaired fasting, and 2 hours post-challenge between 140 to 199, and A1C between 5.7 to 6.4. The ACE includes the metabolic syndrome also by diagnosis by the National Cholesterol Education Program, is also included as part of pre-diabetes by the ACE. So this is about statistics. And in India, we see about 36.5 million patients of impaired glucose tolerance. And in USA, it is 35.8 million people with impaired glucose tolerance. And what's the worrying part of the story is 1/3 of the IGT fall in the age group of 20 to 39 years, and half of the IGT fall around the age of 50 years. So the younger generation is getting affected, which quickly gets converted to diabetes, and that's the cause of concern. Now, the pre-diabetes has been very critically looked by the ACE guideline, and it says in the position statement that the clinical intervention of the pre-diabetes is very essential. That has to be kept in mind. And the adiposity-based chronic disease management is also important. And therefore, redefining the context of pre-diabetes as the evidentiary structure of dysglycemia-based chronic diabetes. And here what they're saying is that there's a continuum with the genome, the epigenome, and the environment, which goes through the phase of a pre-diabetes, which is primarily in prevention with the insulin resistance as the basic criteria. And then you have the pre-diabetes as the biochemical and the cardiometabolic risk factors, eventually stepping into type 2 diabetes. And as per the ACE, when we treat patients of diabetes, we are treating at the level of tertiary prevention rather than treating early. So therefore, there's emphasis that you should treat these patients earlier rather than waiting for them to get into diabetes phase. And therefore, the framework of the dysglycemia-based chronic disease begins with stage 1 with the molecular risk factors, stage 2 with biochemical cardiometabolic risk factors, and the biochemical disease in type 2 diabetes, and eventually the complications of type 2 diabetes. The natural history of pre-diabetes is that 22% undergo remission. This is a study which looked at 918 patients of pre-diabetes, out of which 13% progressed. And this is much higher in this country, as we have studied from the CURE trial from Chennai, where the conversion rate is pretty higher than 13%, and 23% died because of various complications of pre-diabetes, could be contributed by obesity and heart disease and hypertension and peripheral neuropathy. The low systolic blood pressure, absence of heart disease, and a weight loss promoted these patients to normoglycemia, while obesity accelerated the development of diabetes. If you look at the guidelines by the ACE, which talks about the hyperglycemia management in pre-diabetes, where they said use of metformin and acarbose as the low-risk metabolic condition medications versus the TZDs and GLP receptor agonist, consider with caution, but not forgetting the other factors like dyslipidemia and hypertension as well, which requires attention. In the interest of time, I'm restricting my discussion only for the glycemic control. So we are aware of this, the diabetes prevention program published in the February 2002, which looked at 3 arms of placebo, metformin, and lifestyle for a period of 4 years. And we saw that lifestyle brought the reduction of diabetes by 58%, whereas metformin reduced the incidence of diabetes by 38%. So therefore, we had this aspect of using metformin as a part of treatment in patients of pre-diabetes. And the metformin is recommended by the European and American guidelines to treat patients of pre-diabetes. This is a Chinese study which looked at the use of metformin, which reduced the incidence of diabetes by 31%. And if you look at the Indian study, the reduction of diabetes was quite less, it was just 26%. And with metformin, and if you use metformin lifestyle, it is just 28%. But all the same, that metformin can be used to treat patients of pre-diabetes to reduce the incidence of proceeding to diabetes. The alpha glucosidase inhibitors were critically looked in this particular study, which had 1,400 plus patients. And this is a 3 years duration of trial, which showed reduction of new onset diabetes by 36%. Mind you, these are the patients who had impaired glucose tolerance, which was seen with the giving 75 grams of glucose and showing the sugar values postprandially more than 140, but less than 199. And there it showed reduction of diabetes by 36%. And interestingly, it also showed reduction of myocardial infarction by significant number with a p-value of 0.2. And also the CV event reduced significantly with a p-value of 0.3. So the acarbose came as a big promise in patients of IGT, especially reducing the ischemic burden. The pioglitazone also was used by Ralph DiFranzo in the ACT-NO trial, and which had roughly 500 plus patients. And this study was carried on for a period of 46 months. And when you see that at the end of the trial, 72% of the patient did not progress to type 2 diabetes, and 42% of the patient were treated pioglitazone were reverted to normal glucose tolerance when you give this particular molecule. So this molecule brought a great change in the prevention of developing type 2 diabetes, and therefore it became a molecule of a great importance. So not to forget that this tablet also does cause increased weight gain, but then the incidence of diabetes was reduced significantly. Same is true with the DREAM trial, which looked at more than 5,000 patients. And here you can see the reduction in the onset of diabetes was reduced by 60%. And this effect was more pronounced in patients who were overweight rather than underweight patients. So therefore, more the patient has obesity, more has the effect of this particular molecule reducing the diabetes to the tune of 60%. And this is very obviously seen in this particular trial. And eventually based on this trial itself, when the Steve Nissen talked about the new incidence of myocardial infarction in these patients, where the DREAM became a nightmare, where he said there's an increased incidence of acute myocardial infarction in those patients who received rosiglitazone. Zendo's trial, again, looked at patients around 7,000, more than 3,000 patients, And here these patients were given 120 milligram 3 times a day of orlistat, and 20% of these patients had impaired glucose tolerance, and 80% of the patient had a normal glucose tolerance. If you look at all patients at the bottom of the curve, you can see the reduction of type 2 diabetes by 37.3%. But those patients who had impaired glucose tolerance and where the drug was given, besides lifestyle modification, you got reduction of new onset diabetes by 45%. So therefore preventing the weight gain also improved the onset of diabetes in these patients along with lifestyle modification. The DPP-4 inhibitors are also used. There are two studies which looked at it. The first study looked at critically ill patients, 71 individuals with acute coronary syndrome. This is a European site study which looked at using the sitagliptin in these patients and showed reversal of diabetes to some extent. And there's one more study which looked at 242 patients of impaired glucose tolerance, were randomized to receive either 25 or 50 milligrams of sitagliptin over a period of 8 weeks, significantly reduced the area under curve of glucose of these patients after 8 weeks of therapy, suggesting these drugs can also be used as a kind of a drug to reduce the progression of type 2 diabetes. Scale study, which Dr. Rajiv was talking about, had more than 3,000 patients. And in the scale study, large number of population were women, about 78%, and 61% of these patients had pre-diabetes. When you give them liraglutide at the end of 56 weeks, roughly about a year or so, the weight reduction was about 8.4 kilograms in these patients. And you can also see the significant reduction of diabetes, pre-diabetes to diabetes in these patients over a period of 1 year. So therefore, weight reduction was an important contributor in all these studies which looked at the reduction of the incidence of diabetes. This is one more study, which is actually a study which was the double-blind randomized controlled trial looking at 464 individuals from 19 sites from the Europe with a BMI of 30 to 40, where liraglutide was used and the active comparator was orlistat here. And what you see in these patients were followed up for a period of 1 year. And what did you see? 20 weeks. And what did you see here? They're using 2.4 or 3 milligrams. The 2-year prevalence of prediabetes decreased by 52% in the metabolic syndrome. So group A was the metabolic syndrome. Group B was pre-diabetes, and 59% compared to the orlistat group. So therefore, there was a reduction both in the metabolic syndrome and in diabetes in these patients when you use, again, liraglutide. This was the study which looked at the using either 2.4 or 3 milligrams, and this had large number of population which was contributed by women. Again, the Carl Leroux tried the same molecule, 3 milligrams of liraglutide, and showed weight reduction of 4.6 kilograms and showed the normoglycemia in the liraglutide group in 66% compared to 36% in the placebo group, and 3% of the individuals in the liraglutide group versus 11% in the placebo group developed diabetes by the end of the trial, again suggesting that liraglutide did have impact in reducing the conversion of diabetes, pre-diabetes to diabetes. Here we have the DAPA trial. This is a pooled analysis of DAPA-CKD and DAPA heart failure trial, which looked at more than 4,000 individuals, up to which 1,400 belong to DAPA-CKD and 2,600 from DAPA heart failure. The 1995 patients a combo therapy in patients to see the development of pre-diabetes to diabetes. And here you can see that the development of pre-diabetes to diabetes was quite less when you use this molecule in the combination therapy. The use of insulin therapy, the early insulin treatment to prevent cardiovascular disease in a pre-diabetes to over diabetes. And of course, we know that the use of insulin is very important in diabetes. In pre-diabetes also, the insulin promotes mobilization of free fatty acids and therefore prevents deposition of ectopic fat. And the Origin trial was actually looking at this hypothesis. And what you see in Origin trial, conversion from IFG, IG to type 2 diabetes was reduced significantly by 28% with the significant p-value. So if even intensive insulin therapy or insulin therapy in the early phase of pre-diabetes can also have reduction in the onset of diabetes. The probiotics have been always interesting in the field of medicine. And this is again a study which looked at using probiotics in prevention of diabetes. The data is still not out. And here there are 100 people who received probiotics, 100 in the placebo group. And this is a Chinese study. And the primary outcome is the development of type 2 diabetes. The data is still not ready, but most probably the data is likely to be in favor of using these probiotics also to treat patients of pre-diabetes. So these are the data which I showed you about metformin, acarbose, pioglitazone, rosiglitazone. Only stand, there are some antipsychotic medications and bariatric surgery, which also reduce the development of diabetes from pre-diabetes. This is the meta-analysis which published in BMJ Research, which looked at all the molecules which said, and every molecule has the point estimate before the line of unity, again saying that these drugs have been effective. This looked at 21 trials, more than 8,000 patients, lifestyle modification plus drugs. Of course, lifestyle intervention seems to be at least as effective as the drug treatment. So therefore, these are some of the aspects of looking at these drugs. The age recommendation for therapeutic targets in prediabetes is to consider the pharmacological therapy in high-risk patients. You can use the drug in patients who have IFG or IGT or both, or metabolic syndrome, worsening glycemia with the cardiovascular disease, non-alcoholic fatty liver disease, history of gestational diabetes or PCOS. In those patients, it's indicated to use these drugs. Lipid tab, of course, is important to treat lipid and target lipid LDL below 100, blood pressure below 130, and antiplatelet therapy with a low-dose aspirin recommendation for all patients with prediabetes, unless there's a contraindications. And there are no therapies approved by FDA for prevention of diabetes as yet. And now we know that we have been heading for a disaster. What we can do, we still have prevention as the best method to have the onset of diabetes in patients with pre-diabetes. So therefore, diabetes prevention program will always score above all the medication therapy, but still there are some of the options available in certain patients where this can be offered as a form of therapy. With that, I thank you very much and hand over back to Dr. Mayur for further comments and opinion.
Is one of the best of all these studies. I think a lot of noise. Please make others
background noise.
Riya, please make others mute. I just must tell you, Vijay, your capacity to grasp and review all the studies is superb. Now, I'll just mention one thing. The Government of India, DCGI, about 1 month back, has approved metformin to be used for the pre-diabetes to diabetes prevention. It is official now. And following that, Dr. David Nathan, you know him. David Nathan has written a paper in which he has said all the drugs that we have said, from pioglitazone, acarbose, topoisomerase trial, the liraglutide, all the drugs he has said, but he has said we prefer metformin for 2 reasons. Number 1, it is cost effective. Number 2, it also addresses the cardiovascular lipid. It's a vascular drug. So he has said that the drug that United States they have given to FDA to approve is only metformin. I just wanted to add that, but your review was scholarly. And that is the major problem today, because diabetes is only 10%, Vijay. As you know, pre-diabetes in the I7 India study is 14.7%. If you do not prevent them, you rightly so, they're all waiting to be converted. And those who cannot, lifestyle is number 1, number 2, number 3. Those who cannot adhere, drugs are indicated. Thank you, Mayur, for such a beautiful topic. And more than that, selecting, I have never had such a talk, honestly. Vijay, for giving this.
Thank you.
No,
Thank you, sir. You made my day.
15 minutes. If all the studies, 15 minutes, all the studies. I just wanted to tell the audience the Government of India has approved metformin for pre-diabetes, and the dose required, as Ram showed. Ram is my classmate, Vijay. Ram showed it is 850 BD. For us, 500 BD is enough.
Yes. He also said there's some incidence of hypoglycemia. That's why I use a lesser dose compared to what was seen in diabetes prevention program. Yeah, I thank you very much, sir, for your words of appreciation. And once again, thank you, Dr. Mayur, for this opportunity to discuss about this topic.
Thank you, sir. Both your discussion
for this talk is great.
In the presentation.
Thank you.
The presentation was very good, and the discussion post lecture was even enlightening.
Yeah, that's icing on the cake, my sir.
Yes.
Thank you.
Yes. Can we move on to the next session, sir? Okay, so I invite the Hormone India repertoire. This would be a type 1 diabetes session. We already have covered the genetics of type 1 by Dr. A.K. Das, sir. Dr. Harsha Gunna is an MD Medicine, DM Endocrinology, along with me at SCPGI, and he is working as an head of Hormone India, Visakhapatnam. Over to you, Dr. Harsha Gunna. Please introduce our chairpersons.
Yes, thank you very much, Dr. Mayur. And it's a privilege to be a rapporteur for this Hormone India conference. Now we have seen various aspects of diabetes care like CGMS and remission in diabetes. Now let us dig and dive into the most interesting aspect of diabetes, that is type 1 diabetes. For this, we have famous and reputed chairpersons, Dr. Jay Gavli, who is an associate professor in the Department of Medicine, LNMC Bhopal, and Dr. Vinod Dhangi, Assistant Professor in General Medicine at Atal Bihari Vajpayee Medical College, UP. So I'll hand over the session to the chair speakers now.
Hello.
Yes. Hello.
Thank you, Dr. Harsha. Can we move ahead with the talk?
Yes, sir. Yes, sir. Please.
Yes, just one word I would say. Dr. Bharat Sabu is working as a diabetologist in Indore, and he has too many accreditation. He is very active in the this academics, and many of the papers are presented at national and international conferences.
Thank you, Mayur.
Over to you.
Thank you. And first of all, I would like to thank Mayur for pulling up this show where all the people who are fighting for diabetes are on one floor, actually, I would say. And this is such a good show it is being. I hope my slides are visible to you all.
Yes, sir. It's visible and audible.
Sure. So I would again like to thank Mayur for giving me this topic, which is adult onset type 1 diabetes, and for setting up the context. Dr. A.K. Das, sir, I am so thankful to you because you have made my job very easy. Now, the flow of the event would be, I will first be talking about the burden of the diabetes which we have, then the natural history of diabetes, how to diagnose adult onset type 1 diabetes, what are the treatment for the same, and the knowledge gap which is there, and the roadmaps for the future, because I think it is the platform to highlight all these issues. Now the burden, because there would be some light at the end of the tunnel. That's why I've selected this pick. So the global estimate of type 1 diabetes in children and adolescents in India is very bad. I tell you, they are not at all good, because we are having huge number of prevalence of and incidence of type 1 diabetes in children and adolescents. But the situation is not good in adult onset diabetes either. This is a graph which shows type 1 diabetes in 0 to 19 years and in 20 to 64 years. And you can clearly see that the graph is not declining. It is standstill at where it is since 2001 to 2015. Now the proportion of US adults which are diagnosed diabetes by the age, if we plot them, we see as the age increases, the diagnosis of diabetes increases. It includes all type of diabetes. The blue is type 1 and type 2, and the red one is adult onset type 1 diabetes. So it is on an increase as the age increases. We are missing maybe because we are not able to detect it. So again, India has the largest number of children with prevalent and incident type 1 diabetes, as I have told you. And the irony is that it is increasing by 3.4% per year, while 50% are diagnosed before 20 years of age and 50% of the patients are diagnosed after 20 years of age. And most of the time we mistake it for type 2 diabetes because it can make up to 10 to 30% of the patient which we treat as type 2 diabetes. They may have an adult onset type 1 diabetes. Now we all know this thing. This is nothing new to you. A person without diabetes has the normal glucose homeostasis, but in a person with type 1 diabetes, he is not producing enough amount of insulin due to antibodies which destroy the beta cell of the pancreas. Now coming to the natural history of pancreas and taking back from where Dr. A.K. Das sir has taken, It is caused by insulin deficiency because there is an autoimmune destruction of the insulin secreting pancreatic beta cell, which is there, which is going on continuously. So it usually leads to an absolute insulin deficiency over a period of time. A lifelong exogenous insulin injection is what is required to these patients of type 1 diabetes. Now, when we see there is a soil of inherited gene, as Dr. Ekedas sir told us, and then a damage to the cells that make insulin due to the environmental triggers, which cause a decrease in insulin production, and we see the diabetes. So from no disease, we proceed to the active disease. Now, if you want to see the pre-type 1 diabetes natural history, initially the beta cell mass is 100% when the genetic predisposition only is there. But if there is some putative trigger like a virus or an environmental factor, it causes insulinitis or a beta cell injury. Also responsible is cellular autoimmunity. There can be various autoantibodies like ICA, GAD65, ICA 512A, and IA. These all have been mentioned by Dr. Das sir. And there occurs the loss of first phase insulin response. And there is beta cell insufficiency, which we start feeling. Abnormal glucose tolerance test appears. And after that, when there is beta cell depletion, we have a clinical onset of diabetes. Now, coming and again digging more on this autoimmune basis, we see that immune dysregulation impacts all the aspects. Environmental triggers aspect are responsible up to the glucose intolerance effect. And there are antibodies like GAD antibodies, ICA 512 and ICA, and all these lead to the C peptide, which is undetectable over a period of time. And it leads to overt type 1 diabetes. Now, there is a proposed nomenclature for this also: stage 1, stage 2, and stage 3. Stage 1 is based on autoimmunity when there is normoglycemia, the early phase, when the patients are pre-symptomatic. Stage 2 again has autoimmunity because autoimmunity is a core component of these type of diabetes. The patient starts having dysglycemia and becomes pre-symptomatic. And then there is autoimmunity along with dysglycemia and patient becomes symptomatic. That becomes the stage 3 when we call the patient to be a type 1 diabetes patient. Now there are various models for pathogenesis. Some suggest it is primary chronic progressive. In other factors, it may be benign course of action. Then there will be relapsing and remitting sort of a trend. And secondary chronic progressive can also be there. Now this is really interesting. Eyelid cell autoantibodies, insulin, GAD, IA2, ZNTA. In pre-type 1 diabetes, less than 1 is there. In stage 1, more than 2 are there, but the glucose tolerance is normal. So in stage 2, what is altered is glucose tolerance because it becomes impaired along with any 2 of these things. And in stage 3, along with these 2 and more things, there is a symptomatic hyperglycemia. So this is a proposed classification. Now, WHO diagnostic criteria for diabetes, we all know: a plasma glucose level of more than 7 millimole in fasting state. And this is all the tough algorithm which is there. I will simplify it later on. So diagnosis. We all know it is diagnosed in the same manner like the type 1 diabetes is diagnosed, but the patient with type 1 diabetes usually present with acute symptom of diabetes. They have markedly elevated blood glucose levels. They have classical symptoms of polydipsia, polyuria, polyphagia, fatigue, unexplained weight loss, and blurred vision. The criteria remain the same: fasting plasma glucose more than 7 millimole per deciliter, then 2-hour plasma glucose more than 11.1, HbA1c of more than 6.5, or a random blood sugar of more than 200 with a classical hyperglycemic feature. Now, the diagnostic criteria in type 1 diabetes is same as I have told you, but the targets for most adults with type 1 diabetes are also same. We need to have a timing range of more than 70. We need to have a HbA1c goal of less than 7, preprandial capillary blood of 80 to 130, and it all almost remains the same. Now, how and when to test for type 1 diabetes? Because this is a tricky question, because we all are clinicians and in our day-to-day practice, we see patients which are in between and we are not able to decide. So a simple algorithm for it. 4% of people diagnosed with type 2 over the age of 40, in fact, have type 1 diabetes. So mind it, it is 1 in 25. Out of every 25 patients, those who are seeing more than 40 years of age, one would be having a adult onset type 1 diabetes. This is statistics. Now, what favors type 2 diabetes? Patient having a family history of type 2, and there is no family history of type 1, a high BMI, age more than 45, non-white ethnic group, dyslipidemia, specifically focus on a low HDL. But if a patient is not having a family history of type 2 diabetes, first or second degree relative with type 1 diabetes, a low BMI, a age less than 45, a white European sort of genetic descent, any autoimmune disease in patient, and a high HDL, then you should think about type 1 diabetes. You should think. Now, C-peptide can help to differentiate between type 1 and type 2. The enzymatic cleavage of the pro-hormone, pro-insulin, it generates insulin and C-peptide. They are generated in equal amounts. So we commonly measure C-peptide. It is a very common test which we do. Now, the utility is differentiating type 1 from type 2 and identifying patients with maturity onset diabetes of the young, MODY, which is very, very tricky. Now, to make it very simple, in comparison to childhood onset diabetes, the adult onset type 1 diabetes, it has lower concordance rates in twins. It has a less risk of HLA heterozygosity, a lower HLA class 1, more protective genotypes and lower GRS. GADA is again the dominant autoantibody, and it possesses HLA-DR3 genotype as told by Dr. Das sir. But it is little less aggressive in nature. You will not find it to be much aggressive as the childhood type 1 diabetes. And it has a more gradual onset of hyperglycemia, because that is why we are confused and we confuse it to be type 2 diabetes. Now about LADA, because the word LADA has come and it will be never out of type 1 diabetes in adult onset type. It is also known as type 1.5 diabetes. It is a diabetes which is typically diagnosed in people over 30 years of age. Symptoms are similar to type 2 diabetes: excessive thirst, frequent urination, blurry vision, and weight loss. But like type 1 diabetes, LADA destroys the cell that produce insulin. And surprisingly, 10 to 25% of type 2 diabetes, which is diagnosed as type 2 diabetes, is in fact type 1.5, which is LADA. So how to go ahead with it? This is a very simple algorithm. Type 2 diabetes, LADA, type 1 diabetes. GAD antibody titer is in favor of type 1 diabetes and LADA. Number of islet cell autoantibody is in favor of LADA and type 1 diabetes. HLA susceptibility is present in everyone, most in type 1 diabetes. C-peptide would be more in type 2 diabetes and would be very less in type 1 diabetes. Age, again, type 2 diabetes would be at a higher age with metabolic syndrome and with signs of inflammation. So this is a simple algorithm to judge where our patient lies. Now, type 1 diabetes would have positive autoantibody, as I have told you, clear genetic linkage to HLA and very low level of C-peptide. Type 2 diabetes, negative for autoantibody, no HLA linkage and normal level of C-peptide. But type 1.5 would be positive for autoantibody, but low level of C-peptide, unlike type 1 diabetes, which is having very low level of C-peptide and shows some linkage to HLA. This is in between these two. Now, age, BMI, and autoimmune diseases, we asked in history, clinical presentation, we see, look for the signs of metabolic syndrome. If you suspect LADA, then measure GAD antibody. If it is positive, measure C-peptide and act accordingly. If the GAD antibody is negative, we should recommend for type 2 diabetes. Now, this is again a new thing which has come up because WHO has renamed the latent autoimmune diabetes in adult, which is LADA, as slowly evolving immune-mediated diabetes of adult in the new classification. And these are the points which I have already told you. But in autoimmunity point, type 1 diabetes have severely increased autoimmunity while it is just increased in LADA. And ketosis is rare in LADA while it is very frequent in type 1 diabetes. Insulin dependence is right from the onset in type 1 diabetes, while it is gradually in LADA. It usually comes after 6 to 12 months of onset of LADA. Insulin resistance may be increased in LADA, which is again one of the confusing factors. Now, monogenic diabetes. This again confused with adult onset type 1 diabetes. Type 1 is polygenic, monogenic is monogenic. This is as simple as that classification of monogenic and polygenic diabetes, but there are many differences. Acute presentation is what is there with type 1, but monogenic can be variable. There is no autoimmunity in monogenic diabetes, unlike type 1 diabetes. Ketosis is common in neonatal diabetes if it is there with monogenic diabetes. Glycemia is variable. Obesity is usually not high like type 2 diabetes. Acanthosis nigricans is not present, unlike type 2 diabetes. The frequency is 1 to 2% of all diabetes in young patients. It is very rare. And it is usually having strong association with parent with diabetes. So parent with diabetes should put you a suspicion of monogenic diabetes also. Now, this is a very good way to approach diabetes classification, AA, BB, CC approach. A is the age, where I have told you, age can decide whether our patient has autoimmune diabetes or LADA. Autoimmunity, we should look for it. Thyroid diseases or celiac diseases are very common. Goiter or vitiligo we can see by clinical examination itself. BMI is a very important clue. If BMI is very high, type 2 diabetes mellitus becomes a probable diagnosis. Background is very important. A family history of autoimmunity or type 1 diabetes is very important. Unfortunately, we miss most of these things. Control and HbA1c worsening on non-insulin therapy should prompt you to look for adult onset type 1 diabetes. And was there a need for insulin therapy within 3 years of diabetes diagnosis? This should be a trigger factor for evaluating our patient for adult onset type 1 diabetes. And comorbidities should also be looked into because they will progress much faster in adult onset type 1 diabetes. Now, this is a simple algorithm which I have already discussed with you, to how to delineate type 1 and type 2 adult onset type 1 diabetes. Coming to the treatment part, this is a schematic for management of new onset type 1 diabetes in adult. This is given by ADA and EASD. It was a consensus schematic flow chart because it depends on individual preferences. And type 1 diabetes self-management education is the key actually to the treatment of any type 1 patient, let it be adult or childhood type 1 diabetic patient. We should ask our patient to start monitoring his blood glucose values, where CGM is preferred modality, but all should learn BGM for backup and monitoring. If CGM is not available in country like India, we should focus more on self-monitoring of blood glucose. Insulin therapy should be started, preferably multiple dose insulin therapy, but other regime including pump or hybrid closed loop technology can be started based on individual circumstances. Again, it is very individualistic. If patient is affording nothing like a pump, we should prepare our patient for hyperglycemia because we need to give him proper education regarding signs of hypoglycemia, how to manage hypo at home, and we need to ask them to regularly measure for ketone bodies also. And along with this, we need to have give them education on glucagon and the other things. So hyper and hypo both should be taken into account as far as diabetes self-management education is concerned. Now, the general principle for management of glycemia in existing type 1 diabetes adult actually are very simple. If glycemic targets are met, we need to update them regularly on new approaches to treatment which is available, because a patient who is on basal bolus 20 years back can now switch over to pump. We need to assess it regularly. But if the targets are not met, we need to see why they are not being met. And the type 1 diabetes self-management education and support is very important, because we have seen many patients improving out of that only. We should discuss the options for improving outcomes, because unless we improve the outcome, we cannot improve.
Sorry to interrupt, last 30 seconds.
Sure. We should offer CGM if it is they are not using it, and that's how we need to maintain our patients. Now, these are the things which should be there in the diabetes self-management education. At the diagnosis, we should tell them about the disease and all the things annually regarding their all the checkups and all the things. When complication develops, we need to assess them and treat it properly. And when transition in life and care occurs, we need to take them and talk to them about the age-related responsibilities and living situation changes. Now, these are the various non-insulin agents, but they are all in pipeline. So I think time will come when we will talk more about them. The knowledge gaps are many. We need to eliminate the cultural bias. We need to go for population screening, because that is what is most required these days. Disease modifying therapy in early stage, we should instill because we need to reduce the burden of cardiovascular outcomes and other macrovascular complication. We need to focus on adjunctive therapies, and we need to focus more and more on education. The take home is, this is a roadmap to take home. We need to understand the natural history of our patients so that we can diagnose them correctly. We need to diagnose them more and more because that is what is most important. And post-diagnosis, we need to treat them right, aware them about insulinization, because without insulin, a person living with type 1 diabetes cannot survive. This is a life or death issue. Thank you.
I think you ended very well, and we have coined a term, Mayur, that like sunlight and air, the insulin is the birthright of a type 1 diabetes.
Yes,
So,
sir.
Bharat,
Thank you, sir. Thank you.
It's a birthright. Insulin has to provide it to them, and they have to live. And many of the type 1 diabetes in the registry, diabetes in the young registry, they die because of lack of insulin, ketoacidosis, and also of infection. So that has to be taken care of. Wonderful talk, Bharat.
Thank you, sir. Thank you. Thank you, Mayur. Thank you.
Thank you.
Yes, sir. So wonderful talk by Dr. Bharat Sabu, sir. Just like type 1 for type 1 diabetes as insulin is a birthright. Like in the UK, people have been talking about that CGMS should be like given for everyone. At least in India now we have raised the slogan that type 1 diabetes is a birthright. Type 1 diabetes, they should get free insulin. Probably next 10 or 15 years, it will be made by the nation authority that it's given for free. So we'll remain positive about that at least. So very well done talk by Dr. Banshi Sabu sir. I think we'll see for Dr. Vivekananda sir. If he joins, that's okay, or else we'll continue with Dr. Parimal Swami sir's talk.
Thank you.
Yes, sir. So I think Dr. Vivekanand sir is not available. He has some issue. So we'll continue with
joining. We can just move on to the next session.
With Dr. Parimal Swami sir. Yes. So let me introduce Dr. Parimal Swami sir.
I think like other lectures, Dr. Saab, we can skip the introduction and I'll go right away to my topic because of the paucity of time, and we are already running late. So should I share my slides?
Yes, sir. Please go ahead, sir.
Okay. Are they visible? My
yes,
slides
sir.
Are visible and
yes,
am I audible?
Yes,
thank you.
Very
thank
well
you.
visible and quite audible.
Sir, thank you. Thank you, Dr. Das, sir. Good afternoon to you, sir, and to everybody present over here. I think it was the first session, conference where I kept on removing slides from my presentation. Dr. Ashok Das sir has covered, say, almost 4 or 5 slides from my lecture, and remaining slides were covered by Dr. Bharat Sabu. So I have just edited the version right here online. So thank you, Mayur, for asking me to speak on this important and interesting topic. Now, we all know from the previous past lectures that it's a chronic illness characterized by autoimmune destruction of the beta cells and a dependency on insulin for the survival, or the lifetime dependence on exogenous insulin. We all know that now the type 1 diabetes is divided into 3 stages: stage 1, stage 2, and stage 3. All the 3 stages are characterized by beta cell autoimmunity. The stage 1 is basically normoglycemia, and it is called pre-symptomatic. Stage 2 is dysglycemia and the pre-symptomatic state. And then the stage 3 is the full-blown type 1 diabetes with all its complications and the complexities of the management. So it is a disease which is best managed by the prevention, not by the intervention. A bit more detail about the 3 stages. The first stage is characterized by the genetic predisposition, some amount of beta cell stress in the beginning of the autoimmunity. Stage 1, the clear-cut establishment of the autoimmunity, but the patient remains normoglycemic, the role of microbiome, epigenetic and environmental factors, and there is the beginning of beta cell stress. The stage 2, this dysglycemia begins, the autoimmunity remains there, and stage 3 is the full-blown type 1 diabetes, usually detected, especially in our country, with the onset of diabetic ketoacidosis. The patient might be having mortality, definitely increased cost of the treatment, and sometimes mortality as well. Now, why to predict and screen for type 1 diabetes? The early risk identification is coupled with monitoring and counseling, and education enables not only the earlier diagnosis, but it also lowers the risk of DKA at the onset of the symptom. Though the therapies to delay the beginning of the stage 3 or to prevent type 1 diabetes are just for the research, they are not there for the clinical usage. But the most important outcome of the diabetes screening and prediction, type 1 diabetes screening and prediction, is that it lowers the risk of diabetes ketoacidosis at the time of presentation. In fact, in one of the trials, the DAISY trial, only 3% of the children screened and detected they had diabetic ketoacidosis, as against general population where 44% admitted with the diabetes ketoacidosis when they were diagnosed as type 1 diabetes. Also, the prevention of diabetes ketoacidosis with timely intervention, the insulin therapy, the education, the frequent monitoring of the blood sugar leads to the partial remission, and also the reduced insulin requirement for a long time to come. And it is also associated with better long-term metabolic control. So in populations where the background incidence of type 1 diabetes is more, there should be all efforts to do the prediction or the screening for type 1 diabetes. Also, with the advent of newer therapies, I'll just be touching upon them. There is an opportunity to prevent or delay the diagnosis of stage 3 or the clinical type 1 diabetes. And in, say, rare circumstances or in future, in many of the patients, the type 1 diabetes could totally be prevented. Now, the recommendations from various societies, this is I think the latest recommendation from ADA, that screening for pre-symptomatic type 1 diabetes is now, they have accepted it, usually for the research study or in the of children who have got the first degree family members with type 1 diabetes, so that the disease progress could be slowed down and there could be some preservation of the beta cell function. So the leading societies are now also asking for the screening for type 1 diabetes. And also there are certain organizations like Juvenile Disease Research Foundation, the ASK organization, the Addict organization, the TrialNet, they are all sort of providing the screening for type 1 diabetes so that the stage 3 could be prevented, delayed, better glycemic control could be achieved, or the diabetes could be, type 1 diabetes could be prevented altogether. Now, this is the summarization of all the therapies. They are all in the realm of the research or the trial, like the local intervention to improve the beta cell function, to reduce the beta cell stress and improve the beta cell mass. The most promising, teplizumab, is now approved by US FDA in March 2021, the anti-CD3 antibody, and which had shown in clinical trial in human beings that the type 1 diabetes onset could be delayed, the resultant diabetes could be mild, or the stage 3 can be prevented for some time. So these are the things, these are the important factors which basically sort of compels us to think about the screening of or prediction of type 1 diabetes. It's again a slide which Bharat has already showed you. I'm just focusing on the autoantibodies because my presentation is on the autoantibodies. With the onset of autoimmunity or the destruction or insulinitis of the beta cell, the first antibody to appear is the insulin antibody, IAA. Then other antibody which I'll be touching upon in next few slides, that GADA, ICS 5124.2A, IC antibody, ZNT8 antibody, they all appear. And this second diagram shows the location of all those pancreatic antigens against which these antibodies are produced. Now, I think this is one of the most important slides of my presentation. It shows the frequency at the time of diagnosis or even before the diagnosis, because in most of the children who are destined to develop type 1 diabetes, these autoantibodies would be there before they will be having stage 3 presentation or even stage 2. So these antibodies remain a cost-effective and easier method to predict the presence of type 1 diabetes. The persistence following diabetes, ease of detection, certain comments, and the recommendation for the screening. Now, the frequency at the time of diagnosis, the islet cell cytoplasmic autoantibodies, it is 70 to 80%. It is least persistent. The detection is not very easy. The assay is difficult, but it is the gold standard, the sensitive and specific for most sensitive and specific for type 1 diabetic. other islet autoantibodies may be found in the general population in frequency of up to 1 to 3%, but this is very, very specific for the diagnosis of type 1 or the prediction of type 1 diabetes. The GADA antibody, the most commonly known and most commonly used antibody, the presence is 70 to 80% at the beginning of the diagnosis. Even it may be there before the diagnosis. It is the most persistent autoantibody, can be found late in the life. Because of this, it is used for the screening for LADA patient or detection of LADA patient, easily detected. The assay is simple now, and it is for the detection of LADA. The GAD antibody may be more sensitive as compared to ICA, and it is recommended for population screening. Can be done, the test can be done quickly and can be done at a large scale. Large throughput is there. The IA2A antibody, that is called the insulinoma-associated 2 autoantibodies, 60% present are at the time of diagnosis. They are least persistent, but they are easy to detect, and they are also recommended for the screening. The insulin autoantibodies, 50 to 60%, though they are first to appear, so it makes them important for the prediction of type 1 diabetes rather than the follow-up patient, because once the patient receives insulin, then the insulin antibodies and IAA, they are basically indistinguishable from each other. The ease of detection is always there, and they are also recommended for the detection, for the screening or the prediction, because they are the first antibody to appear, and in pediatric age group population, they remain persistent. They disappear with the increasing age of the patient, and they are uncommon in adult population. The ZNT8A antibody, 40 to 60%, a newer antibody, now it is being used. It is most persistent, again, easily detected. And sometimes this is the only antibody which is there before other antibodies are detected. In next few slides, you will see that it is not necessary that all the antibodies or any specific antibodies should be present. The presence of any one antibody makes the diagnosis or prediction of type 1 more likely. Presence of multiple antibody makes it more stronger, and the increasing titer again makes it more and more stronger. So this is the suggested pediatric islet antibody panel, which includes ICA, insulin antibody, GAD, IA2 antibody, and ZNT8 antibody, which is the newer introduction. The adult islet and autoantibody panel is ICA, GAD, IA2A, and then again ZNT8A antibody. And when the LADA is of concern, we should check the GAD antibody and ZN8A antibody testing should be done. Now, these are the reference values. I'm not going into the details of the reference values of the autoantibodies, but just for the completion, these are the reference values. Now, the sensitivity and specificity. Again, this is for the detection of type 1 diabetes and the prediction of type 1 diabetes. As I have already told you, the IC has got the maximum specificity and a reasonable amount of sensitivity. GAD, again, reasonable amount of sensitivity and a good amount of specificity. Again, the IA2A, not that sensitive, but specificity is there. With IA, especially in young children or for the prediction, the specificity is around 25%. And any combination is there, because it is not necessary that only one antibody would be there. Some antibodies may be present, some may not be present. So this inclusion of IA, which is the first antibody to appear, makes the prediction as well as the diagnosis of type 1 diabetes easier or more specific. Now, should single islet autoantibody test be ordered, or should panel be ordered for the prediction as well as for the diagnosis? The caveats are no single islet autoantibodies present in more than 70 to 80% of the patient of new onset subjects, and it is advised that a panel of autoantibodies should be ordered. A single islet autoantibody or multiple islet antibodies, if detected, they are sufficient for the diagnosis, but probably not for the prediction. For the prediction, at least 2 autoantibodies should be there. Because there is clinical background as well as the presence of autoantibody. But in pre-clinical condition, pre-symptomatic condition, stage 1, stage 2, when there is no dysglycemia or only mild dysglycemia is there, the requirement of 2 autoantibodies is there to predict. There is no way to predict which autoantibody or autoantibodies in an individual might be there, other than to state that IA antibodies are uncommon in adults and IA antibodies are first to appear with the onset of or with the preclinical stages of type 1 diabetes. Now, clinical caveats about using autoantibodies assay in an established diabetic. Now, it is not for the prediction, for the management. A negative result might increase the suspicion of an alternative diagnosis like ketosis-prone type 2 diabetes. Negative results might guide us to perform genetic testing to rule out MODY. Especially in pregnancy time, if the phenotype is not usual for the GDM, then it may be type 1 diabetes and could be detected with the help of autoantibody estimation. And again, if there is overlap syndrome, as Bharat has already told us, then the estimation of single autoantibody can guide us towards the treatment. Again, the pitfalls of testing pancreatic autoantibodies, both for the prediction and for the diagnosis. A positive titer may not be diagnostic or may not be predictive sometimes. A negative titer does not rule out or exclude type 1 diabetes. When tested after diagnosis, initial positive titers may become negative. So it depends upon the time after the diagnosis or time after the initial insulin or immunological insult. Most of the laboratories, they do not offer a panel, and if we measure a single antibody, both the prediction and the diagnosis could be missed. Sometimes these are not standardized, they are still evolving technology. And I'm not sure about this, probably Dr. Ashok Das sir could put light onto that they are not very well standardized in non-white ethnic groups. Now, the pragmatic use of autoantibodies after the diagnosis, again, it's an additional slide besides the prediction. Basically, it is the clinical decision making whether the patient is having type 1 diabetes or not. If the ketosis is there, the age is there, then probably the autoantibody estimation may not be worthwhile if the case is very clear cut. Then again, the detection of autoantibodies should support us for the diagnosis or a treatment pathway, or to guide us for genetic testing to rule out MODY. Again, as I've already told you earlier, that only GAD antibodies are estimated by many of the labs, and very few offers the other two antibodies, that is IA2A and the ZNT8 antibodies. Again, if there is a doubt and the patient fulfills the clinical picture of type 1 diabetes, it is better to use insulin. And we can always take the help of the specialist centers who are well versed in the management of these patients. Now, what are the unmet needs for the biomarkers for type 1 diabetes, both for the prediction and diagnosis? For prediction of type 1 diabetes, GAD, IA2A, IAA, and ZN8A antibodies are required. The cost is high, large sample volume is required. Many laboratories, they do the radioactive assay, so special permission is required. And there is low sensitivity in single testing. Sometimes serial testing may be done. The answer, the newer innovation, other antibodies. In fact, one antibody that is called the oxidized insulin antibody, which is also there before the development of the clinical phase of type 1 diabetes. It is sensitive, it requires a small volume, and the assay is quick and cost effective. Now, there are other platforms are being developed where, like usual antibodies like GAD, IA2A, ZNT8A antibodies can be detected with the help of ELISA and PCR. So increased throughput, more amount of can be processed, and the cost would be less. And now JDRF came with a point of care screening where the patient is does a finger prick, put the blood on different dots, send back the sample in an envelope, and the results are declared online within 4 to 6 weeks. The cost is only $55, that is around 5,500 rupees or less than that in Indian currency. And it detects insulin autoantibodies, GAD antibodies, and insulin associated autoantibodies. So IA, GAD, and IA2A. So this is a perfect test for the prediction and to implement all the preventive strategies for type 1 diabetes. It should be offered to all the patients who are having high risk of developing type 1 diabetes. Now, last few slides. Besides autoantibodies, there are multiple factors which leads to the total clinical picture and the causation of type 1 diabetes. The various epigenetic factors, various phenotypic factors, and environmental factors, those could be converted into a risk score. Presently, the genetic risk score, Dr. Das sir has given us a very exhaustive, a very lucid background about the genetics of type 1 diabetes. So this genetic score, once coupled with autoantibody testing, can give us a very good clue for the prediction of development of type 1 diabetes, and all the preventive strategies could be implemented. My last slide basically tells us about the screening strategies in population sample. Again, as Bharat has already said, that the type 1 is increasing by 3% every year in Western world. After COVID, there is a sudden surge or increase in the cases of type 1 diabetes, and they are taking large steps at population level. So this is about one efficient strategies published just last month in Lancet Diabetes. 25,000 children were included in the study before the age of 2 years, before the usual age of onset for type 1 diabetes and DKA, and they were followed up until the age of 15 years or till they developed type 1 diabetes. They checked only two autoantibodies, three antibodies, that is GAD, IA2A, and insulin autoantibodies. And they found out that when checked twice at the age of 2 years and 6 years, the test was quite sensitive, efficient, and cost effective. And they recommended this test to be done and at a population level. And again, the frequency and the age group should be dependent upon the population specific disease characteristics. So this is now the first evidence, first study which shows that the strategy, epidemiological screening for type 1 diabetes should be done, because it is associated with significant improvement in the quality of life, prevention of morbidity, mortality, and significant reduction is the psychological, economical stress on the family as well as on the society. So I thank you, Mayur, for giving me this topic. It was real pleasure to be a part of this wonderful event with all my colleagues. Thank you again.
Many times once we
Thank you, sir. Really nicely covered. And what we could gather is clinical sense and the lab both should be taken into consideration. Nothing is very diagnostic.
Yeah, Mayur, I like to add, what Parimal has presented is superb. He has given you that with including 3 auto antibodies. I think Parimal, somewhere you have to also add gene transporter A. These 4 auto antibodies will give you almost a complete picture, Mayur, of type 1 diabetes prediction. It is mostly used for the people where the disease is high prevalence. But India is a country with diversity, so we need in our country. I just hasten to add that he also talked about non-genetic markers. They are not non-co-antibody markers. We have also found a simple formula, Parimal, which he published as a letter in JAPI 20 years back. The first author is one Dr. Ashida, T.S. Ashida. We said if the onset of diabetes is below 21 years of age, that is LADA. If the person has a BMI of 19.5, has no family history, because type 1 will not have any family history, and the inaugural blood glucose is very high and response to oral is less, 5 criteria. Family history negative, onset at before 21 years of age, BMI 19.5 or less, and no family history, and response to oral OAD is very less. We can almost certainly say that they are LADA, and it was corroborated by the lab test. So I think today we know that we can predict type 1 diabetes by this disease, and we must use it. I think that's a great talk. Thank you, Parimal.
Thank you, sir. Thank you.
Fantastic.
And I think with machine learning now there are various scores which are not using autoantibodies, or they are taking the phenotypic picture and the history from the patient environment, and they could predict type 1 diabetes with some certainty. So thank you, sir. Thank you very much. Thank you, Mayur, again.
Thank you, sir. Okay, we'll move on to the next session. For the next chair session, yeah, you can skip this slide. So I'll be coordinating with the chairpersons and the speakers for the next session, which is the young diabetes case-based approach. So this is really important because now as the diabetes age of diagnosis is falling, it is decreasing. It is very important to diagnose that whether now we see type 1 diabetes in 60, 65 also, and type 2 diabetes in 12, 13 years also. So this is like very important topic to discuss. So for this session, I welcome our chairperson, Dr. Adarsh Vajpayee. He is my colleague in MD, and he is presently as an associate professor at LN Medical College and JK Hospital, Bhopal. Dr. Atisha Jain, again my colleague, now is assistant professor at Jabalpur Medical College. Dr. Amit Chaudhary, my colleague, he is working as a consultant physician at Harda. Dr. Manish Jain, working as a consultant at Sagar. Over to you, Dr. Adarsh, to introduce our first speaker, Dr. Nihal Thomas, sir. He would be speaking on inherited forms of diabetes. And we are very, very lucky to hear from the best of the best.
Thank you, Mayur, for organizing such a beautiful conference. And thank you, Dr. Nihal Thomas, sir, for coming on this conference. And the topic is really very interesting. And you are a very well-known faculty worldwide. And I welcome you, sir, and kindly enlighten us on this topic.
Thank you so much, Dr. Adarsh. Thank you, Dr. Mayur. And it's a privilege being here. I think you need to enable me to share my slides. I'm not being given. Yeah.
Yes, sir. Now you could share, sir.
So I'm going to give a case-based approach towards inherited forms of diabetes. And this is what I'll be covering. 6 different case scenarios and a little bit of an explanation as to what we should be thinking about this. This is a 20-year-old gentleman with excessive sweating, polyphagia, polyuria, osmotic symptoms, insulin from an early age, and also had frequent urination with dribbling of urine and bedwetting from an early age. Was managed as type 1 diabetes till date. You can see over here that his BMI was low, physical examination was normal, there were no complications, no history of diabetic ketoacidosis, and no clinical features of insulin resistance. Grossly uncontrolled glucose levels, and amongst the other tests, besides having normal thyroid functions, normal pancreatic imaging, and GAD negativity, there was a borderline high sodium over here and a borderline low potassium. The C-peptides were detectable. The urine osmolality, interestingly, was low, indicating that we have a concentration defect in the urine, and besides diabetes mellitus, perhaps there was either central or nephrogenic diabetes insipidus. The children, the sister, had a progressive loss of vision and became entirely blind, was also diagnosed as type 1 diabetes at 9 years of age, had seizures, deafness, poor oral intake, and recurrent hypoglycemia, and passed on at the age of 26 years. So here we have the pedigree chart. And with this history, those of you who would have the experience or the expertise would therefore subsequently go for genetic testing. And we did our initial MODI panel and then extended on to our 31 gene panel, and we found that this patient had a mutation for Wolfram syndrome, or WFS1 mutation. This is our recent experience, the largest series of Wolfram syndrome from India, and also one which has actually detected the first founder mutation in the world. So nowadays we should be thinking, besides Wolfram syndrome, we should think about a Wolfram's related disorder, wherein people have a milder illness without the syndrome and may have diabetes as an isolated disorder by itself. So there are treatment options, and that is important to understand. We need to stabilize the endothelial reticulum, and that we could do that by giving dantrolene. Simpler medications like valproate have also been shown to have some effect, and more recently combinations like the phenylbutyric acid and torsodeoxyfolic acid combinations known as chemical chaperones have also been used, and it's actually FDA approved. So these might actually improve the longevity and the prognosis and even extend beta cell function for a little longer time. So here I would like to present a 43-year-old nurse who came with lean diabetes for 15 years. She had several episodes of acute abdominal pain between the ages of 28 and 35. And she was seen by our gastroenterology department. She was a staff at CMC Vellore, and her risk factors for pancreatitis were largely negative, no lipid anomalies, no vasculitis, and she had, as you can see, a necrotic pancreatitis in the acute phase. Subsequently settled after several episodes, and she was on basal bolus insulin. She was being treated by me, and she was on enzyme supplementation, and her glucose controls were good, very compliant, well-behaved patient. Her BMI was 21 kg per meter squared, and then this is, you can see, a CT scan which was done about 3 years back, which showed an atrophic pancreas and intraductal calcification. So if one had seen this, we would have said recurrent attacks of acute pancreatitis progressing to chronic pancreatitis, and I wouldn't have actually worried too much. Now, her daughter came with extreme fatigue and difficulty in getting up from the spot for 3 years, recurrent episodes with lactic acidosis with levels more than 10, and a clinical diagnosis was made of MELAS syndrome. And the other biochemical tests to rule out other causes of myopathy were essentially negative. So over here, one would think in terms of lactic acidosis, and this is a mitochondrial disorder. So this is the muscle biopsy, which showed evidence of ragged red fibers. At this point of time, the pediatric neurologist who was looking after the patient contacted me and said, don't you think there could be something in the family which is causing the same problem? And so whether the whole thing could be maternal in origin and whether the mother in fact had a mitochondrial disorder. And if you really look up the literature, you realize that recurrent pancreatitis can be a presentation of a mitochondrial disorder, a rare but a potential presentation. So we did the genetic testing in our NGS lab, and we found that there was a 45% heteroplasmy in the daughter, indicating a more severe form of mitochondrial disorder in the daughter and a milder disorder in the mother. And in fact, if you use regular Sanger or any of the other techniques, you could actually miss. And this is how NGS actually helps in proving the diagnosis. And you need, of course, a very focused and dedicated geneticist to actually help you pick this up. Why is it important to make the diagnosis? Of course, for predictive screening in the family, it's important. But remember, the other mitochondrial disorders actually respond to mitochondrial cocktail, which includes coenzyme Q10 in a dosage of 100 milligrams twice a day, and can certainly help with the other symptoms of reducing fatigue, episodes of lactic acidosis, but it does not really help in improving beta cell function, unfortunately. But definitely for the other family members, it's useful. It's important to remember that there's a huge spectrum of disorders which happen with mitochondrial disorders. As you can see over here, involving the ear, the brain, the eye, the heart, and the number of presentations, as you can see, focal segmental glomerular sclerosis, strokes, which of course is the classical MELAS syndrome, and myopathy. And the last two are perhaps the most commonly thought about. Remember, hearing defects is also an important presentation, but they occur fairly late in life, the median age being around 37 years of age. Okay. This is a 17-year-old boy who came to the endocrine outpatient department with progressive visual loss and towards the evening and newly diagnosed diabetes, born of second-degree consanguineous marriage, developmental delay, and had poor scholastic performance, and also had prominent night blindness as well by the age of 3 years. So those of you who are familiar with symptoms of obesity could see over here quite clearly that he has polydactyly and he's obese and he has features of hypogonadism, lack of body hair, some gynecomastia, and poor development of secondary sexual characteristics. So the classical finding, as we could see here in the fundus, is evidence of bone corpuscular appearance indicating retinitis pigmentosa and cystoid macular edema and a visual field defect which is progressively worsening and eventually leading on to blindness. So here diabetes is really a milder disorder and you should be focusing on the obesity syndrome per se. It's a classical Bardet-Biedl syndrome. This patient has at least 4 of the 6 cardinal, should have at least 4 of the 6 cardinal signs to make the diagnosis, has mentally challenged state, obesity, hypogonadism, has a distal limb anomalies, and retinal degeneration. So that's how we make the diagnosis, and diabetes is really a minor issue over here, but those focused on diabetes may in fact not even think about this particular condition and say obesity with type 2 diabetes. So the importance here is that the kind of obesity is actually central, and the type of limb deformities is a post-axial polydactyly, which is classical. Lesser common features including hepatic fibrosis and something which may look like a pseudo-Cushingoid syndrome, as well with the facial features. Chronic kidney disease can actually be quite common and up to 60% as well. Let's go to our next case. Another patient, 17-year-old morbidly obese girl with a BMI of 62 kg per meter squared, referred with difficulty in walking and newly diagnosed diabetes. Once again, don't get too distracted by the diabetes, because anyone with such a huge BMI at such an early age, it could be something else. So at the time of birth weight was on the higher, at the higher limit, around 3.5 kilograms, and early deformities started developing around the 5th year. As you can see here, excessive weight gain was seen somewhere during the early part of the first year, during the second half of the first year as well. Someone diagnosed leptin deficiency outside, noticing that the leptin levels were low. And subsequently was started on oral anti-diabetic agents as well. So the carbohydrate-rich diet was being followed by this patient, and there was no family history of any disorder. So over here, probably the shortening was a pseudo shortening of stature because of the varus deformity and the osteoarthritis in addition. The weight was 133 kilograms. She had good scholastic performance, had evidence of insulin resistance, and her Tanner staging was normal. And mind you, her menstrual periods were pretty normal as well. So here are the biochemistry that you can see over here. Borderline high STPT, and lipid levels were essentially, in spite of the gross obesity, the lipid levels were pretty much normal, and diabetes was out of control. Thyroid functions, cortisol, normal, and she had a grade 3 fatty liver. Now, someone diagnosed leptin, but the problem over here, the normative values should be based according to age. And therefore, we have a problem because the leptin was interpreted as an adult cutoff was actually being used for this child at that point of time. And so it was not leptin deficiency. Leptin deficiencies are not short statured, and they do not have an increase in lean mass. And in fact, this patient had an increase in lean mass. So despite being obese, the fat content, the muscle content of the body was reasonably good. So we did screening, a 36 gene panel for screening for morbid obesity, which we have in our lab. And our geneticist came out with a diagnosis of MC4, where you can have severe morbid obesity along with a good scholastic performance. And of course, it's interesting because even the previous case that I showed you, the screening tool is so useful. There are almost, out of this 35 gene panel, about 16 of them have various mutations which can be, which are characteristic of the Bardet-Biedl syndrome. So there are various phenotypic presentations of the Bardet-Biedl syndrome, and this tool is really very useful. And I must credit our lab, and I should also like to credit my colleague, Dr. Nitin Kapoor, as well for working up this particular case with great ardor. So you can see over here that the MC4R gene has a particular characteristic and affects hypothalamic function. It can be either autosomal dominant more commonly, but can be autosomal recessive as well. Loss of function mutations occur in MC4R, and it's the most common monogenic form of obesity in childhood of adults. Okay. So when we have this 36 gene panel, we have a number of abbreviations over here. Put in a little key over here, and of course, once you look at the YouTube video over here, you can pause it and see for yourself that there are a number of syndromes which occur, and I think we should be increasingly looking at this in our patients, wherein you have young people with morbid obesity. About 20% of them may in fact have a mutation of these, and increasingly there may be more specific targeted therapy for these forms of obesity. Case number 5, 16-year-old girl diagnosed to have diabetes during routine investigation, managed with thrice daily insulin, a recurrent history of renal stones with chronic renal failure from 12 years of age, and a baseline creatinine of 2.5. Had cyclical low abdominal pain and had not attained menarche. So lack of menarche and diabetes. Mother was a pre-diabetic, but no other relatives were available owing to a divorce in the family. BMI was within the normal range, and she had Tanner staging indicating that there was reasonable breast and pubic hair development, indicating adequate production of hormone, and no evidence of insulin resistance or acanthosis nigricans. So what should one consider in this sort of a patient? Well, an FSH LH was done, which of course someone said, could this be Turner syndrome? But the FSH and LH were within the normal range. So because of the lack of menstruation with the normal hormones, imaging was done. It showed, the ultrasound showed this, and of course reconfirmed with an MRI showing a bicornate uterus and an absent cervix and vagina. the reason for the cyclical abdominal pain, and MRI, the abdomen showing an atrophied body and tail of the pancreas. And we did a mutation screen, which was positive for MODY5 in our lab. So this is a common and important cause for atrophy of the pancreas and young onset diabetes. They generally tend to have a much lower BMI than the case that you reported here. Now we have a series of MODY5, wherein they can be insulinopenic in most situations, but some can be managed with oral anti-diabetic agents as well. This is a syndrome which can very often present not with diabetes, but with the other symptoms, as in this particular patient, wherein she came, and my colleague, Dr. Felix, still manages her, and she's doing pretty well, other than the fact that she does have renal failure and therefore requires insulin at this point of time. So just recapping on our experience with MODY and the work that we have done. And of course, you do realize that the syndromes of MODY in India can be quite different. MODY2 is uncommon. And then also younger individuals in pregnancy who have a lowish BMI and have diabetes in the earlier part of pregnancy, one should think about MODY as a potential cause, as we have in this particular series. Okay, so finally we go on to our last case, and a 38-year-old lady diagnosed to have diabetes at 19 years of age, present with hyposmolar symptoms, diagnosed as type 1 diabetes. On examination has a lean habitus, a BMI of 17.4, has prominent veins in the limbs. Fundoscopy shows diabetic retinopathy, and insulin requirement is about 400 units per day. Patient is ketosis resistant, and the triglycerides are grossly elevated with significant proteinuria in addition, indicating a glomerulonephritis, insulin resistance, and leanness with abnormal distribution of fat and a high triglyceride level, and therefore one should clinically think of a lipodystrophy. So the partial lipodystrophy, as you can see, we look at the body composition distribution, and with the low BMI, you can see where the head has an increase in body fat, whereas the rest of the body has a reduced body fat content. So partial lipodystrophy over here, and more severe forms of lipodystrophy, complete lipodystrophy, can generally occur with stunting and a generalized reduction in body fat, and of course the prognosis is much worse. They have a tendency to develop non-alcoholic fatty liver disease at a very early age and can go into cirrhosis. Now we have a fairly large lipodystrophy series which is getting published shortly, probably one of the largest in the world, wherein some of them may have formifrosty wherein you do not need insulin, some of the forms of partial lipodystrophy, and they could be very subtle in their presentation, very often being missed and classified as young onset type 2 without gross lipodystrophic features. And of course, the genetic screening over here is very important. So thinking between the lines is important in patients with young onset diabetes. Syndromic conditions should be looked for in the differential diagnosis of diabetes, and genetic testing with next generation sequencing is absolutely important. I'd like to thank my whole team, the funding that we've had, funding organizations, my brilliant scientist, Dr. Arun Chapla, and his team from the lab, who have done all the wonderful work without which his help we could not have made these diagnoses. My colleagues Felix and Nitin, who have contributed some of these cases, and all the consultants and residents in our department as well. Thank you so much for your patient listening.
Thank you very much, sir. This was really nice and very interesting cases of Wolfram, MIDD, Bardet-Biedl, monogenic, MODY, then lipodystrophy, and really it is we should think beyond what is in general diabetes, not just type 2 and type 1. So really an important message and really nice. Anybody has any question can put. Okay, I think we don't have any question. The presentation was really excellent. So I call upon our second chairperson.
Thank you, Mayur.
Thank you, sir. Thank you very much. We are very fortunate to have you. So I call upon another chairperson, Dr. Manish Jain. Please introduce our second speaker, Dr. Arun Pandey. He will be speaking on monogenic diabetes. Okay, I think some issue. Dr. Amit Chaudhary, you can take over. Unmute yourself, please. Dr. Amit, unmute. Yeah.
Yes, sir. Hello.
Yes, please.
I welcome Dr. Arun Pandey to enlighten us with his short talk on this very interesting topic. Sir, please continue with your topic.
Sir
Dr. Arun, sir.
Yeah. Sir has done his DM Endo from SGPJ. He's our senior and presently working at Lucknow. Over to you, sir.
Yeah. Can I be allowed to share the screen?
Yes, sir.
So after that talk by Nihal Thomas, sir, my talk would look a little lackluster. Sir had a galaxy of cases which is there, and we are fortunate at the Department of Endocrinology in CMC. They are doing genetic testing for us, and now we can diagnose more cases of monogenic diabetes. So I'll just try to present my case. So this monogenic diabetes, it's less discussed about. This my interest with monogenic diabetes started during my DM days, and so as we all know, many times monogenic diabetes is a clinically heterogeneous group of disorder characterized by non-ketotic diabetes mellitus, an autosomal dominant mode of inheritance, and onset usually before 25 years of age, and frequently, and the primary defect is in the function of beta cell. So this is the first case which I came across during my residency days, and this was a 23-year male. He was resident near Lucknow only. He was a set-top mechanic, and he was a person with, I'll say, good IQ, and he was a smart guy, and he was a known case of diabetes for last 1 year, which was detected when he had a wound following road traffic accident, and which was not healing. And he came to us with complaint of diminish of vision gradually in both eye over 1 month. At the start, he noticed that he could not see distant object, but presently he can perceive only hand movement. He cannot read. He had history of floaters in front of eye. He could not see the central field of vision, but can see in the periphery. He had an interesting family history, and this is the key. If suppose we want to diagnose monogenic diabetes, it is very important to spend time discussing about the family history. And he gave history of individuals in the family having diabetes who were lean, and the onset was before 20 years. And this was the family tree. In fact, individuals in the family who were of 5 years. So he had a glucometer at home, and he was testing sugar of each and every person in the family. Even individuals from the next generation, kids of 5-6 years, they were having diabetes, and he was just doing the testing of all the family members, because he was finding every day he was finding a new cases. So his blood pressure was 120/78. His BMI was 18.9. His waist shape ratio was 0.89. There was a thyromegaly. Rest all examination, there was no feature suggestive of malabsorption. There was ulceration on the leg. Also, there was the vision was improved. This was his fundus photograph, and if we see there was gross retinal detachment, and there was areas of hemorrhage, bleeding, and atherosclerotic vessels could be seen. Even there was a fibrotic tissue can also be seen. This was his investigation, and it was all absolutely none of them was unremarkable. There was unremarkable, and his A1C was 7.3. Thyroid function was normal in spite of he having thyromegaly. So then at the rounds, we had discussion with our Professor Bhatia sir, and sir told we had a discussion that this could be a case of MODY, and he was having proliferative diabetic retinopathy, sensory neuropathy, and diabetic foot ulcer, and euthyroid goiter. This was a case which we had seen in 2011-12. Then we were not very much aware of this genetic testing facility at CMC Vellore, and the gene testing was not done. But later on, we came across a similar case who had retinopathy, diabetes, and strong family history, and in that case, we could find a mutation of cell gene. Now, this is again interesting case. This was a 37-year-old businessman. He was a known case of diabetes for 19 years, and he came to us with poor glycemic control of blood sugar of 156 and postprandial 280. He was taking sitagliptin, metformin, canagliflozin, and pioglitazone. So 4 oral anti-diabetic agents, but there was no sulfonylurea there. And he was an exercise enthusiastic guy. He was exercising 1.5 hours. He was running at the speed of 10 to 12 km per hour on the treadmill. And he was worried. In spite of all this effort, his sugars were not well controlled. And this was, again, his family tree. But it is very important. Many times patient might give history very vaguely. But on careful follow, what we found is that there was diabetes there in a lot of individual in the family. In fact, we did the gene testing for this patient. He came out to positive, and his daughter was a carrier for the gene. And there was diabetes involving even 4th generation. Most important thing in the examination, if we are suspecting monogenic diabetes, there should be no signs. There is usually no signs of insulin resistance, and here there was no acanthosis nigricans. So this was a clue. So we suspected monogenic diabetes in this patient, and what we did is, as he was living very near to the clinic, what we asked him to do, take Glimepiride 3 mg and come after 3-4 days. And we asked him if there is any problem, you can come any of the days. Unfortunately, what happened, his sugar was very well controlled on just giving 1 OHA, and all the 4 drugs were withdrawn then. And this gene testing was sent to CMC Vellore, and it came out to be positive. In fact, one of the daughters, she was a carrier for the gene, and the OGGT of this patient, the daughter, it also was impaired. Well, the blood sugar was normal in the other daughter who was not the carrier. And one interesting thing which we all expect, as happens in this HNF MODY, there is usually the insulin secretory defect. So the fasting sugar can remain normal, but the postprandial sugars can be high. So usually in GCK MODY, we'll see fasting hyperglycemia, while in HNF 4 alpha and 1 alpha, there is usually secretory defect, and we might have just postprandial hyperglycemia. The fasting might remain normal. So this paper, this case was presented in ESD 2017 by a group. Now, again, this was an interesting case. This was a 52-year gentleman. When he came first to the OPD, he said he is having diabetes for the last 17 years, and he was diagnosed at the age of 35. His BMI was 25, and he was taking premix insulin twice a day, and he was also taking vildagliptin once a day for 5 years. And his fasting was 158, postprandial 301, A1C was 8.6. He was fed up of insulin, and he said, is there any way we can stop the insulin. While taking the family history, what we found is that his parents were having, his father was having diabetes, and all the family members were lean, and his BMI was also not very high, 25. Considering this fact that there was an autosomal dominant pattern of inheritance, we sent the gene testing. And when the gene testing came out to be positive, he then said he was having diabetes at very young age, at 22, 23. So many times patient might give a casual history that he is having diabetes for last 10, 15 years, but it can be actually more. But till the time we were waiting for gene testing, he was given regular insulin and glargine insulin twice a day, and vildagliptin was continued. As the gene testing came out to be a novel HNF4 alpha gene variant, and this was absent in the exon aggregation consortium, then the insulin was stopped to this patient. He was given glycoside 90 mg, metformin and sitagliptin twice a day. His on follow-up, his fasting was 124 and post-Mandel was 145, and A1C was 7.3. And this defect was found to be likely pathogenic. So the final diagnosis for this patient was a MODY type 1 with prior glycemia, and there was no features of macro or microvascular completion. The three daughters, the OGTT done for them, it came out to be normal, and unfortunately, this person, he has not sent the genes sample for the daughters. So the learning from this case was that it was a novel variant of MODY type 1. It also gives us a learning that in our part of world where MODY testing, MODY is diagnosed infrequently, we should still keep it in DDs in older individual with diabetes. And our case again reiterates that MODY type 1, it is sensitive to sulfonylurea and other classes of medication, and diagnosis can help in treatment approximation and genetic counseling. We presented this paper in RSGI UPCon. Now, what about, we have sent a lot of sample to CMC Vellore, and in 2008, we analyzed our cases which we had sent to Vellore, and what we saw is that these are the total cases which we have sent to Vellore. Although we have not published this paper, in 2018, we had this thing in our mind that the gene, there is a calculator for MODY prediction by Exeter University, UK, and we believe because the BMI range is different for Indians as compared to Caucasians, and there are other factors. That's why we believe that the calculator is not very useful in our setting. So total, this was analyzed in 2018. What we saw is that total 26 blood samples was sent, of which 20 was index cases and 6 were of relatives. And what was seen is that of this, the 26 gene testing reports was positive, and a lot, 14 were not having diabetes. And then we learned a new term called as MODY X. Many of the individuals who might clinically satisfy the criteria for monogenic diabetes, they would be lean, there won't be any sign of insulin resistance, and they might respond to sulfonylurea. There would be autosomal dominant pattern of inheritance. They might have young onset diabetic, but still the gene testing can remain negative. And what is happening is that every 2-3 years we are having one new gene involvement for diabetes. So we see there was 26 cases, 20 index case, of which 5 was positive. There was this paper from UK group. What they showed is that for every 6 samples sent for genetic testing, 1 came out to be positive. And in our setting, where there is a big financial constraint, many a times what we found is that 1 in 3 cases, 1 in 3 times it was positive. Now we have a series of around 13 cases of monogenic diabetes, including HNF4 alpha, HNF1 alpha, then BLK. There is this patient who's having BLK and HNF1 beta mutation positive. Recently, we had this patient with PDX positive. We have 2 cases of HNF1 beta, then 2 cases of cell gene mutation. This case, which was discussed in the previous talks also, if suppose we find non-ketotic type 1 diabetes and antibodies are negative, one should then go on for genetics testing. They might have genes positive for monogenic diabetes. And this patient was, again, the 10th case was a case who was diagnosed diabetes at 18 years of age. She gave a vague history that she was not gaining the weight. That's why the sugars were done, and she came out to positive. She never had ketosis. At the age of 45, she presented to us. We did the antibodies for her, and it came out to be negative. Then we sent the sample for genetic testing, and it came out to be positive for PAX mutation. We have a presentation of this case series in the annual conference of Endocrine Society of Australia and New Zealand Endocrine Society. So I think it's important to diagnose monogenic diabetes because it might change the prognosis of the patient. The management would differ, and we can prognosticate our patients well. So my acknowledgement to the Molecular Endocrinology Laboratory, CMC Vellore. They have been of great help during this journey. They were always of great support. And acknowledgement to my fellow colleagues who have also contributed to cases, and the educators who work in a clinic who help in compiling this data. Thank you. Over to the organizers.
Thank you very much, sir. And that was really nice presentation. And also, you're doing really nice as an individual practitioner. You're doing so great. It's not an institute work. So we really appreciate the work you are doing. Obviously, we should do all those and pick up the subtle sign, and genetic testing is important. Then we can diagnose. Many of our doctors who are listening to us are asking the question that what exactly, how do you send the sample, and what is the prerequisite, and what are the charges? That a question has been put.
Nihal sir was raising hand.
Arun, you'd like to answer? And then I just have a few comments. Very nice presentation. I'd like to congratulate you for what you have done.
Thank you, Satya. So the charges is around 13,000, and we have to send the whole blood by the courier, and the DNA extraction is required. DNA being a very stable molecule, and usually the courier will take 1 or 2 days, and never there was any problem. In fact, many times sample reached to CMC around in 2 to 3 days. Till the DNA was extracted, and we could get the report very well in time.
Yeah, thanks, Arun. Just a few comments. I think what you've done is really good. I mean, considering, I know how it is to work in practice and do what you want to do. It's not easy. And your dedicated documentation is really phenomenal, drawing your pedigree charts. And obviously, that's half the job, If you don't get a good pedigree, the chance of getting a MODY positive test is actually less than 4% according to our analysis. One thing which I might, because you did talk about MODY X, what we do now is, and you've probably seen part of what we do, is that after we do the 14 gene panel, and if it's negative, and if the suspicion is strong, we go on to the 31 gene panel. And now with DBT funding, we have a 62 gene panel as well, which includes secretory defects, syndromes, as well as insulin resistance syndromes and mitochondrial mutations. So the 13,000 that you mentioned now will actually cover for 62 genes. And with the good technology which our lab has actually developed under Aaron's leadership, we have cut down the cost of working on this whole thing. So I think from what was 10 years ago, 1,000 pounds for 3 genes in Andrew Hattersley, Exeter's lab has now come down to just 13,000, and it will become cheaper as the years go by. So that's one thing, that if you really want to, and you're looking at MODX, you can actually tell us to go up and look at the 62 gene panel, which we're actually doing as of now for many patients. The second thing is, you talked about having an RFX in one of your patients, and if you have more MODI5s, it's worth imaging the pancreas because RFX can be associated with a hypoplastic pancreas. MODI5 can also be associated with a hypoplastic pancreas. And you should check their stool elastase levels, because if they have a lower BMI and failure to thrive, they could have an exocrine defect in addition. CEL, you mentioned very interestingly. I don't think the WHO likes some of the mutations now, and they've taken it off the classification. I do believe that CEL exists. Maybe it's not that common. And once again, CEL should have a stool elastase check being done. If you look at the WHO classification, they've really cut down the numbers of MODI to around 7. And they have mitochondrial mutations being highlighted as well. Interestingly, glibenclamide is the best drug for most forms of beta cell secretory defects. So if glimepiride doesn't work, you could actually try glibenclamide. And remember, things like KCNJ and ABCC need huge doses of glibenclamide, even in children, up to 40 or 50 milligrams of glibenclamide per day. But you don't need those doses in HNF1 alpha and 4 as well. Yeah, thanks once again for that wonderful talk.
So the obesity panel, how much is that is costing, sir?
It's about the same, something like 12,000 for 35 genes, 12 to 40,000 for 35 genes.
Yeah. Okay. Thank you very much, sir.
Thank you very much. Thank you for enlightening us, sir. So we can move on to next session. For that, I welcome Dr. Manish Jain from Sagar to introduce Dr. Navneet Agrawal.
I think we are already running short times.
Thank you, Dr. Mayur. Hello, sir. Hello, Navneet sir. Navneet sir मेरे टीचर भी रहे हैं. MD के टाइम पे सर मेरे लेक्चरर थे जब मैं वहाँ पे था. एज एक सर बहुत अच्छे लेक्चरर और हमेशा डायबिटीज में बहुत अच्छा काम करने के लिए रहे हैं. सर मैं सर MD, PhD and FICM रहे, consultant, practicing consultant diabetes in the Gwalior. Sir is the chief diabetologist and director diabetes, obesity and thyroid center Gwalior. CEO and founder of DNA Sugar Clinics.
Can we cut short?
There is a very academic. Academically सर की classes वगैरह भी बहुत अच्छी होती थी और definitely तो सर से request करूँगा please अपना session start. Thank you so much.
Can you allow me to share my slides? Just let me know, Manish, when my slides are visible.
Yes, the slides are visible. Kindly make in full mode. Yes, sir.
Is it done?
Perfect.
Okay.
Yes.
So at the outset, I wish to thank the whole organizing team for inviting me, giving this opportunity, and a big congratulations for a wonderful conference. And I'll be speaking on adolescent type 2 diabetes, as my previous speakers have very well explained about the MODI and the other forms of young diabetes. So, like, what are the types of young diabetics we see? We know that diabetes is a global emergency, and India is not lacking behind. We are in number 2 now. But initially, the diabetes, which was considered as a disease of the elderly population, but now, as we have seen, the onset of diabetes has come almost a decade earlier. Even we published data from the Gwalior. We have seen that there was almost a decade earlier onset of type 2 diabetes in the younger population less than 40 years. So, as per definition, the diabetes in young is defined as the onset of diabetes less than 35 years of age. And this is an emerging disorders in the children, adolescents, and young adults. And they all have the unique challenges in both research as well as in clinical care. So, to carry on the discussion forward, let's take an example of these 4 hepatototal patients. And if you can see, these 4 patients, they have A1C of around 10, so somewhere between 9 to 10. The FPG and PPGs are almost equal in all the 4 cases. But do you feel that the type of diabetes is same in all the 4 patients? No, not necessarily. Though they are the age-wise, the FPG, PPG-wise, or the A1C-wise, they are similar, but they might have a different type of diabetes. So let's see how we can differentiate or how we can make a differential diagnosis. So the scenario is changing in young, as we have seen that it is a growing prevalence in the type 2 diabetes, and the prevalence of youth onset type 2 diabetes is increasing worldwide in parallel with the obesity epidemic. As we know that there is an epidemic of diabetes and obesity. So the different types of diabetes which we see in youth is type 1 diabetes, which we are seeing day in, day out, and we know that how to differentiate a patient of type 1 diabetes. Then we have a monogenic diabetes, which was initially termed as MODI, and we had a good discussion on MODI by my previous speakers, Nihal Thomas sir and Dr. Arun Pandey sir. And then we have a type 2 diabetes, that is early onset type 2 diabetes, and we can have other forms of secondary diabetes in young, like the FCPD, drug-induced diabetes, or diabetes that is secondary to endocrinopathies. So we know that it's not only the prevalence of type 2 diabetes or young onset type 2 diabetes increasing, even that there is increasing prevalence of type 1 diabetes in children and adolescents, and this is a global prevalence is increasing of the type 1 diabetes. But there is an emergence of type 2 diabetes and pre-diabetes in the youth. As we know that there is obesity is increasing in young population, particularly in Indian and the Asian countries, even the European and American countries. And if the interventional studies for the reducing the obesity is not done, these all adolescent or young population will develop type 2 diabetes at a later age. So what are the different risk factors for type 2 diabetes in children and adolescents? One is the obesity. We know there is an epidemic of obesity in the adults and even in the school-going children. Then we have a genetic predisposition and the family history. Children born small for gestational age, newborn macrosomia of the diabetic mothers, and premature adrenal in girls. So like there are some risk factors for developing diabetes in the young population. If we talk of the etiopathogenesis, it's same as the responsible for the diabetes in the elderly population. So like pathogenesis is almost the same, but there are some key drivers for the development of type 2 diabetes in young population. One is early life determinants like changes in intrauterine environment, maternal undernutrition, and overnutrition. They might be associated with increased risk of obesity and then later on development of type 2 diabetes. Diet, increasing consumption of energy dense foods, reduced physical activity. The children and the kids are there more on the mobile, more on the apps, more on the computers. So there is a lack of physical activity, which is responsible for weight gain, for the visceral fat gain, and ultimately leading on to the insulin resistance and type 2 diabetes. Some socioeconomic factors might be responsible. Female sex and PCOS, again, there is a preponderance of insulin resistance in this population, and again, they are at a risk of developing type 2 diabetes. Non-alcoholic fatty liver disease, it seems to be a stronger risk factor for young onset type 2 diabetes than for type 2 diabetes that develops in middle or saying that the patient was diagnosed almost 17 years before as a type 2 diabetes, and then he was on the insulin, on the different OADs, and is still not controlled in last 17 years. So that means the diagnosis was at fault. So maybe if we can correct the diagnosis, we can correct the diagnosis and we can bring the patient the target. So if you can differentiate between type 1, how to differentiate between type 1 and youth onset type 2? Pathophysiology of type 2 diabetes, we know that differs from type 1. Youth onset type 2 diabetes is rapidly progressive beta cell decline. So in over a period of time, maybe after 5 years, 10 years, they might be having a reduction in the beta cell. They might require the insulin therapy. And there is the accelerated development of diabetic complications. When you talk of the treatment options for youth onset type 2 diabetes, they are inadequate, limited to 2 approved drugs, only insulin metformin. So like we have to see that what is the correct diagnosis and what we can place. As Nihal sir was saying that the patient to the MODI, they respond well to the glimepiride and glimepiride. So that there are some differences in the clinical characteristics between type 1 and young onset type 2 diabetes. We know that the type 1 diabetic patient, they have autoimmunity present, but it's not present in young onset type 2 diabetics or even type 2 diabetics. And the role of insulin in the management, yes, for type 1, but for the young onset, we may require in patients who are on the rapidly progressive beta cell failure, they might require almost around 50% of the patient may require insulin at 2 to 5 years of diagnosis. But in type 2, yes, there is a gradual progression of the beta cell failure, so this may take longer time to require insulin therapy. As the another form of diabetes which we see in the younger population is MODI, and it has been discussed very well by my previous speakers. We know that is an autosomal dominant inheritance, and there's a multiple types of the MODIs, and as per the genes involved has been explained. Dr. Pandey has shown his cases, 26 cases. So the mode of inheritance, it is monogenic, autosomal dominant. Age of onset in MODI, it's childhood, adolescent, whereas to differentiate it from type 2, it is usually obese. But to differentiate between MODI and the and the type 2 diabetes is that the patients are not obese, and the patients might having a family history of in 3 generations, being like father and grandfather or grandmother. So in 3 generations, you have a family history of diabetes, presence of diabetes, and no marker of insulin resistance. And if it like in the body habitus, yes, they are non-obese of the MODY, whereas in type 2 diabetes, usually we have obese. And if we talk of the dysmetabolic syndrome, in MODY it is absent, whereas in type 2 diabetes it is usually present. So phenotypic expression and natural history of MODY, it is under the age of 25 years and not progressive or slowly progressive. So like there are different types of MODY which we can differentiate by the gene testing, and then we can plan the treatment on the basis of that. Then you have the other form of diabetes which we see in younger population. There is LADA. This is a latent autoimmune diabetes in adults. That is there is a form of autoimmune, that is our type 1 diabetes, which is diagnosed in individuals who are older than the usual age of onset of type 1 diabetes. And the alternative terms that are being used for LADA is type 1.5 or slow onset type 1. But often patients of LADA are mistakenly thought to have type 2 diabetes because of their age. So age is not a criteria, but what is the pathological mechanism for the LADA? They are a genetic susceptible, moderately type 1 diabetics. They have a specific trigger. They have autoantibodies like the GED antibodies. So that leads to the beta cell apoptosis and insulin deficiency. Whereas the type 2 diabetics, like they have a genetic susceptibility, obesity leads to the low-grade inflammation, leading on to the eyelid and autoantibodies formation. There is an accelerated loss of beta cell function, and ultimately they all lead to the LADA. So the potential this is the potential pathological mechanism for LADA. So what is the contribution of type 1 and type 2 to all cases? We know that 90 to 95% patients are of type 2 diabetes, 5 to 6% patients of type 1, but there is some overlap between type 1 and type 2. So the key difference between type 1 and LADA is not the age. So we can see LADA even at the age of 45 or 50, but the gradual way of the disease progression, and most cases with LADA are aged more than 35 years. So the diagnostic features for LADA, they're aged 30 to 35 years, presenting as non-obese type 2 diabetes, initially controlled with diet plus oral antidiabetics, early failure of the oral agent. So maybe over a period of 1 year, 2 years, they might not be controlled with OADs, and they may require the insulin therapy. Most type 2 diabetic patients do well on the oral agent for several years, but not the LADA patients. So the insulin dependency within months is a diagnostic feature or is a clinical criteria for LADA. Ketosis may or may not be present, low fasting and stimulated C-peptide levels, no clinical diagnostic criteria, anti-GED antibodies and eyelid cell antibodies positive. So to differentiate between type 1 and LADA, yes, we can differentiate with the age of diagnosis. Usually the LADA is more than 30 years, whereas the type 1 is in the childhood. Autoimmunity severely increase in type 1, but it is also there in LADA, not in type 2. Onset of type 1 is acute. Usually children, they present with a decay, whereas it is not the case with the LADA. Insulin dependence in type 1, it is at the onset, whereas in LADA, it may take 4 to 6 months, even years. And BMI in type 1 is underweight to normal, whereas in LADA, it is normal to overweight. Risk of metabolic syndrome, there is nothing in type 1, but in LADA, there may be increase. So another form of diabetes which we see in young population, the type 1, the type 2, early onset type 2, MODY, LADA, and then this is secondary form, FCPD. So for the FCPD, patient should be from a tropical country. Diabetes should be present, evidence of chronic pancreatitis, abnormal pancreatic morphology on the USG or the CT scan. Patient usually present with recurrent abdominal pain and steatorrhea. Abnormal pancreatic functions and absence of other causes of chronic pancreatitis indicates that this patient might be having FCPD. So coming on to the entire how to make a differential diagnosis, if you have a patient of the onset of diabetes less than 35 years of age, what to do? First and foremost, we should go for a family history of diabetes. If it is positive, and if this family history is positive in 3 generations, and ketonuria is absent, C-peptide is good, response to the oral drugs, it is MODY. You can have a rough guideline from this graph, and then you can send the sample to the genetic testing, though it is costly. But if you feel that you have a clinical diagnosis of MODY, you can send for the genetic testing. If the family history is positive, but it is not present in 3 generations, ketonuria is absent, C-peptide is good, and patient responds to oral drugs, he may be early onset type 2 diabetes, and you can have the peripheral markers of the insulin resistance like acanthasis or least intakes. But you have a negative family history and ketonuria is positive, C-peptide is absent, that indicates that patient is type 1, and then we can go for autoantibodies. It may be antibodies negative, so it is idiopathic. If antibodies are positive, it is autoimmune type 1 diabetes. So if the family history is negative, ketones are absent, C-peptide is poor, but if we go for abdominal X-ray, we can find that the pancreatic calcification. Pancreatic calcification at the level of L1, it is indicative of FCPD. And if the pancreatic calcification is absent in the abdominal X-ray and pancreatic calculi are not present, we can think of MMDM. So in this way, suppose we have a patient of young onset type 2 diabetes, we can differentiate not type 2 diabetes, but young onset diabetes, be it type 1, be it LADA, be it MODY, be it early onset type 2 diabetes, on the basis of some just a good history, pedigree, as Niyal was saying, a pedigree history, family history, patient's history, clinical examination, then comes the investigation, and baseline investigation, not very very high-fi or very costly investigation. Initially, on the basis of that, you can have a judgment that this patient might be from this category. Then for a confirmation diagnosis, you can go for the investigation, maybe antibodies, maybe genetic testing, and just a plain X-ray might help in some patients of FCPD. So the complication, if we see in the early onset diabetics, is associated with a greater lifetime risk of diabetes complication because they have to live long with that diabetes. So like they are uncontrolled. Suppose a patient developed diabetes at around 27 years, 29 years, and the life expectancy is 80 years. He has to live with his life for almost 50 years. So the chances of developing a complication with the longer duration of diabetes are more in this younger population. And the young onset type 2 diabetes is a much more frequent occurrence of the macrovascular and microvascular outcomes and more rapidly progressing severity of complications. Additionally, impaired hearing, reduced fertility, risk of premature decline in cognitive functions, psychological issues, they are frequently observed in these type 2 diabetics, and these can be substantially reduces the quality of life. So if we come back to our 4 patients, those have a similar FPG, similar PPG, similar A1C. If we see this is a 10-year-old boy who was autoantibodies positive, absent C-peptide, diagnosed as a type 1, this 18-year-old girl, overweight, obese with the markers of acanthosis on just family history as type 2 diabetes, a 15-year-old girl with the same FPG, PPG, and A1C, but a 3-generation history of diabetes, no peripheral marker of insulin resistance, indicates it is a monogenic diabetes, and a 20-year-old man with the FPG, PPG of the same range of the A1C of 10.2, but a pancreatic calcification, a history of steatoria, history of chronic abdominal pain indicates that this patient is FCPD. So we can differentiate on the basis of that. So to summarize and conclude, the phenotype of young onset of diabetes, if we see the stronger family history, greater association with obesity, early loss of both first and second phase of insulin secretion, early onset and rapid progression of micro and macrovascular complication, poor sustainability of responsive to the oral glucose-lowering therapies, and frequently necessitating early introduction of insulin. So exploration of more effective ways to implement preventive lifestyle measures in the family setting and to improve the health education in the school curriculum, because like the pathogenesis of the early onset type 2 diabetes starts from the school-going children. We can find the school-going children or adolescents who are in the 7th or 9th grade. They are obese, they are having a belly fat and more of visceral fat, and these are the kids where we can work on prevention of diabetes to prevent diabetes in the later life in the elderly or the younger age. Thank you very much for the patience here.
Thank you very much, sir, for that lucid presentation. And we have close to 600 viewers for this lecture. There are many questions, but due to already we are lagging behind, I'll just ask one question which I found that it was relevant. One of the delegate has asked that a young patient, adolescent, with typical features of type 2 DM presenting as high sugars, say 300, 400, what would you suggest, OHA or insulin at the beginning?
Yes, so in young patient, irrespective of diagnosis, the patient is come with the higher sugar, 300, 400, the patient is symptomatic. Ideal recommendation is insulin, irrespective of diagnosis. We can make the diagnosis later on, but ideally in this type of high sugars, we should start with the insulin therapy. Let's control it first with insulin therapy, be it type 2, be it type 1, and then we can make a diagnosis.
Okay. Thank you, sir, for that apt answer. As we are running late, I'll just quickly move forward to the next session.
Thank you.
So for next session, we have Dr. Satyanath Mukhopadhyay, sir. He is a DM endocrinologist from Kolkata. He is professor at IPGMR. He has various publications, more than 270. And he was my examiner also for the DM final examination. Welcome to you, sir. The stage is yours. He'll be speaking on secondary diabetes in young.
Thank you, Mayur, for the nice introduction. In these days of virtual meetings, meetings rarely run late, but here we are 90 minutes behind schedule. So without wasting much time, let me share my screen. And before I start, let me tell you that my talk will essentially be a recap of what the three other speakers have already alluded to, because there'll be a considerable overlap between the topics dealt with by them and the topic what I'm going to cover in the next 15 minutes or so. Now, by the term young, I have taken a cutoff age of 30 as less than 30 years young. So all my cases will be having an age of onset of their disease less than 30 years. This is the definition for secondary diabetes, which is either due to destruction of the pancreatic beta cells of genetic or environmental origin, or insulin resistance, and sometimes a combination of the two. And you can run down the list to see exocrine pancreatic disorders, the endocrinopathies, drugs, and so on and so forth. And these are the genetic syndromes, some of which have been covered by Dr. Nihal and Dr. Pandey. So there will be some overlap. I will try to rush through. Dr. Nihal had taken us through one case of Bardet-Biedl syndrome in a boy, and here is a 9-year-old girl with the same Bardet-Biedl syndrome, mental retardation, obesity, diabetes. You can see acanthosis here. And
Sir, sorry to interrupt, but your
okay, now can you see?
Yes, sir. Yes, sir. Perfect, sir.
Sorry for the delay. So these are the lists of conditions that give rise to secondary diabetes. The genetic syndromes have been covered by almost, I say partly, fully by Dr. Nihal. So Dr. Nihal shared with us a boy with Bardet-Biedl, and here you have a girl with Bardet-Biedl. Similar presentation, acanthosis, obesity, mental retardation, postaxial polydactyly. This is slightly different. So presenting with weight loss, osmotic symptoms, uncontrolled hyperglycemia, and you can see partial ptosis, muscle atrophy, and the typical EMG of myotonic dystrophy. This man also had problem with hypogonadism. So myotonic dystrophy. This was the first presentation in the literature of a case of Friedreich's ataxia presenting with diabetic ketoacidosis. Acromegaly presenting with secondary diabetes. So that's endocrinopathy causing diabetes. Typical pituitary Cushing presenting with diabetes secondary to insulin resistance. Thyroid disorders, both hyper and hypothyroidism, can give rise to glucose intolerance and diabetes. And here are the prevalence data for you. So in hyperthyroidism, catecholamine excess causing both insulin resistance and insulin secretory defect can give rise to diabetes. But at the same time, the hyperthyroid state accelerates the degradation of insulin and also promotes faster insulin absorption from the intestine, thereby causing hyperthyroid state. And hyperthyroidism may also come up as part of a polyglandular autoimmune syndrome, decreased GLUT4 expression, and some polymorphism involving the D2 gene causing abnormal local T3 production, which impairs glucose disposal, have been touted as the cause of insulin resistance and diabetes. In hypothyroidism, FCPD has been discussed in details. I will skip. So this is a typical X-ray picture. Pancreatic calculi, ductal dilatation across L1. Here you can see dilatation already covered. What has not been covered possibly is this. The pancreatic cancer can arise out of fibrocalculous pancreatic diabetes. And here you can see pancreatic cancer, huge mass there in the setting of FCPD. And in this brief communication, we have actually presented data on 3 such cases of pancreatic carcinoma under our follow-up. Now, here is a patient who presented with superficial thrombophlebitis, which usually gives you a clue as to look for underlying malignancies, mainly pancreatic malignancy. And this patient had developed diabetes all of a sudden. And so diabetes, presented with diabetes, superficial thrombophlebitis, so which led us to think about some pancreatic pathology. We did an image of the pancreas, and here you can see early pancreatic cancer. So in this patient, fortunately enough, an early pancreatic cancer could be detected because of the presentation with diabetes and superficial thrombophlebitis, and a complete excision of the pancreatic mass was possible. So that was what was presented here. Thalassemia, again, can give rise to both insulin resistance and insulin secretory defect, causing diabetes, as you can see in this 20-year-old male. But what is interesting here is that if you do an HbA1c, it will not give you any clue as to the kind of hyperglycemia that the patient has, because your HbA1c tends to co-elute with hemoglobin F, as is the case here. So after seeing hyperglycemia, somebody ordered HbA1c, and this was the result. So you cannot really depend on HbA1c to look at the degree and duration of glycemic derangement in a patient presenting with diabetes in the background of thalassemia. And if you look carefully across this panel, you can see the variant window, where the value you can see is the area under the variant window is so significantly increased, which actually points towards co-elution of hemoglobin A1c with hemoglobin F. So here's the data for diabetes in thalassemia, 10-year study. As you can see, as the years go by, so does the prevalence of dysglycemia. Now, diabetes and primary infertility in young males, should not forget cystic fibrosis. And again, we presented, published a series of 4 such cases. And here you can see one of them, 32 years male, male factor infertility, and then a low C-peptide, initially managed on glipizide and metformin. Again, HbA1c can be spuriously low in cystic fibrosis-related diabetes. So your diagnosis has to depend on an OGTT, which is the gold standard. The cases can present in a spectrum like normal glucose tolerance, impaired glucose tolerance, then cystic fibrosis-related diabetes without or with fasting hyperglycemia, and finally full-blown diabetes. Insulin is the mainstay of treatment. Some of the patients in the early stages of the natural history of the disease, in presence of some pancreatic beta cell disorder, may respond to meglitinide analogs. MODI has been discussed. So here is one HNF1 beta MODI for you. Then you have a glucokinase. We now have data on a series of glucokinase positive memory, which has been recently published by our group. Down syndrome. This is interesting. It can present with both type 1 and type 2 diabetes. On the left, you see a Down syndrome with type 1 diabetes, autoantibody positive. On the right, you see Down syndrome with autoantibody negative acanthosis plus father having type 2, and this gentleman is having type 2 diabetes. This has been alluded to by Dr. Nihal, also lipoatrophic diabetes, 14 years girl, primary amenorrhea. You can see BMI of 11, high triglyceride with a low HDL cholesterol, acanthosis, and see pronounced loss of body fat. Even the buttocks lack body fat, for the fat is believed to be usually preserved, a significant lipoatrophy. This thin girl also had evidence of fatty liver and polycystic ovaries. They can also have liver fibrosis, as Professor Nihal already told us. So this is kind of presentation like pseudoacromegaly in the Berardinelli shaped syndrome. This is another rare presentation of secondary diabetes in young. Here you can see exuberant hair, hirsutism, and characteristically a double row of teeth present here on the lower jaw, which is a typical finding seen with this syndrome, Rapson-Mendenhall, and they have extreme insulin resistance. This has been discussed, deafness, then sensory neural deafness, and then bilateral optic atrophy, blindness, no hypogonadism. Here you can see primary optic atrophy, retinitis pigmentosa. Similar case was shared by Dr. Nihal also. Autosomal dominant polycystic kidney disease and diabetes, no DKA, hypomagnesemia is considered characteristic, and some of them have also been associated with elevated uric acid level. So this is our experience. This is pre-COVID, pre-2018 data. Actually, the numbers have gone up appreciably since then. So you can see your secondary diabetes, 4 cases of Modi then, now it's 9, glucocorticoid induced, 1 Friedreich's ataxia, then your Cushing's 5, acromegaly, lipodystrophy, cystic fibrosis. As I said, it was then 1 case only, but now we have 3 cases which you have reported. Bardet-Biedl syndrome 2. I think that was the last slide. So thank you for listening, and I'm open to questions.
Thank you very much, sir. Thank you for that excellent presentation. We have too many questions, but already we are running late. So I'll just ask 2 brief questions from all those questions being asked. One delegate has asked how to evaluate, or rather genetic evaluation in a patient who is having recurrent pancreatitis. The other one has asked regarding fetal elastase versus fecal fat in FCPD.
Yeah. So let me take the second one first. The fecal elastase actually has been found to be more sensitive and more specific than stool fat estimation. And then Dr. Shuja Ghosh in his lab at our institute has recently published data on fecal elastase in a series of more than 100 cases of FCPD. But due to time constraints, I could not project his data. So that's about the second question. And going back to the first, genetic screening strategy for pancreatitis. In general, pancreatitis per se does not demand genetic screening. If pancreatitis is associated with diabetes, chronic pancreatitis, not acute pancreatitis. So chronic pancreatitis with diabetes, image the pancreas. If you see pictures characteristic of FCPD, that takes care of the situation FCPD. But if you get hypoplastic pancreas, as Dr. Nihal was alluding to, then you need to run a genetic panel to see whether the patient is suffering from one of the monogenic causes of diabetes. Thank you.
Okay. Thank you. Thank you very much, sir, for answering those questions. As we are running late, I'll move on to the next session. So For the next session, we have Hormone India repertoire, Dr. Pankaj Gupta. He has done his DM from Shere Kashmir, and presently he is heading Hormone India Gwalior Center. Over to you.
Thank you, Mayur. And so far we have wonderful talks, very interesting talks we already have. And we have discussed about technologies in diabetes, type 1 diabetes, various aspects in detail, various monogenic form of diabetes and diabetes in special circumstances like adolescent diabetes. So we will move on to next session. In this session is dedicated to diabetes first diagnosed in pregnancy and management of steroid-induced hyperglycemia. So without taking much time, we will proceed for the session. And I will invite Dr. Kailash. Kindly give a brief introduction of Dr. Yajnik sir and start the session. Dr. Kailash, are you there?
Yeah. Good afternoon, everyone. Whether I am audible or not?
Yeah, you
yes,
are audible.
Sir, you are audible.
You are clearly audible.
Okay. Good afternoon, everyone. Dr. Yajnik is well-known figure in diabetes. He is the director of the diabetes unit at King Edward Memorial Hospital and Research Center in Pune. He trained in Pune and in Oxford, UK, and investigate the high susceptibility of Indians to diabetes and related disorders. He is known for his description of the thin fat Indian, high body fat present at low BMI, and its intrauterine program by maternal nutrition and metabolic factors. He is the current president of the SNEHA India and a trustee of the International Society. He is an honorary visiting fellow. He received certain awards, international and national. He is going to discuss about the controversies in GDM. You know, GDM, there are a lot of controversies regarding diagnosis, cutoff point of the blood sugar level, and the treatment. Dr. Yajnik, please.
Thank you, sir. And I'd like to show my slides. So, okay, Mayur and your team, the chairpersons, thank you very much for inviting me. Slightly provocative topic, and I'm going to say things which have really bothered me over the last many years. And I won't go into many details, but I'm really proud that mine is the only diabetes unit in the world where the logo is mother and baby. And this has been even before I met David Barker because of my interest in gestational diabetes. Recently, I read this interesting book, The Elephant in the Womb, and I thought that was great because that's what we are really talking about. So evolution of the concept really started with NDDG meeting in 1979. And they actually took into notice all the Sullivan and Oman data, which said that pregnancy glycemia associated with later diabetes. But later on, the same group said that actually that can also affect the pregnancy outcomes. And therefore, it's a different entity than just being a precursor to future diabetes. A lot of physiology was tested then, and people described that insulin resistance in the mother was high at 24 to 28 weeks. And therefore, that was the time decided for doing a glucose testing. As time went by, people described both short-term and long-term outcomes in the condition, both in the mother and the baby, which we all know about. However, many times people have described cut points or criteria without any outcomes in consideration, like WHO did in 1985 and 1999. They just took non-pregnant IGT as gestational diabetes. Subsequently, the Chicago group and collaborators across the world did the HAPO study, developed the IAD-PSG criteria, which WHO and ADA have now accepted, and the outcomes are based on macrosomia, as we will see. And finally, the very interesting questions are the outcomes preventable or not preventable? And is there genetic or epigenetic issues involved in this? So this is what Norbert Frankel from Chicago proposed as a problem in the diabetic pregnancy, fuel-mediated teratogenesis. And this word is very similar to what David Barker described as programming. So Norbert Frankel said we know of teratogenesis as abnormalities of development, but even large size birth and body size abnormalities later in life are part of teratogenesis. And that is how he put his fuel-mediated teratogenesis idea. In the same oration, he also drew this figure where he distinguished between pre-gestational and gestational diabetes, saying that gestational diabetes is largely a third trimester phenomenon. And I'm going to challenge this concept. So I wrote an editorial in Diabetes Care in 2010. They invited me to write about fetal programming of diabetes. It's quite an interesting and big editorial. I've just chosen some points here. Okay, do we really know what glucose levels are good or bad in pregnancy for mother or baby? Then we diagnose so-called gestational diabetes in pregnancy and think that it goes away. And we think it wasn't there before. But is it really a de novo diabetes of pregnancy? If there is an element of pre-gestational problem there, then to diagnose so-called gestational diabetes in pregnancy is then too late, because the periconceptional programming which determines the non-communicable risk for the baby is already over. And finally, we are going to see who benefits from treating GDM, mother, baby, in short and long term. And by treating GDM, we always hope that we are going to prevent the diabetes pandemic in the young children and the next generation. Do we have any evidence for that? So do we really know what is diabetes in pregnancy? And diabetes usually in our mind is a yes or no thing. There is a cut point. Now, HAPO study showed beautifully that the association between maternal glucose and the outcomes which they measured, which is large baby, cesarean section, neonatal hypoglycemia, or the 90th centile, are all continuous and monotonic, both for the fasting glucose and 2-hour glucose, and also for 1-hour glucose. So there is a continuous association. There was no indication at all that there is something called diabetes, which is different than the normal distribution. So there was no threshold. The current criteria are based on HAPO, and they are based on outcomes which are largely related to large baby and the problems it faces, like cesarean section or high C-peptide in the cord blood. And ultimately, a statistical committee sat and arbitrated about the criteria. So what we use today are statistical arbitration. In last 2 years, 3 years, 3 trials have been published. There has been a trial for a randomized clinical trial of gestational diabetes screening by the one-step approach, which is doing the 75-gram oral glucose tolerance test as the first investigation, or the classic thing that you first do a glucose challenge test with 50 grams, and then only in a limited number, you do a 100-gram oral glucose tolerance test. In this study, we will see what they found. So here they are doing 1 step against 2 step comparison. Recently, Caroline Crowther published from New Zealand 2 criteria for gestational diabetes. One are the IPSG criteria, which are much more like say intensive and lower level, versus the ADIPS criteria, which are used in New Zealand and the Australasian countries. So 99 and 162. So low versus high glucose. And the third trial was early gestational screening versus routine gestational screening, which is before 20 weeks and after 20 weeks. What did these 3 randomized trials show us? In the 1-step versus 2-step, whether you diagnosed by 1-step a larger number of diabetes, which was almost 3 times higher than the 2-step, in the 2 separate arms of this trial, there was no difference in the LSCS delivery prevalence, preeclampsia in the mother, no difference in LGA, SGA, preterm birth, or shoulder dystocia. Only thing which was higher in the 1-step was the neonatal hypoglycemia incidence. The composite outcomes were similar in the 2. In the Crowther trial, lower versus higher glucose, LSCS similar, preeclampsia similar, but the health service use was much more in the lower than the upper one. That means women were visiting this health services many times. The cost of pregnancy was much higher, and the neonatal hypoglycemia was also higher. So all other neonatal outcomes were similar. In the early versus routine screening, no difference in any of these measurements in the 2 groups. In other words, whether you do 1-step or 2-step, lower or higher glycemia criteria, or early or routine screening, whatever we do to the baby and the mother, to the mother and the baby, doesn't make any difference, except that in certain circumstances, there is a lot of hype around the condition and excess use of health services. So then second issue is, are we really dealing with a gestational abnormality? And now there is a new fad, I put it into inverted commas, that this 24 to 28 weeks is too late, so let us diagnose it before 20 weeks. So diagnosing it early, and we saw what was the result of that trial. There's also a controversy whether only glucose is responsible for the problem or non-glucose markers like lipids are also involved. We won't go much into that. So a whole lot of markers have been described which can be measured in the first trimester, and they vary right from RBP, that's retinol binding protein 4, SHBG, FABP4, adiponectin, risfatin, various miRNAs, various other protein molecules which claim to diagnose gestational diabetes in early pregnancy. It's quite interesting that glucose doesn't appear here, which would be really very simple to measure and actually easily done in any laboratory. But I suppose there is a whole lot of industry around this. So what they are saying is women who had abnormal levels of these molecules were more likely to be diagnosed GDM between 24 and 28. I am a DOHAN specialist, that's Developmental Origins of Health and Disease. And this is an intergenerational and many times a transgenerational, that's more than 2-generation transmission. And this is predominantly environmental than genome and based on epigenomic changes which happen periconceptionally, which in turn affect fetal growth, development, and differentiation. And David Barker picked up on low birth weight, but there are many other aspects. And then subsequent sort of epigenetic changes. What we are saying is the blueprint of the future is already decided very early in pregnancy. And are there any DOHAD markers for risk of gestational diabetes? Low birth weight is a strong risk factor for gestational diabetes. Being short is a risk factor for gestational diabetes, and being short arises out of poor intrauterine linear growth as well as poor pubertal growth. So in other words, what we are saying is woman who is destined to become gestational diabetic already had intrauterine problems, already had pubertal and early life growth, linear growth problems. And in a study which was published from the Kaiser Permanente, they had these many thousand women who were diagnosed as gestational diabetes in their clinic, and many hundred of them had visited them for a whole body checkup many years before. And what they found was woman who was diagnosed as GDM was slightly older. She had a higher family history of diabetes. Her BMI was higher 10 years before pregnancy. Her glucose was higher. Her cholesterol was higher. Her insulin resistance was higher. And everything was actually suggestive of metabolic syndrome. In other words, though she was diagnosed as GDM pregnancy, she had all the abnormalities many years before. I developed this Pune maternal nutrition study in 6 villages near Pune in 1993 with help and collaboration from David Barker and Caroline Fogg from Southampton. And we have now 25 years follow-up, and third generation is being born. And we have serial data on body size, body composition, metabolic abnormalities, cardiovascular risk factor, neurocognitive markers, and very high follow-up rates. Therefore, we are able to talk of various things in a life course model, which not many departments in the world can do. We have also an extensive biobank from the beginning, which has many different biological samples in our biobank. At 18 years of age, in these village boys and girls who had an average BMI of 19, there was 29% prevalence of diabetes. It was twice as much in males compared to the females. So roughly you can say 20% in females, 40% in females. Like it was commented before, IFG was relatively more common, especially in boys. IGT, relatively less common. 2 girls had diabetes. One of them had MODY. The other one, we don't know what type it is. Lot of nutritional deficiencies I have shown for B12. Almost half of the population was B12 deficient. And if we look at these boys and girls who had pre-diabetes at 18 years of age and compare them with those who were normal glucose tolerant at 18 years, we can see that these pre-diabetic boys and girls had higher glucose at 12 years of age, higher glucose at 6 years of age. Their insulin concentrations were similar. Therefore, those who were diagnosed as high glucose in pregnancy had higher glucose in childhood and early puberty. Like Kaiser Permanente study, I mean, this is of course a community-based prospective work. So we are on much stronger sort of footing. And if we look at predictive value of fasting glucose at 6 years and 12 years, higher fasting glucose at 6 years increased the risk of prediabetes at 18 years 3 times and 6 times for 12 years. So there is a strong prediction of prediabetes at 18 years by fasting glucose at 6 and 12 years. And additional risk factors for prediabetes were short birth length and small head circumference and non-overweight mother. In other words, mother with a relative undernutrition and poor fetal growth, especially the linear growth. On this background, it was very interesting that pre-diabetic children's mothers had higher fasting pregnancy glucose, though by no means it was in gestational diabetes range. It was higher of the normal. So there was a double burden of malnutrition in utero related to poor linear growth, but higher exposure to glucose within normal range from the maternal side. And we also measured miRNAs in childhood and adolescence, and we have found markers in miRNAs which are predictive of glucose intolerance at 18 years of age, suggesting epigenetic mechanisms are already at action. Now, the girls in the cohort are now getting married, and we have data on approximately 200 pregnancies in the F1 generation, and we have information on their children and their cord blood. And interesting thing is, if we look at pregnancy glycemia in these F1 generation girls and divide them into higher quartile of fasting glucose versus the remaining 3 quartiles, the fasting glucose divided by this higher glucose in pregnancy again tracks back to 18 years, 12 years, and 6 years of age. In other words, what we call high glucose in pregnancy was already there in childhood, in early puberty, and early adult age. Though their height was similar, their BMI was marginally higher right from early age, though it's very much in the underweight region in the early years. But subsequently, after pregnancy, they continue to put on weight. And this is how within a life course, a double burden of malnutrition arises. No difference in HOMA sensitivity and HOMA beta in early age, but disposition index, which is beta cell function in relation to prevailing insulin sensitivity, was low right from 6 years. In other words, girls whom we would diagnose pre-diabetes in pregnancy for GDM, they had poor beta cell function right from childhood. And it's very interesting that one of the epidemiologists from UK, whom I respect because I trained there, he had said in 1993 that gestational diabetes woman is a woman with glucose intolerance who is also temporarily pregnant. And that's what actually we can now show in this prospective report. So we, of course, have a lot of diabetes in the world now, in the young people and gestational diabetes. And you know, India comes out as highly colored state everywhere. So what are we really doing? By diagnosing more and more of gestational diabetes, either by one step or reducing criteria or doing it early. Aldous Huxley actually quite sarcastically said, medical science has made such tremendous progress that there's hardly a healthy human left. And that's what I think we are moving towards. So who benefits by diagnosing GADM and its treatment? And this, consider this as an audit of current practice. There are 2 major trials of conventional versus intensive treatment of GDM. One ran by Caroline Crowther from Adelaide. That's called ACCOY trial. That was published in 2005. And London's multi-center US trial, which was published, I think, in 2009. What did we find? Treatment of GDM intensively reduced preeclampsia in the mother. Cesarean deliveries were almost similar. Induction labor was higher in a trial, indicating probably a lower threshold on part of the doctor because they were told that woman has gestational diabetes. For the child, serious perinatal complications were reduced in a ACCOY trial, not in the London trial. SGA was similar. LGA was reduced and macrosomia was reduced. In other words, three things which improved during pregnancy is one is in mothers, there was a reduction in preeclampsia, and in the child, there was a reduction in the birth weight. So the LGA and maxomic children were reduced. There was approximately 200 grams reduction in the birth weight. Then these children have been followed up in a COI trial at the time of school enrollment, and there was no protection from childhood obesity measured either as BMI or weight or BMI more than 85th percentile. Resoundingly no effect. In London trial, in addition to body size, and they also measured hypertension, low HDL, elevated triglycerides, impaired fasting glucose, and 3 measures of body size. No difference. In other words, there was no benefit to the child against either diabesity, that means diabetes risk, and obesity adiposity. And this, I think, is really worth thinking, because people make big claims by saying that we'll diagnose GDM and we will prevent the pandemic of diabetes in the next generation. We have followed up 200 children born in my department over the last many years in diabetic pregnancies. What did we find? And I can assure you, given my training in this, we have treated all these pregnancies intensively, though not in a randomized trial. For those who were more 10-year-old at time of follow-up, average age 15 years, there was 5% diabetes and 37% pre-diabetes. That means 42% of 15-year-old children born in diabetic pregnancy were either diabetic or pre-diabetic, as opposed to 20% in those born in non-diabetic pregnancies. And for younger children, where we measured only capillary blood, it was much higher from as early as 2 years of age. In other words, whatever we are doing in our clinic is not in better outcomes in the children. What might be the reason for this? As I said, I am a staunch DOHAD believer, and I believe in periconceptional period as being the most important period in the life course where future risk is determined. The processes which are involved in this are gametogenesis, fertilization, implantation, embryogenesis, and placentation. And all of them are over within a period of 72 hours to 1 week since conception. And this is a fantastic figure coming from Cambridge about how DNA methylation is completely wiped out in first 24 to 48 years. It is re-established, again wiped out, and re-established, which is what actually determines the future risk of various conditions. Louis Walpert, a noted embryologist from UK, said it's not birth, marriage, or death, but gastrulation, which is truly the most important time in your life, and that is somewhere here. That is where the 3 germinal layers are laid down and their fate is determined. We have done epigenetic studies in the cord blood and the young children and found very interesting epigenetic markers which are imprinted very early in pregnancy and which are associated with glucose intolerance and obesity in the children. I am not telling you the markers just now because it's being published soon. Now, what about Indian scenario? Majority of pregnancies are unplanned. So by the time they come to the doctor, it's many weeks into pregnancy, much beyond the periconceptional period. We know there is a high prevalence of prediabetes in the young, data from Pune, and the national report on the nutrition, which was published in 2017, which showed amazingly high prevalence of prediabetes in children between 5 to 10 years and in adolescents between 11 and 19 years. GDM, as diagnosed, is a big burden. Once you diagnose it, the medical thresholds are lowered, costs are increased, cesarean sections are increased, investigations increase, a whole lot of things start happening. There is a substantial inequity in rural, urban, and socioeconomic classes for diagnosis and treatment of this condition. The average national birth weight in India is 2.8 kg, even NFHS 5. In NFHS 4, where data is now available, low birth weight was still between 15 to 25% in different states. In diabetes unit, like where I am, the offspring of diabetic mothers usually have 100 gram extra weight than this. LGA in my department is less than 10%, in fact, actually only 4%. SGA is not uncommon, and there are very few follow-up studies and no RCTs of GDM treatment in India. So really, we are looking at GDM like the story of 7 blind men looking at the elephant. And there is also this elephant in the womb, which is asking us to do more studies and come up with answers. Many years ago, Barbara Corky wrote this piece in Diabetes Care saying, have we got it all wrong for diabetes? And I have a feeling that we need to investigate this for GDM. Lois Javonovic, the very noted name in diabetes pregnancy, one of my mentors. You can see here, I was with her and I convinced her about SGA in diabetes in pregnancy, which she didn't believe till then. So she wrote this piece in Diabetes Care saying, never say never in medicine. And I'll read the last paragraph. She said, I never imagined that the strategy to ignore maternal glucose in women who are carrying fetuses predisposed to intrauterine growth retardation and thus allow maternal hyperglycemia to remain untreated in order to encourage more accelerated fetal growth would be added to this list. Pat Catlano, another of my mentor, said that achieving optimal metabolic control before planned pregnancy may offer the best, but not necessarily the easiest option to achieve a healthy pregnancy outcome in short and the long term. So my take-home messages for you will be, A, there is a lot to learn. We go to meetings and we think of various things and people very vehemently propose various things. Most of it can be challenged and needs to be tested. We need to be sensitive to local situations and remember Indian babies 2.8 kg, American babies are 3.6 kg, and we are accepting all their advice without challenging anything. Diagnosing GDM in pregnancy is too late, so I think the category of GDM is under threat. Preconceptional detection and correction of metabolic abnormalities is the only way to go, and that means from clinic we have to go to the community. That's where I end my talk. Very happy to take any questions and criticism. Thank you. Thank you, Mayur, for this excellent meeting.
Thank you, sir, for the wonderful talk. And as we can conclude from the presentation, GDM not only poses immediate or postpartum risk to fetus, but it is also responsible for metabolic memory of the fetus. So it will decide the future course of that newborn, and maybe he is predisposed for with increased risk of metabolic syndrome, diabetes, and other issues. So thank you, sir, for unveiling many facts and sharing studies and decades of data collection for consecutive generations, sir. Thank you, sir. Now we will proceed to our next talk, and I will invite Dr. Simi Dubey, madam, to introduce our next speaker and proceed for the session. Simi Dubey, madam, and I am your student. I trained under you during post-graduation, and this was my honor to get trained under you.
Thank you.
Please take on, madam.
Yeah. Thank you, Dr. Pankaj. And I extend my congratulations to Mayur for organizing this beautiful and very informative conference. And thank you having me at this meet. So Dr. Sunil Gupta is an eminent national faculty who don't need any introduction. And very soon we may see him as a vice president of RSSDI. So he's practicing diabetologist at Nagpur, and he has many rewards and awards in his, in his pocket, and he's very well known. And now I invite him for his talk on the management of gestational diabetes mellitus. Welcome, Dr. Gupta.
Thank you, madam. Thank you for your kind introduction. I'll just take 30 seconds for uploading my slides. Yes, hope my slides are, oh, I'm sorry. One second, I'll just, I had done something wrong here. Hope my slides are visible and they are full screen.
Yes.
Yes. So thank you very much. It's always an honor to be there, sharing a dais with Dr. Professor C.S. Yaznik, sir. And thank you very much, Mayur. Thank you, madam. Yeah. My today's talk is on management of GDM, and I'll be very, very brief in focusing on some slides on introduction, glycemic targets. What are the targets we have already fixed and across the globe, which is being followed. There's some slides on glucose monitoring. How should we monitoring these cases, and the management part and the carry home masses. Thank you and congratulations, Mayur, Ajay, Tony, and the team of Hormone India. No conflict of interest for this particular session. There's almost multiple thousand years of from now that Chanakya has said that when a life gets seeded in a mother's womb, its age, deeds, wealth, education, and death all are determined right there. And then what Dr. Yaznik has also said, the body's susceptibility to lifestyle disease was programmed intrauterine. Gestational programming is a process where we have just heard from Dr. Yaznik that whereby the stimuli or the stresses that occur at the critical or sensitive period of fetal development permanently change the structure, physiology, and the metabolism, which predisposes an individual to disease in the adult life. And that's why the concept of fetal origin of adult disease. With this background, we understand that even a mildest degree of hyperglycemia might be detrimental for the baby. It may have epigenetic changes, and the exposure to a diabetic environment in utero is associated with increased occurrence of impaired glucose tolerance, defective insulin secretory response in adult offspring, independent of the genetic predisposition. And now let us come to the clinical part of it, that hyperglycemia in pregnancy is being divided into two: diabetes in pregnancy and gestational diabetes. These are the FIGO guidelines, where they have actually, I'll just take the laser pointer here. Yeah. So, yes. That you have one is diabetes in pregnancy, it's a gestational diabetes. We are today focusing on GDM, which is typically appearing in pregnancy, may disappear after delivery. Diabetes in pregnancy is those group of individuals who might be having pre-existing type 1 or type 2 diabetes, and they're becoming pregnant. And the same group, but which was diagnosed during the pregnancy for the first time, and that is actually pre-existing diabetes. So they are also being classified as DIP. Because the treatment or management strategy in DIP differs quite significantly versus the management of gestational diabetes. We have Government of India guidelines, which are published in 2014 and 2018 for management of diabetes, and they recommend that 75 gram glucose to be given orally, irrespective of the time of the meal, maybe fasting or non-fasting, and take 2-hour test. If it is more than 140, we call it GDM. If it is less than 140, it is normal. Now, when we talk about management, we should be knowing about the glycemic targets, and it's almost 20 years, from 30 years from now, when St. Vincent Declaration said that achieve a pregnancy outcome in diabetic mother that should approximate that of the non-diabetic women. Now, let us understand what is the normal blood glucose in non-diabetic pregnancy. And this is the CGM data. The fasting never exceeds around 70s, 1 hour 109 mean, and 2 hour 99, and 24 hours around 88. So this is what is non-diabetic glycemic sugars in pregnancy. And that is why the recommendation says the fasting should be less than 90, the 2 hours should be less than 120. Some of the school of thought they say fasting should be less than 95. But in gestational diabetes, practically fasting remains normal. Usually it is around 10% lower than the non-pregnant state. And that is why, because baby is continuously being fed and mother is taking meals intermittently. And that's why fasting blood glucose in pregnant women remains little on lower side if it is gestational diabetes. And gestational diabetes typically presents to you with postprandial hyperglycemia. So what is the role of HbA1c and CGM when you talk about monitoring? We should try to achieve HbA1c ideally should be less than 6. Less than 6.5 is also acceptable to have almost similar neonatal or the risk of congenital malformation. But anything above 7 is going to increase the risk of congenital malformation. Say if it is around 10 or 11, it comes to further higher. So the risk of congenital malformation increases significantly as the HbA1c goes above 7. 7 is acceptable as per the guidelines if there is a risk of hypoglycemia, especially in type 1 diabetes. So when you talk about preconception care or type 1 or type 2 planning for pregnancy, we should try to achieve 6, maximum 6.5. And in patient with higher risk of hypoglycemia, try to achieve less than 7 at least. There's a new matrix, which is a CGM matrix, where they now says the CGM matrix range of time and range for pregnancy is 63 to 140. And ideally, in type 1 diabetes, more than 70% of them should be having the TIR of 63 to 140, more than 70%. Time below range should be less than 4%, which is less than 63. Less than 54 should be less than 1, and time above range should be less than 25. This is for type 1 diabetes. For type 2 diabetes, they say the TIR should be more than 80% and not 70%. And this is the difference between type 1 versus type 2. And in GDM also, we expect it to be more than 80%. Now, what are the recommendations for use of HbA1c and CGM in pregnancy due to increased red cell turnover? A1c is slightly lower in normal pregnant women, and that's why versus normal non-pregnant women. Ideally, the A1c targets should be less than 6 if they can be achieved without significant hypoglycemia, but the target may be relaxed up to 7 if it is necessary to prevent hypoglycemia, the class B evidence. When used in addition to pre and the postprandial self-monitoring of blood glucose, CGM may help to achieve HbA1c targets better. When used in addition to SMBG targeting traditional pre and postprandial targets, CGM can reduce macrosomia, neonatal hypoglycemia in type 1 diabetes. There's no study in type 2 or GDM. CGM matrix may be used as an adjuvant, but cannot replace SMBG, which is gold standard in pregnancy diabetes. Emphasis and about HbA1c, when you estimate A1c, glucose management indicator, the calculation should not be used. Means we should not be using the POC device. Instead, the NGSP certified best method should be used. Emphasis on the daily frequency of HMBG should be made. We should, if it is a pre-gestational diabetes or some GDM requiring higher dose of insulin, you should always monitor fasting, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, and 3 AM blood glucose on a regular basis. Someone who's on basal bolus therapy. How to achieve these targets? Medical nutrition therapy and exercise. So almost 70% of GDM will do well with MNT and exercise. Few of them will require pharmacotherapy. Let us talk about pharmacotherapy. This is a trial, a European multicentric randomized controlled trial versus where they have shown physical activity versus healthy eating to reduce the risk of gestational diabetes. And they have shown that antenatal healthy eating intervention is associated with less gestational weight gain lower fasting glucose compared with physical activity alone. And these findings requires larger data to further consolidate this idea. This is about the exercise. This exercise data says the moderate intensity resistant exercise was helpful for improving blood glucose control, insulin use, gestational weight gain, and blood pressure. So physical activity means exercise as well as if permitted by obstetrician and MNT is important for GDM. Let's talk about the oral drugs. First is about metformin. Now, this is a meta-analysis where neonatal, infant, and childhood growth following metformin versus insulin treatment in women with gestational diabetes. And this is a systematic review which has shown that the following intrauterine exposure to metformin for treatment of GDM, neonates were found to be significantly smaller than neonates whose mothers were treated with insulin alone. Despite lower average birth weight, metformin-exposed children appeared to have experienced accelerated postnatal growth, resulting in heavier infant and higher BMI by mid-childhood compared to children whose mothers were treated with insulin. And that is why such pattern of low birth weight and postnatal catch-up growth have higher risk of having cardiometabolic diseases in adult life. And that is why there were little question on metformin. Then this is again a hypothesis that fetal concentration of metformin are equal to maternal. This is a fact. And the metformin can inhibit growth, suppresses mitochondrial respiration, have epigenetic modification on the gene expression. It will mimic fetal nutrient restriction and alter the postnatal gluconeogenic response. Because both placenta and the fetus expresses the metformin transporters and exhibit high mitochondrial activity, these properties, they raise important question about the developmental programming of metabolic disease in offspring. And that is why we say insulin remains the drug of choice. But we have then MITI trial, which is again a clinical trial and not the lab data here. MITI trial is those women who are already having type 2 diabetes and metformin is started pre-conception and continued delivery. And they have found that metformin-treated women achieve better glycemic control, required less insulin, gained less weight and fewer cesarean sections compared to placebo. Metformin-exposed children weighed less. Metformin-exposed children had reduced adiposities. But there is higher proportion for small for gestational age. Now, let us see what does the government of India says. It says that metformin or insulin is accepted medical therapy, medical measurement for pregnant women who is not maintained on MNT. Insulin is the first drug of choice, and metformin can be considered 20 weeks after gestation. Insulin can be started anytime during pregnancy, and if pregnant women and also those who are presenting to you GDM before 20 weeks of pregnancy and MNT fails. So metformin in Government of India's guidelines says it should be given after 20 weeks in GDM. These are recent guidelines of February 2022, where European group has approved metformin as a first oral anti-diabetic drug to be used even from the conception to birth. So this is the first government European guidelines which has approved it. What about sulfonylureas? Sulfonylureas are known to cross placenta and have been associated with increased neonatal hypoglycemia. The concentration of this glibenclamide or glyburide in placenta in umbilical cord plasma is of almost 50 to 70% of the maternal level. It is associated with higher rate of neonatal hypoglycemia, macrosomia than insulin or metformin. It has failed to show to found the non-inferiority to insulin-based composite outcome of neonatal hypo, macro, or hyperbilirubinemia. And unfortunately, the long-term safety data of glyburide is not available. That is why glibenclamide is not being commonly used in our country. Few of the people are using it, but it's being commonly used in US. What about insulin? There are some absolute indications for insulin therapy. Those who have high HbA1c, ketonuria, medical comorbidities like renal dysfunction, hepatic dysfunction, obstetric comorbidities, macrosomia, IUGR, hydramnias. These are the cases or sudden expected deterioration of the glycemic control, steroid therapy. Insulin remains a drug of choice. We have some data to share with you. Insulin in pre-existing diabetes, this type 2 diabetes, who there's possibly the data coming from this part of the country. Was the first data that you have in GGI. You have they are requiring insulin, gestational glucose intolerance, which is terminology where we use between 120 to 140 after giving glucose. So that's being classified as GGI. then GDM, and pre-gestational type 2 diabetes. In the first trimester, at the time of diagnosis, not first trimester, at the time of diagnosis, they require around 0.1 unit per kg body weight, GDM requiring around 0.25 unit, and pre-gestational type 2 diabetes 0.5 unit per kg body weight, with increase from 0.1 to 0.15, 0.25 to 0.4, 0.5 to 0.8. So almost 1.5 time increase in the doses of insulin as the pregnancy advances till delivery. This matches with most of the data coming from West. Insulin regimen in diabetic pregnancy. People use twice a day premixed insulin, but when it comes to gestational diabetes, I strongly recommend to go for frequent doses of prandial insulin rather than using the mixed insulin, because your fasting is usually normal, and many of the GDM will require very small dose of 3 times a day bolus insulin. There's a comparison between the basal bolus therapy versus premixed, and it was found that the glycemic control was better with the 4 times a day insulin therapy versus twice a day. Which are the insulin which are being approved? So irregular insulin, Aspart, Lispro, Detemir, and NPH insulin, and the premixed, all this is approved. Aspart faster acting insulin is also approved, except blue lysine and degludec. Most of the other insulins are approved. Glargine, there's a discussion on that it is being recommended that if the physician want or a physician feels that if someone is already on glargine and becomes pregnant, and this lady, if clinicians feel that by withdrawing and changing the insulin from glargine to some other insulin might deteriorate the glycemic control of a woman, in that situation it can be continued. Now, there's a pregnancy outcome in type 1 diabetes using degludec. This is recent data of 2022. The use of degludec during pregnancy resulted in similar pregnancy outcome, but this is from the real world setting. This is not a clinical research. This is an observational data which cannot be accepted. There is no recommendation of using degludec at this moment of time. We have some data on twin pregnancy. This is a data which has come from US that do twin pregnancy women require twice as much insulin as that of singleton pregnancy, and this was in type 1 diabetes. When we did it in our patient with type 2 diabetes, we were not very much convinced. So in collaboration with Dr. Sanjay Gupte's the center from Pune and Nagpur, we have come out with this data of twin pregnancy. GDM women with twin or singleton gestation differed insignificantly in their treatment strategies and insulin doses, and the insulin requirement need not be proportional to the number of fetuses, and the treatment should be planned to achieve the glycemic control. Can we just ask someone, Mayur or the RX team, to mute everyone, if you don't mind?
RX team, please take control.
So finally, the insulin dose has to be individualized. There is no mathematics involved, but we have some guidelines through which you can at least start the insulin therapy. Intrapartum, you should try to achieve between blood sugar between 70 to 120 to avoid neonatal hypoglycemia. Few of the individuals might require insulin infusion if they're on high dose of insulin therapy. I'm not going in detail of it. Let's talk about the postpartum follow-up. So 15% of GDM women may remain glucose intolerant, while rest of them will become normal. Women with GDM around 30 to 70% more likely to develop diabetes in next pregnancy, and almost 50% develop type 2 diabetes within 5 years after delivery. So postpartum, ideally, the government of India says 6 to 12 weeks. You should have 6 days, 6 weeks, and then 6 months, and then every year. That is what is being recommended for postpartum follow-up of diabetes in these women who had GDM. Breastfeeding should be important, and there exists an inverse association between the duration of breastfeeding versus type 2 diabetes risk among these parents women. So we should encourage breastfeeding in every woman so that they can prevent themselves to develop metabolic syndrome in their adult life and diabetes. This is another good paper which has come recently in 2022 that it is very difficult to have a postpartum follow-up after the woman gets discharged from the hospital. And that is why this data is 2 days postpartum compared with 4 to 12 weeks postpartum glucose tolerance test for women with gestational diabetes. And they have concluded that 2 days postpartum OGTT have similar diagnostic values as that of the 4 to 12 weeks postpartum OGTT in predicting impaired glucose metabolism and diabetes. at 1 year after delivery and are associated with 100% adherence to the test. And thus changing the time of glucose tolerance test should be considered to keep a good follow-up of these GDM women postpartum. Finally, if the glycemic control can be maximized to the extent that fetus no longer recognizes that the mother is diabetes, then the treatment of mother during pregnancy may become the first step towards prevention of obesity and diabetes in the offspring of this diabetic mother. This was said almost 30 years from now, 20 years from now in diabetes care. And that is why Government of India recommends one single test, Ek Jaan se bache do jaan, which is again a slogan from DIPSI. And it is our proud to say that Dr. Seshaya has been awarded Padma Shri this year, and on his birthday. India is the only country in the world where National GDM Day has been declared on 10th of March to increase awareness. And that's why on this basis, we started with a Prega Talk, which is a public awareness initiative and campaign across the country on awareness about pregnancy diabetes through DIPSI platform. And this is we have done it in 21 Indian languages across since last February 2022. And Indian Constitution had 22 languages, and we have completed in 21 language. And the second cycle has also recently started. So this is Gujarati, Bengali, then Tamil, Telugu, Hindi, Oriya, Marathi, Assami, and then it is in Telugu again. And this is Tamil, Malayalam, Sindhi, Bihari, English, and then Konkani, Kashmiri, Dongri, Marwadi, Punjabi again, and Hindi again. The second cycle, again, we had Telugu, and we had Tamil, and this is Bengali, and this is Telugu and Gujarati. So we have wonderful sessions for public awareness, and this will continue for this year again. So GDM to type 2 diabetes, a window of opportunity, and as a clinician, we should never try to miss it. Finally, I'll just would like to convey my best wishes for happy Navratra, happy Dashra, Diwali, Christmas, and Happy New Year in advance. Stay safe, stay healthy, and keep smiling. Thank you very much for patience listening. This is just a cake here on your left. We never celebrate cutting any occasion, celebrating any occasion of anniversary or birthday by cutting the cake, but we cut the fruit. And that's another message for every one of us to start and adopt the healthy lifestyle instead of using eating hydrogenated fat, and encouraging in our children better to use fruit, which encourages a healthy lifestyle in future. Thank you very much for patience listening. Thank you, Mayur, once again.
Thank you, sir. Pankaj, unmute yourself.
Thank you, Sunil Gupta, sir, for the wonderful talk and clearing many doubts. And in fact, insulin is the treatment of choice in gestational diabetes mellitus. So there are many queries, but I would like to forward one to you. Sir, what is your experience regarding use of sulfonylurea, precisely glibenclamide, in gestational diabetes mellitus?
Okay, instead of giving my experience, because I have not prescribed a single drug, even 1.25 milligram of glibenclamide to anyone. Sulfonylurea, I'm talking only glibenclamide, no other sulfonylurea. Okay, that's one message. Second, I'll tell you an experience of one of the very renowned diabetologists of the country. He called me one fine day, Sunil, my daughter is in US, and she has been detected to have GDM. With postprandial blood glucose of around 150 or so post-glucose. OGTT was positive in US, and she has been given glibenclamide 1.25 milligram. She started with it since 2 days, and today morning, because India is morning, so he called me in the morning. He said today she's at around 3 o'clock in the night. She had very severe hypoglycemia 2 to 3 a.m. in the morning yesterday, and now what to do in such cases? So I told her, sir, better you withdraw glibenclamide. That was 1.25 milligram. Okay. She has given there in US for pregnancy diabetes. So that's why I said in my lecture that glibenclamide is still being used quite. It is even the use is higher than metformin in US. But I feel in our personal experiences, discussions, and expert advice, at least in this part of the world, we don't prefer glibenclamide as such, because of our limitation. Metformin now, there are a lot of positive things coming up metformin, but we have to be cautious that metformin is contraindicated in patient with placental insufficiencies, IUGRs, multiple abortions in the past, BOH, we should be a little cautious using metformin. Other cases, of course, it can be given.
Okay, sir. Thank you, sir. Thank you for the wonderful talk.
Thank you.
Now I would like to invite Dr. Harsh as our chairperson. Dr. Harsh, are you there?
Yes, Dr. Pankaj. Yeah.
Okay. Kindly introduce our next speaker. Over to you, Dr. Harsh.
Yeah, thank you, Dr. Pankaj Gupta. So our next speaker is Dr. Sachin Gupta, and he's a diabetologist from Bhopal. And he regularly organizes diabetes awareness program in urban and rural areas. He has received 2 national awards, that is Diabetes Awareness Initiative Award by Diabetes India in 2015 and Geo Dilse Award by My FM Dainik Bhaskar Group in 2015. And since February 2014, he is running free charitable site diabetes clinic every Thursday evening and providing free blood sugar tests. So with this, I invite Dr. Sachin Gupta for our next talk.
Okay, good evening, dear all. So let me share my slides. Yeah. Can you see my slides?
Yes, sir. It's not full screen, sir.
Yeah. Now?
Now it's okay, sir.
Is it okay?
Yeah, it's okay, sir.
Yeah. So at the outset, I'm thankful to Mayur for inviting me to deliver this lecture and be a part of Hormone India. And it's my privilege and honor to be part of that Dr. Yagnik and to talk with Dr. Sunil Gupta. They are stalwarts of diabetes. Okay. And I say that this slides and Dr. Sunil Gupta has given me shared me these slides so that I can speak on this outcome of pregnancy. Poorly managed GDM. So we have seen about the management of diabetes.
Is MD Medicine Chairman API UP Chapter Director SSM Cardiovascular Center in Ayodhya, Vice President UP Diabetes.
Hello.
Yes, sir.
What's the problem?
Sir, it's showing that you have started screen sharing, but probably there's network issue. You have to stop and reshare.
Okay. I'll do it again.
Yes, sir.
Shall I? Poorly managed GDM. We have seen about GDM. Dr. Yagnik has cleared so many controversies about GDM. And GDM, we know that it's a big problem in India. And as Dr. Navneet Agrawal and in previous lectures also, we have discussed that the age of type 2 diabetes is coming down. That's why we are seeing more GDM patients. Because now our girls, they become pregnant at the age of 30 years. And that is the age of getting diabetes in India. We have more patients around 30 to 40 years of age. So let us see something about poorly managed GDM. So pregnancy may be complicated by diabetes in 2 distinct forms. We know that diabetes, gestational diabetes and pre-gestational diabetes. But why worry about GDM and pre-GDM? If they have high blood sugar, that we have seen in the last 2 lectures, that uncontrolled diabetes during pregnancy leads to problems, increased maternal and fetal morbidity and mortality, and there is high rate of fetal malformations. It's an occasion for a mother to become pregnant and to have a baby, and that is, you just can't purchase in crores of rupees. So it's a wonderful experience. And if something happens like this, in that, it's a very, nobody wants all these things. So both these situations are associated with increased maternal and fetal morbidity and mortality. And gradually this magnitude of GDM is increasing. This is one study from Dr. Mohan's diabetes specialties. Pregnancy outcomes in pre-GDM and GDM women in comparison to non-diabetic women, a prospective study in Asian Indian mothers. And what they concluded, women with diabetes have worse pregnancy outcomes. That is also told by Dr. Yagnik. Outcomes compared to non-diabetic mothers, and those with pre-gestational diabetes fare worse than those with gestational diabetes. So gestational diabetes is better than pre-gestational diabetes. I'll tell you how. So there is one study, very important landmark study, published in 2008, hyperglycemia and adverse pregnancy outcome, that is HAPO study. So what they looked, maternal hypoglycemia less severe to be diagnosed as type 2 diabetes, but with adverse pregnancy outcome. And they studied more than 25,000 pregnant women and 9 countries, 24 to 32 weeks onwards. And women with glucose levels not suggestive of diabetes by OGTT were included. Very important study. And what was the result? There was a continuous strong association between maternal glucose levels below those diagnostic of diabetes and adverse outcome. This has also been shown by Dr. Yagnik. And you can see that, you can appreciate these figures, glucose categories, OGTT, fasting, and 2-hour OGTT. And you can see that if the sugars are high, birth weight, clinical hypoglycemia, primary cesarean section, and even the cord C peptide more than 90% percentile. So these all include that there is problem. But why to have GDM is safer than pre-GDM? Implications of pre-existing diabetes, the concept of the fuel-mediated teratogenesis. This was also told by Dr. Yagnik. So this is organogenesis, then behavioral pre-existing diabetes. So these two things are also included if the patient is pre-gestational diabetes. And gestational starts after 3rd trimester. So this time is passed. So pre-conceptional diabetes of any type has more serious implications for the fetus than gestational diabetes. This is very important message for us, that when we see our patient, tell them that if you want to become pregnant, you are going for pregnancy, just one should have pre-conception counseling. Usually we see that our diabetic patients, they come with A1C 9, 10, sir, pata nahi, ho gayi pregnancy. This is a very important thing. And then there is problem for us and for patient also. Since the former can influence fetal development, and that is in 1st trimester initial stage, pre-conceptionally as well as throughout pregnancy. Okay, so we know that it's not simple. If the sugars are not under control, baby can have a lot of things, that they are congenital malformation, central nervous system, neural tube defects, meningocele, and a lot of caudal regression syndrome, cardiovascular tetralogy of Fallot, a lot of things, genitourinary system. There is also some renal agenesis, congenital malformation, gastrointestinal, duodenal atresia, anorectal atresia, musculoskeletal system, functional. So these all, and while neural tube defects are the commonest congenital anomaly in infants of diabetic mothers, but they are not specific for diabetes. The most specific anomaly is sacral agenesis, that is caudal regression syndrome. But fortunately, this is rare. So you can see that this is all anomalies, and the timing, the weeks of gestation is, I think you can appreciate this is just 3 weeks, 6 weeks. So all this happens, all anomalies, they happen in initial stage. So if your patient is pre-gestational, you have to be very careful. Pre-conception counseling is very important. So most of the congenital malformations would already have occurred by the time woman realized that she is pregnant. So this is the problem. Hence the importance of pre-conception counseling and achievement of good glycemic control prior to conception. And we know now the prevalence of obesity and diabetes in younger patients. So congenital malformation, infants of diabetic mothers, this is malformation ratio of incidence. So this is on higher side, okay? So this is neural tube defects, most common but non-specific manifestations of diabetic embryopathy, and that's why we provide folic acid to all, folate supplementation to prevent this. Sacral agenesis, caudal regression syndrome. This is sacral agenesis. It's a very pitiable condition. You can see that. So in first trimester, we have the exposure to abnormal mixed nutrients during organogenesis, that is first to 6-8 weeks of gestation may cause spontaneous miscarriage, intrauterine growth retardation, and malformation. This is very precious time for a pregnant woman, first trimester. Second trimester, we have that is hyperglycemia during the second trimester, when the formation and development of brain cells takes place, alters the behavioral, intellectual, and psychological pattern in childhood. So this is second trimester. And those who are already pre-GDM, they pass through all these stages. Third trimester, maternal hyperglycemia. In the third trimester causes, we know, proliferation of fetal adipocytes, muscle cells, and pancreatic beta cells, and neuroendocrine system, which form the base for macrosomia. Macrosomia, big chubby baby, that is very common in type 2 diabetic patient. And this is because of third trimester, if the sugars are not under control, okay? And this may lead to obesity, IGT, and even type 2 diabetes in later life. So to control blood sugar in all trimesters is very important. This is also one study that structural anomalies and periconceptional A1C. Sometimes we know that the patient, they report to us very late with A1C 12, 13, and you can see that. And absolute risk gradually increases if the A1C levels are high. So high A1C is not an indication in itself for terminating the pregnancy. We do not ask for termination, but we know that it's a problem. Maybe a patient can have problem. The pregnancy and neonatal risk associated with high HbA1c should be discussed and proper counseling offered. That's why preconceptional counseling and before conception, the A1C should be below 6. That is very important. So consequences of diabetes on the pregnant mother, more with pre-GDM, that is hypoglycemia, diabetic ketoacidosis, retinopathy, nephropathy. We know all these things: hypertension, diabetic gastropathy, polyhydramnios, preeclampsia, pyelonephritis, other infections, preterm labor, abortions, traumatic delivery, over-diabetes. These all are maternal complications of GDM if the sugars are not under control. And we know that patient can have retinopathy, and if they have already retinopathy, that can worsen. So it's important to get fundus of our patient during pregnancy. That is very important to prevent this complication. Nephropathy is also common in women with reduced creatinine clearance. There is an increased risk of deterioration of renal function during pregnancy, and it becomes problem. There is increased risk of maternal hypertensive complication, and can lead to preeclampsia, increases of fetal growth restriction, and fetal distress due to placental insufficiency. So if the patient is already, she is patient of CKD, they are not allowed to be pregnant. This is a very important thing because there is great risk. So why does one aim for right tight glycemic control or day and night control. So if you just see for perinatal mortality, that is also high if your sugars are on higher side. So this is very important thing. So because of two things are important: failure to diagnose the condition. Maybe we do not know, it's by chance the patient they come to us with high A1C. So that's why importance of pre-conception counseling and degree of glycemic control during pregnancy. That is in our hands, and with that we have to control. So do we need to identify and treat GDM? Yes, that is very important thing. And maybe we all know that these are indications for high risk for GDM. Age more than 25 years, we know that nowadays we see usually around 30 years pregnant ladies because of late marriages. Family history of diabetes, obesity is very common. Mostly they come with obese type of diabetic, bad obstetric history, unexplained perinatal loss, IUD in previous pregnancies, that for gestational age infant, congenitally malformed infant, that is if they have history, polyhydramnias, preeclampsia, and glucose in second fasting urine sample. So education is the cornerstone of all diabetes GDM management. We know that education is the cornerstone of all diabetes management. Likewise, in GDM, you have to educate your patient regarding maternal complication, fetal complication, medical nutrition therapy, glycemic monitoring, SMBG, how to do SMBG, how to take insulin, so many things. Fetal monitoring, ultrasound, planning on delivery, and long-term. This is all to be managed. And so this is my take-home message, that pre-conception counseling is must if you want to prevent outcome of poorly managed GDM. That is, if you want to prevent, if you want to give a good, healthy baby to your expectant mother, okay? And all pregnant women in India should be screened for diabetes. That we have seen universal screening for India. That was told by Dr. Sunil Gupta. First screening should take place at the first antenatal visit. Pre-existing diabetes in a pregnant woman has more serious implications than GDM. That we all know, both for the mother as well as the fetus. And we have opportunity to counsel, to educate the young patient, those coming to us and they are not pregnant, but they are planning for pregnancy, to counsel them, to ask them to reduce, to decrease weight, to control blood sugar, and to keep A1C below 6 before conception. Okay, so this is all about outcomes of poorly managed GDM. And thank you. If you want to prevent all these things, just eat less and work more. Thanks a lot. Thanks, Mayur, for giving me this opportunity.
Thank you, sir.
Thank you, sir, for the wonderful talk and explaining all the effects, right from teratogenic intrauterine effects to future outcome like metabolic syndrome and diabetes in a poorly controlled gestational diabetes. So thank you again, sir. Now I will invite Dr. Kailash. And Dr. Kailash, can you hear me? Kindly introduce our next speaker, Dr. Rajiv Awasthi, sir, and start the talk.
Thank you, Dr. Mayur and Dr. Pankaj, for giving me this opportunity to introduce Dr. Rajiv Awasthi. Dr. Rajiv Awasthi is an internist and special interest in diabetes from Lucknow, Uttar Pradesh. A gold medalist, Dr. Awasthi lays emphasis on incorporating new research into clinical practice to give the benefit of latest treatment to his patients. The Awasthi currently consultant from Pradhana Clinic Diabetes Center, which is managed by him. The clinic is known for its protocol-based care. Dr. Awasthi will be going to discuss about the management of steroid-induced diabetes, a very important problem faced in corona epidemic. Dr. Rajiv Awasthi, please.
Thank you very much. Am I allowed to share my screen now? Am I audible and visible?
Yes, sir.
Yeah, so thank you, Dr. Mayur and Dr. Ajay Shukla and Hormone India for organizing such a wonderful conference. And the topic which I have been asked to speak became very relevant in this present day epidemic of COVID-19, and probably what has seen I think the maximum use of steroid ever done in the world. So let us see how common is steroid use. At any point of time, around 0.9% of general population may be using corticosteroids, with the highest rate around 2.5% seen with the individuals more than 70 years of age. Nearly 1/4 of patients may need to use corticosteroids for more than 6 months, and widely prescribed because of the anti-inflammatory and immunosuppressive property. So why we at all use steroids in clinical practice, and because of the immunosuppressive and anti-inflammatory property? It is across the disease spectrum. It is being used, and specifically in relation with the endocrinology, it becomes a treatment. It's a direct treatment for adrenal insufficiency and the congenital adrenal hyperplasia, and all respiratory, hematology, rheumatology, dermatology, gastroenterology, and organ transplant ophthalmology. Across the board, these steroids are being used almost every day, depending on the situation, in the variable doses, long-term, short-term steroids, all possible permutation combination. So let us discuss what is the steroid-induced hyperglycemia, use of steroid treatment in people with pre-existing diabetes, resulting in the worsening of glucose control. This is the steroid-induced hyperglycemia. Steroid-induced diabetes is a rise in glucose occurring in people without a known diagnosis of diabetes, may or may not resolve when these steroids are withdrawn. What are the risk factors for those at risk, the conditions who are at risk for developing steroid-induced hyperglycemia? So the pre-existing type 1 or type 2 diabetes, a strong family history of type 2 diabetes, previous gestational diabetes, previous impaired fasting glucose or impaired glucose tolerance, people with polycystic ovarian disease or obesity, ethnic minority groups, and history of hyperglycemia with the steroid use in the past. These are the clinical situations where one is expected to develop steroid-induced hyperglycemia. The few major points where actually glucocorticoids act and they cause steroid-induced hyperglycemia at pancreatic level. It's a pro-apoptotic and leading to progressive beta cell failure. At liver level, it increases gluconeogenesis and decreases insulin sensitivity. It causes lipolysis and decreases the insulin sensitivity, increases the resistance. At muscle level, it decreases the glucose uptake. All similar to type 2 diabetes pathogenesis, capillary recruitment, and also it impairs the incretin response. Now the question comes, how do we manage? Before we start managing, we must know how to monitor it in people without pre-existing diabetes. Monitoring at least once daily, preferably be prior to lunch or evening meal. If blood glucose is less than 216 milligram per deciliter, continue to test one daily post breakfast or lunch. If blood glucose reading is more than 216 milligram per deciliter, then the frequency of testing should be increased to 4 times daily before meals and before bed. And then if glucose is found to be consistently more than 216 milligram per deciliter on 2 occasions during 24 hours, then the patient should enter the treatment. What about the people with pre-existing diabetes? Test 4 times a day before meals and before bed, irrespective of background diabetes control. If glucose is found to be consistently more than 216 milligram per deciliter on 2 occasions during 24 hours, then the patient should enter the treatment. Management criteria according to the joint British Diabetes Society 2018 guideline. For those using a basal insulin only, consider switching to morning administration and increase the dose by 10% every 24 to 48 hours, depending on the glucose level. For those using twice daily pre-mixed insulin regimen, 10% increase in the morning insulin dose should be considered every 24 to 48 hours. For those using a multiple dose regimen, an increase in the lunch and the evening meal short-acting bolus may be appropriate. A person should be monitored closely as for the early morning hypoglycemia if basal analog insulin is being used. Steroid-induced hyperglycemia therapy, non-insulin therapies like sulfonylurea, pioglitazone, metformin can be used in all those who are not critically ill or the glycemic excursions are not very high. So one can try in the non-hospitalized patient once daily in the morning, maybe best manage the glucose excursion associated with once daily steroid dose, but you have to seriously monitor for the hypoglycemia event once the doses of steroids are being reduced or removed. For basal human insulin may closely fit the glucose excursion induced by single dose of oral steroid in the morning. Basal analog insulin may be appropriate if a hyperglycemia is present throughout the day, and the multiple daily injection regimen may be appropriate when the multiple doses of oral or shorter acting steroids are being given intravenously. People in hospital acutely unwell with significantly hyperglycemia are unlikely to achieve glucose control with non-insulin therapies. This is the schematic presentation, how we go about to control the steroid-induced hyperglycemia. In the treatment naive, in the treatment experience group, in treatment naive, if it is mild, if it is on the patients are in daycare, one can try sulfonylurea or TZDs or intermediate acting, long-acting insulins. Treatment experienced people, short-acting corticosteroids, use immediate or long-acting insulins. In the long-acting corticosteroids, intermediate or long-acting insulins with the support of plus perennial insulins, if required, are the treatment of choice. There are certain limitations of oral agents, effectiveness of various oral hypoglycemic drugs in treatment of new onset glucocorticoid-induced hyperglycemia, limited efficacy, slow onset of action, limited or non-existent ability to be titrated, and action profile of oral hypoglycemic drugs does not coincide with the pattern of steroid-induced hyperglycemia. So controlling steroid-induced hyperglycemia becomes a difficult proposition using the oral anti-hypoglycemic agents. Why insulin? Because immediate onset of action, easy titration, unlimited efficacy, and the greater flexibility and the predictability, the rapid ability to target postprandial hyperglycemia, and those can be modified related to patient's oral intake. So when to start insulin? Steroid hyperglycemia, fasting glucose more than 126, or glycemia at any time more than 200 milligram per deciliter after 2 hours of glucose load. Then if the preprandial glycemia is less than 200 milligram without precious diabetes mellitus, pre-present diabetes mellitus, and low-dose corticosteroids, controlled diabetes with the oral agents can be tried. Oral hypoglycemic drug like metformin, sulfonylurea, TZDs, or DPP-4 inhibitor can be tried. Despite this, if there is a persistent hyperglycemia, then switch over to insulin. In all those where the preprandial glycemia is 200 milligram or more, then the insulins are to be used. Which insulin therapy to initiate? Basal insulin may closely fit the glucose excursion induced by single dose or of oral steroid in the morning. Basal analog insulin may be appropriate if hyperglycemia is present throughout the day, and the multiple daily injection regimen may be appropriate when the multiple doses or oral IV steroids are being given. Steroid-induced non-insulin therapies given, it's almost recapitulation of the same slide, which we have already talked about. So given once daily in the morning with these doses of steroid in the basal insulin may closely fit the glucose excursion. Basal analog insulin may be appropriate if hyperglycemia is throughout the day, and the multiple injections if multiple doses are being given. So I think it's the last slide probably of my presentation. As non-insulin therapies, if the person is on glycoside, the morning dose should be increased in 40 milligram increment to maximum dose of 240 milligram. Temporary addition of basal human insulin may be indicated, given in the morning. Insulin therapy for those using basal insulin only, consider switching to morning administration and increase dose by 10% every 24 to 48 hours. For those using twice daily premix insulin regimen, 10% increase in the morning dose should be considered, and it retested after 24 to 48 hours. For those using a multiple doses regimen, an increase in the lunch and evening meal short-acting bolus may be appropriate. For type 1 people using twice daily premix insulin, 10% increase in the morning as with the type 2 diabetes. An increase in the lunch and evening meal short-acting bolus insulin doses may be warranted if bolus regimen is utilized. Thank you very much for patient hearing. Over to chairpersons.
Thank you, sir. It is a very well explained talk regarding management of hyperglycemia, steroid induced, and it is a tricky situation. And we have all seen that in recent past, during COVID times, patients on large doses of insulin requiring large doses of steroid and requiring multiple doses of insulin. So in mild hyperglycemia or with low dose of insulin, we can go for with OADs or single dose of insulin, but definitely with the long-acting steroid or multiple doses of steroid, we have to use MDI regime to control glycemia. So, sir, thank you again, and we will finish this session. And I thank all the chairperson, Dr. Kailash, Dr. Simi Dubey Madam, Dr. Harsh, and also our esteemed speaker, Dr. C.S. Yagnik sir, Dr. Sunil Gupta sir, Dr. Sachin Gupta sir, and Dr. Rajiv Avasthi sir. Thank you, sir. Thank you all. And I hand over mic to Dr. Shekhar.
Yeah, good evening all.
Just let me reintroduce. Thank you all the chairperson and speakers for enlightening us, having such a wonderful session. So for the next session, the Hormone India repertoire is Dr. Shekhar. He has done his DM Endo from Shere Kashmir and presently working as Hormone India consultant at Andhra. Over to you, Dr. Shekhar.
Yeah, good evening to all. After diving deep into the management of diabetes in special situations, now we'll be sharing our experience of dawning of new drugs. So now I invite our chairpersons for the next session, Dr. Ramesh Bhargav sir, Gopal Bhatni sir, and Pankaj Agarwal sir. Now I request Dr. Ramesh Bhargav sir to introduce about our speaker, Dr. Arvind.
Good evening everybody. Dr. Arvind Jagdisha, he's MD Medicine, MRCP, FRCP, Glasgow and London, proprietor and chief diabetologist. Dr. Arvind, Diabetes Center, Bengaluru, India, has vast experience for working in various hospitals in the UK, especially in the field of diabetes and endocrinology. One of the few with MRCP London and triple FRCP attachment London and Glasgow. Award Time of India Healthcare Achiever Award in the field of diabetes and endocrinology 2018. Bengaluru highest civilian awards for his work in field of diabetes. Received so many awards and over 75 conference presentation, 30 publication, and involved clinical trial conducted by Arvind Diabetic Center. He is eminent speaker in both national and international level conference and webinar. Most of the recent was International Diabetes Federation conference in Busan, South Korea, and also the part of the organization of committee. I request Dr. Arvind to start his presentation.
50% of the patients we are there. And absence of metabolic, there is 5% of and in the absence of any metabolic compliance and normal expensive weaknesses like so these are haptonames, these are smart categorizations. That's why my understanding.
Hello, can you hear me?
Yes, sir.
Can you start?
I think the speaker has not yet joined.
I think probably there's some network issue, and we can just move on to the second session and I'll call in.
Yeah, okay. Now I request Dr. Gopal Bhatti sir to introduce our next speaker, Professor P.C. Manoria sir.
Good afternoon. Am I audible?
Yes, sir.
Can I have the details of Dr. Manoria sir on the screen, please?
Yes.
Well, it's an honor to me to be introducing my respected teacher, Dr. Professor P.C. Manoria. I've been his student since my third year. He has guided me during my post-graduation and guides me in my career. He's a fantastic teacher. He is a director, Manoria Heart Care and Critical Hospital, Bhopal. He was former professor and head of Department of Cardiology in GMC. He was awarded Lifetime Achievement Award by Bharat Ratna Honorable Shri APJ Abdul Kalam. He's a Master Teacher Award, Indian College of Physicians 2019, Netaji Oration Award, Epicon 2002, Award of Excellence in Academics. He has been organizing several national and international conferences for last 40 years, and which I have been privileged to attend many of them and learned so many things from him. He has edited 33 books and 74 publications in various journals. He has delivered more than 800 lectures in various national and national conferences. And whenever I hear him in each of his lectures, I come out wiser. Sir, it's an honor to have introduced you. Over to Dr. Professor Manoria.
Can I share the slides?
Yes, sir.
Is it okay?
Yes, sir.
So thank you, Dr. Bhatni, for the kind introduction. For the next 15 minutes, I'll be talking on new frontiers in lipid management with a special reference to diabetes. The last couple of years has witnessed a sea change in lipid management, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. Why we are so much concerned about lipid management? The first reason is that cholesterol never sleeps. It works 24/7/365 and executes its ravages on the cardiovascular system in the form of plaques in the arteries. And we know plaques are the major culprit for cardiovascular disease. They put us at risk of heart attack and stroke, and heart attack is the #1 killer of mankind, and stroke is the #1 cause of disability. The second reason why we are so much concerned with lipid management, more so in diabetics who are at high risk of CVD, is that lipid management has reached great strides, and the last quarter of century has passed on big messages of therapeutic importance. So firstly, when we look at the issue, can we stabilize the plaque by lowering LDL? The answer is universally yes. And there are several statin trials. And if the plaque gets stabilized, the probability of developing acute coronary event is minimized. The second issue is, can we reduce the plaque buildup, which means can we arrest the progression of atherosclerosis Again, the answer is a big yes, and we have very clear data from the reversal trial where high-intensity statin 80 milligram showed arrest of progression of atherosclerosis. And this occurs when the LDL levels are less than 65. The third big issue is, can we shrink the plaque by lowering LDL? Again, the answer is a big yes. And data comes from the GLOVE trial where evalucumab, which is a PCSK9 monoclonal antibody along with statin, produces regression of atherosclerosis. And this occurs when the LDL is decreased by more than 50. And the last big issue is, can we make the plaque disappear from the vessel wall by decreasing LDL? This is an unresolved issue, and maybe in future this is possible. So what is the big message coming from all this is, we can modulate atherosclerosis to a great extent. And the new big dicta which is coming up, that if you want to live without ASCVD for 100 years, keep your LDL less than 70 throughout the life after 20 to 30 years. So if you want to be free of ASCVD, this is the big message. And many luminaries in cardiology have their LDL 34, 40, 28, and are over 90s. So this is a big message. Now, when we look at the targets for LDL lowering in the current era, we are running the race to the bottom of LDL. All of us know, if there is a J curve for HDL, if you lower blood pressure less than 120, the J curve comes. If you lower glucose, the J curve comes. But for LDL, there is no J curve at the moment. And that's why all international guidelines and Indian guidelines, the LDL targets are coming lower and lower. And the dicta is, lower is better and lowest is best for the very high risk. So ACC-HA 70, LI 50 before any international guideline showed this target. ESC 55 for the very high risk 40, and the extreme risk by LI, that means Lipid Association of India 2021, which I am also a member, the target is 30. So we are running the race to the bottom of LDL. Now, when we look at the evolution of lipid guidelines from 1988 to 2021, LDL is the primary target and non-HDL is the co-primary target. HDL is a fallen angel because all trials of HDL elevation by drugs have failed to show any benefit on top of statins, and therefore HDL is a fallen angel. Triglycerides is still under evaluation. The Accord LLA trial was negative. The subgroup analysis was positive, but all of us know subgroup analysis only hypothesis generating, and there's no large randomized trial with this. Prominent trial with fibrase recently terminated prematurely because of lack of benefit. Stent trial with omega-3 fatty acids again terminated prematurely because of lack of anticipated benefit. The reducer trial was positive with icosapent ethyl, which I'll show you. Seroglitazar, there's no outcome data. The reducer trial showed improved CV outcome, but when the data was analyzed in subgroup triglyceride less than 50, and more than 150, the same benefit is there, which clearly indicates that the mechanism of benefit in the reduced trial is not related to triglycerides. LPA, at the moment, there is no evidence-based target, but all of us know pelacarsen, which is an antisense to ApoA, which dramatically decreases LPA, is ongoing and is very likely to come out as positive. And in near future, it is very likely we will have an evidence-based target for LPA, and pelacarsen is likely to emerge as a foundational, as a transformational therapy for LPA-induced cardiovascular disease, which all of us know is a malignant cardiovascular disease. So now when we look over the years, say from 1980 to 2020, which means over 40 years, what has happened to different components of the lipids? If you look at the LDL after statin somewhere in 90s, it is mounting up and up. HDL, initially there was a rise, but then all trials are negative, there's a fall. Triglycerides and LPA, there is a rising trend. There's a lot of talk about remnant cholesterol. Remnant cholesterol is nothing but total cholesterol minus HDL cholesterol minus LDL cholesterol, which includes VLDL and ILDL. The normal values are shown here. The normal is less than 15, and then 15 to 23, and 23 to 7, so on. And it is now believed that elevated LDL, it produces plaque formation. LPA elevated produce plaque formation and thrombus formation. And the remnant cholesterol produces inflamed, unstable plaque and plaque rupture, which may result in acute myocardial infarction or a stroke. There is enough data to show that if you have elevation of remnant cholesterol, there is increase in the ACVD event, whether it is myocardial infarction, whether it is PAD or ischemic stroke. But no trial has shown that if you decrease remnant cholesterol, there decrease in the cardiovascular events. And therefore, the guidelines do not talk about remnant cholesterol at the present state of time. None of the guidelines will see there's a target for remnant cholesterol. The king statin continues to remain the foundational therapy for statins, and statins are wonderful drugs. They have multifaceted actions. All of us know they improve endothelial function, they delipidate the plaque, so plaque gets stabilized. Either you can see on a vascular MRI before and after, or by near infrared spectroscopy in the yellow trial, you can see they are delipidating the plaque. And if the plaque gets delipidated, CV events will decrease. And these are hot plaques on a PET CT, and statins cool down these hot plaques if you repeat CT X-ray. They promote calcification of the plaques, and if they are calcified, CV events are decreased, and a lot of pleiotropic effects. One thing which is not often publicized is that statins, dyslipidemia increases the thrombogenicity of the blood. And in real world, out of 10 plaques, only 1 plaque rupture culminates into an acute coronary event. And it is the thrombogenicity at the time of plaque rupture, which is a very important determinant of culmination of a plaque rupture into a cardiovascular event, as you can see here. Now, if at the time of plaque rupture you are on statins, your thrombogenicity will be less, and the probability of a plaque getting ruptured in culminating into an acute coronary event is minimized. And all of us know statins have a legacy effect, which all of us are clear. Statins, no doubt, are the foundational therapy for lipid management. But when we look at the current goals, the LDL goals are not reached in 50% of patients, as you can see on this slide on the left. And on the right shows that if you reach your LDL goals, there's reduction in the cardiovascular events. So when statins fail to achieve the LDL goal, you use ezetimibe. Ezetimibe plus statin also failed to achieve in past. We were using PCSK9 monoclonal antibodies, evolocumab, but that is a very costly drug. But now we have a new solution, bempedoic acid. So the sequence would be statins, ezetimibe, bempedoic acid, and PCSK9 is only for the very high risk group. Improved trial, all of you are aware of it, and this is the benefit of improved trial, which means you decrease non-fatal MI significantly. The p-value is significant. You also decrease non-fatal stroke, which is again significantly. Revascularization is also decreased, but unstable angina on the bottom and CV death are not minimized. The other drug is bempedoic acid, which is a new kid on the block, also available in India for the last few months. Is approved by US FDA also, by EMA also, after the Clear Harmony trial. And it is recommended to be used in ASCVD or HeFH for additional lowering of LDL if it is required. Combination of bempedoic acid ezetimibe, which is a very good combination, is available in the West and is also approved by FDA and other bodies, but is not yet available in India, likely to be available in the near future. Now, bempedoic acid, if you remember, is a prodrug. It has to be activated by ACVL1 into an active drug, which is bempedoyl coenzyme A. Now, this enzyme is not present in the skeletal muscle, and this is the reason that if you are using bempedoic acid, the muscle side effects are not there. It blocks the enzyme ACL, that is ATP citrate lyase, and produces decreased synthesis of cholesterol pathway, which is ahead of statin. This is statin pathway, HMG coenzyme reductase inhibitor. And as you can see, it is excreted through this channel OA2, which is the same as for creatinine and uric acid. And this is the reason why uric acid gets elevated. The side effects of bempedoic acid are very less. The major side effects is hyperuricemia, gout, which can be easily taken by drugs if it is concomitant or if it occurs during the course of the therapy. All other side effects are minor. Tendon rupture is a rare but a serious complication. I'll talk to you about this. It is not diabetogenic, rather it decreases diabetes and has a tendency to decrease weight. Now, tendon rupture usually occurs in individuals who are more than 60, taking steroids, fluoroquinones, renal failure, and a history of tendon rupture. If it occurs, the drug should be stopped right at the onset of any symptoms suggestive of it. What was very curious that in the Clear Serenity and Tranquility trials, which are statin intolerance, tendon rupture was not seen. It was seen in the other two trials, the Clear Harmony and Clear Wisdom, which are on top of statin. So it is very likely that this is not directly concerned with bempedoic acid. If you are on a Simba more than 20 per hour, again, you should stop it because there's more chances. And here you can see a case illustration, which is on statin with ezetimibe and has developed tendon rupture. So bempedoic acid, it seems, is not directly related to this, perhaps statins and other drugs, which now these are the trials of the CLEAR program of bempedoic. When you see CLEAR, it means that it's a bempedoic acid. The upper two trials, Clear Harmony, Clear Wisdom, are on top of maximally tolerated statins. The lower one are in statin intolerant. Now, it is very easy to remember what would be the decrease in LDL if you are using on top of maximally tolerated statin, because statins also decrease synthesis of cholesterol, bempedoic. So the decrease in LDL would be around about 15 plus minus 2. Here you can see it is 16.5. If you are using a statin intolerant patients, which means the patient is not on statins, the decrease will be around about 25 plus minus 2. So 15, 25. And if you are both drunk, it is 35 plus minus. So you can easily remember 15, 25, and 35. It also has an anti-inflammatory action. It decreases high sensitivity CRP. You can see around about 20% or 32% in the statin intolerant trial, and in statin tolerant trial, it is around about 20. When you are faced with statin intolerant, because if you don't take statin, cardiovascular event, cardiovascular mortality, and all-cause mortality increases, please try to have some statin on the board. And one statin which you should never forget is pitavastatin, where statin intolerance is very rare. So when we use both these combination in statin ezetimibe plus bempedoic, as we said, is 35 plus minus 2, so here is 36 in this. So the best strategy for statin intolerance at the present state of time is pitavastatin 2 or 4 milligrams, which is usually tolerated when the patient is not tolerating other statin, ezetimibe 10 milligram, bempedoic acid. And this is going to emerge as a game changer. This is triple combo, and I'll show you the data. So when we use this triple combo here, it was used only in 20 milligram, although you can use it much higher. This is an Australian data. You can see if you use this triple combo, what happens? LDL is decreased by 63%. 90% achieve LDL goal of ACC, which is less than 70. 58% achieve LDL goal of ESC, which is less than 55. So very dramatic decrease in LDL. It also has a favorable effect on the other lipid parameters, non-HDL, total cholesterol, ApoB. The CLEAR outcome trial is ongoing and is likely to be available in a year or two, which will see the effect of bempedoic acid on the cardiovascular event. This is a secondary prevention trial and not a primary endpoint. PCSK9 monoclonal antibodies are the magic bullets for decreasing LDL. and they dramatically decrease LDL by 40 to 60%, which we use in patients with ACS on top of all lipids, whether you are using statin or any lipid, because the mechanism is different. And this reduction translates into reduction in cardiovascular events. And they also have other favorable effects, decreasing the LPA by 25%, and the safety is excellent and no diabetogenicity. This is the trial of statin in stable angina and a 15% statistically 4-year trial reduction in the primary ischemic endpoint. This is the ODCACS trial, a 15% reduction in the ischemic endpoints. And now PCSK9 are also used after the EVOPEX trial, which use PCSK9 right from 0 hours during hospitalization at the time of acute coronary event, and showed it produced dramatic decrease in the LDL and is safe. So we now have lots of trial in ACS, and we use these drugs. Evalucum is available in India, and it has shown great results. Rather than said, if after a PCI, you get a recurrence of cardiovascular events, your LDL has not been to the target. Not reaching LDL target is the commonest and the most important cause of recurrence of myocardial infarction or CV event after a successful AVI. Homozygous hypercholesteremia is a deadly disease. The problem with this is only few receptors LDL are functioning. So even if you use PCSK9 in HoFH, the results are suboptimal. But evanacumab is a new bullet for HoFH because its action is independent of the density of LDL cholesterol receptor. So whether your LDL receptors are working or not, it will continue to act, has already been approved, but is a very costly drug. 15 milligram per kilogram IV once a month, which costs few lakhs. Inclisiran, again, is a very wonderful drug. It melts LDL from the vessel wall, but at a huge price. And the beauty of this is one injection, 300 milligram every 6 months is required. So 2 injections per month, and therefore its adherence is likely to be great because 2 injections per month, per year are simple to take, and decreases LDL by 50%, which remains there for the next 6 months. Icosapentaen, which was carried out in patients with established CVD, diabetes with risk factors, hypertriglyceridemia, 135 to 49, showed positive results, fantastic results. Primary endpoint decreased by 25%, secondary endpoint decreased by 26%. And again, as we see, triglyceride less than 150, more than the data is same, clearly indicating the mechanisms of benefit in this trial, which was carried out in patients with hypertriglyceridemia, is not lowering. There are other mechanisms, antiplatelet, anti-protein, others, which are being investigated. If you look at the secondary endpoint, the benefit was more in TG less than 150. So clearly, again, showing the same. But the trial has produced fantastic results. All hazard ratios to the left, even the confidence interval except one is to the left of the midline, which we rarely see in a trial. So fantastic results is now also available in India. PCSK9 vaccine is a new strategy. 1 vaccine a year. The action lasts for 1 year. Human trials are ongoing. And if this comes out to be positive, a booster dose every year will be a new way to target atherosclerotic cardiovascular disease. Seroglitazar, all of you are more familiar with it, is a drug which lowers triglyceride, also has action on the glycemic control, and is approved for NAFLD, but the problem is that it has no outcome data. It is also approved for NASH and hypertriglyceridemia. LPA-driven disease, cardiovascular disease, is a malignant disease. All of us know it produces myocardial infarction, atherosclerotic events in other territories, and also severe aortic stenosis. But LPA-driven disease has been called as a slow death sentence, as a gloomy prognosis because of malignant nature. But with now pelacarsen, which is likely to emerge as a foundational therapy, we are on a verge of new dawn in LPA therapeutics. So in times to come, pelacarsen will improve the life of these patients. And pelacarsen is nothing but an anti-sense therapy to ApoA. It acts in the liver, it decreases synthesis of ApoA, and therefore LPA synthesis is also decreased. This is the secondary phase 2 study with pelacarsen, you can see 97% reach LPA level less than 50. So trial very likely to come out positive. And this is the secondary prevention trial, Horizon, which is ongoing and is likely to be expected results 2024. Gene therapy is now also emerging as a real reality. The first volunteer in New Zealand has become the first person to undergo DNA editing in order to lower his blood cholesterol in gain of function of PCSK9, which produces severe hypercholesteremia. And the Heart-1 trial is now initiated with VAR101 to treat 40 patients. So in times to come, gene editing is also becoming a real reality. And the beauty of gene editing is the big stick, because one and done. You don't ever come back for treatment. So when we look at the evolution of lipid modulating therapy, we have statins, oral therapy, which is the foundational drug. You can combine statin with ezetimibe, icosapentethal, bempedoic acid, and fibrate. All are daily drugs. Evolocumab, which is available in India, is either every second week, between 14 days, or once in a month. Evolocumab is also monthly therapy. And we have pelacarsen, which is weekly or monthly, usually for 80 milligram once a month. Small interfering RNA, which is inclisiran, is biannually, which means 6 monthly therapy. PCSK9 one is annual, and gene editing is for life. So in summary, LDL is the primary target, and non-HDL is the co-primary target. And all of us know that LDL has a causal relationship with ASCVD. Non-HDL is a co-primary. Lowering LDL to very low levels, like 30 or even up to 10, is safe and has been documented and provides incremental benefit even at very low LDLs. LDL less than 50 causes regression of atherosclerosis, less than 35, arrest of progression of atherosclerosis. And in the current scenario, LDL can be cut to any size by the modern therapy. Inclisiran has great adherence and melts cholesterol, but at a very big price. And icosapentethal is now available in India, and pelacarsen is likely to emerge as a transformational therapy to deadly LPA-induced cardiovascular disease. Thank you very much for your time.
Thank you, sir. Thank you for the extensive presentation and covering all the aspects of your lipid treatments in such a short and brief time. There are many questions, but I would like to take one question which is pertinent. What is the role of mass statinization?
What is the role of?
Mass statinization in diabetic patients after the age of 40 years.
Statinization?
Yes, sir. Mass
Statins are mandatory for diabetes. Diabetics are very high risk for cardiovascular disease. Although statins has a diabetogenicity, but the benefit is many times more. So all diabetics must be given statin type 2 diabetes. There's no question about it.
Okay. Thank you, sir. Over to Dr. Mayur.
Yeah, Dr. Arvinda has joined, I believe. Sir, are you there? Yes. Dr. Gopal Patni, sir. Can you introduce Dr. Arvinda?
Dr. Arvinda already introduced by Dr. Ramesh.
Okay, okay. So can we start?
Yeah, sure.
Okay.
Can I get the permission to share my screen?
Yes, sir.
Are you able to see my screen now?
Yes, sir. It is visible.
Yes.
Kindly make in presentation mode.
Yeah.
Yeah, perfect, sir.
Yeah, so good evening, everybody. At the outset, I thank Dr. Mayur Agarwal for organizing this wonderfully organized conference, Hormone India. So with a lot of good faculties, he has taken personally and invited many faculties and with good topics. That should I should say, because this is, I should say, it's a scientific extravaganza. So congratulations, Dr. Mayur.
Thank you.
So yeah, my topic is on an interesting topic. I know the time is running short. I'll be quick because it's a new thing. So twin creatine, the next leg in diabetes management. First of all, greetings to all of you from Bangalore. So if you take the overview of incretin hormones, GIP and GLP-1, so GIP and GLP-1 are responsible for the incretin effect, a phenomena in which a orally administered glucose leads to a greater release of insulin than does the IV glucose administration. You can see on the left-hand side, the GIP discovered in 1970. It is secreted by the duodenal K cells. It is stimulated by lipids and glucose. On the right-hand side, GLP-1 is discovered in early 1980s, secreted by distal ileal L cell, and it is stimulated by glucose. So this is how the incretin effect it looks like because of the oral and the IV glucose. So you can see the glucose-dependent effect of GIP on insulin and glucagon secretion, how the combination and hypoglycemia and hyperglycemia will be well balanced. This is an interesting slide which gives the overall picture of GLP-1 and GIP, where the complementary effects and how they improve glucose and lipid metabolism. On the left-hand side, the GLP-1 receptor agonism, you can see it acts on the central nervous system, where it increases the satiety, causes nausea, decreases food intake, and decreases body weight. In pancreas, it increases the insulin, decreases the glucagon. In stomach, it decreases the gastric emptying time. Indirect action in liver increases insulin sensitivity, decreases the hepatic glucose production, decreases ectopic lipid accumulation, and systemic, it decreases the hyperglycemia. On the right-hand side, you can see the GIP receptor agonism. This is one new concept for all of us, where it decreases nausea, decreases food intake, and decreases body weight. You can see here, GLP-1 causes nausea and GIP causes decreased food intake and decreased nausea. In pancreas, it increases insulin and increases glucagon here. Adipose tissue, it increases insulin sensitivity, increases lipid buffering capacity, increases blood flow, increases storage capacity, decreases pro-inflammatory immune cell infiltration, increases insulin sensitivity, metabolic flexibility, and decreases ectopic lipid accumulation, ultimately decreases hyperglycemia and triglycerides. This is how the mechanism of action of GIP and GLP-1 in pictorial demonstration. So this article was, you can see, tells about the twin creatine published in way back in 2016. Twin creatine as a potential therapeutic for the management of type 2 diabetes with obesity. You can see here how the twin creatine acts on the pancreatic islets, that is GLP-1 and GIP, and how it leads to decreased glucose level, increased insulin sensitivity, ultimately leading on to weight loss and improved diabetes control. So Lilly's diabetes treatment, tirzepatide, gets the FDA nod. That is, the FDA has granted approval to its dual GIP and GLP-1 RA, that is the tirzepatide injection. So it comes in the name of Mounjaro. It is approved in recently 3 months back, that is May 2022. It's available in US pharmacy. It's a GIP and GLP-1 receptor agonist. So the FDA stated that tirzepatide represents an important advance in the treatment of type 2 diabetes, lipid disorders, and obesity. It is an experimental drug that works by stimulating two different receptors, GLP-1 and GIP. This is known as dual GLP-1 and GIP agonist. The action in brief, you can see it causes decreased appetite, decreased food intake, and increased weight loss. In pancreas, it increases the insulin secretion and synthesis. It increases the beta cell survival. In white adipose tissue, it increases lipolysis and increases lipogenesis. So combining incretin hormones, you can see the phase 2 trial on the efficacy and safety of tirzepatide, the body weight outcomes of treatment of tirzepatide compared to dulaglutide. You can see this particular molecule showed significantly better efficacy regarding weight loss compared to dulaglutide and placebo, with an acceptable safety and tolerability profile. Now coming to few of the clinical trials with this molecule, SURPASS clinical trial, it began in 2018. The dosage used was 5, 10, and 15 milligram. You can see in this slide, there was various trial. On the left-hand side, you can see the SURPASS 1, 2, 3, 4, 5. The SURPASS 1 was the comparator was with placebo, SURPASS 2 with the semaglutide, SURPASS 3 with insulin and insulin degludec, SURPASS 4 with insulin glargine, and 5 with placebo also. You kindly note there were the patients were on concomitant therapy as well. The primary outcome was A1C. If you see the overall outcome of this particular trial, tirzepatide was found to be superior to each comparator group in lowering both A1C and weight. Now coming to the another interesting trial that is done with tirzepatide is the SURMOUNT-1 trial. It is an international phase 3 double-blind randomized trial involving 2,500 patients who are obese, overweight, plus weight-related complication or some without diabetes. So the dosage, this is a weekly subcutaneous injections of tirzepatide for 72 weeks. You can see the 5 milligram, 10 milligram, 15 milligrams, and the placebo was compared. The mean weight change at 72 weeks, you can see in percentage with regards to 5, 10, and 15 milligram. When compared to placebo, you can see the 20% reduction in weight, again, 20% reduction in weight when it comes to tirzepatide. More than 5% weight reduction at 72 weeks. 72 weeks, you can see here 90% of the patient on tirzepatide had more than 5% weight reduction at 72 weeks when compared to placebo of 34%. When it comes to adverse effect, yes, there are certain adverse effects like GLP-1RA, that is nausea, diarrhea, and constipation. When you compare tirzepatide versus GLP-1, you can see on the left-hand side of the slide, there is a decrease in HbA1c, where you can see on the tirzepatide column, you can expect the reduction of HbA1c of up to 2.3 when it comes to semaglutide of 1.86. On the right-hand side, you can see when it comes to weight loss, you can expect up to 11 kg weight loss in tirzepatide when you are seeing 5.7 kg weight loss in semaglutide. Now, comparing tirzepatide with semaglutide, you can see here the maximum dose was used was tirzepatide was 15 milligram and Wegovy, that is semaglutide, that is 2.4 milligram. The average weight loss was 20.9% and 14.9% with sema. Actual weight loss with tirzepatide was 17.8%. With sema, it was 12.5%. Coming to the side effects profile, you can see the nausea, vomiting, and diarrhea both is seen in both, but comparatively less with the tirzepatide. So, SURPASS clinical program, if you take in type 2 diabetes, it has first SURPASS 1 with monotherapy, then compared with semaglutide, then with the insulin degludec, SURPASS 4 with glargine, and SURPASS 5 with placebo. In all this study, you can see when it is used as a monotherapy, the reduction in HbA1c was 2%, up to 2%. when it's add on to metformin, when it is superior to semaglutide, superior to insulin deglutide in SURPASS 3, and superior to placebo in SURPASS 5. In all this SURPASS study, tirzepatide showed the superiority with regard to HbA1c. When it comes to body weight as well, when it comes in all these 5 studies, SURPASS 1, 2, 3, 4, 5, you can see the reduction of body weight up to 10 to 12 kgs weight reduction when it compared to the comparators. So the key efficacy of efficacy finding, that is more than 5% weight loss maintenance, that is very important. You can see it is up to 77% to 88% when it compared to the comparators in all the SURPASS 1 to 5 study. More than 10% weight loss, yes, still it is better with SURPASS when compared to the competitors. So the key 15% weight loss, once again, you can see 15% weight loss is quite a significant one. When it compared to the comparators, 15% weight loss was also seen with tirzepatide. Gastrointestinal side effect, once again, the vomiting, diarrhea, and nausea was seen with in SURPASS study program. The safety and tolerability, the overall safety profile is consistent with the GLP-1RA. The most frequent adverse effect were GI, generally mild to moderate and transient. Discontinuation of the study drug due to AIs, adverse event ranged from 3% to 11%. Hypoglycemia was low in the SURPASS program when tirzepatide was not combined with sulfonylurea or insulin. That means you should be careful when you are using this particular tirzepatide with insulin or sulfonylurea. The dosage has to be reduced of that particular molecule. So coming to the other side effect, pancreatitis, though they saw a few incidences of pancreatitis, but none of the events were serious. Anti-drug antibodies, there was no evidence. Medullary thyroid carcinoma, no clinical relevant changes. Diabetic retinopathy, the cases of treatment, emergent diabetic retinopathy are reported in SURPASS 2 program. Can you mute somebody? Can you mute?
नहीं, दवाई ऐसे नहीं, वो प्रिवेंशन के रूप पे जैसे जिन डॉक्टर के साथ कर रहे हैं ना,
हेलो,
कम से कम 50 मरीजों की दवाई छुड़वाई।
प्लीज म्यूट,
आपको बता दें। चलिए आइए, ताड़ासन करते।
So the good candidate is BMI greater than 30, BMI greater than 27 with obesity-related medical condition. Weight loss average, that is, if you say compare with bariatric surgery, you are seeing 25 to 30% body weight reduction. Tirzepatide is 15 to 20.9% body weight reduction. The only limiting factor will be cost, highlighting the major stumbling block that could limit tirzepatide's uptake. Contraindication also we should know. The contraindications are family history of medullary thyroid carcinoma, patients with multiple endocrine neoplasia syndrome type 2, then hypersensitivity. The major drug interaction, delayed gastric emptying can impact absorption of any oral medication administered concomitantly, like hormone contraceptive, sulfonylurea, insulin, and Syncalide. So that administration, the dosage is 2.5 milligrams, 5 milligrams, 7.5, 10 milligrams, 12.5, and 15 milligrams. So increase the dosage, like starting from 2.5 milligrams, then increase by 2.5 milligrams at 4-week increments as needed. No renal or hepatic dose adjustment. It's a once weekly subcutaneous injection. It can be administered into abdomen, thigh, or upper arm. Ongoing research, still many are to come. That is SURPASS 6 comparing with insulin lispro, summit study, that is its effects on heart failure and obesity, which will come next year, and SURMOUNT 1, its effect on weight loss and obesity, it will come in 2024, and SURPASS CVOT, that is SURPASS versus dulaglutide, time to first cardiac event, that will come in 2024. So ladies and gentlemen, to summarize my talk, unimolecular peptide-based dual agonist, that is twin cretins, tirzepatide, have been gaining much attention recently as a novel anti-diabetic agents that can potentially control glycemia and body weight. Twin cretins can add additional therapeutic efficacy to tailor diabetes care, especially among obese individuals with type 2 diabetes. However, caution should be exercised as to whether or not these drugs are appropriate for the management of Asian type 2 diabetic patients, which are primarily characterized by non-obesity and impaired beta cell function, as well as in that of elderly adults with type 2 diabetes who tend to develop sarcopenia and frailty as a result of poor energy intake. It is still not available in India. Once it is available, we can use it in our patient, see the efficacy to know the practicality of this particular molecule. Thank you for your patience hearing. Thanks, Dr. Mayur, for the opportunity. Over to question and answer. If there is any question, we can discuss.
Dr. Arvinda, semaglutide 2.4 milligram injectable and tirzepatide both are available in the West.
West, yeah.
Semaglutide 2.4 subcutaneous weekly.
Yeah.
And tirzepatide 15 milligram both are available in the West.
Correct.
Maybe available in India too. So what is your preference for diversity, tirzepatide or 2.4 sema?
So that's an interesting question, sir. Because tirzepatide and both Wegovy 2.4, like we have to wait and watch for the further studies, because semaglutide also, if you take the cardiac outcome trial is not out. So this also is cardiac outcome is not out. So both of them are not out. It all depends upon the cost. Whichever the cost is better, whichever the cost is economical, we try to use that as of now. But in the days to come, we have to see the further studies and efficacy.
And what is your opinion on the future of Cagrisima, which is cagrilide plus sema 2.4? Cagrisima. Future of Cagrisima.
Yeah, it looks good. We it looks exciting. But in our country, always the cost is a factor. So we have to wait and watch. That is the thing. But the concept, if you take, sir, as you are rightly pointed out, the future is full of newer molecules in the field of diabetes. And the good thing about this molecule is, along with the diabetes control, we have a molecule which have the reduction in body weight as well, and less chances of hypoglycemia. So definitely these molecules are patient-friendly, maybe with future good cardiovascular mortality data.
Just one question from my side, sir. Sir, we have been using GLP-1 analogs for a long time now. Some of my colleagues and physicians, they are skeptical about starting because few of them have had incidents of pancreatitis and cholecystitis. So have you experienced such incidences? Because I have personally not seen it, sir. So have you experienced that in your clinical practice, and what did you say about it?
The main side effect I've seen in my patient is the nausea and vomiting. That is there. Apart from that, not much of concern. The usual question I face is whenever I put this molecule, patient will ask how long this has to be taken. So they don't understand it has to be taken continuously. They'll ask how long it has to be taken. Because how much ever the rich is the patient, still feel in our country that the costlier the medication, the stronger is the molecule. So that is what the mentality is there. We need to explain that this is the situation like that. So they convince them and tell them this has to be taken regularly. Even telling that in few of my patients have stopped abruptly on their own because they explained they experienced unexplained weight loss. Sorry, unexplained weakness. They don't know anything. The moment they started taking this, they explained weakness, though they stopped on their own. But a good thing is now 4 or 5 months over, we are part of one study called a solid study. We are waiting for the 6 months follow-up study also. As of now, the reduction is body weight. We have seen in up to 8 kgs I have seen in one of the patients. So the reduction is good. So the next month is the 6 months data will be having the follow-up. We have to see for that further results. But no question of pancreatitis or cholecystitis as of now in my patients as well.
Thank you. Thank you.
Thank you, sir, for the lucid and very well presented and the newer thing. I'll take help. I have a next week the same topic: GLP versus the tirzepatide, Mounjaro versus Wegovy, a debate. So let's move on to the next session. For the next session, Dr. Gangupadhyay will be available later on. So we are moving to diabetes and the kidney, as many of our speakers are queued and we are already running late by 2 hours. So the recorded session of Dr. Matthew John, I'll ask the tech team to play later on, and we can have Dr. Prabhat Pandey. For this, I welcome the Hormone India Repertoire, Dr. Pankaj Gupta. Please introduce our chairpersons.
Without taking much time, we will quickly move to our next session. So chairperson for this session would be Dr. Chaitanya Kulkarni. He is trained in nephrology, DNB nephrology, and did post-graduation from GMC Bhopal. And next other chairperson is Dr. Mohit Naredi. He is working as consultant nephrology and assistant professor at Pacific Medical College, Udaipur. So, Dr. Mohit, please introduce our next speaker and start the session. Dr. Prabhat Pandey, sir.
Hello. Good evening, everybody. So, continuing with our sessions and not wasting much time, I would like to introduce our next consultant, Dr. Prabhat Pandey, who is a professor in medicine, and he's actually from Durg, and at Sri Shankacharya Institute of Medical Sciences, Bhilai, he's associated with. He's a renowned physician and trained in cardiology, diabetes, thyroid diseases. He's a fellow at Indian College of Physicians. He's a fellow of Cardiological Society of India and a member of American College of Cardiology, American Diabetic Association, Internal Diabetic Federation, and a faculty
Yes,
of
Dr.
DNB,
Mohit, I think we can
National Board,
start.
etc. So I would request sir to please continue with the session.
Yeah. Thank you very much. I hope I'm audible.
Yes, sir, you're audible.
At the outset, thank you very much, Mayur, for including me in such a big show. And the topic which has been given to me is of a very, very practical approach, and I will try to ease out as much as possible. The topic given is ACE and ARB, SGLT2 inhibitors, and a non-steroidal MRA, either in the combination or a sequential in a DKT. So this is really a very practical topic, and both the nephrologists are my chairpersons, and I hope they will throw much light on it after I finish my talk. So I go ahead. My flow of the slides will be like this. You know that diabetic kidney disease is almost 40% in the patient in diabetes develop a kidney.
Yes, sir, perfect.
You know, the basic problem in the diabetes is a hyperglycemia, inflammation, and the hemodynamic changes which cause all the problems, including the diabetic kidney disease. And the prevalence is increasing as a consequence of the growing rates of obesity, metabolic syndrome, and the westernization of the lifestyle, which have made the complications of diabetes much more worsening, including the diabetic kidney disease. Next. This is the prevalence of CKD in patients with diabetes, which varies considerably across the countries and the setting. Here, I would like to specify that African Americans, Middle East people, Asian, and the polycystic patients with the diabetes have a higher prevalence of elevated urinary albumin and the subsequent diabetic kidney complications than the European populations. Next. This is the silent diabetic nephropathy progression, and this is how it starts developing. One when it is a hyperfunctional or hyperinfiltration state. From there, it goes to the normal albuminary urea state, then subsequently the incipient nephropathy. Initially, when the excretion of the albumin is below 30 milligram per day, then between 30 to 300, then it becomes overt and it is more than 300 milligram per day, and subsequently the GFR goes on decreasing and it leads into the end-stage renal disease. And this happens in both the conditions. Yes, next. You see, DKT associated with increased incidence and the prevalence of other diabetic complications also. We know that diabetes is a multi-system disease and it involves all the system of the body, especially the heart, brain, eye, peripheral diseases and all that, including the brain. The pathomechanism and the temporal associations of the diabetes mellitus basically is because of hyperglycemia, which it triggers series of manifestations. First, the renal hemodynamic changes, then activation of the RAS system, then ischemia and inflammation, and the oxidative stress. And because of this, these all events happen, which leads to different arterial constriction, glomerular hypertension, then glomerular hypertrophy, sclerosis, then podocyte injury, then proteinuria, and all these problems start basically with hyperglycemia, which generates series of events. Now, the recommendations according to this kidney disease improving global outcome guidelines. Next. The management of CKD and diabetes is a multifactorial risk factor control. And you see, this is how things have to be managed. First, the lifestyle modification, and the first line drug therapy as shown here, which is starts from the metformin, then SGLT2 inhibitor, RAS blocker, statin, then the goal-directed therapy if you have to add on some other anti-diabetic for the blood sugar control and subsequently the blood pressure control also. The RAS inhibitors are recommended in patients with albuminuria and hypertension. So most of the diabetic patients have hypertension associated, but even if the albuminuria is seen in a patient of diabetes, RAS inhibitors are introduced and are recommended. Similarly, SGLT2 becomes definitely a first choice in a patient. If a diabetes patient has a kidney disease, SGLT2 is the first choice unless contraindicated. Next. Now, the lifestyle measures and the multiple new therapies such as SGLT2 inhibitors and MRAs, which we are going to talk, can give a good control of the diabetes. As I said in the beginning, the lifestyle and the first line drug, which includes metformin, SGLT2 inhibitor, RAS inhibitors, then the targeted therapy, whatever anti-diabetic you want to add, and then subsequently the non-steroidal MRAs, which are also included nowadays in the management of diabetic kidney disease. Yeah. So ACE inhibitor, ARBs, SGLT2 inhibitor, and the new phenomenon, which we are talking about, non-steroidal MRAs. Now, the recommendation is the patient with diabetes, albuminuria, even with the normal blood pressure, treatment with ACE inhibitor or ARB can be considered. Once the albuminuria sets in, one should have no hesitation in starting ACE inhibitors and monitor the serum creatine and the potassium level. The two important things which you have to see. If there is a normokalemia, you can continue with the RAS inhibitors, and unless there is an increase in the serum creatine, which should be more than 30%. But if it is a hyperkalemia, then you have to think about either the reducing the dose or stopping it or adding some other medicine along with it. The overall quality of the evidence was rated as a moderate, and ACE inhibitor have to be either reduced or stopped as per the situation of the potassium level. So in all patients of diabetes with hypertension and albuminuria, the ACE inhibitor have to be introduced, and there is a high value on the potential benefits of the RAS blockade with ACE inhibitors and ARBs. Yeah, next. Now, there is a practical approach to introduce SGLT2 inhibitor in patients with type 2 and diabetes, CKD. You can see with the chart that the patient selection is very, very important. The assessment, then intervention, and then the follow-up. Naturally, if the GFR is high, more than 20 ml per minute per square body meter, then the high priority features, if the albuminuria ACR ratio is more, and there is, unless there is a contraindication, SGLT2 inhibitor should be started. And the various SGLT2 inhibitors have their dose schedule. This should be started, whatever one wants to start, and then the follow-up assessment is to be done. The glycemia part, as far as other factor which have to be looked at, is by glycemia part and the volume reduction, which is a very important feature in SGLT2. The side effect and the effect both have to be considered whenever the SGLT2 is to be started. Next. Now, proven clinical renal and the cardiovascular benefits have been shown with the non-steroidal mingofactor receptor antagonist. It should also be added if the GFR is more than 25 ml, there is albuminuria, and the serum potassium level is normal. These are the very important criteria. Serum potassium has to be normal. And the recommendation places a very high value on the high quality evidence. The two very special trials which have come in favor of NS non-steroidal MRA, the Fidelio DKD trial and Fiagro DKD trial. But it places a relatively lower value on the risk of hyperkalemia. Next. This is a comparative study between the two landmark trials. We need not go into the detail, the Fidelio and the Fiagro, because these are the two important trials which have been done in favor of the new molecule. And both trials have shown the benefit in the diabetic control and the cardiovascular outcome. Both have been found to be kidney friendly and the cardiovascular friendly. Of course, the Fidelio trial has shown much better effects on the kidneys, and the Fiagro trial has shown much improved effects on the cardiovascular outcome. Next. Now, the phenomenon resulted in the lower risk of CKD progression in the cardiovascular event, and the conclusion which was drawn with this Fidelio DKD trial was the phenomenon which resulted in the lower risk of progression of the CKD and the cardiovascular event than the placebo, and the dose which was used was 10 milligram and was increased even up to the 20 milligram. Next. Definitely reduces the progression of the CKD. The another trial which was done was a Fiagro trial, which I said that the conclusion was the primary outcome, the cardiovascular outcome was significantly lower in the finerenone group in this Fiagro trial than in the placebo group, and it has shown improvement in the cardiovascular as well as the renal outcome. Next. Now, the SGLT2 inhibitor. We have already accepted that the SGLT2 inhibitors are the first drug of choice in a patient with diabetic kidney disease unless contraindicated, and they reduce the risk of serious hyperkalemia because it checks out the volume. And in people with the type 2 diabetes at a high cardiovascular risk or with the CKD without increasing the risk of hypokalemia, because it has shown a benefit over the cardiovascular outcome in so many trials. SGLT2 has shown, including the heart failure, various heart failure trial with all kind of preserved ejection fraction, reduced ejection fraction. And that is why if the diabetic patient has some comorbid condition in the form of cardiovascular disease, I think this should be the drug of choice. And if it is a DKD, even it has shown not only in this trial, but also a canvas trial, which has shown improvement in the kidney function and the delaying the complications of the kidney, worsening of the GFR if the SGLT2 inhibitors are used. Next. Now, this is a real-world study on SGLT2 inhibitor and the diabetic kidney disease progression, which has also shown the benefits of SGLT2 on CKD progression and end-stage kidney disease. The effect is more pronounced in the moderate to advanced CKD patients. RAS inhibitor in patient at a high risk for a vascular event. You see the primary outcome had occurred in so many patients in the combination therapy also. So there's no question about showing the benefit of RAS inhibitors in DKD patients. Next. So now the ACE inhibitor or ARBs, SGLT2 inhibitors, this is how it shows the improvement. ACE inhibitor ARBs, they cause the cardiovascular event reduction, blood pressure reduction, the albuminuria is reduced, Similarly, the SGLT2 causes reduction in the volume overload, cardiovascular risk is reduced, body weight is reduced, the systemic blood pressure, systolic blood pressure, triglyceride, HDL cholesterol level are reduced, renal risk is reduced. So these two molecules have shown its efficacy as far as the cardiovascular and the renal outcome is concerned. Next. Now the question is, which is the headline of the topic, whether in combination or in the sequential therapy, the benefits of SGLT2 and the phenomenon may be additive. So definitely it should be initiated prior to the adding a non-steroidal MRIs for the treatment of type 2 diabetes and kidney disease. The addition of phenomenon to the SGLT2 inhibitor may offer clinically relevant improvement in albuminuria compared with the SGLT2 inhibitor alone. And the clinical benefits of the phenomenon have only been demonstrated when added to RAS. So if you have to give a suggestion, definitely in a diabetic kidney disease, first the RAS inhibitor, ACE inhibitors or ARB should be started, then the SGLT2 inhibitor, then the phenomenon should be started. The high renal risk that remains during the ACE inhibitor ARB's treatment might be the consequence of the aldosterone breakthrough phenomena. Next. So this is all the total, but my message is that though we have not tried this molecule very oftenly in a DKD, but we have been using this molecule ACE inhibitor ARBs and SGLT2, and I think this is the right time to add the newer molecule to prevent the progression of the kidney disease. And as far as the sequential therapy, and I have made it very clear that first it should be started ARB or ACE inhibitor, then subsequently SGLT2 inhibitor, and then this new molecule phenomenon which should be started. Thank you.
Thank you, sir. Very well explained the role of SGLT2 inhibitors and newly introduced non-steroidal mineralocorticoid receptor antagonist role in diabetic kidney disease, sir. So I thank you again, sir, and we will quickly move to our next presentation. So I will invite Dr. Chaitanya Kulkarni. Kindly introduce our next speaker and please start the presentation.
Thank you, Dr. Pankaj. Our next speaker is Dr. Rakesh Nair. He's DM nephrology and then MRCP nephrology. It's
Dr. Rakesh Nair, sir. You can take on your session. You can start now, sir. Sir, are you there?
Yeah, I'm here.
Okay, sir.
Okay.
Please start.
He is DM nephrology, presently working as nephrologist at Cochin, and he also trains the fresh postgraduate at Marrow Coaching. Not only that, he trains all the post MBBS student to crack the postgraduate exam, NEET PG also. Over to you.
First of all, thank you, Mayur, for this great opportunity that you have actually given me in being able to come to a platform like this and be giving a talk along with some of the legendary stalwarts in endocrine whom have been actually, a fan of right from my MBBS times. So many of them, I'm not mentioning anybody by name, but I've been a fan of these people right from MBBS times. So a very tricky topic that is given to me today, a very tricky topic that is non-diabetic renal disease in diabetic patients. When you think of a diabetic patient, automatically what comes to your mind is diabetic renal disease. There is no question about it. But the truth is this is the truth. End-stage renal disease in type 2 diabetes is related to non-diabetic kidney disease in nearly 50% of patients, which means what you assume as diabetic kidney disease and what in reality is diabetic kidney disease is a very, very, very big difference. Okay. So many people are under the assumption that when a diabetic patient comes to me and he's having a creatinine high, that is equal to diabetic kidney disease. What is there else? What else can be there? No, that is absolutely wrong. First and foremost thing to keep in mind is that we always think of diabetic nephropathy as the last diagnosis. Our first thought process has to be going to a whole lot of other things. If nothing actually fits the box, that is when we start thinking about diabetic nephropathy. So please don't consider that a diabetic patient with renal failure is having diabetic nephropathy first up. You think of diabetic nephropathy in a diabetic patient at the end, because that is actually a diagnosis. If you talk about end-stage renal disease due to diabetes, then that is a diagnosis wherein what you can offer to the patient is actually speaking very less. So that is why please do keep in mind that end-stage renal disease in diabetes is related to non-diabetic kidney disease. So it is non-diabetic kidney disease that we will be focusing on here. Now, why this is so important to know? You can actually see the natural history of diabetic nephropathy, which is studied in type 1 diabetes. And what you understand is that the rate of fall in GFR over here is quite significant. It is very, very, very significant. So when you tell a patient who is having diabetes with a creatinine 2, that he is having a GFR of maybe around 55, 60, and this GFR is going to become end stage, that is 15, in a matter of 3 years or 4 years, then you're literally killing his confidence. And more or less, he comes to an understanding himself that he is going to become dialysis dependent in a matter of 4 or 5 years. And whatever diabetes you control, whatever kind of control you bring into, whatever HbA1c you try and achieve, that is not going to prevent him from going into end stage. So that is a very pathetic state. So
Hello.
nephropathy. So when you actually make a diagnosis called diabetic nephropathy and you're cementing on the diagnosis and you're actually disclosing it to the patient, then you are in reality giving a very, very bad news. What is the bad news that you're giving? Because the GFR right now, which may be say 55 or 60, in diabetic nephropathy progresses at a rate of 8 to 10 ml per minute per year. So the rate of fall in GFR in diabetic nephropathy is 8 to 10. 8 to 10 money, you will be losing around 50 ml per minute in a matter of 5 years. Which means if a person has 55 GFR now, which will be his approximate GFR if his creatinine is 2, then he will become 15. 15 is end-stage renal disease. He will become 15 in a matter of 4 years, which means he will become dialysis dependent in a matter of 4 years. And if you become dialysis dependent in a country like India, the chances that you cross 1 year without having a significant illness or without having a significant hospital admission is hardly 30%, which means that diabetic nephropathy is never the diagnosis that you're looking for. It is your last diagnosis. It is a very bad diagnosis too. Let us accept that. And what you can do to the patient is in fact very minimal. So when you actually see a diabetic patient, you always hope for and you always seek for whether this patient is having something else. And that is the most important part of it. And that is the most important thing that I want you to be knowing. So when a patient with diabetes has diabetic nephropathy, let us just look into it. When a patient with diabetes has diabetic nephropathy, invariably it goes without saying that it all starts off with glomerular hyperfiltration. So hyperfiltration is the first thing. Intraglomerular hypertension because of glomerular hyperfiltration is what actually is the starting point of diabetic nephropathy. So there is no diabetic nephropathy in the world without proteinuria. So proteinuria is the most important thing. Symptoms relating to proteinuria are very, very important, which means that the patient definitely does explain to you about frothing of urine. So asking the patient in detail about how frothy the urine is and how long this has been happening like that, and the patient's urine routine analysis, which has to show albuminuria. So there is no way in the world that you can think of diabetes or diabetic nephropathy without proteinuria. So proteinuria goes hand in hand. As and when there is a disease to the glomerulus, the tubules will start to compensate. SGLT2 inhibitors are overactivated in diabetes. You'll be having salt and water retention. You'll be having glucose uptake. Invariably, that will lead to intravascular overload. That will sweep out. So you'll be having extravascular overload. There is always edema. Edema goes without saying. So edema, proteinuria are two things which are almost always there. Diabetic retinopathy is one other thing, which is got 100% concordance in type 1, 65 in type 2. And then, of course, hypertension. So the 4 essential hallmarks which you should be thinking about when you think of diabetes with diabetic nephropathy are edema, proteinuria, hypertension, retinopathy. If in case you feel that something on this line is not fitting, or this is slightly odd, that is when you have to be gearing up and looking out for non-diabetic causes. You start seeing these non-diabetic causes. You can see these are all basically non-diabetic causes. List of non-diabetic kidney diseases you can actually see. Non-diabetic kidney diseases starting from ischemic nephropathy, embolism. You can actually see glomerular diseases, polycystic kidney disease, reflux, etc., etc. It is not possible to actually remember it this way. What we understand is very, very basic. What I understand first and foremost is that if there is absence of retinopathy, 65% concordance in type 2, 100% concordance in type 1. But if there is absence of retinopathy, please take it very seriously. Straight go ahead and do a biopsy. There is no point in thinking about it. Proteinuria goes always hand in hand with diabetes. But the moment you are having anything other than proteins in urine, if you're having very active sediments, you're having RBCs in urine, please, that never happens in diabetic nephropathy. It is a 100% indication for biopsy. When you're having a very significant worsening of proteinuria that is disproportionate to the degree of renal failure, proteinuria that is disproportionate to the duration of diabetes, that once again is an indication to go for biopsy. And rapid decline in renal function without significant proteinuria. The moment you don't have proteinuria, again, you're thinking something other than diabetes. And again, after starting ACE inhibitors or ARB, if there is a fall in GFR, again, you're thinking of something other than diabetic nephropathy. So all these things you basically know when you're seeing a patient with diabetes, that these are the chances that it cannot be diabetic nephropathy. So let me just try and see what else is possible. The 3 compartments in the kidney that you have are the vascular, the glomerular, and the tubulointerstitial. So there are 3 compartments. Diabetic nephropathy is a proper glomerular disease. It's a proper glomerular disease. So a person with diabetes can have a kidney disease other than diabetic nephropathy due to involvement of the vascular compartment, due to involvement of the glomerulus, due to involvement of the tubulointerstitial compartment. What can he have as an involvement of the vascular compartment? Vascular compartment, he can very easily have what is called ischemic nephropathy. So ischemic nephropathy patient can also present in ischemic nephropathy, I mean renal artery stenosis. Renal artery stenosis end stage is called ischemic nephropathy. So a patient with renal artery stenosis can also present to you just like how a diabetic patient presents to you with kidney disease. So that is why it's very important for you to know whether it is a vascular disease predominating. When you see the patient, look for proteinuria. Significant proteinuria doesn't happen in vascular disease. Disproportionate hypertension happens in vascular disease. History of POVD, smoking, coronary artery disease, all these things are favoring vascular disease. When you see a lean patient, slim patient with very little edema who has got renal artery stenosis kind of features with CAD, proteinuria, nil edema, very little proteinuria, and actually has got something like a bruit or even having other features suggestive of multiple vessel involvement, in all that points to ischemic nephropathy. Ischemic nephropathy is one condition wherein you shouldn't be actually giving ACE inhibitors, ARBs, because that can worsen your GFR. So the first compartment that has to come to your mind is vascular. Can a diabetic patient have a tubulointerstitial disease? A diabetic patient having a chronic tubulointerstitial disease is very unlikely, but a diabetic patient can have an acute tubulointerstitial disease or an AKI, which is due to involvement of the tubule, primarily because you can make it happen. You can make it happen by giving drugs. You can make it happen by giving contrast. It can happen in the context of sepsis. So every time a patient is having a worsening of GFR, you always think of ATIN, or what we call acute tubulointerstitial nephritis. Acute tubulointerstitial nephritis very, very commonly happens when you give something from outside. That's a drug. Any drug that can worsen AKI, any contrast that you give, or very importantly, sepsis. And these patients can have infections due to hundreds of reasons. They may be having a cellulitis, they may be having a UTI, they may be having something like a pneumonia. All these things can actually worsen. So please be careful about that. In a tubulointerstitial involvement, there will not be edema. In a tubulointerstitial involvement, there will not be significant proteinuria. In a tubulointerstitial involvement, there will be no RBCs in urine. So when you're seeing a patient who has got a very rapid worsening, with no significant edema, no proteinuria, having no RBCs in urine, you are basically thinking of a tubulointerstitial involvement. And tubulointerstitial involvement more or less has a reversible cause. So please do keep that in mind. And $1 million point that we have to always keep in mind is that these are elderly patients. They can have myeloma, and myeloma is no more a disease of the elderly. It's a disease which you can see from 40, 45 years onwards. So when you see a diabetic patient who has disproportionate proteinuria, but that is not algorithm. That's why doing 24-hour protein is very important. The moment you are having 24-hour protein value very high, but your urine routine is not showing so much of albuminuria, that means it is something else. And that something else is very often light change in urine. So please keep in mind that diabetic patient, anemia, high ESR, don't keep high thresholds, keep a very low threshold for testing out for multiple myeloma. Myeloma and amyloidosis are very common. The more you see proteinuria, especially in myeloma, which is not albumin, that's a big chance. Anemia high, yes, sir. Urine albumin not significant, but 24-hour urine albumin with 24-hour urine protein high means always keep in mind myeloma. Please go ahead and do a biopsy. So that's also extremely important to keep in mind. That is about the tubulointerstitial compartment. When you come to the glomerular compartment meaning mostly it's diabetic nephropathy itself. But can you have a glomerular disease other than diabetes? Yes, you can have a glomerular disease other than diabetes when the patient presents with nephrotic syndrome. See, very, very wrongly we are taught that diabetes produces nephrotic syndrome. No, diabetes produces nephrotic proteinuria. Nephrotic proteinuria and nephrotic syndrome are two different things. You can get nephrotic proteinuria but need not necessarily syndrome. Which means nephrotic proteinuria with hypoalbuminemia, with edema and hyperlipidemia is called nephrotic syndrome. Diabetic patients don't get nephrotic syndrome. You check their serum albumin levels, they will be normal. They get nephrotic range proteinuria. So the moment you have a diabetic patient with nephrotic syndrome, that means that the syndrome is due to some other cause, we have to do a biopsy. Okay, so actually speaking, these are the list of things that you can see over here. Macroscopic hematuria means there is something else in the glomerulus. Acute renal failure, look out for the cause. Nephrotic syndrome, always look out for the cause. Very rapidly progressive renal failure, look out for the cause, especially is going to be an infection. Progressive proteinuria, disproportionate, again look out for. RBCs, WBC, cause look out for. Renal disease less than 5 years, again look out for. And the most important things that I want to tell you is diabetic nephropathy is the most common cause of nephrotic range proteinuria without syndrome. It seldom presents as syndrome. It doesn't really present as syndrome. Elderly with renal failure disproportionate to albuminuria should always raise a suspicion of a plasma cell dyscrasia. Smoker with POVD plus CAD having minimal proteinuria plus edema is never diabetic kidney disease. It is very often a vascular disease. It is very often renal artery stenosis. Autoimmune diseases in the background of diabetes in a young female to be never missed. So anything and everything can be SLD. It's not mandatory that the girl need to be having only SLD. We're seeing a lot of patients with polyglandular autoimmune syndromes who do have type 1 diabetes alongside, and on top of it, they may be having so many manifestations. One manifestation among that can be an autoimmune disease, which may be anything like SLD. So that also to be kept in mind. So when you see a patient with renal failure from today, please try to localize the compartment first. Okay, patient having significant proteinuria, edema, RBC is glomerulus. If that is not there, it is vascular tubulointerstitial. Vascular will have hypertension, tubulointerstitial will not have hypertension. So if you know this much, you can come to the compartment. If you think it is vascular, then it is never diabetic nephropathy. It is likely to be RAS ischemic nephropathy. Do Doppler and go for angio if required. If it is tubulointerstitial, it is acquired, acute, and the most important acute causes to be kept in mind are drugs, infection, contrast, and myeloma. If you come to glomerulus, in the glomerulus, mostly it is diabetic nephropathy. If you are having macroscopic hematuria, then it is not diabetic nephropathy. If you are having nephrotic syndrome, then it is not diabetic nephropathy. For every case of nephrotic syndrome and macroscopic hematuria, please do a biopsy. Okay, so this is basically the take home that I want to tell you. And once again, emphasizing on the fact that to make a diagnosis of diabetic kidney disease, anybody, any Tom, Dick, and Harry can do. But to come out with the diagnosis that it is not a diabetic kidney disease is where I think we should be showing our talent. So these are all the drugs which somebody else will be actually talking about. This is what we have with us in our armamentarium. But as such, the diagnosis part is what I have dealt with. Thank you. And once again, thank you, Mayur, for this great opportunity to share space with some of the legends in this field of endocrine. Thank you.
Pankaj, please take over.
Thank you, Dr. Rakesh Nair, and very well explained the necessity of considering non-diabetic kidney disease in patient presenting with over symptoms without vaguely making a diagnosis of diabetic kidney disease. So we have Dr. K.K. Gangopadhyay sir with us now. We will consider this presentation and followed by our next presentation. So next presentation is by Dr. K.K. Gangopadhyay. He is MD post MRCP and CCST in endocrinology, consultant diabetes in University Hospital, Birmingham, UK, and he is a investigator in several clinical trials. He has Stephen Whittaker Prize, Owen Wade Prize, Endocrine Society Prize, and UC Prize in his pocket. He has many international and national publications, and he is a renowned figure in the field. So over to you, sir. Please start the presentation.
Okay, thank you, Chairperson, sir. I hope you can hear me. I'm having some internet issues.
Yeah, yes, sir, you are loud and clear, sir. You carry on, sir. You are loud and clear.
Okay,
Please
so
share your slides, sir.
yes, I'm sharing my slides. So my topic is a bit unusual. It's once weekly insulin. So I think whatever we have talked about is the current scenario, and I'm talking about the future. So many people, many patients come to us and say, "हफ्ते में एक बार वाला दवाई नहीं दे सकते हैं." They mistake the GLP once weekly GLP-1 to be as once weekly insulin, and they come and say, "मुझे हफ्ते में एक बार वाला insulin मिल रहा है." So that is not there yet in the market, but it is soon going to be. So I think we should have a good idea of what that once weekly insulin is. So I think this is a no-brainer. The 27% of our patients, they think that taking insulin with the meals, that becomes a big headache for them. And more than 90% of them expressed a wish that the insulin, if it can not be injected every day, but at least once a week, that will be a great improvement. So if you see here, this is the current insulins which are there, and this is Icodec, which is the once weekly one. So look at the mechanism of protraction of the insulins which are there. So glycemic in 300, you are reducing the surface area, causing even slower dissociation, which is applicable for glargine U300. Detimir and degludec, they bind to serum albumin, and that is how their action is prolonged. And Icodec is separate from these because it uses 2 or 3 mechanisms to prolong its action. So this is the most studied once weekly insulin till date, which is called Icodec. So here it is not only albumin binding, but also increase proteolytic stability and reduce receptor affinity. And I'll come to that in a minute. So you can see the half-life here of 24 hours for glargine, and here you can see this 196 hours for the Icodec. Now these are the changes which are there in the Icodec. So you can see there are a few changes here. So here you can see tyrosine into glulicin, histone change here. These red means these are borrowed from oral insulin which they were planning. They use this to reduce the proteolytic, making it more stable, to reduce the proteolytic dissociation. So you have got another change here, which is B16. And this is very important because what happens, because of this change of tyrosine to histone, it reduces receptor affinity. Now we know that if the receptor affinity is reduced, then it will work less. But hang on, it is not just reducing the receptor affinity. Because it is reduced, it reduces the receptor-mediated clearance. If it is not binding that well, it will not be cleared that well. So the main thing is it will bind slowly, not that much, and will get dissociated also very slowly because receptor-mediated clearance is not there. And there is a mini peg spacer with which it links to the albumin, and that is how the action is prolonged. So you can see here, there are 2 or 3 mechanisms by which the action is prolonged. One, by binding to the albumin and getting released slowly. Second, by reducing the receptor affinity. Therefore, receptor-mediated clearance, because when the insulin binds to the receptor, it is internalized and then degraded. That is reduced. And the third is it increases the proteolytic stability of the insulin molecule. So the 3 mechanisms, of which I feel that this one is the most important one and the one which contributes most to the increase in the duration of action. So the mean half-life is about 196 hours, and clinical state is achieved after 3 to 4 once-weekly subcut insulins. And so although insulin Icodec has been designed to have a prolonged PK, remember, just like others where they use the albumin, a slow and steady PD effect, which is mainly due to the receptor binding and receptor-mediated clearance, that is more important for their enhanced or prolonged duration of action. Just give me a second. Okay, so I hope I'm still audible. So, hello?
Yes, sir.
Yeah,
Yes,
I'm
sir.
audible?
Please,
Okay.
please continue, sir.
Yes. So this is the mechanism. So you can see here in day one, in here, when the icodec is injected. So at day 7, there is little bit coming into the blood, and then it is stuck to the albumin and then slowly released from the albumin. Now, automatic question comes, if something is getting stuck to the albumin and prolonging the action, then in what happens if your albumin levels are very low? So you see here, the concentration of icodec is about less than 500 nanomoles per liter, which is substantially lower than the albumin concentration, which is 6 lakh nanomoles per liter. And each albumin molecule has at least 4 high affinity sites. So therefore, even in higher concentration of icodec, there are more than 2,000-fold excess of binding sites. Therefore, even if there is albuminuria or low albumin, you would not have any problems with the icodec concentration. So you can see here, this is glargine, and this is the number of weeks. So this is glargine here. You can see the levels going up and down. And at the bottom of that is the icodec. So it's slowly going up at 1 weeks going up, and at around 4 weeks, it reaches the steady state. Another graphical explanation, the insulin icodec concentration at 1 week. This is a model predicted one. So 1 week is roughly around 40 to 50% effect you will get. At 2 weeks, you will get about 60%. 3 weeks, you will get close to 80%. And at more than 90% at 4 weeks. So you require at least 4 weeks to reach a steady state. So, however, the model predicted distribution of glucose lowering effect, the steady state, that doesn't look too bad, because if you draw a line here, it is somewhere there. So between 12% to 16%. So that's the variation that is there, which is not too bad. Now, how about the hard endpoints? Now, this is the phase 2 trial wherein they compared the once weekly icodec with once daily glargine. Now, mind you, if you are going to give once weekly icodec, you have to give 7 times the dose that you would get for glargine. For example, if you are giving glargine 10 units daily, for icodec, you have to give 70 units weekly. So 70 units all in one go. So 70 units on Monday, and then next Monday, 70 units, like that. So this one, what they did was they compared 3 types of titration. Titration A, titration B, titration C versus glargine. Okay. So icodec was initiated at 70 units weekly, and glargine was initiated at 10 units weekly. So what was the titration? So this is titration, this is titration A. That was going very slowly. So you start at 10 units, that is 70 units every week. So 70 units one day, and then after 1 week, 70 units. And if you want to make any changes to the blood sugar, so your target blood sugar is between 80 to 130 fasting. If it is less than 80, you reduce by 21 units. If it is more than 130, you increase by 21 units, because 21 divided by 7 is 3 units. That's the change you are making. Titration B, that here slightly higher titration. So 4 units per day, that is 28 units per week. And titration C is you choose a tighter fasting blood sugar level between 70 to 108. So you can see here, at the end of treatment, the titration A seems to fare better and almost as good as insulin glargine, perhaps slightly better. The other titration mechanisms fare slightly better than glargine, but they have slightly more hypoglycemic range blood sugar readings, which the titration A doesn't have. So glargine 10 units once a day and icodec 70 units weekly. So hypoglycemia with the titration A, if you look at the rate, it is 0.73, which is comparable to the glargine, which is 0.58. However, if you want to titrate at a higher dose or you choose a lower fasting sugar, then you get more hypoglycemia with the icodec. Again, the titration C is where you're aiming for a lower fasting glucose. There you can see the fasting sugars coming down, but otherwise titration A and B both are similar to glargine. And this is the number of patients achieving HbA1c of less than 7. You can see glargine and titration A are about the same. So what does it tell us? It tells us that if you're using glargine 10 units daily versus icodec 70 units once a week, one dose, that is equivalent in many respects. So was the dosage? Dosage were the same. So you can see here titration A 142 units and 145 units. And there was no increase in weight. So the other question is that this is, I've shown you in insulin naive patients. What about those who were already on basal insulin? Suppose somebody is already on 20 units of glargine. Now you want to change over to this once weekly icodec. If you start with 70 units a day, it will take a bit of time to pick up because, as I said, it will take 4 weeks to reach a peak effect. So till that time, will the blood sugar stay high? So they come up with this idea, this trial, individuals switching from a daily, sorry, there's a lot of noise. So individuals switching from a daily basal insulin, what they did was they went into 2 steps. One group, they had a loading dose. So you give double the dose on the first week and then subsequent weeks the same. And the other one, no loading dose. So like insulin initiation. So they were randomized to one initial 100% loading dose, no loading dose, and the third one was insulin glargine. Now you see the pen they have mentioned here for the first time, it is 700 units per ml. Initially, I was wondering if you're giving 70 units, there's so much of insulin, the patient will have a lot of pain, discomfort, lipohypertrophy, etc., etc. But this is what they've shown, 700 units per ml. So that means that the volume is not that much. Okay. So here what they showed is those who have loading dose given, they seem to do better as compared to glargine U100, albeit slightly more hypoglycemia, but loading dose seems to be better than no loading dose. So you can see here, where should I follow? So look at this, I think that will give us a better picture. So this is the one where no loading dose is given. So patients who are already on basal insulin, no loading dose given, look, the blood sugar shoots up because the insulin has not started to work yet. And when you give the loading dose, it almost follows the curve of that of glargine. So the hypoglycemia was similar. I'll have to quickly go through because I've got very little time left. The other trials, they have got only top line results. So all I'm showing you are these are top line results. We don't have it published yet. So onward 1 to onward 6. So they compare icodec with glargine in insulin naive patients and insulin on basal insulin. Patients on basal bolus insulin is only one, which is onward 6, which is type 1 diabetes that they have used. And here you can see in onwards 1 and onwards 4, the HbA1c drop was similar to glargine. The hypoglycemia also was similar to glargine. The other comparison with degludec, again, HbA1c seems to be better than degludec. In 2 of the trials, only thing is in the type 1 trial, the hypoglycemia was much more and statistically significant in the icodec arm. I will skip this, and there is one more trial going on with once weekly icodec and once weekly semaglutide to give you once weekly icosema. So GLP-1 plus basal insulin once weekly. So some unknown areas, so last two slides, some unknown areas, we don't have data on hepatic or renal insufficiency. What about hypoglycemic potential in response to unexpected exercise? Dose adjustment would only be possible after a week. So if somebody has got hypoglycemia, maybe for the rest of the week, we have to keep on increasing the carbohydrate intake. Safety in type 1 diabetes still unclear. And what about real world dressings? So the good thing is once weekly, there is no increase in hypoglycemia, efficacy is retained, but the slow onset of maximal action. So we have to wait. The patients will have to wait for 4 weeks to see the maximum action. I was initially worried about the high amount of injection, but I can see in one trial they mentioned that it is 700 units per ml. Should we or should we not be giving the loading dose is the other question. And we need more data in presence of hyperalbuminemia or hyperalbuminemia, even though it does suggest that it should not affect it. So with that, I end. And thank you. And sorry, I'm 30 seconds overstepped my talk.
Thank you, sir, for such an interesting talk over once weekly ipodec insulin, which could be a future in field of diabetes. So very well explained various aspects of ipodec insulin, structure, pharmacokinetics, pharmacodynamics, and dose consideration. So thank you, sir.
There is a question in the chat box. Is any data available for the Indian patients?
No, nothing. So they have just finished the phase 2 is over. So dose finding is over. What I've shown you is top line results from phase 3 trials. So these are all Western data. We don't have any Indian data yet. So it's still a way away, but significant advance. If they're in phase 3 and they have done it comparing with glargine 100, degludec in type 1, that means they are very serious about it. And I think within the next 1 or 2 years, we should be seeing it.
Thank you, sir.
Thank you, sir. We will move to our next talk. Dr. Mohit, please introduce Dr. Manoj Indulkar, sir, for the next talk and start the talk. Dr. Mohit? Okay, maybe he's not there. Let me introduce Dr. Manoj Indulkar, sir. He is a well-renowned teacher and he is a medical consultant and he is a member of IMA, Madhya Pradesh, Riva. So, sir, kindly start the talk.
Before you start, I'll just say a very quick hello to Dr. Indulkar. He was my senior to me by 1 year in Indore. So nice to see you.
Yes.
And sir is presently as an HOD of Riva Medical College, and he was our examiner in MD final.
Arre baapre, okay. To see you.
Thank you. Okay. So thank you for introducing me and thank you organizing committee, especially Mayur. Today I have given a very interesting topic that we are dealing in day-to-day practice. That is some special situation like urinary tract infection. So you know, when a patient of a diabetic develops some complications, so one of the important situation, either it may be acute or it may be a chronic. There are some of the scenarios seen in diabetes, and they usually comes with the hyperglycemia, like or some complication like diabetic ketosis. And during that time, they develop some complication. Secondly, many of them, they may have a infection which lead to the hyperglycemia. So it is a vice versa. Some of them, they may comes with the significant complication like urinary tract infection or other infection. Diabetic itself is a condition which is responsible for many complications. And infection is one where many infections we can see during our day-to-day practice. So one of the complications which is very common is the urinary tract infection that we are seeing in diabetic. So it is very common and it is usually seen in patients who are poorly regulated. And not only the urinary tract infection, there are many more infection, like we can see infection in the eyes, ear, respiratory infection, especially during these days when the COVID is still prominent. Although many of them, they have a negative report, but many of them, they are diabetic and they have a worse outcome also when they are suffering from the diabetes. So UTI is the one of the important and life-threatening complication. Many of them, they may comes with a very unique complication, like they may comes with the mucormycosis, especially during the period of COVID. We have seen many patients of mucormycosis in our ward, and commonly in the diabetic, what we are seeing is the candidiasis. We are seeing the cellulitis, especially of the limbs, and definitely not only the COVID, the other pneumonia is also very common in diabetes. Apart from that, rarely we are seeing the emphysema cholecystitis. Many of them, they comes in a life-threatening situation. Acute cholecystitis, many of them, they may acalculous cholecystitis with the sepsis. But there are infections which are only seen with the diabetic. One is the malignant otitis externa, and apart from that, in the urinary tract, there is pyelonephritis, Fournier's gangrene, and many more other infections. They are unique to the diabetes. Right. Spectrum of urinary tract infection and diabetes. Many of them, they only have a asymptomatic bacteriuria. Symptomatic bacteriuria, they need proper attention, and most of them, it is usually seen when there is a high glucose concentration. That is the one which is responsible for colonization of this organism. So high glucose concentration is the favorable into your atmosphere for many of the organisms. The most common organism which responds is the E. coli, which totally dependent on the glucose. And there are various mechanisms which are responsible for that. We are going to discuss in the next. Now, if we see age and gender wise, as the age increases, its prevalence and incidence is increasing, especially always we think of it is a disease of women. But after the age of 52 or 53, when the men developing a prostatitis or benign prostatic hypertrophy, then the males also coming with the high prevalence and high incidence of urinary tract infection in diabetes. So as the age increases, the prevalence of the UTI is also increases, especially in the women. But in the postmenopausal lady, also they have a high prevalence of the UTI. In one study, they have found only 6% of non-diabetic women are suffering from this UTI, while 26% of the women who are suffering from diabetic, they are developing diabetes, and they UTI, and there is a recurrence in a 1 year. 2 or 3 episodes are commonly seen of the UTI, and recently the drugs also responsible for the UTI in postmenopausal ladies. Now, what are the risk factor for UTI? So one, it is in the diabetic as well as in the non-diabetic. The indwelling Foley's catheter. Many of our patients, they remain on Foley's catheterization. Sometimes they comes with the obstructive uropathy. Antibiotic use. So rational use is mandatory in all patients. Then spermicides that responds to the irritation and attachment to the sites of mucosal bladder mucosa. And the E. coli is the one which has a very good attachment with the mucosa. Then apart from the behavioral pattern, if a person have a frequent sexual intercourse, are susceptible to develop. Then if a patient of a diabetic who develop autonomic neuropathy, then they may have a voiding dysfunction which lead to the cystopathy, and that may be the one risk factor. Excuse me. Then very important is the vesico-ureteral reflex, the retrograde infection, which is usually very common phenomena in a diabetic patient. In the pregnancy, because of the pregnancy, it is compressing the urinary bladder and ureter. That may lead to the obstruction, and that is the floor for bacterial growth. In a normal individual, there are certain defense mechanisms, like if urine is acidic, if they have a good urinary osmolarity, very high osmolarity, in that case, the chances of growth of this organism are very high. There are some of the substances, there are some peptides which are responsible for the reduction of the bacterial adherence to the mucosa. So these are the important host defense. There are some mucopolysaccharides, there are mucosal immunoglobulin A, and in main, there are some bactericidal zinc and urethral secretion. Sorry. Yes. So, there are anti-viral peptides and protein. They are responsible. So this is the important host defense. If this is the failure of these antimicrobial peptides in the urinary bladder, you can see in the right side of the picture, the E. coli is ascending and it is being destroyed by some insulin-dependent amino peptides, and they destroy these uropathogens, that is a E. coli in the urinary bladder. But if there is some defect in the immune system, this uropathogenic E. coli, they enter into the collecting that, they ascend, and then there are a beach in the continuity, and they may be responsible for the infiltration of this uropathogenic E. coli. So these are the important antimicrobial peptides which protect the urinary bladders, collecting the system, and kidney from the urinary tract infection. Next. Control. So I already pointed out how this organism ascends. So one mechanism is aminopeptides. There are different peptides. There are first, what is the steps? The first is that this organism enter into the urethra and then they ascends. Then there are this organism, they are fibria, allow bladder epithelium cell attachment and subsequently penetration. So all depend on the immune system. After penetration of this organism, they replicate and they form biofilms in the urinary bladder, and then subsequently there is ascension. The organism ascends into the ureter and subsequently into the kidney, that responsible for the pyelonephritis. So that is an infection of renal parenchyma, and there are cascade of inflammation which lead to the acute kidney injury. Next. So there are problem in the immune system. Either it may be humoral, there may be cellular, or there may be immunity that may be responsible. Now, what are the organism? You must know the organism, because in subsequently we have to give a specific treatment for specific organism. There is a specific antibiotic also. So it is important. We have to culture the urine, and then we must know which organism is responsible. So outrightly, the E. coli is the #1 organism which is responsible for the urinary tract infection. Subsequently, the Klebsiella, Pseudomonas, they are the organism which is responsible for the life-threatening with a worse outcome in complication in diabetes patient. The gram-positive organism is also responsible for the UTI, that is alpha streptococci or Staph aureus. They may be also responsible for UTI. So common one is the E. coli. So these are the mechanism. The glycosuria, which is responsible for providing the beds for this organism. Then increase adherence to the epithelial cells. So the uropathogen is having a very important property of flexibility. by which it will allow filling and emptying of the bladder. At the same time, it is impermeable to the fluid and is able to cope with the varying pH, osmolarity, and various toxic substances like high ammonia level. So, in the pathogenesis, if this uropathogen responsible for adherence, then sometimes there are some substances like adenosine is responsible, which adhere to the uroepithelium, and then there are other substances like uroplakins, the glycolipids. They are responsible for adherence of this organism. Then immune dysfunction, either humoral or cell-mediated immunity. In the cell-mediated immunity, they affect the polymorphism leukocyte function, and the phagocytosis is affected. Chemotaxis is also affected. So there are many systems which affect by this organism. Apart from that, if you see, there is a lower urinary concentration interleukin A and interleukin C in women who are suffering with diabetes. They may be the responsible, which is responsible for the lower urinary WBC count and which lead to the adherence to this organism to the bladder or ureter. Apart from that, there are various studies which has shown the SU2 inhibitor may be the one drugs which may be responsible for the genital infection or urinary infection. But there are a scientific report which is published in Nature where they showed it required a long analysis. Then we can say the SU2 inhibitor may be the responsible for urinary infection. But after postmenopausal, there are studies where they have clearly mentioned there are genital infection, there are urinary infection. So right now, there are no data or meta-analysis which reveal the SGLT inhibitor is definitely responsible for the genital infection or urinary infection. Now, if you see the spectrum of urinary tract infection, it varies from the asymptomatic bacteria. It is more common in diabetic women as compared to non-diabetic women, where patients do not have any symptom, but the bacteria are there. So, but we should not treat until unless the patient becomes symptomatic. So, what are the symptoms that, and what is the spectrum? They may have an infection in the urinary bladder because of the autonomic neuropathy, autonomic cystopathy that may be responsible. Then the infection may ascend into the kidney, where it may be a complicated or it may be uncomplicated pyelonephritis. What are the symptoms? In most of our patients, they comes with the burning. So burning micturition is the most common symptom. Then they may have an urgency. They may have a cloudy urine. Sometimes they may comes with the
sorry to interrupt. Last
also.
1 minute.
Okay. So these are the symptoms of urinary tract. When we have to suspect, if first of all, the first and foremost diagnostic way of urinary tract infection is the microscopic examination. If a microscopic examination is positive, we must go for the urine culture. That is another way by which we can confirm. If patient may have symptoms which pertain to cystitis, means they may have a suprapubic pain, we can suspect. If some patient comes with the costovertebral angle pain, we can suspect pyelonephritis. So emphysematous pyelonephritis is a severe necrotizing form of bacterial nephritis, which is responsible for the gas formation within the parenchyma of the kidney. In this picture, you can see that there is a translucent picture which is surrounding, and there is a response of the inflammation of the kidney. So this is a classical picture of emphysematous pyelonephritis, which is a unique to the diabetes. Yeah, this is ultrasound where you can see there is the gas bubbles. So radiological diagnosis, CT scan, ultrasound may reveal the complicated pyelonephritis. So in this picture, you can see there are gases. This is another complication, perinephric abscess. Just outside of the kidney, you can see a abscess. That is another complication. In this picture, you can see there is a renal papillary necrosis. So these are the life-threatening. For that, we have to do CT scan, and clearly we can see the diagnosis based on the microscope examination. There are depistic tests. We can see the colonization, and as far as the management is concerned, on the basis of presence of symptoms, any severe complication. Next slide. So if patient is asymptomatic, either men or women, we should not give any treatment. But patient who comes with a simple urethritis or cystitis, the first line therapy is nitrofurantoin, fosfomycin, trimethoprim, sulfamethoxazole. And if it is a complicated, in that case, we can do a add-on therapy with a cefuroxime. In a woman, we can add a quinolin aminoglycoside. If it is complicated pyelonephritis, the piperacillin, tazobactam, ertapenem, or aminoglycoside to be added. Means patient must be hospitalized and to be started with the injectable therapy. And for a longer period, so hospitalization is required. We start with the broad-spectrum antibiotic. So in the last, one of the common complications which we are seeing in the diabetic patient, so we must take agency regularly every 3 months or 6 months. If it is very high, ask them to control it. So make them euglycemic, and UTI, a simple UTI may lead to the worst outcome if the patient is not euglycemic. So antibiotics are very specific. Most common organism is E. coli. Thank you very much.
Thank you, sir. Thank you, sir, for a wonderful, informative talk. So rightly told, diabetics are at increased risk for some infection, and some are unique to diabetics, and which could be life-threatening also sometime if not properly addressed, sir. So right from hyperglycemia to autonomic neuropathy, all increasing the risk of infection and UTI as well. So thank you again, sir. And I thank all the chairperson and all the esteemed speaker for the session. And with this, we conclude this session. We will quickly move to our next session. So over to you, Mayur.
Thank you very much, everyone who has joined in. Thank you for contributing and making this conference so successful. All the topics are very nicely covered. For the next session, I welcome Dr. Tony. He'll be rapporteur for the next session, Practical Tips in Diabetes Management. Dr. Tony, please introduce our chairpersons for the next session.
Thank you, Dr. Mayur. So we are running late by almost 2 hours. In spite of that, thank you all speakers and chairpersons for being with us. So we have 4 speakers for this session, which is on practical tips in diabetes management. And I'd like to introduce the chairpersons first. First, we have Professor Dr. Vijay Garg, sir. He is from R.D. Gardi Medical College since 10 years, and he has many publications. Then we have Dr. Ashok Gupta, sir, Senior Consultant in Internal Medicine in Basal Hospital, Bhopal. And we have Dr. Sanjay Jain, who is an MD Medicine in Bhopal, working as a unit head at Kamla Nehru Hospital, Bhopal from 2018. So thank you all chairpersons. So I would request Dr. Vijay Garg, sir, to introduce Dr. Tejal Lathia, madam.
Yeah, just to add a remark, since we are running late, we have a recorded session from Dr. Sushil Jindal, sir. He is an endocrinologist at Bhopal. So we'll play later on, since many of our speakers are queued in live. Tech team, please display the CV slide of ma'am.
Vijay sir, could you please introduce ma'am?
It's visible, the slide, sir.
Vijay sir, you're muted.
Dr. Vijay Garg, sir, kindly unmute.
Yeah, I'm introducing Dr. Tejal Lathia for her talk, and she is DM Endocrinology from Mumbai. I'm not able to see. You can introduce her.
Okay, I'll just
see her.
Okay, sir, I'll just briefly introduce. Okay, madam is working in Apollo and Fortis Hospital, Navi, Mumbai. She is co-author for language Yeah. So, and she has various publications to her credit. So over to you, madam, for your talk on communication in diabetes.
Yeah, if you could stop sharing your slide. Yeah, so I apologize, but I have kind of tweaked the topic a little bit and made it a little bit more general, because I think diabetes is really talked about. So I will still stick to my field, which is endocrinology, but I've kind of made it a little broad to communication in endocrinology. I promise I will finish in exact 15 minutes. So good evening, everyone. And I think probably everybody right now is thinking that what is this communication business and why are we even really discussing it at this conference? So at the beginning, congratulations to the entire team for the first meeting and for letting me choose my topic. This topic is actually now going to be included in the Endocrine Society of India textbook as a chapter. And that is why I was very keen to do it. So this is something which Daniel Kahneman, who received the Nobel Prize for Economics, said that people don't choose between things, but between description of things. Means that people don't choose between an X-ray and maybe a CT scan, but how the doctor communicates about the X-ray or the CT scan and what is the value of that investigation to the person is probably what helps people to make choices. The same way about treatment, if I want to convince somebody to take a GLP-1 analog, even if it's 10,000 rupees a month, the way I communicate has a great impact on what choice the person will ultimately make. Now, why did we start this journey of communication in endocrinology? Because we had conducted a survey in about 1,000 endocrinologists and diabetologists across the country, and we listened to all the physicians' perspectives on patient communication and how that impacts diabetes adherence. And what most doctors said is they tend to show their disappointment in their patients' progress. They use scare tactics to convey the severity of the disease, and they all said that communication cues are really, really important. However, we also did focus group discussions with a lot of patients, and these were some of the phrases that patients recalled had been said to them during consultations. With these sugars, your kidneys will fail and your life will be cut short by 10 years. When I went to the doctor, the first time the doctor scared me. Every time I went back, they told me, you will have a heart attack. Whatever patient has to face, he has to face, but the scare tactics only create fear psychosis. So somewhere, as doctors, we know what's the right way to communicate. We know what's important, but somehow in clinical practice, maybe because there are too many patients, maybe that's what you've seen your seniors do. We tend to use a lot of scare tactics in our communication with our patients of diabetes as well as endocrinology. I will never forget this lady. She died a few months after, this interview was done. And she said, you know what? I'm an animal lover. And my doctor told me that my pancreas is like a dead horse. I mean, what is the relationship between a dead horse and a pancreas? And she was very, very upset. And unfortunately, I lost her a few months after we conducted this interview. So the question is communication a desirable skill in endocrinology? How does good communication impact our practice? And is it the need of the hour? Now, I know that doctors and endocrinologists respond to data. So let's talk a little bit about data in endocrinology and whether it's a desirable skill. Now, there's a beautiful paper. All they did is they conducted a survey of program directors in endocrinology and recent graduates of endocrinology. And they asked them that if we create a leadership training in endocrinology fellowship, what were the skills that you would rate as the most important for somebody to include in the curriculum for leadership training? So if we had to teach people to be leaders in endocrinology, what is the one skill or what are the different skills that you would really want in the curriculum? So what the program directors, 97.5% of the program directors of endocrinology in various hospitals in the US felt that communication skills were the topmost skills that were required to be in the curriculum to create good leaders. And more than 80% of the recent graduates also concurred with this opinion. So to people who are designing endocrinology and diabetes courses, communication skills are really important. This next paper is called Clinical Excellence in Endocrinology, and Dr. Howard Baum is trying to define what are the elements that are needed to be excellent in endocrinology. And he rates communication and interpersonal skills above knowledge and scholarly approach. So all our life in medicine, we're told it's what we know that's most important. But I think it's now time to shift the perspective. Yes, of course, we need to know the subject matter very well, but probably how we communicate the subject matter is a little bit more important than how much knowledge you have. Why are we even talking about communication in endocrinology? What is so unique about endocrinology? Well, first off, endocrinology is a complex condition, and endocrinologists at sometimes we struggle even to explain to another general practitioner what exactly the condition is that I'm trying to talk about. So it's a complex science, and it's difficult for doctors to understand. It's even more difficult for patients to understand. These are conditions like diabetes, which have a major impact on quality of life and therefore are sensitive. We also deal with a lot of intense personal issues like sexuality, fertility, never being able to have children, body image, and that's why it's even more important how we communicate about these conditions. The other thing is that, and this will, I think, most of us will understand that most of the patients with endocrine conditions, including diabetes and thyroid, require lifelong medications. But still, in spite of our best efforts, it seems to be that most patients are going for alternative therapy, because how we communicate about the medicines we write is a very important part of treatment adherence. And when we don't communicate adequately, when we don't give enough patient education in the right way, then this contributes to treatment non-adherence. So you can write the best prescription in the world, but if you don't communicate it properly, the patient is just not going to take it. And this is a reality. Furthermore, endocrinology doesn't have any heroics, right? You can't perform a surgery, you can't deliver a baby, you can't really do much. So it's a cognitive, non-procedural discipline. And that is why communication skills and the physician-patient rapport is completely king in endocrinology. So now that I've brought to your notice that training programs, clinical excellence in endocrinology does require good communication skills. Endocrinology is a sensitive, complex subject which requires a lot of communication. But how does it actually impact our practice? And always the proof of the pudding is in the eating. So these are, quickly, I'll show you 3 to 4 slides which say the patients of physicians who had high scores on the Jefferson scale of empathy, that is, they spoke with empathy and concern, their patients were more likely to have lower HbA1c and lower LDL cholesterol. And I definitely think that somewhere the empathy translates into treatment adherence and therefore into better results. This is another study which said that when a person goes to meet a doctor, and if they feel or they perceive that the physician is inattentive to their problems and there is a lack of engagement with the doctor, you're looking down at the reports, you're looking at the computer, you're in a hurry, you're rushed, patients of such physicians are more likely to be less adherent with their insulin regimens and ultimately display higher HbA1c values. Now, why am I saying this? My intention is not to judge doctors or blame doctors or anything like that. What I'm trying to bring to your notice is that whatever medication we write, until we communicate with the patient, engage with them with full attention, even if it's for a couple of minutes, 4 to 5 minutes, this directly translates into better results. And that is why you and I became doctors, so that we could do good. I found this study very interesting, that in patients who received extensive education about the pharmacological treatment of osteoporosis, there was a 92% adherence rate as compared to 80% adherence rate for those people who did not require, did not get intensive education. By now, you must have guessed that I read a lot of books. And there's a beautiful study shared by Malcolm Gladwell in his book, Blink. And what they did is they looked at videotapes of surgeons talking to their patients. And they divide them into 2 groups, surgeons who had been sued by their patients for medical negligence and surgeons who had not been sued by their patients for medical negligence. And they looked at everything, how the person spoke, how long they spoke, how much detail they went into, did they cover all the pros and cons of the surgery, everything they covered. And the single factor which decided whether or not a patient would sue a doctor is the tone of voice that the doctor used while talking to the patient. So many times in a rush clinic, there are 100 things going on in your mind, and your tone of voice may convey your displeasure or inattention, or sometimes we talk down to our patients, and this can be make or break. So though the suing doctors has not yet become very popular in our country, but it may soon. So Patrick Barry, in his book, author of Good with Words, says, if you're good with words, you can be pretty darn persuasive. And ultimately, that is what you and I want to do. We want to persuade our patients to take the prescription that we're offering them. Because if they do take the prescription, only then are they going to get benefits. They're going to have better health and better quality of life. Now, I'll just explain this concept called framing, that the words you use and how you communicate to your patients can make all the difference. So for example, if I told you that, you need this surgery, but there's a 10% chance you're going to die. Chances are you're not going to get the surgery done and you're going to run out of my OPD screaming and probably just go to the next doctor. But if I were to tell you, if you get this surgery done, there's a 90% chance that the surgery will go perfect. There will be no issues whatsoever and you'll be able to go home all right. I'm more likely to do the surgery. Similarly, the previous speaker was talking about urinary tract infection. So when I tell my patients, you may get a urinary tract infection because of this medicine I'm writing, there's a frown on their face and they're like, why is she writing me this medicine at all? But the minute I say the next sentence, that is, if I were to give this medicine to 100 people, 98% of them would not have any problems. Only 2% will have a problem. Immediately the face clears and say, okay, doctor, I'm okay to try it. So just the very fact that if we take a second to think about how we're conveying the information, you have the best knowledge in the world, but you convey it in a manner which is encouraging, then the person is likely to listen to you. Otherwise, they won't. We recently wrote this paper, which is called as Doctor-Patient Communication in People with Thyroid Conditions. And the basic reason we wrote this paper is because to most doctors, thyroid is the simplest thing to treat. Nobody dies in thyroid conditions. Like, what's the big deal? And why do patients need so much time with us? But there are several things that you need to think about when you're talking about a thyroid condition. And I'll just touch 2 or 3. Now, whenever you start and write the first prescription of a thyroid medication for the first time in a person's life, it takes you exactly 2 minutes to write that prescription, but you're quite literally writing something which the person will have to take for the rest of their life. So imagine it's somebody who's 25 and it's quite literally a death sentence, and for the next 50 to 55 years of their life, they're going to have to take this medication. So how you communicate about this need for lifelong medications is very, very important. And one of the tricks we use is that instead of saying that I'm giving you this medication, you say that we're replacing the hormone to support your body. So the minute that people think it's a medication and it's for the rest of their life, they think my life is over. And so many times you'll come across patients who went to some homeopathic doctor, Ayurvedic doctor, stopped the medications, they're back with a TSH of 500. So taking those extra 3 to 4 minutes when you're initiating a thyroid medication for the first time in somebody's life is very, very important. Also explain to patients the limitations of treatment. The hair fall sometimes doesn't go away. They don't lose weight. The skin doesn't miraculously become like Shilpa Shetty. So there are limitations of treatment. We acknowledge that the treatment has its limitations rather than telling them, oh, you know what, it doesn't matter. It's all right. What's the big deal? It doesn't work. One of the very important points that I think we never consider, did not consider up about, say, until about 6 to 8 months ago, is that people who have thyroid eye disease and their proptosis, and what is the impact of that on their mental health? I will illustrate this by, an example where an ophthalmologist came to me and she had bilateral proptosis. And she walks out of the hospital, she goes out of the gate of the hospital, and there's a chai wala at the corner. And the chai wala tells him, madam, aap to aankh ke doctor ho na, aapke aankh ka kuch karte kyun nahi ho? So proptosis has huge impact on social interactions, on what people speak to them, and can have a huge impact on mental health. So maybe just a quick question about how are you dealing with the eye disease, and do you need any support for that? Refer to a psychologist if you feel that they need help. And one of my patients, I just remember till today, Nalini Tendulkar, she told me, you know what, doctor, in the beginning, it was really tough. But now I've kind of explained to myself that it's okay. I just have to ignore people. Only one example in polycystic ovary syndrome. So over the past 1 month, I've had at least 3 to 4 girls, all of whom have developed eating disorders. Because from the time they were 13 till date, the time that they come to see me, all they've been told is you are responsible for your PCOS. You have a bad lifestyle. You're lazy, or you're not doing your lifestyle modifications. And that's why your PCOS is not getting better. 3 of these girls, all of them have ended up with either a binge eating disorder, they vomit, and one of them has actually got anorexia nervosa because at 13 years of age, the doctor told her, you know what, you have a bad lifestyle. She was just 13 and she cried in my clinic when she left. So in the last slide, what I would like to say is that it's very easy for me to tell you, what communicate better. But if you ask me exactly how to communicate better, I think diabetes is the best illustration. So instead of telling patients that, if your sugars are high, you will die early, or you will live less, or you will die 10 years early, you can say that if we manage your sugars well, you will live longer. Please notice my use of the word we and not you, because management of diabetes is a partnership between doctor and the patient, and we can't put the onus on the patient alone, and it's a partnership. So if we manage your sugars well, you will live longer. If we manage sugars consistently well, we can avoid the complications of diabetes. If you take your medications regularly, we can avoid insulin, or we can try to avoid insulin. A lot of times, people who are, children of people with diabetes, they think their life is over when they get diabetes. So using this sentence that, today we have so many better tests, amazing medications for diabetes, you are not going to have the same outcome that your parents had, and your future is much, much brighter. So according to me, communication in endocrinology, and especially diabetes, thyroid, PCOS, is definitely the need of the hour. And I thank you so much, Team Hormone India, to let me speak on this topic. Thank you so much.
Thank you, ma'am, for that excellent talk. So I feel that all of us, at least me, is responsible and guilty for giving these for giving into this fear tactics. Like we used to say, like if your diabetes is not controlled, next time you'll be on insulin, your kidneys will go off, you'll lose your eyesight and all. But over time, we have learned that this is not the way. Patients usually come back with the same results the next time. As you rightly said, ma'am, communication is the key. Talking to the patient, giving 2 minutes or 5 minutes extra makes a lot of difference. Next time we see them, they are very compliant. They come with a better sugars or a better thyroid report, or at least they follow what you're telling, and you can escalate the drugs. Not like they are just not following anything. So thank you, ma'am, for that excellent talk.
One comment. Just the last comment is this, that we can't blame you and me, because there's no communication skills training when you're becoming a doctor. So the future is that if we could have mandatory communication skills training, then you and I would have done a better job. Hopefully the next generation will do a better job.
I think that is incorporated in the new, this thing, NMC, the new thing they have come up with, the communication guidelines.
Yeah. Just to add a remark, 100% for the presentation and 200% for the energy level.
Thank you so much, and all the best, guys, for the rest of the conference.
Thank you.
Thank you, Dr. Tej.
So I'll be introducing our next chairperson, Dr. Sanjay Jain, to come forward and introduce Dr. Ashish Tengra. Dr. Sanjay Jain.
Yes, kindly unmute Dr. Sanjay Jain. Please unmute yourself, Dr. Sanjay Jain. I think some issue at his end, he cannot unmute.
Hello.
Mayur, you can go ahead.
I'll just, yeah.
He is diploma in diabetes, Cardiff University, UK, FISCM, FAMS, fellow RSSDI and fellow Diabetes India. He is basically CPS Diabetology and All India Institute of Diabetes, SL, Raheja Hospital. Can I sort this?
Sure. We are
yes, sir.
He's basically the he has been the organizing secretary, Jabalpur Diabetes Update, Jabalpur Thyroid Update and WhatsApp, and president of API and president Jabalpur Endocrine Society. He has awarded and received fellowship award for the year 2020 and received Best Diabetes Awareness Initiative Award at RSSDI 2011. Best State of Art Diabetes Food Clinic Award and presented paper in various national and international journals. Can I request Dr. Ashish Tengra to deliver his lecture?
Thank you, Sanjay Jain sir, for kind introduction. And at the outset, I would like to thank Mayur and his team at Hormone India for inviting me for the excellent workshop and the conference going on, and it is very nice lectures going on. So I would request to screen. Please allow me to share my screen. Yeah, can you see my slides? Hello.
Can you make in portrait mode? Then it
Yeah.
would be better. Yes. Yeah, you can go.
So thanks a lot for inviting me here to deliver an important talk on mitigating hypoglycemia in clinical practice. So in the coming few minutes of journey, we will be going through the hypoglycemia, what is it and how we can mitigate in our clinical practice, because it is very important to prevent the episodes of hypoglycemia, to prevent the future complications, and a lot of money we can save. So what is hypoglycemia? We all know that level 1 is less than 70, 54 is level 2, and no specific glucose levels. If we see, it is very severe, alarming condition. You know, we all might be thinking that the higher admissions rates are for hyperglycemia, but no, my dear friends, the hospital admissions for hypoglycemia are higher than the hypoglycemia. So most misconception is that there is hypoglycemia is not a concern for type 2 diabetic, but my dear friends, it is a 12 times as many type 2 diabetic patients develop emergency department admissions for hypos. So prioritize hypoglycemia prevention is very important in type 2 diabetes also. So predictors for hypoglycemia, which we have to mitigate, is the food related. In one study, they have shown it is 48%, delayed or missed meal is 31%. The patients ate less carbohydrate and they went up into hypoglycemia, unexpected vigorous exercise. Patient usually take more insulin than prescribed, and somebody ingest alcohol a lot and then they don't take the meals. So all these are the factors which we should mitigate. And the problem of hypoglycemia is very high. 90% of cases are associated with hypoglycemia admissions, and 39% cases result in hospitalization in the real world scenario. So causes of hypoglycemia are a lot which we should mitigate in our clinical practice, like new exercise beginning and not taking the snacks, and inconsistent food intake, weight loss, gastroparesis, alcohol intake, and number of factors which we should take care. Aggressive insulin use and sulfonylurea, which we prescribe in our patient coming with sugars of 400, and we jump into the insulin and sulfonylureas high dosages. Chronic kidney disease or liver disease, they are the major thing which we should see. The consequences of hypoglycemia are a lot. Apart from the hypoglycemic episode, sweating, and they can go into cognitive dysfunction, seizure, coma, and the cardiovascular risk is increased, quality of life is decreased, and the severe hypoglycemia has proven that it is harmful in the advanced VADT and ACCORD trial. And severe hypoglycemia is a major risk factor for adverse outcome, mostly in the older age population, and it leads to cardiovascular disease. And the meta-analysis have proven that severe hypoglycemia is associated with a higher risk of cardiovascular disease. So, my dear friend, there is a pathophysiological pathway which you can see. There is increase in the inflammatory markers, sympathoadrenal drive increased, and cardiovascular risk is very high. And in the older population also, we have to be vigilant to mitigate these episodes, like prior episodes or older age polypharmacy. Don't remember, the cognitive impairment can lead to high sugars due to the polypharmacy. So in older adults, we should be vigilant. The hospitalization for hypoglycemia in adults and the subsequent transition to home. In this study, they have shown the patients with more than 80 years, they have more hospitalization due to the hypoglycemic episodes. What factors we should mitigate? The most common predictors or factors which causes hypoglycemia are missing a meal or taking too many medicines or insulin and not taking the food. So my dear friend, the predictors of hypoglycemia are number of previous hospitalization, insulin treatment, sulfonylurea treatment, higher age, CKD, and number of emergency department visits. So these all you have to mitigate. But how? How we have to mitigate the hypoglycemia? The ADA recommends we have to individualize the pharmacotherapy in patients with the diabetes to prevent or reduce the risk of hypoglycemia, avoiding the over-treatment with multiple polypharmacy, simplifying the complex regimes while maintaining the A1C target. So treatment goals are individualized. If the patient is healthy adult with few comorbidities, 7.5 and below. If the patient is older age, we should be not too much aggressive. We should keep the A1C of less than 8. So integrated approach, insulin or sulfonylurea, dementia or cognitive impairment, multi-professional educational tool, all these are the high-risk patients which require the proper follow-up. So how you have to mitigate by risk stratification, targeting the high-risk population and identifying them, intervene with them and prevent the future hypoglycemic events. You have to advocate for mitigation, provide patient information on symptoms, management, counseling, and shared decision-making with the family members, disseminate information about the A1C accuracy, educate both the providers and the patient. That is very important about the hypoglycemic events or food, and ensure the providers and patient having an understanding for medication safety and future risk. So better is to take care of take the medicines in the adult population which are having the low risk of hypoglycemia, like metformin, GLP-1, DPP-4 inhibitors, or SGLT2 inhibitors, which have the less chances of hypoglycemia. So the challenges can be mitigated by real-time CGM or intermittent viewed CGM. You can prevent the episodes of future hypoglycemia. In the type 1 diabetic population, CGM is proving a wonder to mitigate the hypoglycemic event. And during the Ramadan or any other fast, like during the Navratris, you should follow up the patient with SMBG or with the CGM. In this ProFast IT study, they have mitigated hypoglycemia during Ramadan by using the flash glucose monitoring system, following dose adjustment of insulin and sulfonylurea in patients with taking the multiple dosages. So structured education and adjustment of the dose of glucose lowering agent along with CGM, it helps to mitigate the hypoglycemic episodes in the Ramadan population. So you have to individualize the target. Don't jump into the 7% in all the population. Please see how is the cognitive function, what are the comorbidities, then you can take care of the HbA1c. So to finish with a few slides, mitigating hypoglycemia is very easy by identifying and addressing the cause, encouraging the SMBG by patient, education and empowerment of patient is very important. Flexible insulin or oral anti-diabetic regime, don't stick to the guidelines strictly in the older patients or patients who are going into hypoglycemia. Rational individual glycemic goals should be taken care. Ongoing professional guidance and support is very much important in all aspects of diabetes management. So regime of periodic nighttime blood sugar monitoring should be given in the recurrent hypoglycemic patients. Patient wear identification card that they are hypoglycemic. Give patient positive feedback when they demonstrate good judgment. And what nutrition changes can be made should be dietitian care should be taken. They should be provided with the middle meal snacks and do not skip or delay meals. Please teach them properly. So the lifestyle changes are very important to mitigate the hypoglycemia. Work closely with the healthcare provider. Your goal of blood sugar should be individualized. How and when to check the glucose levels. All these things can be discussed and taken care. Do not drink alcohol on an empty stomach. Check your exercise before, during, and after exercise. So to conclude, the patients with hypoglycemia risk like renal impairment, CVD, or polypharmacy, and the advanced age, they have the more chance of hypoglycemia. You have to be vigilant in these patients. In older population, you have to use the drugs like DPP-4 inhibitors or SGLT2 for mitigating the hypoglycemic episodes. So my dear friends, take a team approach. Mitigating hypoglycemia should be a part of composite diabetes management. Don't only jump onto the management of fasting and PP, but you have to mitigate the hypoglycemic episodes by proper education of patient and family members, choosing the right treatment for different subgroup of diabetes patient. You have to individualize the treatment. Frequent glucose monitoring is an important tool to mitigate hypos in all subgroups of diabetes patient, whether they are type 1, type 2, or GDM, along with CGM monitoring. A1C goal should be individualized as per the patient profile to avoid future hypoglycemia. So thank you for patient hearing. In the nutshell, we have to mitigate with family member education, patient education, and frequent monitoring. Thank you. Thanks a lot.
Thank you, sir, for wonderfully covering that topic. Hypoglycemia is definitely a major problem that we face, but it is unaddressed. I think most of the time we don't explain to our patients that you may have hypoglycemia with these drugs and what you should do. So as you rightly said, sir, education, you have covered very nicely on education, how to adjust the drugs, and the use of technologies to mitigate hypoglycemia, and especially about the eating habits. If you miss a meal or if you reduce your meal, you have to reduce your your drugs, especially insulin, short-acting insulins. Otherwise, you'll end up in hypoglycemia, and also about alcohol, the patient card. So you have covered everything in detail, but in a crisp way, sir. Thank you, sir, for the wonderful talk. So thank you, sir.
Thanks a lot for patient hearing and inviting me to the Hormone India conference. Thank you, Mayur. Thank you, Tony.
Thank you. So we can go on next. Yeah, we can go on for our next topic. So this will be delivered by Dr. Manoj Chawla, sir. So this is also a very important topic, diabetes distress, because most of the times we know that diabetes is a chronic disease, and patients are all mostly stressed. They are upset about having diabetes, that they cannot eat this and that. They may develop complications. They always ask, why me? Can I do something to cure diabetes? So they are in a state of distress. So how we can mitigate this distress, we'll hear from our next speaker, Dr. Manoj Chawla, sir. So sir is MBBS, Diploma Diabetes, FRSTI, FRCP. So he's the Director and Consultant Diabetologist at Lina Diabetes Care in Mumbai. So he's a consultant diabetologist at PD Hinduja Hospital, Kar, Mumbai. And he has won various awards and accolades. He has various papers in national and international journals. So over to you, sir. So sir's record is actually a recorded session. He's in Sweden, that is what I know. But sir will be joining us. So tech team, can you please play sir's recording?
Good evening, everyone. At the outset, let me thank Dr. Mayur Agarwal and Team Hormone India for inviting me and giving me a topic that I feel that I'm reasonably passionate about, which is diabetes distress. I have no conflict of interest for today's conversation. I'm speaking in interest of patients with diabetes and how clinicians should be looking at reducing their distress. In my presentation over the next 13-14 minutes, I would like to cover about the burden of diabetes distress in both patients with type 1 and type 2 diabetes, highlighting the differences between depression and diabetes distress, what should be the comprehensive approach to screening and diagnosis of diabetes distress, and what are the targeted areas and treatment approaches that we should consider for our patients with diabetes. This was the work done by the group led by Dr. Sanjay Kalra, and I was happy to be part of it, which came out with the paper on euthymia in diabetes, clinical evidence and practice-based opinion from an international expert group. And this was this lovely term euthymia, which is coined to again highlight the diabetes happiness and the lack of distress which we should move our patients towards when we treat a chronic condition like diabetes. So what really is euthymia in patients with diabetes? Let's understand this concept better. It refers to optimal mental state or mood and is an essential part of good health and well-being. The word euthymia is eu is well and thymos is the emotion or the soul. So this was first defined by a Greek scholar, Democritus, as one who is satisfied with what is present and available, taking little heed of people who are envied and admired, and observing the lives of those who suffer and yet endure. So euthymia could be broadly described as a state of positive mental health, eustress, and psychological well-being. And that's largely the definition of health also as per WHO, which is both mental and physical health. Euthymia should also be considered as an important tool and target in diabetes care, as the burden of mental health dysfunction is high in patients with diabetes, something which is rather ignored by most of us who treat. Let's look at why we are discussing this problem, because there's a huge burden. When you're looking at the struggles of those living with diabetes, let's think for a minute for them and the problem that they go through living with diabetes on a daily basis. So diabetes-related emotional distress is associated with burden of self-care, interpersonal issues, emotional worries regarding how do you ability to cope with the illness, and relationship with caregivers and healthcare professionals. And this is an ongoing cycle. It is not limited. It's something which happens through the life of the individual. How do we really define diabetes distress? Well, so diabetes distress is defined as an emotional response characterized by extreme apprehension, discomfort, or dejection due to perceived inability in coping with the challenges and demands of living with diabetes. You will hear different words and expressions from people with diabetes who may say, there's just no interest. Or in different colloquial languages, they'll say, they'll say, ruchi nahi hai koi cheez mein. So you will hear these different expressions where it's not really depression or a major depressive disorder, but it is the burden of living with diabetes, the diet, the monitoring, the medications, and all of that. Let's look at the prevalence of diabetes distress, and there has been data put up, and this is looking at patients with type 2 specifically. Diabetes distress is a major concern in type 2 diabetes patients, with a higher prevalence noted in the female gender and patients with comorbid depressive symptoms. And I think this is going to be extremely true even in a country like India, where women very often may prioritize the welfare of the male members in the house, often neglecting their needs, their health issues, and of course their mental health. The overall prevalence of diabetes distress, which was noted in a meta-analysis of 55 studies on this aspect and subject, was found to be about 36%. So every third patient that we see with diabetes with type 2 has some amount of diabetes distress, and hence the need for us to discuss this more often, just as we talk about the cardiac problems and renal issues and nephropathy and retinopathy and so on. We look at the prevalence of diabetes distress in adults and adolescents with type 1 diabetes. And these are some of the aspects of diabetes distress and their incidences. We'll talk about feeling powerless in type 1 patients, and it has high as 72%. Distress related to managing their disease, 42% patients have reported. Hypoglycemia worry, about 43%. Negative social perceptions, 33% for type 1 that's important. Eating distress in about 54%, and so on. So there are different kinds of distress, and we should be aware so that we can pay attention and try and minimize that as much as possible. So in a study, prevalence and 9-month incidence of elevated diabetes distress were reported as 42% and 54% respectively in type 1 diabetes patients. Time points in the life of a person with diabetes, which may be associated with increased levels of diabetes distress. And this is interesting and worth noting, because these are definitely the time points or events in the life of a person with diabetes which we know are going to be likely to be associated with distress, and we can pay more attention and help them minimize. So around the time of diagnosis, yes, going through the emotions of denial, anger, fear, and eventual acceptance, that is the time for distress. At the time of learning how to self-manage diabetes. And hence where we say sometimes, trying to teach your patient newly detected with diabetes with all the aspects at the same time may be difficult. If you want to talk to them about diet, medication, maybe learning insulin and monitoring, for us who do this job on a daily basis, it's fine. For a patient who's newly detected, if you're trying to teach them all at the same time, many patients may find it too overwhelming. And hence we may need to plan as to what I want to really do at each visit rather than trying to do everything. And this completely depends on the patient's ability to learn and absorb and adhere and understand. So it has to be individualized. Whenever there is a new complication onset, it's going to again add to distress. Telling a patient that there is rise in your creatinine, you've seen microalbuminuria, there seems to be some aspect of leakage in the eye and so on, is going to cause distress. Also, when you switch patients' medications within the oral segment or addition of insulin is a kind of distress to the patient, so you need to heed special attention to that. And also when patients move from one doctor to another for whatever reason, we may feel that patients are so-called doctor shopping, but it's actually stressful for them also to go and see a new doctor, and which is very often you see in the clinics that patients will come who never had high blood pressure but are found to have detected new blood pressure on the higher side when they've come to see you because of the white coat hypertension and the anxiety that they have. Now, we spoke about trying to say that diabetes distress is not really clinical depression, so it has to be differed from major